Brain herniation is what it's called when some brain tissue moves outside of the skull, or moves across or into a structure within the skull. Brain herniation typically happens in response to increased intracranial pressure, which refers to a high pressure within the skull. An intracranial pressure above 15 millimeters of mercury is considered high. Okay, let's start with some basic brain anatomy. The brain has a few regions. The most obvious is the cerebrum, which is divided into two cerebral hemispheres, each of which has a cortex, or an outer region, divided into four lobes, including the frontal lobe, parietal lobe, temporal lobe, and the occipital lobe. There are also a number of additional structures, including the cerebellum, which is down below, as well as the brainstem, which connects to the spinal cord. Now, zooming in, the brain and spinal cord is covered by the meninges, which are three protective layers of the brain. The inner layer of the meninges is the pia mater, the middle layer is the arachnoid mater, and the outer layer is the dura mater. These first two, the pia and arachnoid maters, form the subarachnoid space, which houses the cerebrospinal fluid, or CSF. CSF is a clear, watery liquid which is pumped around the spinal cord and brain, cushioning them from impact and bathing them in nutrients. The outer membrane is the dura mater, which forms the meningeal folds, such as falx cerebri and tentorium. The falx cerebri goes down into the longitudinal fissure that separates the hemispheres of the brain. The free edge of the falx cerebri is in close contact with the central part of the brain, called corpus callosum, which connects the left and right hemisphere. There's also the tentorium, which is located in the back of our skull, that separates the cerebrum from the cerebellum. The free edge of the tentorium is in close contact with the brainstem, which is the region that connects the brain to the spinal cord. The skull has a set volume, and the pressure inside of the skull is kept relatively constant. In other words, the sum of the volumes of the brain, cerebrospinal fluid, and intracranial venous and arterial blood is always about the same. So, if there's an increase in the volume of any one of these three, there's a compensatory decrease in the other two. For example, when a high-speed golf ball hits you in the head, an artery could rupture within the skull. As the artery bleeds, the blood starts to pool, and that leads to what's called a mass effect within the skull. And that mass effect increases the intracranial pressure. To help reduce the volume and pressure back to normal, there's less CSF production and more CSF reabsorption. Over time, if the arterial bleed continues, then it might overwhelm the body's ability to compensate, and the intracranial pressure could start to get quite high, and that can lead to a brain herniation. So, brain herniation can be caused by either a focal mass effect, like the arterial bleed, or a diffuse mass effect, depending on whether the problem is in one area or involves the entire brain. In addition to intracranial bleeds, other causes of focal mass effects are tumors and abscesses. All of these focal masses also create surrounding inflammation, which causes local edema, and that makes the focal masses even larger. Diffuse mass effects are caused by generalized cerebral edema, which is an excessive buildup of fluid throughout the brain tissue. There's cytogenic edema, which is when there's fluid buildup within the cells of the brain due to a retention of sodium and water, and there's vasogenic edema, which is when fluid builds up right outside of the cells, in the interstitial space. Some causes of cerebral edema are large ischemic strokes or meningitis. Depending on the size and location of the mass effect, there's a possibility of brain herniations, and it can either be supratentorial or infratentorial herniation. Supratentorial herniation refers to displacement of the cerebrum, which is above the tentorium, and infratentorial herniation refers to herniation of the cerebellum, which is below the tentorium. Alright, so supratentorial herniations include 4 types of displacement, and these differ by the exact part of the cerebrum that's affected. The first type of supratentorial herniation is uncal herniation. also referred to as transtentorial herniation. In this, the innermost part of the temporal lobe, called the uncus, slips down toward the tentorium and puts pressure on the brainstem. The uncus can squeeze the oculomotor nerve, resulting in an oculomotor nerve palsy. In oculomotor nerve palsy, the eyeball is in a down and out position due to a loss of innervation of muscles controlled by the nerve. Also, the affected pupil becomes dilated and fails to constrict in response to light. The posterior cerebral artery can also be compressed, which results in ischemic stroke of the occipital part of the brain, which is responsible for processing of visual information. This leads to homonymous hemianopia, which is a loss of vision in either the left or right halves of the visual field of both eyes. The vision is lost in halves that are contralateral to the posterior cerebral artery that is affected. Although there is a partial loss of vision, macular function is spared, meaning that the central vision is still sharp and detailed. This is because the part of the occipital lobe in charge of the macula gets blood from both the posterior cerebral artery as well as the medial cerebral artery. Uncal herniation stretches and sometimes breaks branches of the paramedian basilar artery, which nourish the brainstem. That causes small linear or flame-shaped hemorrhages called Duret hemorrhages, which can be seen on an autopsy. So let's say there's a focal mass effect on the right side of the skull, which increases intracranial pressure and squeezes the uncus down onto the brainstem. Now, the uncus isn't only directly compressing the right side of the brainstem, but indirectly, it's also pushing the left side of the brainstem against the free edge of the tentorium, forming what's called a Kernahan's notch. The compressed part of the brainstem is called the left cerebral peduncle, and it's rich in motor fibers that travel from the cortex on the left side of your brain to muscles on the right side of your body. Eventually, this injury of the left cerebral peduncle will result in weakness on the same side of the body as the side of the focal mass effect, also called ipsilateral weakness. Now, normally damage to brain tissue results in weakness on the contralateral side, so the Kernahan's notch causes a false localizing sign. The second type of supratentorial herniation is central herniation. And that's when the diencephalon and parts of the temporal lobe slip under the free edge of the tentorium. The diencephalon is a part of the brain that processes sensory information and emotions, as well as regulates hormone production, so all of these processes can be affected. Central herniation can also cause dilated and fixed pupils, and paralysis of upward eye movement, which leads to the sunset eyes sign. That's where the eyeballs are in a downward position and part of the lower pupil is covered by the lower eyelid. Just like in uncal herniation, Duret hemorrhages can be seen in central herniation. The third type of supratentorial herniation is cingulate or subfalcine herniation. In this, the innermost part of the frontal lobe, called the cingulate gyrus, gets squeezed below the free edge of the falx cerebri to the opposite side of the skull. The displaced part of the brain can compress the anterior cerebral artery, and that can cause an ischemic stroke. Finally, a cingulate herniation is often a forerunner of other types of supratentorial herniation. The fourth type of supratentorial herniation is transcalvarial herniation, which is also called an external herniation. In this, the brain squeezes out of the skull through a fracture or surgical site during an operation. Now, the other category of herniations are infratentorial herniations. There are two types, upward herniation and tonsillar herniation. In upward herniation, there's a displacement of the cerebellum upward through a notch in the tentorium cerebelli. In tonsillar herniation, parts of the cerebellum, called cerebellar tonsils, slip down through an opening in the skull called the foramen magnum. This is particularly dangerous because the displaced cerebellum can push onto the brainstem and affect neurons responsible for breathing and cardiac function. The most common signs of the tonsillar herniation are headache and neck stiffness. The level of consciousness may also decrease and give rise to flaccid paralysis, where there's reduced muscle tone. On a physical exam, increased intracranial pressure should be suspected in individuals with a decreased level of consciousness, focal neurological signs, and papilledema. Papilledema is the swelling of the optic disc, which is the point where the optic nerve fibers leave the retina. Also, these individuals may have increased blood pressure, irregular breathing, and bradycardia. These signs are referred to as Cushing's triad, and they represent a physiological response of the central nervous system to increased intracranial pressure. Lumbar puncture is classified as a relative contraindication in individuals with suspected increased intracranial pressure due to possible herniations. In order to confirm the presence of a mass effect that may be causing increased intracranial pressure, medical imaging, such as CT or MRI, can be used. If CT and MRI fail to prove any mass lesions within the skull, lumbar puncture can be performed. Once the needle is inserted into the spinal canal, it's attached to a manometer, which is a device that measures the CSF pressure. Normal opening pressure on lumbar puncture is 100 to 180 millimeters of water, or 8 to 15 millimeters of mercury. Above that is considered increased intracranial pressure. Treatment of increased intracranial pressure and brain herniation is aimed at reducing the pressure within the skull. It may include treatment of the underlying cause, such as surgical removal of a tumor, abscess, or hematoma. Furthermore, it may include external ventricular drain, which requires a placement of a drain through a hole in the skull to get rid of excessive cerebrospinal fluid, or decompressive craniectomy, which is where a part of the skull is removed to help relieve the pressure. Another way of treating increased intracranial pressure includes using osmotic therapy, such as mannitol, which helps remove excess water from the body. Alright, as a quick recap. Brain herniation typically results from increased intracranial pressure. There are two main classes of herniation: supratentorial, which refers to a displacement of the cerebrum, and infratentorial, which refers to a herniation of the cerebellum. Furthermore, supratentorial herniations are subdivided into 4 types. Uncal herniation, also referred to as transtentorial herniation, which affects the innermost part of the temporal lobe, the uncus; central herniation, which affects the diencephalon and parts of the temporal lobe; cingulate or subfalcine herniation, which affects the cingulate gyrus; and transcalvarial herniation, which occurs when the brain squeezes out of the skull. On the other hand, infratentorial herniations are subdivided into upward herniation and tonsillar herniation. In upward herniation, there's a displacement of the cerebellum upward through a notch in the tentorium cerebelli. While in tonsillar herniation, parts of the cerebellum slip down through an opening in the skull called the foramen magnum. Diagnosis is done by CT or MRI, and treatment includes options like decompressive craniectomy and osmotic therapy.
Kluver-Bucy syndrome is a neurobehavioral condition first observed in the 1930s by Heinrich Kluver and neurosurgeon Paul Bucy. They discovered that monkeys that had bilateral temporal lobe lobectomies developed dramatic behavior changes in their memory, as well as their social and sexual behaviors. In retrospect, it's not surprising that having a significant portion of the brain removed caused behavior changes in monkeys. The biggest one was probably anger at Kluver and Bucy for putting them through that. The temporal lobe is one of the 4 major lobes of the brain. It has a variety of functions which are involved in sensory processing. The ventral or anterior part of the temporal lobe helps process visual information, like recognition of objects and faces. The medial or middle portion of the temporal lobe, on the other hand, along with the hippocampus, is responsible for formation of new memories. The temporal lobe also houses the primary auditory cortex, which is needed for speech comprehension. Other important structures found within the temporal lobe include the olfactory cortex, which processes the sensation of smell, and the amygdala, which processes emotions. The amygdala also plays a role in the reward center of the brain, which motivates and reinforces behaviors that elicit positive feelings. In Kluver-Bucy syndrome, there's a bilateral lesion of the temporal lobe. The most common cause of such a brain lesion is herpes simplex encephalitis, which is a viral infection that particularly affects the temporal lobes. Other causes of Kluver-Bucy syndrome include trauma, stroke, Alzheimer's disease, and Niemann-Pick disease, which is a rare metabolic condition that affects various organs of the body, including the brain. The damage affects the amygdala, which is a part of the brain that regulates emotions and reinforces behaviors related to food and sex. Amygdala damage also causes a diminished fear response. With that in mind, there are three main symptoms caused by Kluver-Bucy syndrome: hyperphagia, hyperorality, and hypersexuality. Hyperphagia means compulsive overeating. Sometimes this also presents as the consumption of inedible substances like soil and chalk, a condition known as pica. Hyperorality is a type of compulsion where one needs to examine objects by putting it in their mouth. Blech. And as the name implies, hypersexuality refers to an elevated sex drive, sometimes associated with various paraphilias, or fetishes. In addition, damage to the ventral temporal lobe, which is responsible for visual processing, results in visual agnosia, or the inability to recognize familiar objects or people. Damage to the medial ventral lobe and hippocampus, which both play a role in memory formation, results in amnesia. Diagnosis of Kluver-Bucy syndrome is typically made based on having the classic symptoms and is usually confirmed based on bilateral temporal lobe damage on an MRI. Treatment is generally supportive and include things like assistance with daily living and occupational therapy. Selective serotonin reuptake inhibitors might help treat some of the abnormal behaviors, while carbamazepine might be given to specifically treat symptoms of hypersexuality. Alright, as a quick recap, Kluver-Bucy syndrome is a neurological condition caused by bilateral lesions in the temporal lobe, and symptoms include hyperphagia, hyperorality, hypersexuality, docility, visual agnosia, and impaired memory. It's associated with herpes simplex encephalitis, and can be treated with selective serotonin reuptake inhibitors and carbamazepine.
Wernicke-Korsakoff syndrome is a rare neurological condition that causes degeneration of brain cells, or neuronal atrophy. It's caused by thiamine or vitamin B1 deficiency. Thiamine is a vitamin absorbed in the intestines and used for energy metabolism to support growth, development, and cellular functioning, especially in the brain and nervous system. Thiamine deficiencies are commonly seen with conditions that lead to malnutrition, such as chronic alcohol use. The condition includes two stages: Wernicke encephalopathy, which is the acute and reversible stage, and Korsakoff syndrome, which is when the condition progresses to a chronic and irreversible stage. Now, Wernicke-Korsakoff syndrome commonly presents with the triad of altered mental status, including confusion and memory deficits, nystagmus, or involuntary rapid and repetitive movements of the eyes, and ataxia, or impaired coordination of voluntary movements, balance, and speech. Other symptoms that may develop include agitation, hallucinations, and confabulation, which is when affected individuals create stories they believe to be true to fill gaps in their memory. Diagnosis of Wernicke-Korsakoff syndrome is typically based on the individual's history and physical examination. Laboratory tests like a complete blood count, liver function tests, and thiamine levels are also commonly done. In some cases, diagnosis may be confirmed with an MRI of the brain showing degeneration of the mammillary bodies, which are two areas in the brain responsible for memory. Now, the treatment for Wernicke encephalopathy is to consider it a medical emergency, and it must be addressed immediately to prevent the development of Korsakoff syndrome. Treatment involves intravenous thiamine administration as soon as there is clinical suspicion of Wernicke-Korsakoff syndrome. If Wernicke encephalopathy is treated promptly, affected individuals can begin to improve within 2 to 3 weeks of treatment. However, if Wernicke encephalopathy progressive to Korsakoff syndrome, affected individuals may require lifelong treatments that include oral thiamine and rehabilitation. Alright, as a quick recap. Wernicke-Korsakoff syndrome is a rare neurological condition that causes neuronal atrophy due to thiamine or vitamin B1 deficiency, and is commonly seen in chronic alcoholism. It consists of a classic triad of altered mental status, nystagmus, and ataxia. Diagnosis is usually based on clinical evaluation. Lastly, treatment involves the prompt administration of thiamine, addressing any underlying cause, and long-term care as needed.
Wernicke-Korsakoff syndrome is named after Karl Wernicke and Sergei Korsakoff, the physicians who discovered the condition in the late 1800s. Wernicke-Korsakoff syndrome is caused by vitamin B1 or thiamine deficiency, and it refers to a spectrum of disease. Wernicke's encephalopathy is the acute, reversible stage of the syndrome, and if left untreated, it can later lead to Korsakoff syndrome, which is chronic and irreversible. Thiamine is typically stored in the liver and absorbed in the jejunum and ileum, and then moves throughout the body, where it's involved in numerous cellular processes that require thiamine. The enzyme thiamine pyrophosphate synthetase transfers a pyrophosphate group from ATP to thiamine, turning it into the coenzyme thiamine pyrophosphate, which is the metabolically active form of thiamine. Now, as a coenzyme, thiamine pyrophosphate functions to assist other enzymes carry out reactions, like pyruvate dehydrogenase, alpha-ketoglutarate dehydrogenase, and transketolase, particularly regarding glucose metabolism. Furthermore, within the brain, thiamine pyrophosphate helps metabolize lipids and carbohydrates as well as maintain normal amino acid and neurotransmitter levels. In some neurons, thiamine even helps with propagation of neural impulses down the axon. Given its multifaceted role, a deficiency of thiamine can have serious consequences. Specifically, thiamine deficiency impairs glucose metabolism, and this leads to a decrease in cellular energy. One of the major causes of thiamine deficiency, and therefore Wernicke-Korsakoff syndrome, is alcohol abuse. Alcohol leads to decreased thiamine levels in various ways. First, alcohol interferes with the conversion of thiamine to its active form, thiamine pyrophosphate, by blocking the phosphorylation of thiamine. Second, thiamine is normally absorbed through the first portion of the small intestine, called the duodenum. However, ethanol prevents this absorption process, and it's believed that alcohol does this by reducing the gene expression for thiamine transporter 1 within the intestinal brush border. Third, chronic alcohol abuse can lead to fatty liver or cirrhosis, which interferes with the storage of thiamine within the liver. Other causes of thiamine deficiency are inadequate intake, like in malnutrition and anorexia, or due to malabsorption, like in stomach cancer and inflammatory bowel disease. The brain is especially vulnerable to impaired glucose metabolism, since it utilizes so much energy. Early on in thiamine deficiency, the cerebellum gets affected, and that can affect movement and balance. In addition, the brainstem can be affected, and that's the region that gives rise to the cranial nerves that provide motor and sensory innervation to the face and eyes. If the medulla region of the brainstem is affected, it can impair the heart rate and breathing. Later findings in thiamine deficiency are hemorrhage and necrosis of the mammillary bodies. The mammillary bodies are two small round structures located under the brain and are part of the limbic system, which is responsible for memory, emotion, and behavior. Now, Wernicke-Korsakoff syndrome can be thought of as a spectrum of disorders. Wernicke's encephalopathy symptoms happen first, and can eventually develop into more severe symptoms found in Korsakoff syndrome. Wernicke's encephalopathy is characterized by ophthalmoplegia, meaning weakness or paralysis of the eye muscles, as well as ataxia or unsteady gait, and changes in mental state like confusion, apathy, and difficulty concentrating. And untreated Wernicke's encephalopathy can lead to coma and death if not treated quickly. Korsakoff syndrome, on the other hand, mainly targets the limbic system, causing severe memory impairment. This includes anterograde amnesia, which is the inability to create new memories, as well as retrograde amnesia, which is the inability to recall previous memories. One of the characteristic findings of Korsakoff syndrome is confabulation, in which the person creates stories to fill in the gaps in their memory which they believe to be true. Not too different from what young children sometimes do in retelling a story. Diagnosis of Wernicke-Korsakoff syndrome is typically made by clinical impression of the presenting symptoms, as well as basic blood and liver function tests to measure thiamine levels. Sometimes diagnosis can be confirmed by an MRI, which would show degeneration of the mammillary bodies. Wernicke's encephalopathy is considered a medical emergency and must be treated immediately to prevent the development of Korsakoff syndrome. The therapy is an infusion of thiamine over a few days to get rid of the deficiency. It's usually given alongside glucose, but it's important to normalize the thiamine levels first, because without thiamine pyrophosphate, most of the glucose will become lactic acid, and that can lead to metabolic acidosis. Alright, as a quick recap. Wernicke-Korsakoff syndrome is caused by thiamine deficiency and is commonly seen in chronic alcoholism. It's a combination of Wernicke's encephalopathy, which consists of the triad of ophthalmoplegia, ataxia, and confusion. And if left untreated, might result in Korsakoff syndrome, which manifests as amnesia and confabulation. Treatment involves the prompt administration of thiamine, followed by glucose.
Brain tumors are broadly classified into primary tumors originating from cells within the central nervous system and metastatic tumors originating from cells outside the central nervous system. Primary brain tumors are the most common solid tumors in children, while metastatic tumors are more common in adults. The most common primary brain tumors in both adults and children are gliomas. There's a subset of these called astrocytomas. In adults, gliomas are followed by meningiomas, and in children, medulloblastomas and ependymomas are next on the list. These are all followed by the less common schwannomas, oligodendrogliomas, craniopharyngiomas, choroid plexus tumors, germinomas, hemangioblastomas, and primary central nervous system lymphoma. Also in children, most brain tumors are located below the cerebellar tentorium, or are infratentorial, whereas in adults, most brain tumors are above it, or are supratentorial. Just remember that adults are taller than children, to remember that it's above, Now, in order of decreasing frequency, metastatic brain tumors most commonly come from cancers of the lung, breast, and melanoma. The main environmental risk factor for brain tumors is exposure to ionizing radiation, which can come from therapeutic radiotherapy for cancer or diagnostic imaging like CT scans. The electromagnetic radiation from cell phones and microwaves is currently being researched as a potential risk factor in humans. Immunocompromised people, like organ transplant recipients or individuals with AIDS, are at a higher risk of primary central nervous system lymphoma caused by the Epstein-Barr virus, or EBV. Meningiomas are particularly more common in women, possibly because the tumor cells possess estrogen and progesterone receptors. A small proportion of brain tumors occur secondary to genetic syndromes. For example, neurofibromatosis type 1 is associated with optic nerve gliomas and schwannomas, whereas neurofibromatosis type 2 is associated with bilateral schwannomas. Tuberous sclerosis is associated with subependymal giant cell astrocytomas. The word subependymal literally means under the ependymal cells which line the cerebral ventricles, so these tumors are commonly found along the border of the lateral ventricles. Turcot syndrome is a rare polyposis syndrome that increases the risk of colonic polyps and colorectal cancer, but also increases the risk of brain tumors, specifically gliomas and medulloblastomas. Finally, in addition to renal tumors and pheochromocytoma, cerebellar and retinal hemangioblastomas are features of von Hippel-Lindau disease. Individuals with brain tumors typically have some combination of 4 symptoms: headache, focal neurological deficits like cranial nerve palsies or seizures, a neurocognitive disturbance that often causes a decline in school or work performance, and psychiatric symptoms, including depression. The headache caused by a brain tumor is usually dull, slowly progressive, and poorly localized, usually involving the whole head. Often, the headache is worse in the morning during a change in position, such as bending or when coughing, sneezing, or Valsalva maneuvering. That's because during all of these states, the intracranial pressure, or ICP, increases, worsening the headache. Additionally, the headaches may be accompanied by nausea and vomiting in the morning. Now, preverbal children may not be able to communicate a headache. But because brain tumors in children tend to be infratentorial, there's a high risk of the tumor interrupting CSF flow and causing obstructive hydrocephalus. Because the skull sutures are still unfused in infants, this may lead to an enlarged head, or macrocephaly. This is actually relatively fortunate, because it means the head can accommodate the mass without causing a rapid increase in ICP, and deterioration of the child's neurological status. As for focal neurological deficits, brain tumors tend to cause gradually developing deficits, which differentiates them from the sudden onset deficits seen in strokes. But sometimes the blood vessels in a rapidly growing tumor can rupture, causing acute bleeding within the tumor, and therefore the acute symptoms of intracranial hemorrhage. The pattern of symptoms depends on the location of the tumor. For example, involvement of the primary motor cortex would cause weakness, whereas involvement of the primary sensory cortex would cause sensory symptoms, like astereognosis, which is the inability to identify objects by touching them. Involvement of the language areas can cause different types of aphasia, such as expressive aphasia when Broca's area is involved, or receptive aphasia when Wernicke's area is involved. The complex intertwining visual pathway runs through the brain from the eyes to the occipital lobe, so brain tumors can cause a variety of visual field disturbances, like bitemporal hemianopia, which is blindness in the outer half of both the right and left visual fields. This classically occurs with pituitary tumors that compress the optic chiasm. Also, infratentorial tumors, which can cause cranial nerve palsies, or cerebellar symptoms like ataxia. Because vestibular schwannomas arise from the 8th cranial nerve, they specifically cause sensory neural hearing loss and tinnitus. Craniopharyngiomas arise above the sella turcica, where the pituitary gland sits. If they get big enough, they can compress the pituitary gland, causing disturbances in growth and pubertal development in children. Germinomas of the pineal gland, or pinealomas, cause Perrineau syndrome, a unique syndrome that results from the tumor compressing the dorsal midbrain, which is below the pineal gland. The classic triad includes paralysis of upward gaze, pupillary light near dissociation, which means the pupils react to near objects but not to light, and thirdly, convergence retraction nystagmus, which is the oscillation of the eyes inwards, that is convergence, and backwards, that's retraction. However, this syndrome is not unique to pineal gland tumors and happens to occur in cases of obstructive hydrocephalus, multiple sclerosis, and strokes. Another focal neurologic finding is that brain tumors can cause focal seizures, and occasionally they can cause generalized seizures as well. It's the location of the tumor rather than the size that predicts the seizure symptoms. For example, a small meningioma located at the cortex is more likely to cause seizures than a large subcortical glioma. The location of the tumor also determines the pattern of focal seizure symptoms. For example, a frontal lobe tumor may cause focal tonic-clonic movements in one limb. On exam, there may be signs of cranial nerve defects as well as signs of increased ICP. Fundoscopic examination of the eyes may reveal papilledema or swelling of the optic disc. Also, Cushing's triad, which includes hypertension, bradycardia, and an irregular breathing pattern, also strongly suggests an increased ICP. If a brain tumor is suspected, the next step is a brain MRI with contrast, which is optimal for identifying soft tissue structures like tumors. Sometimes a CT can be helpful as well, because it can more easily identify calcifications, which are seen in oligodendrogliomas and craniopharyngiomas. Now, if an individual has sudden onset neurological deficits that are suggestive of intracranial hemorrhage, then a non-contrast CT scan may be done first. In the acute phase of intracranial hemorrhage, blood may obscure your view of the tumor on imaging. Therefore, a follow-up MRI is usually done about 7 to 10 days after the event, once the blood has been absorbed. Primary brain tumors that tend to bleed include gliomas and oligodendrogliomas. Metastatic tumors that are most susceptible to hemorrhage include melanoma, renal cell carcinoma, choriocarcinoma, and thyroid cancer, which can be remembered as MRCT. Normally, contrast is unable to penetrate the blood-brain barrier, so if there's contrast enhancement, that means that the tumor has broken down that barrier and leaked in. The MRI also shows the edema surrounding the tumor, or hemorrhage inside the tumor. Also, large tumors can cause a mass effect, which manifests as a midline shift to the opposite side. If the tumor obstructs the flow of cerebrospinal fluid, then hydrocephalus becomes apparent above the level of obstruction. Now, grade is a basic pathology term referring to the degree of tumor differentiation, or in other words, how closely does the tumor resemble normal tissue. The higher the grade, the less it resembles normal tissue, and the more aggressive the tumor is. Gliomas are classified into grades 1 and 2, which are low grade, and grades 3 and 4, which are high grade. A grade 4 glioma, also called glioblastoma multiforme, is unfortunately the most common form of glioma. Glioblastoma commonly shows a rim of enhancement along the margins of the tumor, also called a ring-enhancing lesion. The reason behind this appearance is that the center of the tumor does not enhance because it's mostly made up of necrotic cells, whereas the peripheral rim is made of live tumor cells. Cerebral metastasis and lymphoma can also give off this ring-enhancing appearance, so it's not unique to glioblastoma. Now, glioblastoma does tend to be really aggressive, and in fact may cross from one cerebral hemisphere to the other across a white matter bridge called the corpus callosum, giving the tumor the appearance of a butterfly. Okay, now on the other hand, low-grade gliomas may or may not enhance, and there's minimal or a complete lack of surrounding edema. A special type of glioma that commonly occurs in children is pilocytic astrocytoma. This tends to arise from the cerebellar hemisphere or along the optic nerve, and appear as a contrast-enhancing mass surrounded by a large cystic component. Medulloblastomas are also common in children, but in contrast to pilocytic astrocytomas, they arise in the cerebellar vermis rather than the cerebellar hemisphere. Because of their location, medulloblastomas have the potential to spread through the CSF, resulting in drop metastases, which is when the tumors originating in the posterior fossa spread down to the spinal cord. In children, ependymomas are most commonly located within the fourth ventricle, whereas in adults, they're usually found in the spinal canal. Similar to medulloblastomas, drop metastasis is a concerning prospect. In both ependymomas and medulloblastomas, a spinal MRI is indicated to rule out drop metastasis. Okay, now meningiomas are benign, homogeneously enhancing tumors that often have a characteristic attachment to the dura mater called the dural base or tail. The adjacent bone may become irritated and react by proliferating and thickening, which is called hyperostosis. Most meningiomas also tend to occur parasagittally, meaning they're located parallel to the plane that divides the body into right and left halves. Next are choroid plexus papillomas, which are rare, benign tumors that arise within the cerebral ventricles. Vestibular schwannomas, also called acoustic neuromas, arise from the eighth cranial nerve and therefore appear as homogeneously enhancing masses at the cerebellopontine angle on MRI. Additionally, to evaluate the degree of hearing loss, an auditory brainstem response test called an ABR test should be performed. This involves attaching a source of sound, such as a headphone, and then measuring the evoked action potential from the eighth cranial nerve by attaching electrodes to the scalp. Next are hemangioblastomas, which give the appearance of a bright, contrast-enhancing nodule surrounded by a black cystic component. Uniquely, hemangioblastomas secrete erythropoietin, causing polycythemia. Next are craniopharyngiomas, which are located above the sella turcica and appear as single or multiple calcified cysts. Because metastatic tumors follow cerebral blood flow, they appear as contrast-enhancing lesions along the gray-white matter junction. Now, before we go on to definitive diagnosis, some individuals require symptomatic therapy. Systemic glucocorticoids, like dexamethasone, relieve symptoms by decreasing cerebral edema, and are necessary to give to individuals with severe symptoms, evidence of cerebral edema on imaging, or impending cerebral herniation. Now, these benefits have to be weighed against the risk of steroids interfering with interpretation of a future biopsy. Also, individuals who had a seizure should be given an anti-seizure medication, such as levetiracetam. However, anti-seizure medications are not used prophylactically in individuals who did not have a seizure. Because brain tumors can obstruct the flow of cerebral spinal fluid and cause hydrocephalus, a CSF shunt is often placed. If left untreated, hydrocephalus may lead to a fatal cerebral herniation. CSF shunts are essentially really long catheters that allow CSF to drain from the cerebral ventricles to another part of the body. Ventriculoperitoneal, or VP shunts, are the most commonly used, but others include ventriculopleural or ventriculoatrial shunts. Some shunts have slit valves at the level of the cerebral ventricles that force unidirectional flow of CSF. Complications of shunt placement include obstruction and infection. Okay, to accurately make the diagnosis of a brain tumor, a tissue sample is needed for histopathological and molecular studies. This sample can be obtained by stereotactic biopsy or by surgical resection of the tumor. The choice depends on many factors, including the location, size, operability, and suspected type of tumor. In addition to the histopathological type and grade of the brain, an emphasis has been recently placed on identifying the unique molecular markers of different brain tumors, as they aid in treatment decision-making. Examples include isocitrate dehydrogenase, or IDH mutations in gliomas, or WNT activating mutations in medulloblastoma. The treatment of brain tumors is individualized to each affected person depending on many factors such as the age of the person, the type, grade, location, and size of the tumor, and the desires of the individual. In general, treatment may include a combination of surgery, radiation therapy, and chemotherapy. When it comes to chemotherapy, the blood-brain barrier hinders medications from getting to the tumors. Contrast enhancement on MRI means that the tumor has partially destroyed the blood-brain barrier, so it's a helpful clue that tells us if chemotherapy will be a useful treatment option. Because if the blood-brain barrier is disrupted, then we know the chemotherapeutic medication will have no problem getting to the tumor. Other ways around this barrier include using lipophilic chemotherapeutic agents that are able to cross the membranes of the blood-brain barrier, such as the nitrosoureas, carmustine, and lomustine. Another method is to introduce chemotherapy intrathecally, which means directly into the CSF, usually by doing a lumbar puncture. For some highly vascular tumors like meningiomas, preoperative embolization may help shrink the tumor by interrupting its blood supply, and this makes surgical resection easier. Alright, as a quick recap, brain tumors are classified into primary and metastatic tumors. The most common primary tumors in both adults and children are gliomas. Gliomas are followed by meningiomas in adults, and medulloblastomas and ependymomas in children. Metastatic brain tumors usually come from lung and breast cancer as well as melanoma. Brain tumors tend to be infratentorial in children and supratentorial in adults. Brain tumors present with headache, focal neurological deficit, seizures, or neurocognitive disturbance. On examination, increased intracranial pressure causes papilledema, as well as the Cushing's triad, which includes hypertension, bradycardia, and irregular breathing. MRI with contrast is the imaging test of choice, which helps determine the size, location, and contrast enhancement of the tumor. Gliomas are low-grade or high-grade. Glioblastoma multiforme appears as a ring-enhancing lesion that crosses the corpus callosum, whereas low-grade gliomas may or may not enhance. Meningiomas are usually located parasagittally and have a dural tail. Medulloblastomas arise from the cerebellar vermis, whereas ependymomas sprout out from the fourth ventricle in children and from the spinal canal in adults. Both tumors have the propensity to cause drop metastasis, and therefore a spinal MRI is often warranted. Vestibular schwannomas arise from the eighth cranial nerve, causing sensory neural hearing loss and tinnitus. Metastatic tumors follow cerebral blood flow, and therefore are commonly located at the gray-white matter junction. Symptomatic treatment with dexamethasone is crucial for individuals with severe symptoms, cerebral edema, or impending cerebral herniation. Anti-seizure medications should be given if the person had a seizure. In cases of obstructive hydrocephalus, a CSF shunt is placed to relieve the increased intracranial pressure. For definitive diagnosis, a tissue sample obtained by stereotactic biopsy or surgical resection is required. Treatment is highly individualized and may include a combination of surgery, radiation, and chemotherapy.
In the neurology ward, a 64-year-old female named Angela came in complaining of morning headaches along with nausea and vomiting for the past few weeks. Her husband says that her personality has changed over the last few weeks, and she seems more aggressive. Brain MRI revealed a mass in the frontal lobe. Tissue biopsy shows a pseudopalisading pattern with necrosis in the middle and viable cells lining up in the periphery. Now, next to Angela, there's Jerry, a 59-year-old male who's also been having morning headaches for the past few months. A brain MRI is ordered and reveals a mass on the brain surface, just under the dura mater. Tissue biopsy shows psammoma bodies. And finally, there's a 40-year-old male named Dan who complains of ringing in the ears and hearing loss on one side. A brain MRI is done and showed a mass on the cerebellopontine angle. Tissue biopsy shows a mass with biphasic appearance with alternating hypercellular and hypocellular regions. Tumor cells stain positively for S100. Okay, Angela, Jerry, and Dan all have a brain tumor. Brain tumors occur when there's uncontrolled growth of abnormal cells within the brain. They're broadly classified into primary tumors originating from cells within the nervous system and metastatic tumors originating from cells outside the nervous system. Now, brain tumors can occur in both children and adults. In this video, let's focus on adult brain tumors. In adults, metastatic tumors are much more common than primary tumors. In fact, they account for more than half of the cases. In order of decreasing frequency, they metastasize from the lung, breast, melanoma from the skin, kidneys, and colon. Now, the most common primary brain tumor in adults is glioblastoma multiforme, which is a type of astrocytoma. Meningiomas and pituitary adenomas are next on the list. Less common brain tumors include oligodendrogliomas, hemangioblastomas, and schwannomas. Immunocompromised people, like organ transplant recipients or individuals with AIDS, are at high risk of primary central nervous system lymphoma caused by the Epstein-Barr virus. Okay, Brain tumors can also be categorized based on their location as either supratentorial, or above the cerebellar tentorium, and infratentorial tumors, or below the tentorium, though some tumors can form in either. In children, most brain tumors are infratentorial, whereas in adults they are usually supratentorial. That's something you must know for the test. Glioblastomas multiforme, meningiomas, pituitary adenomas, and oligodendrogliomas are generally supratentorial, whereas hemangioblastomas and schwannomas are usually infratentorial. Metastatic tumors can arise in both regions. And finally, brain tumors can also be classified or graded based on their severity on the World Health Organization scale. The scale goes from 1 to 4 depending on the morphologic and functional features of the tumor cells. A grade 4 tumor being the most abnormal looking cells that also tend to be the most aggressive. But not all brain tumors have all 4 grades, because some tumors are typically more benign, whereas others are more aggressive. Alright, let's look at the causes of brain tumors in general. The main environmental risk factor for brain tumors is exposure to ionizing radiation, which can come from therapeutic radiotherapy for cancer, or diagnostic imaging like CT scans. Electromagnetic radiation from cell phones and microwaves is currently being researched as potential risk factors in humans. Another concept that's frequently tested on the exams is that meningiomas are particularly more common in women, possibly because the tumor cells possess estrogen and progesterone receptors. Now, a small proportion of brain tumors occur secondary to genetic syndromes. For example, neurofibromatosis type 1 is associated with optic nerve gliomas and schwannomas, whereas neurofibromatosis type 2 is associated with bilateral schwannomas. Both are associated with meningiomas, which can also arise in people with multiple endocrine neoplasia type 1. Tuberous sclerosis is associated with subependymal giant cell astrocytomas. The word subependymal literally means under the ependymal cells, which line the cerebral ventricles, so these tumors are more commonly found along the border of the lateral ventricles. Turcot syndrome is a rare polyposis syndrome that increases the risk of colonic polyps and colorectal cancer, but also increases the risk of brain tumors, specifically gliomas and medulloblastomas. They are slow-growing tumors and are typically grade 1. Hemangioblastomas are associated with von Hippel-Lindau syndrome, a genetic disorder that causes many different types of tumors, like clear cell renal carcinoma, pancreatic tumors, and adrenal tumors that cause pheochromocytoma. In the head, it causes hemangioblastomas in the brain and retina, but also endolymphatic sac tumors in the inner ear. Alright, now let's take a closer look at the different types of supratentorial adult brain tumors, since they make up the large majority in adults. The most common supratentorial adult tumors are glioblastomas multiforme, meningiomas, pituitary adenomas, and oligodendrogliomas. Let's start with glioblastoma multiforme, which is a type of astrocytoma. Because astrocytes are found throughout the brain and spinal cord, astrocytomas can form in all of these locations, but glioblastomas are more common in the cerebral hemispheres. And while astrocytomas can be graded 1 through 4, glioblastomas are only grade 4 because they are highly malignant tumors. Because of their quick growth and invasion of nearby tissues, glioblastomas tend to rapidly cross the corpus callosum, creating what's called a butterfly glioblastoma. Cancer cells typically recruit blood vessels to provide them with nourishment in a process called angiogenesis. But glioblastomas proliferate so fast that even with angiogenesis, their nutrient demand outpaces the blood supply. As a result, because the blood supply serves the peripheral tumor cells first, the tumor cells at the center of the tumor die off, creating necrotic regions, with viable cells around the edges. Another common supratentorial tumor is a meningioma. Meningiomas come from cells found in the arachnoid matter of the meninges, called arachnoid cap cells, and they often attach to the dura mater. Since these tumors are not within the brain parenchyma, They're also called extraaxial tumors. They typically form in the parasagittal regions of the brain, but they can also arise on the spinal cord. They are graded 1 through 3 and tend to be relatively slow growing. Next up is the pituitary adenoma, which is formed in the pituitary gland by hormone-secreting cells of the anterior pituitary. There are several cell types in the anterior pituitary that each secrete a tightly regulated level of a particular hormone. For example, lactotroph cells secrete the hormone prolactin. Pituitary adenomas are typically benign, so they're classified by the hormone that's released as a tumor forms, and by the size of the tumor, rather than using the standard WHO classifications. Now, a relatively rare supratentorial tumor is an oligodendroglioma. Because oligodendrocytes are found throughout the brain and spinal cord, oligodendrogliomas can form in any of these locations. But adult oligodendrogliomas typically form in the frontal lobes of the cerebral cortex, because those neurons are the most heavily myelinated. These tumors are categorized as grade 2 or 3 with an overall tendency to be relatively slow-growing tumors, though they still have the ability to become malignant. Okay, so now let's focus on infratentorial adult tumors, such as hemangioblastomas. Hemangioblastomas are tumors that derive from cells with blood vessel origins. So, while they can develop anywhere, in the brain they're most often found in the cerebellum, especially in a middle-aged person. They're slow-growing tumors and are typically grade 1. Hemangioblastomas are associated with von Hippel-Lindau syndrome, a genetic disorder that causes many different types of tumors, like clear cell renal carcinoma, pancreatic tumors, and adrenal tumors that cause pheochromocytoma. In the head, it causes hemangioblastomas in the brain and retina, but also endolymphatic sac tumors in the inner ear. Finally, schwannomas are found outside the brain. They arise from Schwann cells, which are a subtype of glial cells that surround and support the peripheral nervous system neurons. They arise in the nerves of the trunk, arms, or legs. They're usually slow-growing and benign, meaning that the cells don't invade surrounding tissue structures. Now, a small number of schwannomas are related to a disease called neurofibromatosis type 2. In neurofibromatosis type 2, there's a deletion on chromosome 22. This mutation inactivates myelin, allowing Schwann cells to divide uncontrollably. As a consequence, several schwannomas develop in multiple locations. For your exams, a high-yield fact is that it causes schwannomas on both vestibulocochlear nerves, at the cerebellopontine angle, and are known as vestibular schwannomas, or acoustic neuromas. Okay, now moving on to symptoms. Individuals with brain tumors typically have some combination of 4 symptoms: headache, focal neurological deficits, a neurocognitive disturbance that often causes a decline in work performance, and psychiatric symptoms, including depression. The headache is usually dull, slowly progressive, and involves the whole head. Often, it's worse in the morning and can be accompanied by nausea and vomiting. As for focal neurological deficits, the pattern depends on the location of the tumor. For example, the involvement of the primary motor cortex would cause weakness, whereas involvement of the primary sensory cortex would cause sensory symptoms, like astereognosis, which is the inability to identify objects by touching them. Involvement of the frontal lobe can cause personality changes, while the involvement of the language areas can cause different types of aphasia, such as expressive aphasia when the Broca's area is involved, or receptive aphasia when Wernicke's area is involved. For the tests, also remember that vestibular schwannomas cause bilateral hearing loss, tinnitus, and problems with balance. Now, if the visual pathway is affected, it can lead to a variety of visual field disturbances, like bitemporal hemianopsia, which is blindness in the outer half of both the right and left visual fields. This classically occurs with pituitary tumors that compress the optic chiasm. In addition, tumors can compress cranial nerves, causing cranial nerve palsies, or compress the cerebellum, causing cerebellar symptoms like ataxia and gait instability. Another focal neurologic finding is that brain tumors can cause focal seizures, and occasionally they can cause generalized seizures as well. Now, it's also important to consider the cell type that's involved. For example, a pituitary adenoma causing an increase in prolactin secretions may lead to amenorrhea in women and infertility in men. Hemangioblastomas, on the other hand, can secrete erythropoietin, which leads to polycythemia. In addition, as a tumor grows in size, it can compress nearby cells and structures, interrupting their normal functions. For example, as meningiomas enlarge, the mass of the tumor can compress nearby ventricles, blocking the flow of cerebrospinal fluid, causing swelling which results in obstructive hydrocephalus and an increase in intracranial pressure, or ICP. Findings that strongly suggest an increased ICP are papilledema, or swelling of the optic disc on fundoscopy, as well as Cushing's triad. Remember on your exams that this is hypertension, bradycardia, and an irregular breathing pattern. Alright, for diagnosis. If a brain tumor is suspected, the next step is a brain MRI with contrast, which is optimal for identifying soft tissue structures like tumors. Sometimes a CT can be helpful as well, because it can more easily identify calcifications, which are seen in some types of brain tumors like oligodendrogliomas. For imaging, remember that tumors arising in different regions of the brain are more likely to be due to metastasis. Both glioblastomas and metastatic tumors can show ring-enhancing lesions, where areas of low density appear dark and they're surrounded by a ring of high-density tissue, which appears bright white. Don't confuse these with brain abscesses and multiple sclerosis, which also have ring enhancements. Okay, to accurately make the diagnosis of a brain tumor, a tissue sample is needed for histopathological and molecular studies. This sample can be obtained by stereotactic biopsy or by surgical resection of the tumor. The next clue for diagnosis can be the unique molecular markers associated with certain types of brain tumors. Examples include isocitrate dehydrogenase, or IDH mutations in gliomas, or WNT activating mutations in medulloblastomas. Stains are also helpful. Remember that astrocytomas and oligodendrogliomas derive from glial cells, so they stain positively for glial fibrillary acidic protein, or GFAP. Metastatic tumors will have markers or stains for the primary tumor. For example, melanoma will be positive on S100 antibody stain, but keep in mind that this is also positive in schwannomas. Now, it's also important to remember some histologic findings, since they might be the best clues for identifying each specific tumor type. Let's start with glioblastoma multiforme. Histologically, it appears like the cells of the tumor are lining up like fence posts against necrosis in the middle, producing a characteristic pseudopalisading pattern. Next up, meningiomas form nests of cells, or a multinuclear mass of fused cells, which have an appearance like a wave in the ocean. Another high-yield fact is that these tumors may also cause the formation of calcifications, called psammoma bodies. Psammoma bodies are round, eosinophilic structures that can also be seen in papillary thyroid carcinoma and serous papillary ovarian adenocarcinoma. Now, in pituitary adenomas, the particular hormone secreting cell that's causing the pituitary adenoma will increase in number. As for oligodendrogliomas, remember that the prominent features can vary. Grade 2 tumors have fairly small round nuclei, surrounded by well-defined halos, or thick white cytoplasm, giving them a fried egg appearance. In grade 3 tumors, they have a chicken wire pattern of blood vessels with areas of calcifications. Alright, now hemangioblastomas are composed of thin-walled capillaries that are arranged close to one another. And finally, another high-yield fact that you have to know is that schwannomas have a biphasic appearance, meaning they have alternating regions with different cell patterns, called Antony A and Antony B. Areas with an Antony A pattern are hypercellular, meaning that they have lots of tightly packed Schwann cells with elongated or spindle-shaped nuclei and little surrounding cytoplasm. They can also have Verroquet bodies, which are fibrous cell processes between two rows of palisading or lined-up Schwann cells. Now, areas with an Antony B pattern are hypocellular, with fewer, more loosely packed Schwann cells that appear scattered. Okay, as a quick recap. In adults, brain tumors are usually metastatic tumors originating from cancers of the lung, breast, and melanoma. Primary brain tumors are usually supratentorial and include glioblastoma multiforme, meningiomas, pituitary adenomas, and oligodendrogliomas. Other less common infratentorial tumors include hemangioblastomas and schwannomas. Diagnosis can be made with imaging tests like brain CT and MRI scans, as well as tissue biopsy. Now, back to the patients. Let's start with Angela. Tissue biopsy showed a pseudopalisading pattern, which is typical for glioblastoma multiforme. Jerry's brain MRI revealed a mass just under the dura mater, and tissue biopsy showed psammoma bodies. These are consistent with the diagnosis of meningioma. Finally, Dan presented with hearing loss and tinnitus, which are symptoms indicative of acoustic neuroma. MRI and tissue biopsy confirm the diagnosis.
Adult brain tumors are masses of abnormal cells that generally occur in adults and result from the uncontrolled growth of those cells within the brain. Okay, let's start with some basic brain anatomy. First off, there's the cerebral cortex, which is the part of the brain that's supratentorial or above the tentorium, and the cerebellum, which is infratentorial or below the tentorium. And the brain has four interconnected cavities called ventricles, which are filled with cerebrospinal fluid, a fluid that helps provide buoyancy and protection, as well as metabolic fuel for the brain. Highest up are two C-shaped lateral ventricles that lie deep in each cerebral hemisphere. The two lateral ventricles drain their cerebrospinal fluid into the third ventricle, which is a narrow funnel-shaped cavity at the center of the brain. The third ventricle makes a bit more cerebrospinal fluid and then sends all of it to the fourth ventricle via the cerebral aqueduct. The fourth ventricle is a tent-shaped cavity located between the brainstem and the cerebellum. After the fourth ventricle, the cerebrospinal fluid enters the subarachnoid space, which is the space between the arachnoid and pia mater, two of the inner linings of the meninges which cover and protect both the brain and the spine. So this makes it possible for cerebrospinal fluid to also flow through the central canal of the spine. Now, focusing in on cells within the brain, there are many different types with specialized functions. For example, neurons communicate neurologic information through neurotransmitter-regulated electrical impulses. Then there are cells that secrete hormones into circulation and regulate the functions of other cells throughout the body. These cells are found in glands, like the supratentorial pineal gland, which is located just behind the third ventricle, or the infratentorial pituitary gland located near the front of the third ventricle. There's also a category of cells called neuroglial cells that help support brain homeostasis and neuronal functions. These include astrocytes, which have cellular processes coming off their cell body, giving them a star-shaped appearance. Astrocytes are found throughout the brain and the spinal cord, and their main roles include maintaining the blood-brain barrier, providing nourishment to neurons, and recycling neurotransmitters. Another type of glial cell is the oligodendrocyte, which has a few cellular processes that look like branches. They're mostly found in the brain, though they are in the spinal cord too. These branches wrap themselves around neurons and produce a fatty substance made of lipoproteins called myelin, which helps transmit electrical impulses along the axons. Some brain cells have a limited ability to be replaced, especially during injury, and they do it by having undifferentiated stem cells, called embryonic stem cells, in the brain activate and mature into specialized cells. Now, a tumor develops if there's a DNA mutation in any of these cell types that leads to uncontrolled cell division. Typically, these are mutations in proto-oncogenes, which results in a promotion of cell division, or mutations in tumor suppressor genes, which results in a loss of inhibition of cell division. You can think of proto-oncogenes as the accelerator or gas pedal, and tumor suppressor genes as the brakes. Too much acceleration, or an inability to brake, can lead to a runaway cell division. As a result, the mutated cells can start piling up on each other and can become a tumor mass. Some of these tumors are benign and stay well contained or localized, but some become malignant tumors or cancers, and these are the ones that break through their basement membrane and invade nearby tissues. Malignant tumor cells can get into nearby blood or lymph vessels and travel from the primary site to establish a secondary site of tumor growth somewhere else in the body, and that's called metastasis. Brain tumors can be categorized by their primary site location as either supratentorial or infratentorial tumors, though some tumors can form in either. They're typically named by the cell type involved. So, for example, an astrocytoma is a tumor formed by mutated astrocytes. But their severity is classified or graded by the World Health Organization's scale. The scale goes from 1 to 4 based on the morphologic and functional features of the tumor cells. A grade 4 tumor being the most abnormal looking cells that also tend to be the most aggressive. But not all tumors have all 4 grades, because some tumors are basically always more benign, whereas others are just more aggressive. So let's start with tumor types that are generally supratentorial, because those make up the majority of adult brain tumors. A common one is a type of astrocytoma called a glioblastoma. Because astrocytes are found through the brain and the spinal cord, astrocytomas can form in all of these locations, but glioblastomas are mostly in the cerebral hemispheres. And while astrocytomas can be graded 1 through 4, glioblastomas are only grade 4 because they're highly malignant. Because of their quick growth and invasion of nearby tissues, glioblastomas tend to rapidly cross the corpus callosum. The corpus callosum is the midline structure that separates the two cerebral hemispheres. It looks like a characteristic butterfly on a cross-section of the brain. Cancer cells typically recruit blood vessels to provide them nourishment in a process called angiogenesis. But glioblastomas proliferate so fast that even with angiogenesis, their nutrient demand outpaces the blood supply. As a result, because the blood supply serves the peripheral tumor cells first, the tumor cells at the center of the tumor die first because they're the furthest from the blood cell network. Meanwhile, the remaining viable tumor cells collect along the edges of the necrotic regions. Histologically, it appears like the viable cells are lining up like fence posts against the necrosis in the middle, producing a characteristic pseudo-palisading pattern. Another common supratentorial tumor is a meningioma. Meningiomas come from cells found in the arachnoid mater of the meninges called arachnoid cap cells. They typically form in parasagittal regions and on the surface of the brain, just under the outermost layer of the meninges, the dura mater. They're graded 1 through 3 and tend to be relatively slow-growing. Histologically, they form nests of cells, or a multinuclear syncytium of fused cells, which have an appearance like a wave in the ocean. These tumors may also cause the formation of calcifications called psammoma bodies. Another common supratentorial tumor in adults is the pituitary adenoma, which is formed in the pituitary gland by hormone-secreting cells of the anterior pituitary. There are several cell types in the anterior pituitary that each secrete a tightly regulated level of a particular hormone. For example, lactotroph cells secrete the hormone prolactin. Pituitary adenomas are typically benign, so they're classified by the hormone that's released as the tumor forms, and by the size of the tumor, rather than using the standard WHO classifications. Histologically, the particular hormone-secreting cell that's causing the pituitary adenoma will increase in number. Now, a relatively rare supratentorial tumor is an oligodendroglioma. Because oligodendrocytes are found through the brain and the spinal cord, oligodendrogliomas can form in any of these locations, but adult oligodendrogliomas typically form in the frontal lobes of the cerebral cortex because those neurons are the most heavily myelinated. These tumors are categorized as grade 2 or 3, with an overall tendency to be relatively slow-growing tumors, though they still have the ability to become malignant. Histologically, prominent features can vary from fairly small round nuclei surrounded by well-defined halos or thick white borders of cytoplasm, giving them a fried egg appearance in grade 2 tumors, to having a chicken-wired pattern of nearby blood vessels with areas of calcification in grade 3 tumors. Okay, so now let's focus on one of the infratentorial adult tumors, a hemangioblastoma. These tumors derive from cells with blood vessel origins, so while they can develop anywhere in the brain, they're most often found in the cerebellum, especially in a middle-aged person. They're slow-growing tumors and are typically grade 1. Histologically, there are often thin-walled capillaries that are arranged close to one another. Now, the most common symptoms of brain tumors include headaches, nausea, vomiting, and seizures, and they're a result of the compression and destruction of healthy brain tissue. In addition, it's important to consider the cell type that's involved. So, for example, a pituitary adenoma causing an increase in prolactin secretions may lead to amenorrhea in women and infertility in men. As the tumor grows in size, it can compress nearby cells and structures, interrupting their normal functions. For example, as pinealomas, medulloblastomas, and ependymomas enlarge, the mass of the tumor can compress nearby ventricles, blocking the flow of cerebral spinal fluid, which causes swelling, called hydrocephalus. Generally, the diagnosis of central nervous system tumors includes medical imaging, like CT scans, but more commonly MRIs. But definitive diagnosis needs to be made based on the histologic and molecular characteristics of a tissue biopsy. Treatments depend on the tumor type, grade, and symptoms, but can include surgical removal, radiotherapy, or chemotherapy, frequently in a combination. But specific courses of treatment are guided by the molecular characteristics of the tumor based on the biopsy. Finally, the chance of recurrence gets higher in high-grade tumors and in tumors that have not been fully removed or destroyed. Okay, quick recap. Adult brain tumors can be infratentorial and supratentorial and form from a variety of cells. Tumor types are classified using WHO grading based on morphologic and functional features. Tumor symptoms depend on tumor cell type, size, and location. Diagnosis includes medical imaging, with a definitive diagnosis being made with a tissue biopsy. Treatments are largely dependent on the molecular characteristics and tumor grade, and can incorporate surgical removal or a combination of radiotherapy and chemotherapy.
In the neurology ward, 2 children came in with the same symptoms: morning headaches, nausea, vomiting, and frequent falls. One of them is a 12-year-old named Greg, and the other is a 14-year-old individual named Suzanne. Greg's symptoms started a few months ago and retained the same level of severity, while Suzanne's symptoms started a few weeks ago and are rapidly worsening. A brain MRI with contrast is ordered for both of them, which showed a well-circumscribed cystic lesion in the cerebellum for Greg and a solid heterogeneous mass in the cerebellum that compresses the fourth ventricle in Suzanne. Okay, so both Greg and Suzanne have pediatric brain tumors. Brain tumors occur when there's uncontrolled growth of abnormal cells within the brain. They're broadly classified into primary tumors, originating from cells within the nervous system, and metastatic tumors, originating from cells outside the nervous system. Primary brain tumors are the most common solid tumors in children and can either be benign or malignant. Now, for the exams, it's important to remember that the most common primary brain tumors in both adults and children are gliomas, and more specifically, a subset of these called astrocytomas. In children, medulloblastomas and ependymomas are next on the list, while in adults, gliomas are followed by meningiomas. Less common brain tumors include craniopharyngiomas, pinealomas, pituitary adenomas, oligodendroliomas, hemangioblastomas, and schwannomas. Now, metastatic tumors are much more common in adults and are always malignant. In order of decreasing frequency, they most commonly come from cancers of the lung, breast, skin melanomas, kidneys, and colon. Okay, brain tumors can also be categorized based upon their location as either supratentorial or above the cerebellar tentorium, and infratentorial tumors, or below the tentorium, though some tumors can form in either. In children, a very high-yield concept is that most brain tumors are infratentorial, whereas in adults, they're usually supratentorial, and that's something you have to remember for the test. Finally, brain tumors can also be classified or graded based upon their severity by the World Health Organization scale. The scale goes from 1 to 4, depending on the morphologic and functional features of the tumor cells. A grade 4 tumor being the most abnormal looking cells that also tend to be the most aggressive. But not all brain tumors have all 4 grades, because some tumors are basically always more benign, whereas others are more aggressive. Alright, in this video, let's focus on pediatric brain tumors, starting with tumor types that are generally infratentorial, since they make up the majority of tumors in children. The most common infratentorial pediatric tumors are pilocytic astrocytoma, medulloblastoma, and ependymoma. Let's start with pilocytic astrocytoma, which is the most common primary pediatric tumor. It's a subtype of astrocytomas, which are tumors derived from astrocytes. Astrocytes are glial cells, or non-neuron support cells that protect and support the neurons. Astrocytes have processes coming off their cell body, giving them a star-shaped appearance. Pilocytic astrocytomas can form anywhere in the brain and spinal cord, but they're mostly infratentorial tumors in the cerebellum or near the brainstem, and this will be a big hint on your exams. But keep in mind they can also appear less frequently in the hypothalamic region or optic pathways. And while astrocytomas can be graded 1 through 4, pilocytic astrocytomas are only grade 1 because they're generally benign and slow-growing. Keep in mind that in adults, astrocytes can give rise to glioblastomas, which are usually supratentorial and high-grade. Okay, moving on to medulloblastoma, which is the second most common pediatric tumor. However, medulloblastoma is the most common malignant pediatric tumor, since pilocytic astrocytoma is usually benign. Medulloblastomas originate from embryonic stem cells and primitive neuroendocrine cells. Remember that medulloblastomas also form in or around the cerebellum, just like astrocytomas. A very problematic location that's high yield is the region adjacent to the fourth ventricle, which is a tent-shaped cavity located between the brainstem and the cerebellum. These tumors tend to be extremely aggressive, and one relatively unique feature is that they metastasize through the cerebrospinal fluid, in a process called drop metastasis, where the tumor spreads to the base of the spine. Because of this, medulloblastomas are typically only classified as grade 4. Finally, the most common infratentorial tumor is ependymoma. Ependymal cells are also neuroglial cells, and they're cuboidal to columnar, or square to rectangular shaped. They're ciliated cells that line the ventricles and central canal. One of their main roles is to regulate the circulation of cerebrospinal fluid. Ependymomas can form in the brain and spinal cord because that's where ependymal cells are found, but pediatric ependymomas tend to form in the fourth ventricle, and that's also something you have to remember for the exams. Now, there are a few types of ependymomas, and they're WHO graded 1 through 3. In grade 2, classic ependymomas, tumor cells have a regular round to oval nucleus. Now let's switch gears and talk about supratentorial pediatric tumors, which include craniopharyngiomas and pinealomas. The most common is craniopharyngioma, which forms near the pituitary gland. During fetal development, neuroectoderm from the brain evaginates downward to form the posterior pituitary, while oral ectoderm grows upward, forming Rathke's pouch. This will pinch off from the oral mucosa and fuse with the tissue above, and they will differentiate into the cells that will make up the anterior pituitary. Now, remnants of Rathke's pouch that remain undifferentiated can give rise to craniopharyngiomas, and this usually occurs above or around the pituitary. They're typically only classified as WHO grade 1 tumors because they're typically benign and slow growing. Finally, a rare supratentorial pediatric tumor is a penioloma, which forms in the region of the pineal gland. Peniolomas can arise from the pineocytes or from germ cells. They can be grade 1 through 4. Okay, now moving on to symptoms. Individuals with brain tumors typically have some combination of 4 symptoms: headache, focal neurological deficits, a neurocognitive disturbance that often causes a decline in school or work performance, and psychiatric symptoms, including depression. The headache is usually dull, slowly progressive, and involves the whole head. It's high yield to remember that, often, it's worse in the morning and can be accompanied by nausea and vomiting. As for focal neurological deficits, the pattern depends on the location of the tumor. For example, the involvement of the primary motor cortex would cause weakness, whereas involvement of the primary sensory cortex would cause sensory symptoms, like astereognosis, which is the inability to identify objects by touching them. Involvement of the language areas can cause different types of aphasia, such as expressive aphasia when Broca's area is involved, or receptive aphasia when Wernicke's area is involved. Now, if the visual pathway is affected, it can lead to a variety of visual field disturbances, like bitemporal hemianopsia, which is blindness in the outer half of both the right and left visual fields. This can occur with craniopharyngiomas that compress the optic chiasm. In addition, infratentorial tumors can compress cranial nerves, causing cranial nerve palsies, or compress the cerebellum, causing cerebellar symptoms like ataxia and gait instability. Another focal neurologic finding is that brain tumors can cause focal seizures, and occasionally, they can cause generalized seizures as well. Okay, now infratentorial tumors like medulloblastomas and ependymomas and supratentorial tumors like peniolomas can compress nearby ventricles and obstruct CSF flow. This can cause obstructive hydrocephalus. Because the skull sutures are still unfused in infants, this can lead to an enlarged head or macrocephaly. This is actually relatively fortunate because it means the head can accommodate this mass without causing a rapid increase in intracranial pressure and deterioration of the child's neurological status. On exam, there can be signs of cranial nerve defects as well as signs of increased ICP. For example, fundoscopic examination of the eyes can reveal papilledema or swelling of the optic disc. Also, Cushing's triad, which includes hypertension, bradycardia, and an irregular breathing pattern, also strongly suggest an increased ICP. Alright, now there are some clues that can help you distinguish the different tumor types. Infratentorial tumors, including pilocytic astrocytomas, medulloblastomas, and ependymomas, typically present with headache, accompanied by nausea and vomiting, cerebellar symptoms like ataxia and gait instability, and visual disturbances. As for supratentorial tumors, craniopharyngiomas, which arise above the sella turcica where the pituitary gland sits, can compress the pituitary gland, causing disturbances in growth and pubertal development in children. Finally, peniolomas cause Peyronie's syndrome, a unique syndrome that results from the tumor compressing the dorsal midbrain, which is below the pineal gland. The classic triad includes paralysis of upward gaze, pupillary light near dissociation, which means the pupils react to near objects but not to light, and thirdly, convergence retraction nystagmus, which is oscillation of the eyes inwards or convergence and backwards or retraction. However, This syndrome is not unique to pineal gland tumors and happens to occur in cases of obstructive hydrocephalus, multiple sclerosis, and strokes. What is relatively unique to pinealomas is that they can secrete HCG, which can lead to precocious puberty in males. Alright, let's look at diagnosis. If a brain tumor is suspected, the next step is a brain MRI with contrast, which is optimal for identifying soft tissue structures like tumors. Sometimes a CT can be helpful as well, because it can more easily identify calcifications, which are seen in some types of brain tumors, like craniopharyngiomas. Another helpful tip is that pilocytic astrocytomas and craniopharyngiomas can appear cystic, while medulloblastomas and ependymomas are solid tumors. Okay, but to accurately make the diagnosis of a brain tumor, a tissue sample is needed for histopathological and molecular studies. This sample can be obtained by stereotactic biopsy or by surgical resection of the tumor. In addition to the histopathological type and grade, an emphasis has been recently placed on identifying the unique molecular markers of different brain tumors, as they aid in treatment decision-making. Examples include isocitrate dehydrogenase, or IDH mutations in gliomas, or WNT activating mutations in medulloblastoma. Now, it's also important to remember some histologic findings, since they might be the best clues for identifying each specific tumor type. Pilocytic astrocytomas are typically well-differentiated neoplasms which can have cysts and bodies of granular material. They also have Rosenthal fibers, which are fibers that clump together in the cytoplasm of the astrocyte and look a bit like a worm or a corkscrew. Among the fibers is the structural protein gliofibrillary acidic protein that's typically found in astrocytes. Next, medulloblastomas can have small, round, blue cells since they're neuroendocrine in origin. A high mitotic index is also common. Medulloblastomas also have a histologic feature called Homer-Wright rosettes, which are dense tangles of neurons and neuroglial cells, surrounded by ring-like structures formed by tumor cells. Keep in mind that this can also appear in pinealomas as well as other brain tumors. As for ependymomas, a prominent histological feature are their perivascular pseudo-rosettes, which are ring-like structures formed by tumor cells with rod-shaped ependymal processes like cilia surrounding a centralized blood vessel. Moving on to craniopharyngiomas. These are pretty complex tumors, with lots of prominent features including multiple cysts filled with thick motor oil-looking fluid and cholesterol crystals. Tumor cells also stratify or arrange themselves in layers. The innermost layer tends to have loosely packed cells that retain their nuclei, despite being filled with keratin, a strong protein, creating what's called a wet keratin appearance. Finally, prominent features of pinealomas include large, round tumor cells resembling germline tumors. Alright, as a quick recap, pediatric brain tumors are usually primary tumors that originate from cells within the central nervous system, and they're located below the tentorium or infratentorial. Pilocytic astrocytoma is the most common pediatric tumor, and it's typically benign, while medulloblastoma is the most common malignant pediatric tumor. Another common infratentorial tumor is ependymoma. Supratentorial brain tumors include craniopharyngiomas and pinealomas. Diagnosis can be made with imaging tests like brain CT and MRI scans, as well as tissue biopsy. Now, back to the patients. Due to their symptoms and the brain MRI results, both Greg and Suzanne have a brain tumor. Due to their age, they most probably have a primary brain tumor. Both tumors are infratentorial, and so they most likely have either pilocytic astrocytoma, medulloblastoma, or ependymoma. Greg's cystic lesion in the cerebellum is more typical of pilocytic astrocytoma, while Suzanne's lesion, which is a heterogeneous mass adjacent to the fourth ventricle, can be either medulloblastoma or ependymoma. To accurately make the diagnosis, tissue biopsy must be done.
Pediatric brain tumors are masses of abnormal cells that generally occur in children and result from the uncontrolled growth of those cells within the brain. Okay, let's start with some basic brain anatomy. First off, there's the cerebral cortex, which is the part of the brain that's supratentorial or above the tentorium, and the cerebellum, which is infratentorial or below the tentorium. And the brain has four interconnected cavities called ventricles, which are filled with cerebrospinal fluid, a fluid that helps provide buoyancy and protection, as well as metabolic fuel for the brain. Highest up are two C-shaped lateral ventricles that lie deep in each cerebral hemisphere. The two lateral ventricles drain their cerebrospinal fluid into the third ventricle, which is a narrow funnel-shaped cavity at the center of the brain. The third ventricle makes a bit more cerebrospinal fluid and then sends all of it to the fourth ventricle via the cerebral aqueduct. The fourth ventricle is a tent-shaped cavity located between the brainstem and the cerebellum. After the fourth ventricle, the cerebrospinal fluid enters the subarachnoid space, which is the space between the arachnoid and pia mater, two of the inner linings of the meninges which cover and protect both the brain and the spine. So this makes it possible for cerebrospinal fluid to also flow through the central canal of the spine. Now, focusing in on cells within the brain, there are many different types with specialized functions. For example, neurons communicate neurologic information through neurotransmitter-regulated electrical impulses. Then there are cells that secrete hormones into circulation and regulate the functions of other cells throughout the body. These cells are found in glands, like the supratentorial pineal gland, which is located just behind the third ventricle, or the infratentorial pituitary gland located near the front of the third ventricle. There's also a category of cells called neuroglial cells that help support brain homeostasis and neuronal functions. These include astrocytes, which have cellular processes coming off their cell body, giving them a star-shaped appearance. Astrocytes are found throughout the brain and the spinal cord, and their main roles include maintaining the blood-brain barrier, providing nourishment to neurons, and recycling neurotransmitters. Ependymal cells are also neuroglial cells, and they're cuboidal to columnar, so square to rectangular shaped, ciliated cells that line the ventricles and central canal. One of their main roles is to regulate the circulation of cerebrospinal fluid. Some brain cells have a limited ability to be replaced, especially during injury, and they do it by having undifferentiated stem cells, called embryonic stem cells, in the brain activate and mature into specialized cells. Now, a tumor develops if there's a DNA mutation in any of these cell types that leads to uncontrolled cell division. Typically, these are mutations in proto-oncogenes, which results in a promotion of cell division, or mutations in tumor suppressor genes, which results in a loss of inhibition of cell division. You can think of proto-oncogenes as the accelerator or gas pedal, and tumor suppressor genes as the brakes. Too much acceleration, or an inability to brake, can lead to a runaway cell division. As a result, the mutated cells can start piling up on each other and can become a tumor mass. Some of these tumors are benign and stay well contained or localized, but some become malignant tumors or cancers, and these are the ones that break through their basement membrane and invade nearby tissues. Malignant tumor cells can get into nearby blood or lymph vessels and travel from the primary site to establish a secondary site of tumor growth somewhere else in the body, and that's called metastasis. Brain tumors can be categorized by their primary site location, as either supratentorial or infratentorial tumors, though some tumors can form in either. They're typically named by the cell type involved. So, for example, an astrocytoma is a tumor formed by mutated astrocytes. But their severity is classified or graded by the World Health Organization scale. The scale goes from 1 to 4 based on the morphologic and functional features of the tumor cells. a grade 4 tumor being the most abnormal looking cells that also tend to be the most aggressive. But not all tumors have all 4 grades, because some tumors are basically always more benign, whereas others are just more aggressive. So let's start with tumor types that are generally infratentorial tumors, because they make up the majority of pediatric brain tumors. Overall, the most common malignant tumor is a medulloblastoma, which typically forms in or around the cerebellum adjacent to the fourth ventricle. Medulloblastomas originate from embryonic stem cells, and they tend to be extremely aggressive. One relatively unique feature is that they metastasize through the cerebrospinal fluid in a process called drop metastasis, where the tumor spreads to the base of the spine. Because of this, medulloblastomas are typically only classified as grade 4. Histologically, medulloblastomas often have a feature called Homer-Wright rosettes, which are dense tangles of neurons and neuroglial cells surrounded by ring-like structures formed by tumor cells. While medulloblastoma may be the most common malignant tumor, the most common primary pediatric tumor is a type of astrocytoma called a juvenile pilocytic astrocytoma. Because astrocytes are found throughout the brain and spinal cord, astrocytomas can form throughout these locations. But juvenile pilocytic astrocytomas are mostly infratentorial tumors in the cerebellum or near the brainstem. And while astrocytomas can be graded 1 through 4, juvenile pilocytic astrocytomas are only grade 1 because they're generally benign and slow growing. Histologically, they can have cysts or sacs filled with fluid, bodies of granular material, and Rosenthal fibers, which are fibers that clump together in the cytoplasm of the astrocytes and look a little bit like a worm or a corkscrew. Among the fibers is the structural protein glial fibrillary acidic protein that is typically found in astrocytes. Finally, another common infratentorial tumor is an ependymoma. Now again, they can form in the brain and spinal cord because that's where ependymal cells are found. But pediatric ependymomas tend to form in the fourth ventricle. Now, there are a few types of ependymomas, and they're WHO graded 1 through 3. In grade 2, classic ependymomas, tumor cells have a regular round to oval nucleus. Histologically, a prominent feature are their perivascular pseudorosettes, which are ring-like structures formed by tumor cells with rod-shaped ependymal processes, like cilia, surrounding a centralized blood vessel. Okay, so now let's focus on supratentorial pediatric tumors. The most common is a craniopharyngioma, which forms near the pituitary gland. During development, some cells migrate down from the brain and form the posterior pituitary, while some cells migrate up from the back of the throat, called the oropharynx, first forming the Rathke's pouch, and then eventually forming the anterior pituitary gland. Now, remnants of Rathke's pouch that don't mature can form craniopharyngiomas. They're typically only classified as WHO grade 1 tumors because they're typically benign and slow growing. Histologically, it's a pretty complex tumor with lots of prominent features, including multiple cysts filled with a thick, motor oil-like fluid, and cells that stratify or arrange themselves in layers. The innermost layer tends to have loosely packed cells that retain their nuclei despite being filled with keratin, a strong protein, creating what's called a wet keratin appearance. A rare supratentorial pediatric tumor is a pinealoma, which forms in the region of the pineal gland. Pinealomas primarily emerge from the endocrine cells of the pineal gland, and they can be grade 1 through 4. Histologically, prominent features include large round tumor cells resembling germline tumors, or small cells forming Homer-Wright rosettes. Now, the most common symptoms of brain tumors include headaches, nausea, vomiting, and seizures, and they're a result of the compression and destruction of healthy brain tissue. In addition, it's important to consider the cell type that's involved. So, for example, a pinealoma may lead to increased secretion of the hormone beta-human chorionic gonadotropin that can cause an early onset of puberty. In addition, as the tumor grows in size, it can compress nearby cells and structures, interrupting their normal functions. For example, as pinealomas, medulloblastomas, and ependymomas enlarge, the mass of the tumor can compress nearby ventricles, blocking the flow of cerebral spinal fluid, which causes swelling, called hydrocephalus. Generally, the diagnosis of central nervous system tumors includes medical imaging, like CT scans, but more commonly MRIs. But definitive diagnosis needs to be made based on the histologic and molecular characteristics of a tissue biopsy. Treatments depend on the tumor type, grade, and symptoms, but can include surgical removal, radiotherapy, or chemotherapy, frequently in a combination. But specific courses of treatment are guided by the molecular characteristics of the tumor based on the biopsy. Finally, the chance of recurrence gets higher in high-grade tumors and in tumors that have not been fully removed or destroyed. Okay, quick recap. Pediatric brain tumors can be infratentorial and supratentorial and form from a variety of cells. Tumor types are classified using WHO grading based on histologic and functional features. Diagnosis includes medical imaging, with a definitive diagnosis being made with a tissue biopsy. Treatments are largely dependent on the molecular characteristics and tumor grade, and can incorporate surgical removal or some combination of radiotherapy and chemotherapy.
There are two main types of stroke. An ischemic stroke, which is when there is a blocked artery that reduces blood flow to the brain, and a hemorrhagic stroke, which is when there is an artery in the brain that breaks, creating a pool of blood that damages the brain. Of the two, ischemic strokes are much more common, and the amount of damage they cause is related to the parts of the brain that are affected and how long the brain suffers from reduced blood flow. Now, if symptoms self-resolve within 24 hours, it's called a transient ischemic attack, and there are usually minimal long-term problems. Okay, let's start with some basic brain anatomy. The brain has a few regions. The most obvious is the cerebrum, which is divided into two cerebral hemispheres, each of which has a cortex, an outer region, divided into four lobes, including the frontal lobe, the parietal lobe, the temporal lobe, and the occipital lobe. There are also a number of additional structures, including the cerebellum, which is down below, as well as the brainstem, which connects to the spinal cord. The right cerebrum controls muscles on the left side of your body and vice versa. The frontal lobe controls movement and executive function, which is our ability to make decisions. The parietal lobe processes sensory information, which lets us locate exactly where we are physically and guides movement in a three-dimensional space. The temporal lobe plays a role in hearing, smell, memory, as well as visual recognition of faces and language. Finally, there is the occipital lobe, which is primarily responsible for vision. The cerebellum helps with muscle coordination and balance. And finally, there's the brainstem, which plays a vital role in functions like heart rate, blood pressure, breathing, gastrointestinal function, and consciousness. The brain receives blood from the left and right internal carotid arteries, as well as the left and right vertebral arteries, which come together to form the basilar artery. The internal carotid arteries turn into the left and right middle cerebral arteries, which serve the lateral portions of the frontal, parietal, and temporal lobes of the brain. Each of the internal carotid arteries also gives off branches called the anterior cerebral arteries, which serve the medial portion of the frontal and parietal lobes, and connect with one another with a short little connecting blood vessel called the anterior communicating artery. Meanwhile, the vertebral arteries and basilar arteries give off branches to supply the cerebellum and the brainstem. In addition, the basilar artery divides to become the right and left posterior cerebral artery, which mainly serves the occipital lobe and some of the temporal lobe as well as the thalamus. Finally, the internal carotid arteries each give off a branch called the posterior communicating artery, which attaches to the posterior arteries on each side. So together, the main arteries and the communicating arteries complete what is called the circle of Willis, a ring where blood can circulate from one side to the other in case of a blockage. The circle of Willis offers alternative ways for blood to get around an obstructed vessel. In general, the brain can get by on diminished blood flow, especially when it happens gradually, because that allows enough time for collateral circulation to develop, which is where a nearby blood vessel starts sending out branches of blood vessels to serve an area that's in need. But once the supply of blood flow is reduced to below the need of the tissue, it causes tissue damage, which we call an ischemic stroke. There are two main ways an ischemic stroke happens. One mechanism is endothelial cell dysfunction, which is when something irritates or inflames the slippery inner lining of the artery, the tunica intima. One classic irritant is the toxin found in tobacco, which floats around in the blood, damaging the endothelium. That damage becomes a site for atherosclerosis, which is where a plaque forms. This is when a buildup of fat, cholesterol, proteins, calcium, and immune cells form and start to obstruct arterial blood flow. This plaque has two parts to it: the soft, cheesy, textured interior and the hard outer shell, which is called the fibrous cap. Branch points in arteries, and particularly the internal carotid and middle cerebral arteries, are the most common spots for atherosclerosis. Usually, though, it takes years for plaque to build up, and this slow blockage only partially blocks the arteries. And so even though less blood makes it to the brain tissue, there's still some blood. So strokes happen when there is a sudden and complete or nearly complete blockage of the artery. So let's see how that can happen. Since plaques sit in the lumen of the blood vessel, they're constantly being stressed by mechanical forces from blood flow. And interestingly, it's often the smaller plaques that are more dangerous. Their fibrous caps are softer than the large ones and are prone to getting ripped off. Once that happens, the inner cheesy filling is exposed to the blood and is thrombogenic, which means that they tend to form clots very quickly. Platelets adhere to the exposed cheesy material, and they release chemicals that enhance the clotting process. Within a minute, that artery can be fully blocked. Another mechanism for ischemic stroke formation is an embolism. An embolic stroke typically happens when a blood clot breaks off from one location, travels through the blood, and gets lodged in an artery downstream, typically an artery, arteriole, or capillary with a small diameter. These blood clots typically emerge from atherosclerosis, but they can also form in the heart. For example, stagnant blood flow can form a clot, and blood can stagnate due to atrial fibrillation or after a heart attack. If a clot forms in the left atrium, it moves into the left ventricle, and from there it has direct route to the brain. On the other hand, if a clot forms in the low-pressure veins or right atrium, then it goes to the right ventricle and gets lodged in the pulmonary capillaries, with no way of getting to the brain. An important exception is if a person has a heart defect, like an atrial septal defect, that allows blood, and potentially a blood clot, to wander from the right side of the heart over to the left side of the heart. In that situation, a venous or right atrial blood clot will have bypassed the pulmonary circulation and established a route to the brain. One specific type of ischemic stroke is called a lacunar stroke, and they typically involve the deep branches of the middle cerebral artery that feed the basal ganglia. Lacunar refers to lake, and is called that since after a lacunar stroke, the damaged brain tissue develops fluid-filled pockets called cysts that look like little lakes under a microscope. Lacunar strokes classically develop as a result of hyaline arteriolosclerosis, which is when the arteriole wall gets filled with protein. This can happen as a result of hypertension or diabetes, and can make the artery wall quite thick, reducing the size of the lumen. In addition to problems specific to an artery, something like shock can lead to reduction in blood flow throughout the entire body. In these cases, the tissues that are the furthest downstream are affected the most. This is because healthy tissue continues to extract what it needs from the blood flowing by, leaving little to no oxygen and nutrients for the tissue furthest away. The furthest downstream tissues in the brain are at the border of two different blood supplies. When the blood flow throughout the body is diminished for any reason, they get damaged, and this pattern of injury is called a watershed infarct. Regardless of the mechanism of an ischemic stroke, It's helpful to remember that there is an ischemic core, which is the brain tissue that will likely die from ischemia, and then there is the tissue around the core, called the ischemic penumbra, which is preserved for a period of time by collateral circulation and has a chance to survive if blood flow is restored quickly enough. Regardless of the type of ischemic stroke, without a steady supply of glucose and oxygen, cells run out of energy within minutes, and you get a high buildup of sodium and calcium levels in the cells. High sodium levels draw water into the cell, making it swell, and this is called cytotoxic edema. And high calcium leads up to the buildup of reactive oxygen radicals that react with lipids in the membranes of mitochondria and lysosomes. Damage to these organelles allow apoptosis-inducing factors and degradative enzymes to seep out of the cell. Over a period of 4 to 6 hours, immune cells begin to haul away damaged cells, and the resulting inflammation damages the blood-brain barrier, allowing fluids and proteins to get into the brain tissue, causing swelling or vasogenic edema. Because the skull creates a fixed volume, the swelling leads to a mass effect where the swollen brain tissue pushes into the unaffected side of the brain, called cingulate or uncal herniation, or slips down and out of the base of the skull, called cerebellar tonsil herniation, which is particularly dangerous because it can push onto the brainstem and affect breathing and consciousness. Stroke symptoms depend on the exact part of the brain that is affected. For example, an anterior or middle cerebral artery stroke can cause numbness and sudden muscle weakness. If a stroke affects the Broca area, which is usually the left frontal lobe, or the Wernicke's area, which is usually the left temporal lobe, then it can cause slurred speech or difficulty understanding speech respectively. If there's a posterior cerebral artery stroke, then it can affect vision. An acronym to remember some common stroke symptoms is FAST: facial drooping, arm weakness, speech difficulties, and time. Time is obviously not a symptom, but just a reminder to help as quickly as possible to minimize cell injury and maximize the chance of a full recovery. To diagnose and confirm the location and size of an ischemic stroke, medical imaging with a CT or MRI can be used. Also, angiography, which uses a contrast injected into the blood, can help to visualize the exact location where blood flow is blocked within an artery. In addition, using flare sequence MRIs, it's possible to distinguish a new stroke injury from an old one. In an ischemic stroke, the ultimate treatment is to re-establish blood flow as quickly as possible to prevent further cell injury, particularly in the penumbra. Every minute counts. So, thrombolytic enzymes like tissue plasminogen activator or TPA are used to activate the blood's natural clot busting mechanism. But TPA does have a time limit of when it can be used. Aspirin is also used to prevent platelets from forming additional clots. If TPA is unsuccessful, surgical procedures can be used that push a wire through the artery and physically remove the clot. In mechanical embolus removal in cerebral ischemia, called MRCI for short, the wire grabs onto the clot and draws it out of the artery. In suction removal, the wire is used to physically break down the clot, and the clot fragments are removed with suction. After a stroke has occurred, there is an elevated risk of having additional strokes, so it's important to minimize risk factors, the main one being quitting smoking, but others include having a healthy blood pressure, normal LDL cholesterol levels, and controlling other diseases like diabetes. Occasionally, a surgery may be necessary to help clean arteries obstructed by severe atherosclerosis. For example, in a carotid endarterectomy, the internal carotid artery is opened up and atherosclerotic plaque is removed. Alternatively, a stent might be placed to keep the artery opened up. Okay, as a quick recap, an ischemic stroke occurs when there is an acute decrease in the arterial blood supply. It can be due to atherosclerosis, a thrombus, or an embolus, or a global reduction in blood flow. The goal is to identify symptoms and reestablish blood flow to prevent long-term damage. To remember this, a common acronym is FAST: facial drooping, arm weakness, speech difficulties, and time.
With meningitis, meninge refers to the meninges, which are 3 protective membranes that cover the brain and spinal cord. And itis refers to inflammation, so meningitis is an inflammation of the meninges. More specifically, it refers to inflammation of the 2 inner layers, which are called the leptomeninges. The outer layer of the meninges is the dura mater. The middle layer is the arachnoid mater, and the inner layer is the pia mater. These last two, the arachnoid and pia maters, are the leptomeninges. Between the leptomeninges, there's the subarachnoid space, which houses cerebrospinal fluid, or CSF. CSF is a clear, watery liquid which is pumped around the spinal cord and brain, cushioning them for impact and bathing them in nutrients. In 1 microliter or cubic millimeter, there are normally just a few white blood cells, up to 5. If we look at a bigger sample, like say a deciliter, then around 70% of those will be lymphocytes, 30% will be monocytes, and just a few will be polymorphonuclear cells, or PMNs, like neutrophils. That same volume will have some proteins in it as well, about 15 to 50 milligrams, as well as some glucose, about 45 to 100 milligrams, which is close to 2/3 of the glucose we'd find in the same volume of blood. The cerebrospinal fluid is held under just a little bit of pressure, below 200 millimeters of water, which is just under 15 millimeters of mercury, which is less than 1/5 of the mean arterial pressure. Now, at any given time, there's about 150 milliliters of cerebrospinal fluid in the body, and this is constantly replenished, with around 500 milliliters of new cerebrospinal fluid produced every day, and the excess, or 500 minus 150, or 350, is absorbed into the blood. But for any nutrients to enter or leave the cerebrospinal fluid, and the brain itself for that matter, they have to go through the tightly regulated blood-brain barrier. The blood-brain barrier is a special name given to the blood vessels in the brain. That's because the endothelial cells in the blood vessels are so tightly bound to one another that they prevent leakage and only allow certain molecules to slip through them. Meningitis is the inflammation of the leptomeninges, which remember are the inner 2 membranes around the brain and spinal cord. It is not the inflammation of the brain itself. That's encephalitis. But sometimes they can happen together, and when that happens, it's called meningoencephalitis. So, meningitis needs some kind of trigger for the inflammation. And this could be an autoimmune disease where the body attacks itself, like lupus, or the body having an adverse reaction to some medication, which can happen with intrathecal therapy, when medication is injected directly into the cerebrospinal fluid. But by far, infection is the most common trigger for meningitis across all age groups, like with the Neisseria meningitidis bacteria or herpes simplex virus. Now, there are 2 routes that an infection can take to reach the cerebrospinal fluid and leptomeninges. The first way is direct spread, which is when a pathogen gets inside the skull or spinal column, and then penetrates the meninges, eventually ending up in the cerebrospinal fluid. Sometimes the pathogen will have come through the overlying skin or up through the nose, but it's more likely that there's an anatomical defect to blame. For example, it could be a congenital defect, like spina bifida, or an acquired one like a skull fracture, where there might be cerebrospinal fluid leaking through the sinuses. The second way is hematogenous spread, which is when a pathogen enters the bloodstream and moves through the endothelial cells in the blood vessels that make up the blood-brain barrier, and get into the cerebrospinal fluid. To do this, the pathogens typically have to bind to surface receptors on the endothelial cells in order to get across. Otherwise, they have to find areas of damage or more vulnerable spots like the choroid plexus. Once the pathogen finds a way into the cerebrospinal fluid, it can start multiplying. Soon enough, the handful of white blood cells surveilling the cerebrospinal fluid identify the pathogen and release cytokines to recruit additional immune cells. Over time, a microliter of cerebrospinal fluid might go on to contain thousands of white blood cells, but any more than 5 usually defines meningitis. In most bacterial cases, there'll be above 100 white blood cells per microliter, and more than 90% polymorphonuclear cells. In most viral cases, there'll be 10 to 1,000 white blood cells, and over 50% lymphocytes and under 20% PMNs. In most fungal cases, there'll be 10 to 500 white blood cells, with over 50% being lymphocytes. In most cases of tuberculosis meningitis, there'll be 50 to 500 white blood cells, with over 80% being lymphocytes. The additional immune cells attract more fluid to the area and start causing local destruction as they try to control the infection. As a result, the cerebrospinal fluid pressure typically rises above 200 millimeters of water. The immune reaction also causes the glucose concentration in the cerebrospinal fluid to fall to below 2/3 of the concentration in the blood. It also makes the protein levels increase to over 50 milligrams per deciliter. When it comes to the causes of meningitis, viruses and bacteria usually cause acute meningitis, whereas fungi usually causes chronic meningitis. Now, for bacteria, there are a lot of possibilities. In newborns, the most common causes are group B streptococci, E. coli, and Listeria monocytogenes. In children and teens, the most common causes are Neisseria meningitidis and Streptococcus pneumoniae. In adults and the elderly, the most common causes are Streptococcus pneumoniae and Listeria monocytogenes. There are also tick-borne causes of meningitis, like Borrelia burgdorferi bacteria, which is the cause of Lyme disease. As for viruses, the main culprits are enteroviruses, especially Coxsackie virus, as well as herpes simplex virus. HIV is usually contracted through body fluids and can also cause viral meningitis. Less common causes include the mumps virus, varicella-zoster virus, and lymphocytic choriomeningitis virus. There's also the fungi, like those from the Cryptococcus and Coccidioides genuses, which mainly affect immunocompromised individuals. And then, of course, there's tubercular meningitis, which is caused by the Mycobacterium tuberculosis bacteria. And finally, parasitic causes of meningitis like P. falciparum, which is the main cause of malaria. Now, the classic triad of meningitis symptoms are headaches, fevers, and nuchal rigidity, or neck stiffness. It can also cause photophobia, which is discomfort with bright lights, or phonophobia, which is discomfort with loud noises. Meningoencephalitis can cause an altered mental state or seizures. The diagnosis of meningitis starts with a physical exam. One maneuver is when a person lies flat on their back facing upwards, and one of their legs is raised with the knee flexed to a 90-degree angle. Then the leg is supported and slowly straightened at the knee. If this causes back pain, then it's called Koenig's sign. Another maneuver is when a person again lies flat on their back facing upwards, and then has their neck supported and flexed. If this causes them to automatically flex their knees or hips, then it's called the Brzezinski's sign. If meningitis is suspected, a lumbar puncture can be done. And this is when a needle goes through the lower lumbar vertebral levels of the spinal cord, between L3 and L4, for example. The needle penetrates into the subarachnoid space and a few milliliters of cerebrospinal fluid is taken. The opening pressure can be measured, and the cerebrospinal fluid can be analyzed for white blood cells, protein, and glucose. Polymerase chain reaction, or PCR, might also be used to find specific causes, like HIV, enteroviruses, HSV, or tuberculosis. If a particular infection seems like an obvious cause, then a test for that might be used, like the Western blot for Borrelia burgdorferi bacteria, or a thin blood smear for malaria. The treatment of meningitis depends on the underlying cause. For bacterial meningitis, it's common to administer steroids and then antibiotics to prevent massive injury to the leptomeninges from the inflammation caused as the antibiotics destroy the bacteria. In general, drug treatments like antivirals, antibacterials, antifungals, or antiparasitics are aimed at the specific cause of meningitis. Prevention with a vaccine is appropriate for some causes like Neisseria meningitidis, but also for mumps and for disseminated tuberculosis. Prophylactic antibiotics can also be administered to avoid outbreaks of bacterial meningitis, like in households where individuals haven't been vaccinated against Neisseria meningitidis. Alright, as a quick recap, meningitis is an inflammation of the leptomeninges, which is the inner two membranes that surround and protect both the brain and the spinal cord. It normally starts when a foreign substance, oftentimes bacteria, makes its way inside the leptomeninges, either by direct contact or hematogenous spread through the blood-brain barrier. The immune system responds to the antigen by flooding the subarachnoid space with white blood cells, which release cytokines and create inflammation. And this results in the classic triad of symptoms, which is headaches, fevers, and neck stiffness. Hey guys, what's up? Thanks for watching that video on meningitis. Hopefully you learned a thing or two. If you are interested in learning more about that topic, you should for sure head over to our platform called Osmosis at osmosis.org. We have a bunch more flashcards and quiz questions that you can help test your knowledge on that topic. And also, in addition to that, we have a lot more videos as well. We have a whole series on ECG, and we're starting to build up a bunch of embryology videos, as well as some more physiology videos. So if you are interested in checking those out, I would highly encourage heading over to osmosis.org and making an account. Otherwise, you can always support us by donating on Patreon and subscribing to our channel and following us on social media. All right, guys. Till next time. See ya. With aqueductal stenosis, aqueductal refers to a channel in the brain that allows fluid to flow through, and stenosis refers to a narrowing. So aqueductal stenosis is a problem where a channel in the brain's ventricular system gets narrowed, and that makes it hard for cerebrospinal fluid to flow through. Now let's start with some relevant anatomy. The brain has 4 interconnected cavities, called ventricles, and each one contains a structure called the choroid plexus. The choroid plexus is made up of ependymal cells which produce cerebrospinal fluid, which is a fluid that helps provide buoyancy and protection, as well as metabolic fuel for the brain. Highest up are 2 C-shaped lateral ventricles that lie deep in each cerebral hemisphere. The 2 lateral ventricles drain their cerebrospinal fluid into the 3rd ventricle, which is a narrow funnel-shaped cavity at the center of the brain. The 3rd ventricle makes a bit more cerebrospinal fluid and then sends all of that fluid to the 4th ventricle via the cerebral aqueduct. The 4th ventricle is a tent-shaped cavity located between the brainstem and the cerebellum. After the 4th ventricle, the cerebrospinal fluid enters the subarachnoid space, which is the space between the 2 inner linings of the brain, the arachnoid and the pia mater. Cerebral aqueduct stenosis develops when there's a blockage of the cerebral aqueduct between the 3rd and 4th ventricle, and most of the time this blockage is caused by a tumor. Most often it's a pineal gland tumor, which sits just dorsal to the aqueduct at the level of the midbrain. Cerebral aqueduct stenosis can also be a congenital problem, like if the channel itself is malformed, with lots of abnormal branchings that have dead ends. Sometimes when there's forking, cerebral spinal fluid accumulates in these branches, and it causes them to expand and compress the main cerebral aqueduct. Eventually, if this compressive force closes off the aqueduct, it can stop the flow of cerebrospinal fluid completely. Regardless of the cause, when that cerebral aqueduct is shut off, it leads to obstructive hydrocephalus, which is where there's a buildup of cerebrospinal fluid inside the ventricles. That makes the ventricles dilate, and that in turn compresses the surrounding brain tissue. The main symptoms of aqueductal stenosis are related to the brain compression. So that includes headaches, vomiting, seizures, balance disturbances, and visual problems. Children with hydrocephalus can have an enlarged head and developmental delays, as well as intellectual disability and muscular spasticity. The best way to diagnose aqueductal stenosis is with an MRI, because it can visualize the entire length of the aqueduct. Treatment for aqueductal stenosis typically involves the placement of a shunt, like a ventricular peritoneal shunt, which connects the ventricular system to the peritoneal cavity, in order to allow fluid to drain out and get reabsorbed by the cells lining the peritoneal pleura. This helps to reduce the intracranial pressure caused by hydrocephalus. In addition, individuals often benefit from physiotherapy to help them develop their motor skills. Alright, as a quick recap. Cerebral aqueduct stenosis is a narrowing of the cerebral aqueduct, which blocks the flow of cerebral spinal fluid from the third to fourth ventricle. It most commonly happens due to a pineal gland tumor or congenital malformation, and results in obstructive hydrocephalus.
It's pretty well established that your brain's really important. It's like if your body was a computer, your brain's the mainframe. It controls everything, whether you're aware of it or not. Cerebral palsy means brain condition causing paralysis. So essentially, cerebral palsy refers to damage to the brain that causes loss of muscle control. Like, for example, if the cerebellum was damaged, patients might have issues with fine motor skills like writing or typing. That being said, though, cerebral palsy is a broad umbrella term to basically cover a wide variety of issues, since ultimately the muscles affected and severity depends on which part of the mainframe's been affected, right? Cerebral palsy is considered a neurodevelopmental condition, meaning that something happens to an area of the brain during its initial development, which is an extremely sensitive period. If that area doesn't develop right, then it can't carry out whatever function it's supposed to control. But what's this vague something that can happen, though? Well, it's something because there's a wide variety of causes. The majority of cerebral palsy cases are thought to happen before birth, or prenatally, which typically means the underlying cause is really hard to pin down. Exposure to radiation or infection during fetal development can cause cerebral palsy. Hypoxia to the developing fetus has been linked as well. In this case, the developing brain doesn't get enough oxygen, potentially from problems like the placenta not being able to supply oxygen and nutrients. Cerebral palsy doesn't have to happen prenatally, though, and some postnatal causes are things like head trauma, or again, an infection or a period of oxygen deprivation. Although most cases are likely due to some trauma or injury, a very small proportion of cases are due to a genetic mutation. Even though the brain damage or injury or abnormality is permanent, one super important point to remember about cerebral palsy is that it doesn't get worse over time, and for that reason, it's considered a non-progressive condition. Cerebral palsy is classified by the type of muscle movements that result from the brain injury and how that affects what activities the patient can perform. The first type is called spastic cerebral palsy, which accounts for about 70% of cases. And this is characterized by having really tight or stiff muscles, which can make patients' movements seem jerky. This tightness results from a lesion in an upper motor neuron. So with a lesion, which just means some kind of abnormality, the ability of some of these neurons to receive GABA might be impaired. And GABA is the main inhibitory neurotransmitter. So if nerve impulses can't be inhibited, which is a double negative, then those nerves are basically overexcited, leading to hypertonia, which is an abnormal increase in the muscle activity, basically like if the muscles were constantly contracting. This is why some people with spastic cerebral palsy have a scissor gait. Think about how hard it'd be to walk when your adductor muscles were always partly contracted, which causes your knees and thighs to constantly touch. Similarly, sometimes patients have a toe walk because their calf muscles are always contracted, which pulls the Achilles tendon up and causes someone to go up on their toes. A second type of cerebral palsy is athetoid or dyskinetic cerebral palsy, and this one involves damage or injury to the basal ganglia. The basal ganglia is this structure here, which essentially helps us to initiate and prevent certain movements. If the basal ganglia becomes damaged, patients can lose the ability to prevent movements, and therefore they can have involuntary movements, meaning out of their control. So, dyskinetic cerebral palsy is characterized by dystonia and/or chorea. Dystonia is random, slow, and uncontrolled movements in the limbs and trunk. Chorea is random dance-like movements since the small uncontrolled movements seem to move from muscle to muscle. Finally, there's ataxic cerebral palsy. Taxis refers to an order or arrangement, so ataxic essentially means without order, which is in reference to patients with this type being shaky or uncoordinated, and this is caused by damage to the cerebellum, which helps with coordination and fine or precise muscle movements. These patients often have clumsy or unstable movements and poor balance when doing things like walking or picking something up. Although different from patient to patient, many patients with muscle control issues have other symptoms as well. Patients often experience pain from tightened muscles or abnormal posture and stiff joints. Also, abnormal movements might make it difficult to sleep at night, and patients can develop sleep disorders. Eating can become difficult as well, which can range from the preparation of food to the action of chewing and swallowing food. Other brain-related issues are also associated, like difficulties with speaking and communication, vision problems, and learning disabilities. Diagnosis of cerebral palsy is typically done clinically. However, in some cases, additional lab work can be done to rule out other conditions that present similarly, such as thyroid disorders or inherited metabolic conditions. Imaging tests like a brain or spine MRI or CT scan can also support the diagnosis of cerebral palsy, or rule out other central nervous system lesions. Since cerebral palsy involves a permanent abnormality to the brain's structure, it's not curable, but that doesn't mean it's not treatable. Treatment for cerebral palsy usually involves a multidisciplinary approach, pulling from a number of clinical specialties like neurologists, rehabilitation specialists, occupational therapists, speech therapists, and others, hopefully to find a unique approach for each patient, ultimately improving their quality of life. Physical therapy can be used to build strength and improve walking ability, along with stretching to reduce contracture, which is a permanent shortening of muscle tissue from being hypertonic or contracted for so long. Sometimes muscle relaxants are given, or botulinum toxin is injected into certain muscles to relax them, which can both help reduce pain associated with hypertonus and also help fit patients with specific orthotic braces. Sometimes surgery might also be performed to help with a variety of issues, like loosening tight muscles, straightening out bones that have been subject to abnormal muscle forces over time, and cutting certain nerves to reduce their associated movements or spasms. Alright, as a quick recap. Cerebral palsy is when central nervous system structures like the brain or cerebellum are damaged, and this affects motor function, causing palsy. Even though the damage is permanent, the condition doesn't get worse over time, so it's considered a non-progressive disorder. There are 3 types of cerebral palsy: spastic cerebral palsy, which is the most common, athetoid or dyskinetic cerebral palsy, and ataxic cerebral palsy, all of which are typically diagnosed based on the clinical picture. Treatment for cerebral palsy usually involves a multidisciplinary approach, and the team can comprise of neurologists, rehabilitation specialists, occupational therapists, speech therapists, and others, who work together to ultimately improve the quality of life.
Chiari malformations are a group of conditions where the cerebellum of the brain extends down into the spinal canal and results in the blockage of normal flow of cerebrospinal fluid. The cerebellum, or little brain, is divided into 2 hemispheres which are separated by a narrow worm-like structure in the middle called the vermis. Directly beneath the hemispheres are 2 smaller lobes called cerebellar tonsils. Normally, the cerebellum and cerebellar tonsils sit right above the foramen magnum, which is the opening at the base of the skull through which the spinal cord passes through. The cerebellum is contained within the posterior fossa, or floor of the back of the skull, which also contains the medulla oblongata. The cerebellum controls balance, posture, and helps to initiate as well as fine-tune voluntary motor activity. Think about the fancy finger work of a piano player, or the vocal cords of a singer. That's the cerebellum in action. The medulla, on the other hand, controls autonomic functions like breathing and blood pressure, as well as reflexes like coughing, vomiting, gagging, and swallowing. Now, there's also a set of 4 interconnected cavities in the brain called ventricles, each of which create and circulate cerebrospinal fluid. Highest up are two C-shaped lateral ventricles that lie deep in each cerebral hemisphere. The two lateral ventricles drain their cerebrospinal fluid into the third ventricle, which is a narrow, funnel-shaped cavity at the center of the brain. The third ventricle makes a bit more cerebrospinal fluid and then sends all of the cerebrospinal fluid to the fourth ventricle via the cerebral aqueduct. The fourth ventricle is a tent-shaped cavity located between the brainstem and the cerebellum, and is continuous with the central canal. After the fourth ventricle, the cerebrospinal fluid enters the subarachnoid space, which is the space between the two inner linings of the brain, the arachnoid and the pia mater. Now, below the brain is the spinal cord, and within it runs the spinothalamic tract. The spinothalamic tract is an ascending spinal pathway that carries sensory information from the spinal cord to the brain, and it's actually made up of two distinct tracts. The lateral spinothalamic tract carries information about pain and temperature, while the anterior spinothalamic tract carries information about touch. These fibers usually decussate, or cross the spinal cord near its center at the anterior white commissure, before finally carrying the signal upwards to the thalamus and brain. So, Chiari malformations happen when parts of the cerebellum slip down through the foramen magnum and into the upper spinal canal. It's usually caused by underdevelopment of the posterior fossa of the skull during fetal development. As the cerebellum continues to develop and grow within the confined space of the malformed posterior fossa, it eventually gets pushed down through the foramen magnum. And there are different types of Chiari malformations. The two main ones are called a type 1 Chiari malformation and a type 2 Chiari malformation, and they differ in terms of what structures herniate. A type 1 Chiari malformation happens when only the cerebellar tonsils herniate down into the foramen magnum. As a result, the displaced cerebellum can compress the fourth ventricle and block the normal flow of cerebrospinal fluid from the ventricles into the subarachnoid space. Consequently, cerebrospinal fluid builds up in the ventricles, which is called hydrocephalus. And this leads to increased intracranial pressure. Over time, cerebrospinal fluid might also build up in the spinal canal, although the exact mechanism of how this happens remains unknown. Eventually, though, this fluid can pool in the spinal canal and cause a syrinx, or fluid-filled cavity, to form at the center of the spinal cord. This is a condition known as syringomyelia. As the syrinx enlarges, it starts to expand outwards from the center of the spinal cord and causes the destruction of the nearby nerve fibers, particularly of the spinothalamic tract. Typically, type 1 Chiari malformations are asymptomatic, or found incidentally and therefore usually only discovered during adolescence or adulthood. By comparison, a type 2 Chiari malformation, also called an Arnold-Chiari malformation, is a lot more severe, and is therefore more readily apparent in childhood. Just like in type 1, there's herniation of the cerebellar tonsils, but a type 2 Chiari malformation also includes the herniation of the cerebellar vermis. Furthermore, type 2 Chiari malformations are commonly associated with a myelomeningocele, a type of spina bifida. A myelomeningocele is a neural tube defect that happens when the spinal cord and the surrounding meninges protrude out of an opening in the bony vertebrae, and are held together by a sac of skin that pouches out from the back. The symptoms of Chiari malformations depend on which structures of the brain and spinal cord are affected. Oftentimes, type 1 Chiari malformations can be asymptomatic. Type 2 Chiari malformations, on the other hand, can cause occipital headaches, or headaches at the back of the head, and they worsen with Valsalva maneuvers like yawning, sneezing, and coughing, because those things increase intracranial pressure and worsens the cerebellar herniation. If there's cerebellar dysfunction, it can cause vertigo or dizziness, as well as nystagmus or irregular eye movements, or an unsteady gait. If there's excessive crowding in the posterior fossa, excess pressure on the medulla oblongata can impair the cough and gag reflexes, as well as cause difficulty breathing and sleep apnea. Finally, hydrocephalus itself leads to symptoms like a headache and vomiting. And if the Chiari malformation is associated with syringomyelia, there'll be a loss of pain and temperature sensation in the shoulders and arms. That happens in a cape-like distribution, due to the destruction of the spinal thalamic tract at the level of the cervical spine, usually C4 to C6. Chiari malformations are usually diagnosed with a brain MRI, and are generally suspected when cerebellar structures are seen more than 5 millimeters below the foramen magnum. If a person with a Chiari malformation has neurological symptoms, posterior fossa decompression surgery can be done. And that's a type of craniotomy where a portion of the back of the skull is removed in order to widen the foramen magnum. And this helps release the buildup of pressure within the brain and restore normal cerebrospinal flow. Similarly, the dura, or outermost membrane of the spinal cord and brain, might also be incised to relieve additional tension. Afterwards, the expanded incision is stitched together with a graft material known as a dura patch. If hydrocephalus is present, a shunt can be used, like a ventriculoperitoneal shunt, which connects the ventricular system to the peritoneal cavity in the abdomen, in order to allow fluid to drain out and get reabsorbed by the cells lining the peritoneal pleura. This also helps to reduce intracranial pressure. Alright, as a quick recap. Chiari malformations are due to the herniation of the cerebellum through the foramen magnum. A type 1 Chiari malformation is caused by the herniation of only the cerebellar tonsils, and is associated with syringomyelia. In contrast, a type 2 Chiari malformation, called an Arnold-Chiari malformation, is more severe, and is caused by the herniation of both the cerebellar tonsils and the vermis, and is associated with a myelomeningocele. Dandy-Walker malformation, first described by Dr. Walter Dandy and Dr. Arthur Walker, is a congenital brain defect where there's a cystic malformation in the cerebellum that blocks cerebrospinal fluid from exiting the brain. This results in increased intracranial pressure and can affect the cerebellum's ability to control motor skills like walking. The cerebellum, or little brain, sits just below the main part of the brain, and it's divided at the midline into two hemispheres by a short worm-like structure called the vermis. The cerebellum is contained within the back of the skull, in an area known as the posterior fossa, and it sits above the foramen magnum, an opening at the base of the skull through which the spinal cord enters. The cerebellum controls balance and posture, and helps to initiate as well as fine-tune voluntary motor activity. Think about the fancy fingerwork of a piano player, or the vocal cords of a singer. That's the cerebellum in action. Now, within the brain, there are also 4 interconnected cavities called ventricles, each of which create and help circulate cerebrospinal fluid. Highest up are 2 C-shaped lateral ventricles that lie deep in each cerebral hemisphere. The 2 lateral ventricles drain their cerebrospinal fluid into the 3rd ventricle, which is a narrow, funnel-shaped cavity at the center of the brain. The 3rd ventricle makes a bit more cerebrospinal fluid and then sends all of the cerebrospinal fluid to the 4th ventricle via the cerebral aqueduct. The 4th ventricle is a tent-shaped cavity located between the brainstem and the cerebellum, and is continuous with the central canal. After the 4th ventricle, the cerebrospinal fluid enters the subarachnoid space, which is the space between the 2 inner linings of the brain, the arachnoid and the pia mater. In a Dandy-Walker malformation, there are 3 main defects. First, there's a cyst in the 4th ventricle, which causes the ventricles to enlarge, and as a result press against the cerebellum, interfering with cerebellar function. Second, the posterior fossa space is usually enlarged as well. And third, the cerebellar vermis, which divides the cerebellum into its hemispheres, is either smaller than normal or absent altogether. Although the mechanism isn't well understood, these features block the normal flow of cerebrospinal fluid from the 4th ventricle into the subarachnoid space. Since the cerebrospinal fluid can't flow out of the 4th ventricle, it builds up in the ventricles and makes them expand, which result in hydrocephalus, or the buildup of fluid within the brain. Hydrocephalus leads to an increase in intracranial pressure as well as an enlarged head circumference, or macrocephaly. The symptoms of Dandy-Walker malformation typically start at birth or soon after birth. They include irritability, vomiting, and seizures. Over time, infants might have delays in motor skills like crawling and walking. And the cerebellar dysfunction can lead to movement symptoms like an unsteady gait or ataxia, abnormal eye movements, muscle paralysis or spasticity, and abnormal breathing patterns. Dandy Walker malformation is often diagnosed prenatally via ultrasound and can be confirmed with a brain MRI. Treatment for Dandy Walker malformation typically involves the placement of a shunt, like a ventriculoperitoneal shunt, which connects the ventricular system to the peritoneal cavity in order to allow fluid to drain out and get reabsorbed by the cells lining the peritoneal pleura. This helps reduce the intracranial pressure caused by hydrocephalus. In addition, individuals often benefit from physiotherapy to help them develop their motor skills. Alright, as a quick recap, Dandy Walker malformation is a congenital disorder characterized by 3 features: a cyst that dilates the fourth ventricle, enlargement of the posterior fossa, and an absence of the cerebellar vermis. Symptoms include movement abnormalities and hydrocephalus, and it's commonly treated with a ventriculoperitoneal shunt. The term spina bifida comes from the Latin split spine, which is actually a pretty good description because spina bifida is a birth defect where the tissue on the left and the right side of the back that normally come over the spinal cord to protect it don't completely meet up to form a nice seal, leaving behind various degrees of an opening right down the middle of the lower back. Very early on in fetal development, the ectoderm, which is the outer layer of the fertilized egg, starts to develop a bit of a ridge that eventually becomes the neural tube. This neural tube goes on to become the spinal cord, the brain, as well as tissues that enclose and protect them, called the meninges. And spina bifida occurs when a portion of this neural tube fails to close properly, typically in the lower back. This constitutes a defect or absence of the vertebral arches due to a failure of mesoderm to organize over the region of the defect, and it may or may not involve the underlying meninges and neural tissue. Alright, so there are 3 main types of spina bifida, and the first is myelomeningocele, also called meningomyelocele. And this is the most severe of the 3 and happens when the spinal cord and the surrounding meninges protrude out of an opening in the bony vertebrae and are held together by a sac of skin that pouches out from the back. In really severe cases, there's no skin at all, and the nerves of the spinal cord are therefore exposed, a condition called open spina bifida. And this can cause serious damage to the exposed nerves, as well as risk an infection, resulting in symptoms like loss of sensation or paralysis in the areas of the body below the damaged site, bladder or bowel movement problems, seizures, as well as leg and foot deformities. Now, a myelomeningocele is typically associated with a condition called an Arnold-Chiari II malformation, which is where cerebellar and brainstem tissues slip down into the foramen magnum, the opening at the base of the skull. This Arnold-Chiari II malformation results in a variety of symptoms related to the cerebellum, and often results in hydrocephalus, an abnormal accumulation of cerebrospinal fluid in the brain. Alright, the second type of spina bifida is meningocele, sometimes called a meningeal cyst. In this condition, the prenatal spinal deformities result only in the meninges and not the spinal nerves, slipping into the gaps between the deformed vertebrae. This one's the least common form of spina bifida, and because the spinal cord itself isn't damaged, these individuals often don't experience the severe symptoms that are seen in myelomeningocele. Alright, the third and final type is spina bifida occulta, and this is the most common and most mild form of spina bifida. In fact, occulta is Latin for hidden, which is appropriate since many of the normal prenatal tests used to diagnose spina bifida don't catch the disorder because the deformities in the tissues of the lower back are tiny. In spina bifida occulta, the spinal cord and surrounding tissue don't protrude, nor is any of the tissue forced into spaces between the vertebrae. Since the spinal nerves are undamaged, people with this form of the disorder are often asymptomatic, and the condition is usually only found accidentally later in life. At most, people might have hair, a dimple, or birthmark on their back above the site of the lesion. Now, the exact cause of all three types of spina bifida isn't known, but there are known risk factors like folate or vitamin B9 deficiency during fetal development. And therefore, prenatal vitamins include folic acid, which is the manufactured form of folate. The developmental deformities, though, that cause spina bifida often take place in the 4th week of pregnancy, which is 21 to 28 days. And this could be before a woman might know that she's even pregnant, and therefore she's not taking the prenatal vitamins yet. To help combat this, enriched grain products like breakfast cereals made with whole grains have folic acid added to the flour as a general preventative measure. Other risk factors for having a child with spina bifida include obesity, poorly controlled diabetes, and taking medications that interfere with folate metabolism, like certain anti-seizure medications. Diagnosis for the most severe form of spina bifida, myelomeningocele, is often done prenatally by looking for an increased level of alpha-fetoprotein, or AFP, in the mother's serum, which can happen when the skin surrounding the fetus's spine is missing and AFP leaks into the amniotic fluid and into the mother's bloodstream. AFP, though, can be elevated in other conditions as well. So in order to get a more exact diagnosis, additional blood tests for human chorionic gonadotropin, or HCG, inhibin A, and estriol, as well as an ultrasound are usually done. In more serious cases, amniocentesis, where a sample is taken directly from the amniotic sac surrounding the fetus, can be performed. For treatment, prenatal surgery is done to close a myelomeningocele, but this surgery can be dangerous to the developing fetus as well as the mother. In cases where postnatal surgery is chosen, it's often done within the first few days of an infant's life in order to minimize the risk of infection like meningitis. Even if the surgery is successful, people with this condition typically need additional interventions like urinary catheterization to help with urination and crutches or wheelchairs in case of paralysis or low muscle tone, because the damaged or underdeveloped spinal nerves can't be repaired. Alright, as a quick recap, the three types of spina bifida are spina bifida occulta, which is the most common and least severe, meningocele, which is the least common and also typically not very severe, and myelomeningocele, which is the most severe form of spina bifida. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel or telling your friends about us on social media.
Spinocerebellar ataxia, or SCA, refers to a group of rare genetically inherited conditions caused by mutations in several types of SCA genes. These mutations result in degenerative changes in the cerebellum and often in the spinal cord, which causes progressive problems with coordination and balance, known as ataxia. The cerebellum sits at the back of the skull, posterior to the brainstem. Neurons send their axons carrying input from the spinal cord, the brain, and the internal ear through the brainstem into the cerebellum. Once there, the cerebellum uses this information to coordinate and plan movement, as well as maintain balance. So, with mutations in the SCA genes, the cerebellum, along with the spinal cord, slowly degenerate. In fact, many different gene mutations have been identified, each of which is known to cause different types of spinocerebellar ataxia. The types are described using SCA followed by a number, according to their order of identification. So, there's SCA1 through SCA48, with SCA3 being the most common type. However, in about 40% to 25% of the cases, the causative genes are still unknown. Now, most of these gene mutations are inherited in an autosomal dominant pattern, meaning that one copy of an altered SCA gene is enough to cause the disease. Affected individuals have a 50% chance of passing on the altered gene to their child, causing that child to have the disease. In some cases, the involved gene contains a triplet repeat, where the nucleotides C, A, and G are repeated multiple times in a row, And since CAG codes for the amino acid glutamine, the encoded protein will have multiple extra glutamines in a row. The specific way in which extra glutamines causes the disease's symptoms isn't fully understood, but the abnormal protein seems to aggregate within the neurons of the cerebellum and the spinal cord, causing them to die. The expanded CAG repeats also affect DNA replication itself. When copying the mutated gene, DNA polymerase can basically lose track of which CAG it's on and accidentally add extra CAGs. This expansion of the originally inherited gene means a child of a parent with the disease can inherit even more CAG repeats than the parent. The higher number of repeats in the protein, the earlier the age of onset, and the more severe the symptoms. Symptoms vary depending on the type of spinocerebellar ataxia, but usually include poor coordination of hands, speech, walking, and eye movements. These symptoms may develop any time from childhood to late adulthood. Diagnosis is based on a neurological examination and family history. Neuroimaging tests like CT or MRI usually show cerebellar atrophy. Finally, genetic analysis of the involved genes confirms the diagnosis and helps identify the specific type of SCA. Treatment involves physical therapy to strengthen the muscles, speech therapy, and special devices that assist in mobility, like canes, braces, and wheelchairs. Other devices can also be used to assist with writing, feeding, and self-care. Even though there is no cure yet, research is going strong, and several medications that target different steps in the pathology of SCA have shown promise in animal models of the disease, and have progressed to clinical trials in humans. Alright, as a quick recap. Spinocerebellar ataxia is a group of progressive neurodegenerative diseases of genetic origin. Many different types have been identified, most of which are autosomal dominant. It can present at any age with progressive loss of coordination of hands, speech, walking, and eye movements. Diagnosis includes neuroimaging and genetic sequencing, and treatment is mostly supportive.
In syringomyelia, syrinx means cyst or cavity, and myelia means a condition of the spinal cord. So syringomyelia is a cystic enlargement of the spinal cord, and it typically starts medially and enlarges outward, eventually damaging the spinothalamic tract, which is a part of the spinal cord that sends sensory signals about pain, pressure, temperature, and touch to the brain. Now, the spinal cord itself is composed of both gray and white matter. Gray matter is found within the medial portion of the spinal cord and is shaped like a butterfly. This is where the cell bodies of different neurons can be found. In the center of the gray matter, there's a small cavity called the central canal, which is filled with cerebrospinal fluid. Cerebrospinal fluid helps provide nutrients and mechanical support to the brain and spinal cord. Surrounding the gray matter is white matter, which consists of the axons of various neurons. The spinal cord has different neural tracts that carry sensory information to and from the brain. The cortical spinal tract is a descending pathway which carries motor information from the brain to various muscles. The dorsal column, found in the posterior portion of the spinal cord, is responsible for sending pressure, vibration, fine touch, and proprioception, or the awareness of one's body in space. Then there's the spinothalamic tract, which is divided into two distinct tracts. The lateral spinothalamic tract, which is responsible for sensing pain, pressure, and temperature, as well as the anterior spinothalamic tract, which senses crude touch. The spinothalamic tract carries all of this sensory information from the spine up to the thalamus of the brain, where the information is processed. This happens through three neurons that synapse with one another. First, a primary neuron carries sensory information, like pain, from the skin to the dorsal horn of the spinal cord, where it synapses with a secondary neuron. The secondary neuron ascends 1 to 2 vertebral levels, and decussates or crosses to the opposite side of the spinal cord via an area of white matter called the anterior white commissure. The secondary neuron then ascends up the length of the spinal cord via the anterior or lateral spinal thalamic tracts, eventually synapsing at the ventral posterior nuclei of the thalamus. Finally, from there, a third neuron arises from nuclei in the thalamus and carries the signal to the primary sensory cortex, or the post-central gyrus of the brain where the sensory signal is interpreted. In syringomyelia, the central canal of the spinal cord that houses the cerebrospinal fluid gradually expands. This expansion might be caused by acquired factors, but the main cause of syringomyelia is a congenital condition called Arnold-Chiari II malformation, sometimes shortened to Chiari malformation. In this condition, the cerebellar and brainstem tissue slip down into the foramen magnum, the opening at the base of the skull. This malformation results in a variety of balance and movement symptoms related to the cerebellum and usually results in hydrocephalus, an abnormal accumulation of cerebrospinal fluid in the brain. Normally, cerebrospinal fluid would flow through the 4 ventricles of the brain, and after the 4th ventricle, the fluid would have 2 options. It could enter the ventricular system through openings called the medial and lateral apertures, and into the subarachnoid space where it's reabsorbed. Alternatively, the fluid could go into the spinal canal. In Chiari malformations, however, the displacement of the cerebellum ends up blocking the openings where cerebrospinal fluid would exit into the subarachnoid space. As a result, the fluid backs up with the canal, eventually causing the spinal canal to widen, and this leads to syringomyelia. Aside from Chiari malformations, syringomyelia can also be caused by any acquired condition that blocks the flow of cerebrospinal fluid, like a tumor. Alternatively, it can be caused by damage to the spinal cord, which results in an enlarged spinal canal. Examples of that include spinal cord trauma, spinal tumors, and spinal cord abscess. Regardless of the cause, the expansion of the central canal in syringomyelia interferes with the fibers within the anterior white commissure of the spinal thalamic tract. This leads to the loss of pain, pressure, temperature, and crude touch. As the central canal cavity expands, it damages the lower motor neurons connected to the corticospinal tract, which leads to muscle atrophy, muscle weakness, and paralysis. Syringomyelia usually spares the dorsal column, so sensations of pressure, vibrations, fine touch, and proprioception typically remain intact. Although it sounds nice to not feel pain, this can lead to several problems. One of these is neuropathic arthropathy, or Charcot joints, which is when there's repeated trauma and inflammation in a joint since there's no pain response. In syringomyelia, this is particularly seen in the shoulders. Lastly, the widening spinal canal can also lead to changes in the spine like scoliosis, which is a sideways curvature of the spine. Classically, the destruction of the spinal thalamic tract leads to the bilateral loss of pain and temperature in the upper extremities and back, which is often described as a cape-like distribution, due to the destruction of this tract at the level of the cervical spine, usually C4 to C6. Motor symptoms include weakness, muscle atrophy, and paralysis when lower motor neurons are damaged. Syringomyelia is typically diagnosed using an MRI, which can help visualize the syrinx as well as possible causes like an Arnold-Chiari malformation and spinal tumors. The treatment for syringomyelia depends on the specific cause of the condition, but a surgical intervention is usually needed. If a Chiari malformation is seen on MRI, then a posterior fossa decompression surgery is required. This procedure is a type of craniotomy where a portion of the back of the skull is removed in order to widen the foramen magnum, which helps release the buildup of pressure. If hydrocephalus is present, a shunt to drain the excess fluid within the brain might also be required. Catheters may also be used to drain the syrinx directly. Alright, as a quick recap. Syringomyelia happens when a fluid-filled cavity, or syrinx, develops within the spinal cord, and it's most commonly caused by an Arnold-Chiari II malformation. The expanding cavity interferes with the spinal thalamic tract, which is responsible for pain, pressure, temperature, and crude touch, and results in the loss of these sensations in a cape-like distribution along the arms and back. Syringomyelia is also commonly associated with scoliosis and Charcot joints.
At the neurology department, a 60-year-old male named Oliver is brought in by his son because lately Oliver has become more aggressive, impolite, and he seems to have lost his interest in his family. Recently, he has also started repeating conversations. Next, there's a 72-year-old female named Iris, who is also brought in by her son. Iris is always staying at home because she's embarrassed that she's unable to hold her urine. She also has a hard time finding her things at home because she forgets where she's placed them. Her son has noticed that she's walking strangely, as if her feet stick to the ground. And finally, there's a 35-year-old male named Alistair, who's brought in by his partner because in the past few weeks, he's started repeating conversations and misplacing their belongings. Alistair also has episodes of jerking movements of his left arm, and he's fallen twice in the last few days. His medical history reveals a corneal transplantation 6 months ago. Okay, so all of these people have dementia. Dementia occurs when there's a decline in at least one cognitive function and it impairs daily functioning. Remember that they need to have intact consciousness. Dementia can result from reversible and irreversible causes. Reversible causes include alcohol dependence, hypothyroidism, vitamin B12 deficiency, neurosyphilis, normal pressure hydrocephalus or NPH, and depression. Irreversible causes include Alzheimer's disease, which is by far the most common cause of dementia, vascular dementia, which is the second most common cause, frontotemporal dementia, Lewy body dementia, Parkinson's disease, Huntington disease, and Creutzfeldt-Jakob disease, or CJD. Okay, so let's take a closer look at the irreversible causes of dementia, starting with Alzheimer's disease, which is a very high-yield topic for the exams. In the cell membrane of a neuron, there's a molecule called amyloid precursor protein, or APP. Normally, old APP gets chopped up by two enzymes called alpha secretase and gamma secretase to a soluble peptide. But if another enzyme called beta secretase teams up with gamma secretase instead, then the chopped up fragment isn't soluble, and it creates a monomer called amyloid beta. For the test, remember that these amyloid beta monomers bond together outside the neurons and form beta amyloid plaques. These plaques get between the neurons and impair brain function. Also, it's important to know that amyloid plaque can deposit around blood vessels in the brain, causing amyloid angiopathy, which weakens the walls of the vessels and increases the risk of hemorrhage. Alright, now neurons are held together by their cytoskeleton, which is partly made up of microtubules, which also form tracks along the cells to ship nutrients and molecules. A protein called tau makes sure that these tracks don't break apart. And it's thought that the beta amyloid plaques outside the neuron initiate pathways inside the neuron that lead to activation of kinase, an enzyme that transfers phosphate groups to the tau protein. The tau protein stops supporting the microtubules, gets tangled with other tau proteins, forming neurofibrillary tangles inside the neuron. This makes Alzheimer's disease a tauopathy. Okay, so remember, the tangles are found inside the cell, as opposed to the beta amyloid plaques that are found outside the cells. Neurons with tangles and non-functioning microtubules can't function, and end up undergoing apoptosis. The number of neurofibrillary tangles increases as the disease progresses. In addition, low acetylcholine levels in the nucleus basalis and the hippocampus also contribute to the cognitive symptoms seen in Alzheimer's disease. This is due to impaired activity of an enzyme responsible for acetylcholine synthesis, called choline acetyltransferase in these areas of the brain. Okay, now Alzheimer's disease can either be sporadic or familial. Sporadic is used to describe the late onset type, which is probably a combination of genetic and environmental risk factors, and accounts for a majority of the cases. A gene that's been identified as possibly contributing is the E4 allele of apolipoprotein E gene, or APOE-E4. Apolipoprotein E helps break down beta amyloid, but the E4 allele seems to be less effective than the other alleles, meaning patients are more likely to develop beta amyloid plaques. Okay, now familial Alzheimer's disease is used to describe cases with early onset Alzheimer. This can be caused by several gene mutations and accounts for about 5 to 10% of cases. For example, mutations in the PSEN1 or PSEN2 genes on chromosome 14 or chromosome 1 respectively have been linked to early onset Alzheimer. These genes encode for presenilin 1 and presenilin 2, both protein subunits of gamma secretase. Mutations in these genes change the location where gamma secretase chops up APP, producing different length beta amyloid molecules, which seem to be better at clumping up and forming plaques. Another known genetic cause of Alzheimer is trisomy 21, or Down syndrome. The gene responsible for producing APP is located on chromosome 21, which means that individuals with Down syndrome have an extra APP gene, potentially increasing the amount of amyloid plaque buildup. Next up is vascular dementia, where there's a progressive loss of brain function caused by long-term poor blood flow to the brain. Vascular dementia develops when atherosclerosis starts to form in the arteries supplying the brain, like the internal carotid arteries. This leads to a gradual decrease in blood flow to the brain, which is called chronic ischemia. Sometimes small parts of the plaques can break away and can eventually block a smaller artery, completely stopping the blood supply to the parts of the brain. Other times, the tiny perforating arteries are affected by atherosclerosis and can get completely blocked off by plaque growing within them. Regardless of the cause, once blood supply to the brain falls below the demands of the tissue, it's considered an ischemic stroke. The tissue damage from an ischemic stroke is usually permanent, and the dead tissue liquefies in a process called liquefactive necrosis. Brain tissue necrosis leads to a loss of mental functions governed by that area. Now, if another stroke happens later on, more brain tissue might die off. Over time, this damage gets worse and worse, and the final result is dementia. This is referred to as multi-infarct dementia, and it's a subtype of vascular dementia that you have to remember for your exams. Next is frontotemporal dementia. For the test, remember that frontotemporal dementia refers to atrophy of the frontal lobes that eventually progresses to the temporal lobes, with relative sparing of the parietal and occipital lobes. A high-yield subtype of frontotemporal dementia is Pick disease, which is characterized by the presence of Pick bodies, which are tangles of tau proteins. Tau comes in different isoforms, like the 3R and the 4R isoforms. In Pick disease, 3R isoforms get hyperphosphorylated, change shape, and stop being able to tie together the microtubules in the neuron's cytoskeleton. They also start clumping together, forming tangles. So Pick disease is a tauopathy, like Alzheimer's disease. A key difference is that the tangles in Pick disease are called Pick bodies, and they're only made up of the 3R isoforms, whereas the neurofibrillary tangles in Alzheimer's disease are made up of both 3R and 4R tau isoforms. Now, neurons with loads of tangles and non-functioning microtubules don't function well, and the neurons undergo apoptosis. Okay, so next is Lewy body dementia. The underlying cause of Lewy body dementia isn't well understood. Normally, neurons contain a protein called alpha-synuclein, and in Lewy body dementia, this protein gets misfolded within the neurons. The misfolded alpha-synuclein aggregates to form Lewy bodies that deposit inside neurons, particularly in the cortex and the substantia nigra. Under a microscope, Lewy bodies look like dark eosinophilic inclusions inside the affected neurons. As the disease progresses, more and more neurons accumulate Lewy bodies and die. The significance of Lewy bodies, however, is unknown, but remember that they're also seen in other diseases, like Parkinson's disease. Alright, now Parkinson's disease can also cause dementia. This is a slowly progressive genetic disorder that primarily affects individuals over 50 years old. It's characterized by the loss of dopamine-producing or dopaminergic neurons in the substantia nigra, which is a part of the basal ganglia. Normally, within the basal ganglia, there's a balance between dopamine, which promotes movement, and acetylcholine, which inhibits movement. In Parkinson's disease, the loss of dopaminergic neurons results in less movement, difficulties in speech and swallowing, as well as cognitive symptoms like dementia in the later stages of the disease. Next, there's Huntington's disease, which is very high yield. So Huntington's disease is an autosomal dominant neurodegenerative disorder that typically affects individuals around 40 years of age. It's caused by a mutation in the Huntington disease or HD gene on chromosome 4. This gene contains a CAG trinucleotide repeat, which encodes for the amino acid glutamine. The gene encodes for a protein called huntingtin. The mutated protein aggregates within the neuronal cells of the caudate and putamen of the basal ganglia, causing neuronal cell death. So the caudate and the putamen of the basal ganglia are the areas of the brain affected in Huntington's disease. The brain regions affected by Huntington's disease have decreased GABA and acetylcholine and increased dopamine levels. There's also excessive activation of a subtype of glutamate receptors called NMDA receptors that leads to glutamate excitotoxicity, a process by which neurons are damaged. Over time, if enough neurons die in the caudate and putamen, which together form the dorsal striatum, this can cause actual loss of brain tissue volume in these areas, which can expand to the lateral ventricles. These areas of the brain play an important role in movement, particularly inhibiting it, and that's why Huntington's disease causes movement problems like chorea and athetosis. But they also have cognitive symptoms like dementia. Now, another high-yield concept about Huntington's disease is a phenomenon called anticipation, which is where there's an increased number of trinucleotide repeats in subsequent generations. This leads to an earlier onset and more severe presentation of the disease. This process of adding more repeats is called repeat expansion. It happens way more in the production of sperm than eggs, and so anticipation generally occurs when the biological father is the affected parent. Finally, a rare cause of dementia is Creutzfeldt-Jakob disease, or CJD. CJD is the most common cause of spongiform encephalopathy, and it's a high-yield topic for your exams. Spongiform encephalopathy refers to a group of neurodegenerative diseases caused by the accumulation of infectious misfolded proteins, called prions. Misfolded means that they change from having mostly alpha helices to having a lot of beta-pleated sheets. And so, they become resistant to being broken down by proteases. When a misfolded prion protein enters a neuron, it induces a misfolding of the normal prion proteins found inside the cell. As a result, prions accumulate within the neuron and trigger apoptosis with the help of an intracellular 14-3-3 protein. When large numbers of neurons die, the brain gets replaced by cysts, making it look like a sponge. That's why these diseases are called spongiform encephalopathies. Now, there are actually 4 types of CJD: familial, or FCJD, variant, or VCJD, iatrogenic, or ICJD, and sporadic, or SCJD. Familial Creutzfeldt-Jakob disease occurs when there is a mutation in the PRNP gene, which encodes for the prion protein. Variant Creutzfeldt-Jakob disease is caused by eating the meat of cows with prions in the muscle tissue. In cows, these prions cause bovine spongiform encephalopathy, which is more commonly called mad cow disease. When sheep are fed cow meat, the prion causes the disease scrapie. If a person eats the meat of affected cows or sheep, the prions get absorbed through the intestines into the bloodstream. The protein can somehow get through the blood-brain barrier and then enters neurons by a process called absorptive endocytosis. Absorptive endocytosis is a process where the plasma membrane of the nerve cell folds inwards to bring in substances that otherwise would not be able to cross the plasma membrane by themselves. Iatrogenic Creutzfeldt-Jakob disease is caused by medical procedures, like a corneal transplant, where the transplanted organ or the instruments gets contaminated by prions. Finally, there's sporadic Creutzfeldt-Jakob disease, which pops up in populations randomly without a clear cause. Now let's quickly go over the reversible causes of dementia. Common ones include chronic alcohol use, hypothyroidism, vitamin B12 deficiency, or tertiary syphilis. Another important reversible cause is depression, and cognitive impairment due to depression is referred to as pseudodementia. A key finding in pseudodementia is that individuals are often anxious about their memory impairment, as opposed to other causes of dementia like Alzheimer's disease. A very high-yield reversible cause of dementia is normal pressure hydrocephalus, or NPH. NPH typically occurs in the elderly, so it's often misdiagnosed as Alzheimer's disease. It's caused by abnormal venous drainage of the cerebrospinal fluid, resulting in hydrocephalus. Since the frontal lobe is the most affected, individuals with NPH usually present with urinary incontinence and gait disturbance at first, and then dementia. Now let's switch gears and talk about clinical presentation. Although all these disorders can cause dementia, many of them also cause other symptoms that will be key clues for the correct diagnosis. But before that, let's take a look at how dementia typically presents. Most of the time, a close family member or friend notices the individual's change in cognition. This includes impaired memory, which leads to repeating conversations or misplacing belongings. Language impairment can make it hard to think of common words. Additionally, concentration and executive function are impaired, so individuals have a hard time with complex tasks like managing their finances. Visual spatial impairment can prevent them from recognizing faces and navigating in familiar locations. Sometimes, family members also notice changes in the individual's personality. Okay, now there are specific symptoms that can help you identify the different causes of dementia. For the exams, remember that Alzheimer's disease has an insidious onset and gradual progression. Individuals usually go through 3 phases. First is the asymptomatic phase. Second is a pre-dementia phase called mild cognitive impairment, during which there's gradual onset of memory impairment without much impairment in other cognitive domains, and no impairment in daily functioning. This differs from normal aging because the memory impairment is greater than expected for the individual's age. The third phase is the dementia phase, and that's where individuals develop more significant memory loss, followed by slow, gradual loss of the other cognitive functions, such as language, visuospatial, and executive functions. Now, there are 2 main types of memory: episodic memory, which is memory of events, and semantic memory, which is memory of words and vocabulary. Early on, episodic memory is impaired, but semantic memory remains intact. Later on, both episodic and semantic memory get impaired. Episodic memory can be subclassified into immediate, recent, or long-term. Immediate memory is sometimes called procedural memory, and it's the memory you use to repeat back a phone number right away. Recent memory is the memory you use to remember a list of 3 words 5 minutes later, like those 3 words from earlier. This is a type of memory that's impaired early on in Alzheimer's disease because the disease affects the hippocampus first, which is responsible for recent memory. Long-term memory is a memory of events that have occurred years ago, and these aren't impaired until late in the course of this disease. For example, an individual with Alzheimer's may remember details of their wedding 50 years ago, but they won't be able to remember where they were yesterday. Now, symptoms of vascular dementia vary depending on which region of the brain is damaged. For example, if someone has strokes in the temporal lobe, it might be difficult for them to remember things or make new memories. Someone with a stroke in the left parietal lobe might lose the ability to speak, which is called an aphasia. But then if they get another stroke in the frontal lobe, their personality might begin to change. One thing that's constant is that the symptoms of dementia appear suddenly, and brain function decreases with each stroke. Another characteristic finding in vascular dementia is that individuals have neurological deficits which correspond to the region of the brain that's affected by the stroke. They can also have other manifestations of atherosclerosis, like coronary artery disease, and other comorbidities that increase the risk of stroke, like hypertension and diabetes. Now, in multi-infarct dementia, there's a characteristic stepwise decline in cognitive function. For example, the individual develops a stroke, and then, as a consequence, demonstrates a sudden decline in their memory. Then, in between stroke events, there is no progression of their cognitive dysfunction until another stroke occurs, and they suddenly lose another cognitive domain, such as language, and so on. This pattern, alongside a temporal relation to the stroke, is what differentiates it from Alzheimer's disease, where the decline in cognitive function is steady and gradual. Also, unlike in Alzheimer's disease, where recent memory is usually lost first, the pattern of cognitive decline in vascular dementia varies depending on which area was infarcted. Individuals with frontotemporal dementia usually present before the age of 65. And it's very important to remember for the test that early on, they have behavioral symptoms, with relative sparing of memory defects. These symptoms include personality changes, impaired judgment, apathy, and disinhibition. They also have perceptual motor functional loss, meaning individuals struggle with things like hand-eye coordination or body-eye coordination. There are two variants of frontotemporal dementia. In the behavioral variant, first, there are 3 or more of the following 5 symptoms: disinhibition, apathy or inertia, loss of sympathy or empathy, stereotyped compulsive or ritualistic behavior, hyperorality, which is when people put inappropriate objects in their mouth, and dietary changes. And second, there's a decline either in social cognition or in executive abilities, which are a set of skills necessary to adapt to the environment and to achieve goals. The language variant is when there's a prominent decline in language skills, or aphasia. Individuals have difficulty in speech production, word finding, object naming, grammar, or word comprehension. Okay, now 2 very similar types of irreversible dementia syndromes are Lewy body dementia and Parkinson's disease dementia. Both include dementia and Parkinsonism, a term used to describe the movement disorder in both diseases. The symptoms of Parkinsonism can be remembered with the mnemonic TRAP: T for tremor, R for rigidity, A for akinesia or bradykinesia, which is absence or slowness of movement, and P is for postural instability. Lewy body dementia is distinct from dementia secondary to Parkinson's disease in that the onset of dementia occurs before the onset of motor symptoms, and this takes place less than 1 year apart. In Parkinson's disease, motor symptoms develop first, and it can take many years before the onset of dementia. Other features of Lewy body dementia include recurrent episodes of having vivid visual hallucinations, and fluctuating episodic deficits in attention and alertness, which may be confused with delirium. In addition, individuals with Lewy body dementia can have sleep behavior disorder, where individuals move a lot while sleeping. Okay, now in contrast to Parkinsonism, individuals with Huntington's disease often have chorea, which are involuntary, random, rapid, dance-like movements, or athetosis, which are slower, writhing, snake-like movements that mainly affect the hands. They can also have psychiatric symptoms like depression, psychosis, or aggressive behavior. Death usually occurs within 10 to 20 years of diagnosis, often by aspiration pneumonia on account of discoordinated swallowing, or by suicide. For the test, remember that individuals with CJD have a long incubation period, but after the onset of symptoms, individuals develop rapidly progressive dementia within weeks to months. It's also classically associated with ataxia, which is defined as lack of coordination of voluntary movements, and myoclonus, a jerking movement of a muscle group. Hiccups are an example of myoclonus. In CJD, the myoclonus is usually generalized and can be triggered when the person is startled, and that's why it's referred to as startle myoclonus. CJD eventually leads to death since there's currently no cure. Finally, for NPH, remember that it affects the elderly and symptoms can appear over a month and presents with dementia, urinary incontinence, and gait disturbances. Their gait is described as magnetic because it seems like the person's feet are glued to the ground. Alright, now let's move on to diagnosis. The Montreal Cognitive Assessment, or MoCA, or the Mini Mental Status Examination, or MMSE, can be done to assess orientation, registration, recall, attention, and language. For your exams, it's helpful to remember how each of these cognitive domains is assessed. For example, orientation is assessed by asking individuals what time it is, where they are, or who the president is. Registration is assessed by telling the individual 3 words, like dog, table, and cake, then asking them to repeat it immediately. Then they're asked to repeat those 3 names 5 minutes later, which assesses recall, or short-term memory. Long-term memory is assessed by asking the individual details about significant events in his or her life. For example, the date of their marriage. Attention, or concentration, can be assessed by asking the individual to spell a word backwards, or recite the months of the year backwards. Language is tested by asking the individual to name presented objects, or repeat a phrase. Additionally, individuals are asked to obey a command written on a piece of paper, such as pick up the pen on the table. Comprehension is assessed by asking the individual to follow a 3-step command, such as take this paper, fold it in half, and place it on the table. Finally, individuals are asked to write a sentence and copy an illustration, such as a pentagon. The MMSE totals to 30 points, and a score of less than 24 implies cognitive impairment, which may suggest delirium or dementia. A very high-yield concept is how to differentiate the two. Delirium is usually acute in onset, lasts only a couple hours to days, and the cognitive symptoms fluctuate, meaning they come and go. On the other hand, dementia is usually gradual in onset, lasts months to years, and the cognitive symptoms usually progress over time. Also, consciousness and awareness are always impaired in delirium. However, they are only impaired in the later stages of dementia. Additionally, delirium always occurs as a direct physiological consequence in the event of acute insult, such as an infection, electrolyte imbalance, change in medication or intoxication, or due to a psychiatric condition like schizophrenia or depression. Now, after the diagnosis of dementia is made, it's important to find out if the cause of dementia is reversible, so treatment can be started before permanent damage occurs. So, it's helpful to send off TSH levels for hypothyroidism, vitamin B12 levels to assess for a deficiency, and a rapid plasma reagent test, or RPR, for syphilis. For NPH, a brain MRI shows ventriculomegaly of all the ventricles, a patent cerebral aqueduct, and no signs of cortical atrophy. As suggested from the name, a lumbar puncture will show a normal opening pressure. Okay, now on to the irreversible causes of dementia. The presumptive diagnosis of Alzheimer's disease is made clinically, and investigations are done to exclude other causes of dementia. For your exams, it's important to know that even in these early stages, a brain CT or MRI can show hippocampal atrophy that can progress to diffuse cortical atrophy. As the brain atrophies, or shrinks, the gyri get narrower and the sulci get wider, and the ventricles get larger. Enlargement of the ventricles due to brain atrophy is referred to as ex vacuo ventriculomegaly. A brain biopsy showing extracellular amyloid plaques that stain with Congo red and intracellular neurofibrillary tangles is the only investigation that would definitively diagnose Alzheimer's disease. But that usually isn't done until there's an autopsy after death. Vascular dementia can be diagnosed using brain imaging, most commonly CT or MRI, which will show multiple cortical and subcortical infarcts and changes like atrophy of the brain cortex, confirming the ischemia. Diagnosis of frontotemporal dementia is also based on a brain CT or MRI of the brain, which shows atrophy of the frontal and temporal lobes with narrower gyri, wider sulci, and ex vacuo ventriculomegaly. The parietal and occipital lobes are typically spared. Diagnosis of Lewy body dementia is based on the pattern of symptoms. Onset of dementia less than 1 year after Parkinsonism, along with vivid visual hallucinations, indicates Lewy body dementia. But the diagnosis of Lewy body dementia can only be confirmed with a brain autopsy that shows Lewy bodies in the neurons. Now, to diagnose Parkinson's disease dementia, you first need to diagnose Parkinson's disease. This requires the presence of bradykinesia in addition to one of the other trap symptoms, and ruling out other potential causes. However, the diagnosis can be confirmed with a brain autopsy that shows Lewy bodies in neurons, like in Lewy body dementia, and also the presence of depigmented dopaminergic neurons in the substantia nigra. Huntington disease should be suspected in an individual around 40 years of age with dementia, movement disorders like chorea and athetosis, and psychiatric symptoms. The combination of these features in a young individual can be mistaken for substance abuse. Family history of a first-degree relative with Huntington disease is a very important clue. The diagnosis is confirmed using polymerase chain reaction of the HD gene, which shows the CAG repeats. MRI imaging of the brain characteristically shows atrophy of the caudate and putamen and ex vacuo ventriculomegaly. On a brain MRI, CJD classically shows enhancement of the basal ganglia and thalamus, and EEG shows periodic bursts of high-voltage sharp waves. The combination of the clinical presentation and these investigations is usually sufficient to diagnose CJD. If a lumbar puncture is done, there may be elevation of protein 1433. Ultimately, the definitive diagnosis of spongiform encephalopathy is done after a person dies with a brain biopsy. Brain biopsy shows intracytoplasmic vacuoles that transform into cysts, giving the characteristic spongy appearance of the gray matter. Okay, now let's discuss treatment. The good news is that reversible causes can be treated and the dementia will usually go away. Alcohol dependence can be treated with medications like acamprosate, disulfiram, and naltrexone. Hypothyroidism can be treated with thyroid hormone replacement. Vitamin B12 deficiency is treated with vitamin B12 supplementation. And syphilis is treated with penicillin. The treatment for NPH is placing a ventriculoperitoneal shunt, which drains the excess cerebrospinal fluid. However, although placement of a ventriculoperitoneal shunt helps improve walking, it doesn't always improve cognition. Now, about the irreversible causes. Low acetylcholine levels contribute to Alzheimer's disease, and so cholinesterase inhibitors like donepezil, rivastigmine, and galantamine can be used for treatment since they increase cholinergic transmission at the synaptic cleft. In individuals that can't tolerate cholinesterase inhibitors, NMDA receptor antagonists, like memantine, can be used. These medications don't slow the progression of the disease, but they do help mitigate some of the cognitive and behavioral symptoms like forgetting family members or personal info, making day-to-day life relatively easier for affected individuals. Finally, depression is common in all types of dementia, but especially in Alzheimer's disease, and selective serotonin reuptake inhibitors, or SSRIs, are an effective treatment option for behavioral symptoms, although they don't improve cognition. Unfortunately, there is no available treatment that can help reverse vascular dementia. Instead, treatment mainly focuses on preventing another stroke from happening. This includes blood pressure, diabetes, and cholesterol control, lifestyle modification, such as exercise, dietary changes, and smoking cessation, as well as starting antiplatelet agents like aspirin. In vascular dementia, the evidence is mixed for the cholinesterase inhibitors, but they're often prescribed because of the frequent co-occurrence of cerebrovascular and neurodegenerative disease. There is no current treatment available that will help delay the progression of frontotemporal dementia. However, selective serotonin reuptake inhibitors can help with the behavioral symptoms, and atypical antipsychotics can be used for the psychosis. Okay, now in Lewy body dementia, treatment is aimed at alleviating motor symptoms. These symptoms respond to drugs used to treat Parkinson's disease, like levodopa, a dopamine agonist. However, individuals with Lewy body dementia are dopamine sensitive, meaning that dopamine agonists can cause them to have hallucinations, agitation, and confusion. This unique reaction is also a clue that the person has Lewy body dementia. Also, although it might be intuitive to give antipsychotics like haloperidol or risperidone for the visual hallucinations, these medications should be avoided in Lewy body dementia as they can worsen Parkinsonism. Now for Parkinson's disease dementia, rivastigmine, which is a cholinesterase inhibitor used for Alzheimer's disease, is approved along with the medications used for Parkinson's disease, like carbidopa-levodopa, and dopamine agonists like pramipexole and ropinirole. These will help motor symptoms, but will not reverse or slow the course of the disease. As for Huntington's disease, there is no treatment that affects overall survival. However, medications that decrease dopamine levels, like the neuroleptics, which are dopamine receptor antagonists, and tetrabenazine, which deletes dopamine, are used to treat chorea. Unfortunately, there's no current treatments for CJD, and so prevention of transmission is a key management strategy of the disease. Alright, as a quick recap, dementia occurs when there's a decline in cognitive domain like memory, language, or executive function, causing impairment in daily functioning. Dementia can result from reversible causes like alcohol dependence, hypothyroidism, vitamin B12 deficiency, neurosyphilis, and NPH. But it usually results from irreversible causes, such as Alzheimer's disease, which is by far the most common cause of dementia, vascular dementia, frontotemporal dementia, Parkinson's disease dementia, Lewy body dementia, Huntington disease, and Creutzfeldt-Jakob disease. Dementia can be diagnosed based on symptoms, clinical tests like the Montreal Cognitive Assessment or the Mini Mental Status Examination. The causes can be identified by symptoms specific to the disease, imaging tests like brain CT or MRI, and more definitive tests like a brain biopsy during an autopsy. Okay, back to the patients. So, Oliver, due to his age and the history of behavioral symptoms with relative sparing of memory, most likely has frontotemporal dementia. Diagnosis can be confirmed with a brain CT or MRI showing atrophy of the frontal and temporal lobes. Iris has a characteristic triad of NPH, urinary incontinence, magnetic gait, and dementia. Brain MRI will show enlarged ventricles with no signs of cortical atrophy. Also, a lumbar puncture will reveal normal opening pressure. Fortunately, NPH can usually be reversed by placing a ventriculoperitoneal shunt. Finally, due to Alistair's young age, history of rapidly developing dementia along with myoclonus and ataxia, and history of corneal transplantation, Alistair most likely has iatrogenic Creutzfeldt-Jakob disease.
Dementia isn't technically a disease, but more of a way to describe a set of symptoms like poor memory and difficulty learning new information, which can make it really hard to function independently. Usually dementia is caused by some sort of damage to the cells in the brain, which can be caused by a variety of diseases. Alzheimer's disease, now referred to as Alzheimer's disease, is the most common cause of dementia. Alzheimer's disease is considered a neurodegenerative disease, meaning it causes the degeneration or loss of neurons in the brain, particularly in the cortex. This, as you might expect, leads to the symptoms characteristic of dementia. Although the cause of Alzheimer's disease isn't completely understood, two major players that are often cited in its progression are plaques and tangles. Alright, so here we've got this cell membrane of a neuron in the brain. In the membrane, you've got this molecule called amyloid precursor protein, or APP. One end of this guy's in the cell, and the other end's outside the cell. It's thought that this guy helps the neuron grow and repair itself after an injury. Since APP is a protein, just like other proteins, it gets used and over time it gets broken down and recycled. Normally, it gets chopped up by an enzyme called alpha secretase and its buddy, gamma secretase. This chopped up peptide's soluble and goes away, and everything's all good. If another enzyme, beta secretase, teams up with gamma secretase instead, then we've got a problem. And this leftover fragment isn't soluble and creates a monomer called amyloid beta. These monomers tend to be chemically sticky and bond together just outside the neurons, and form what are called beta amyloid plaques, these clumps of lots of these monomers. These plaques can potentially get between the neurons, which can get in the way of neuron-to-neuron signaling. If the brain cells can't signal and relay information, then brain functions like memory can be seriously impaired. It's also thought that these plaques can start up an immune response and cause inflammation, which might damage surrounding neurons. Amyloid plaque can also deposit around blood vessels in the brain, called amyloid angiopathy, which weakens the walls of the blood vessels and increases the risk of hemorrhage, or rupture and blood loss. Here's an image of amyloid plaque on histology. These clumps are buildups of beta amyloid, and this is happening outside the cells. Another big part of Alzheimer's disease, though, are tangles, and these are actually found inside the cell, as opposed to the beta amyloid plaques. Just like other cells, neurons are held together by their cytoskeleton, which is partly made up of microtubules, these track-like structures that essentially act like a minecart shipping nutrients and molecules along the length of the cell. A special protein called tau makes sure that these tracks don't break apart, kind of like railway ties. Although, again, it's not completely understood, it's thought that the beta amyloid plaque buildup outside the neuron initiates pathways inside the neuron that leads to activation of kinase, an enzyme that transfers phosphate groups to the tau protein. The tau protein then changes shape, stops supporting the microtubules, and clumps up with other tau proteins and gets tangled, and leads to the other characteristic finding of Alzheimer's disease, neurofibrillary tangles. Neurons with tangles in non-functioning microtubules can't signal as well, and sometimes end up undergoing apoptosis, or programmed cell death. Here's an image of histology showing these neurofibrillary tangles formed inside the neuron. As neurons die, large-scale changes start to take place in the brain. For one, the brain atrophies, or shrinks, and the gyri get narrower, which are the characteristic ridges of the brain. As those get narrower, the sulci, which are the grooves between the gyri, get wider. With atrophy, the ventricles, or fluid-filled cavities in the brain, get larger as well. So that's the pathophysiology part. But why does this happen in some people and not others? Well, Alzheimer's disease can be split into two groups, sporadic and familial. Sporadic's used to describe the late onset type where the exact cause isn't very well defined, and is probably a combination of genetic and environmental risk factors. And sporadic accounts for the vast majority of cases. With sporadic Alzheimer's, the risk increases significantly with age, affecting around 1% of people between ages 60 and 65, and 50% of people over the age of 85. In fact, a gene that's been identified as possibly contributing to an increased risk of Alzheimer's disease is the E4 allele of apolipoprotein E gene, or APOE-E4. Researchers have shown that the risk of developing Alzheimer's disease increases for patients that inherit one E4 allele, and increases even more for patients who inherited two E4 alleles, one from each parent. Apolipoprotein E helps break down beta amyloid, but the E4 allele seems to be less effective than the other alleles, like the APOE2 allele, meaning patients are more likely to develop beta amyloid plaques. Familial Alzheimer's disease, on the other hand, is used to describe cases where some dominant gene was inherited that speeds up the progression of the disease. So sometimes familial Alzheimer's disease is referred to as early onset Alzheimer's. Familial accounts for about 5 to 10% of cases and can be caused by several gene mutations. First, mutations in the PSEN1 or PSEN2 genes on chromosome 14 or chromosome 1, respectively, have been linked to early onset Alzheimer's. These genes encode for presenilin 1 and presenilin 2, both protein subunits of gamma secretase. Mutations in these PSEN1 or PSEN2 genes can change the location where gamma secretase chops APP, producing different length beta amyloid molecules, which seem to be better at clumping up and forming plaques. Another known genetic cause of Alzheimer's is trisomy 21, or Down syndrome, which involves an extra copy of chromosome 21. It turns out that the gene responsible for producing APP is located on chromosome 21, which means that people with Down syndrome have an extra APP gene, and presumably increased expression of APP, potentially increasing the amount of amyloid plaque buildup. For this reason, familial Alzheimer's disease often progresses by age 40 in patients with Down syndrome. Symptoms of Alzheimer's disease worsens as plaques and tangles build up and damage to the neurons accumulates. In the early stages, symptoms might not even be detectable. As it progresses, though, patients lose short-term memory, like, for example, they might not be able to remember what they had for breakfast that morning. They then progress to loss of motor skills, making things like eating difficult without help. Also, language becomes affected, making it more difficult to communicate. Eventually, they lose long-term memory, like forgetting the name of their spouse or even that they're married in the first place. And they progressively become more disoriented, which can be dangerous because they might wander from home and get lost. In the late stages, they become bedridden, and the most common cause of death is actually infection, like pneumonia. Diagnosis of Alzheimer's disease is really tough because the only way to definitively show that a person had Alzheimer's is by performing a brain biopsy after autopsy. Usually, a clinician will therefore make a diagnosis after excluding other causes of dementia. Currently, there isn't any cure for Alzheimer's disease. Some medications exist, but the benefits are small, and there haven't been any medications that clearly and definitively halt the progression of Alzheimer's. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media.
Delirium is a transient and reversible condition characterized by an acute change in consciousness and cognition, as well as a decreased ability to maintain or shift attention. Delirium is usually seen in older patients and is always associated with some underlying condition or trigger. The mnemonic "Pinch Me" can help you remember the most common causes of delirium, which include pain, infection, constipation and urinary retention, hydration, medications and substances, and finally, environmental triggers. Now, if a patient presents with signs and symptoms suggestive of delirium, you should first perform an ABCDE assessment to determine if they are unstable or stable. If unstable, stabilize their airway, breathing, and circulation. Next, obtain IV access, and if needed, provide supplemental oxygen to maintain saturation above 90%. Finally, put your patient on continuous vital sign monitoring, including heart rate, blood pressure, and oxygen saturation. Now, let's go back to the ABCDE assessment and discuss stable patients. First, perform a focused history and physical. Most often, patients are over 65 years old and might have a history of neurologic conditions like dementia or Parkinson's disease. They may present with acute hallucinations, while family members or caregivers often report that the patient has been exhibiting unusual behavior. Physical examination might reveal hyperactive delirium with signs like agitation, restlessness, and combativeness. However, some patients might present with hypoactive delirium with signs like drowsiness, apathy, withdrawal, or diminished speech. Finally, some patients can have mixed delirium, switching between hyperactive and hypoactive signs throughout the day. No matter what type of delirium your patient has, keep in mind that these findings must represent an acute change from baseline, with a fluctuating course described as waxing and waning. If that's the case, you should suspect delirium. Now here's a clinical pearl to keep in mind. Delirium is a diagnosis of exclusion. In other words, there are no laboratory or imaging methods that can confirm the diagnosis. So be sure and rule out other conditions that can mimic manifestations of delirium. Ask about neurologic symptoms, such as slurred speech and new onset weakness, and examine your patient for focal neurologic signs, such as expressive aphasia and hemiparesis, because these findings are suggestive of an acute neurologic event. Now that you suspect delirium, you should confirm the diagnosis using a validated metric, such as the Confusion Assessment Method, or CAM. Diagnosis requires the presence of an acute and fluctuating change in mental status, poor attention span, and evidence of either disrupted thought processes or alteration in consciousness. If your patient doesn't meet these criteria, the CAM is negative, so consider an alternative diagnosis. On the other hand, if the criteria are met, the CAM is positive, so you can diagnose delirium. Now that you've diagnosed delirium, the next step is to assess the patient's risk of harm to themselves and others. Patients at low risk will generally present with hypoactive signs of delirium and should generally receive non-pharmacologic management. This includes reducing the dose or discontinuing medications known to have CNS side effects, like opioids, as well as frequent mobilization and orientation improvement, like providing a clock and calendar so they can keep track of the time and date. Next, ensure proper nutrition and hydration, encourage good sleep hygiene, and minimize sensory deprivation with vision and hearing aids. On the other hand, patients at high risk of harming themselves and others will generally display hyperactive signs of delirium. These individuals could also try to remove catheters and tubes, and they might even try to leave the hospital. In this case, start with non-pharmacologic management, including redirection and extra staff attention like a one-to-one sitter. Additionally, consider pharmacologic management with haloperidol or second-generation antipsychotic like olanzapine. Haloperidol is generally a preferred agent since it's associated with lower risk of side effects, primarily hypotension and oversedation. But keep in mind that haloperidol is contraindicated in individuals with prolonged QT interval or neurologic conditions like Parkinson's disease and Lewy body dementia. After initiating management, you should assess the underlying cause. Cover the most common causes of delirium using the Pinch Me mnemonic. To get started, order labs, including a CBC and CMP. First, let's start with pain. These patients usually report severe pain or have a potential source of pain, like recent surgery or trauma. Sometimes your patient could present with hypoactive delirium and diminished speech. Look for indirect signs of pain, such as grimacing, clenching of the jaw, moaning and groaning, as well as guarding of the affected body part. In this case, consider poorly controlled pain as a cause of delirium, and be sure to optimize pain control by adjusting doses or switching to alternative medications. Next up are infections. In these individuals, history reveals fever and chills, typically in combination with more specific symptoms associated with the infectious source, like cough or dysuria. On the other hand, physical exam might show abnormal lung sounds or suprapubic tenderness, while labs usually reveal leukocytosis. At this point, you should suspect infection and order further testing to evaluate. This includes sputum or urine cultures, urinalysis, as well as imaging like a chest X-ray. Next, follow up on the tests you've ordered. If the urinalysis shows white blood cells, leukocyte esterase and nitrates, and urine cultures are positive, then diagnose urinary tract infection and start appropriate antibiotics. On the other hand, if the sputum culture is positive or the chest X-ray shows new infiltrate or consolidation, diagnose pneumonia and start appropriate antibiotics. Next up are constipation and urinary retention. These are commonly overlooked causes of delirium since they are usually associated with nonspecific history and physical exam findings. History may include hard or infrequent stool, frequent small urine voids, or symptoms of BPH, and history of medications known to cause constipation or urinary retention. Physical exam may reveal fecal impaction or the presence of a functional disability. In these patients, consider constipation or urinary retention as possible triggers of delirium. So make sure to review the patient's medication list to stop any possible cause, and proceed with a bowel regimen or bladder catheterization. Moving on to hydration. Let's suppose that your patient exhibits physical exam findings of dehydration, like dry mucous membranes, poor skin turgor, or labs showing low sodium or calcium levels, or even high sodium or calcium levels. These findings suggest dehydration and electrolyte imbalance as possible triggers for delirium. So optimize hydration and correct the underlying electrolyte imbalance. Next up are medications and substances. If your patient presents after recent use of alcohol or an illicit substance, order a serum alcohol level and a urine toxicology screen. Positive results are highly suggestive of delirium due to intoxication. The management includes supportive care and monitoring of the patient until the intoxication subsides. On the other hand, if your patient presents with hypertension or tachycardia and has a history of long-term alcohol or substance use, but no recent alcohol or substance use, suspect withdrawal syndrome, especially from alcohol or benzodiazepines. Again, order a serum alcohol level and urine toxicology screen. Negative results are highly suggestive of delirium due to withdrawal syndrome rather than acute intoxication. In this case, the management includes supportive care and monitoring of the patient until the withdrawal subsides, including giving benzodiazepines if delirium tremens is present. Now, some patients can have no history of recent or long-term alcohol or substance use, but have a positive history of use of medications with known CNS side effects, such as benzodiazepines, opiates, and anticholinergics. These patients might have medication-induced delirium, so discontinue the causative medication, adjust dosing, or switch to an alternative option. Finally, we have environmental triggers. If your patient is in the ICU, has had recent major surgery, or has recently been administered anesthesia or sedation, consider environmental triggers as a cause of delirium. Management consists of creating a more structured environment, like reducing exposure to noise, improving daytime light, and reducing nighttime light, and promoting sleep. Now, here's a clinical pearl. One important cause of delirium is azotemia, which is commonly seen in individuals with acute kidney injury. These individuals usually present with elevated BUN and creatinine levels, as well as oliguria or anuria. Additionally, there could be a positive history of use of nephrotoxic medications such as NSAIDs. And here's another clinical pearl. No matter what the underlying cause of delirium, once it's been addressed, the patient should be monitored until they reach baseline mental status and receive the necessary supportive care measures. All right, as a quick recap, delirium is a syndrome characterized by an acute change in attention, consciousness, and cognition, as well as a decreased ability to focus or to maintain or shift attention. If you suspect delirium, use the confusion assessment method to rule out or confirm the delirium. Once you diagnose delirium, assess the patient's risk of harm to themselves and others. Patients at low risk require non-pharmacologic management, such as reducing or discontinuing a medication with CNS side effects, frequent mobilization, orientation improvement, proper nutrition and hydration, as well as good sleep hygiene and minimizing sensory deprivation. On the flip side, patients at risk of harm to themselves and others may require pharmacologic management with haloperidol or a second-generation antipsychotic. Next, you should assess the underlying cause of delirium. Use the pinch me mnemonic to cover the most common causes, which include pain, infections, constipation and urinary retention, hydration, medications and substances, and environmental triggers.
Delirium is a common and very serious neuropsychiatric syndrome. Typically, it affects older patients with multiple medical problems. In fact, up to half of all elderly patients in the hospital will have an episode of delirium at some point. But that being said, it can affect anyone, even children, even though that's much less common. So what is delirium exactly? Let's look at a quick example. Let's say that there's an elderly man with diabetes and heart disease who comes into the hospital with pneumonia. He might be slowly recovering, even about to go home, and then one evening things change all of a sudden. He might get really hyperactive, and by that I mean that he might get agitated or aggressive with the staff, mumble or say things incoherently, and have disorganized thoughts or even delusions, maybe talking about things that haven't happened or happened years ago. He might even hear or see things like hallucinations, and not know where he is or what he's doing there. We would call this an episode of delirium, and it can be really scary for him or someone who's taking care of him, especially the first time it happens because it can come out of the blue. These are the symptoms of what we call hyperactive delirium, but there's also hypoactive delirium, which is like the flip side of this coin. As an example, you might have a woman with a history of chronic constipation who's recently come out of back surgery. If she has hypoactive delirium, she might feel suddenly sluggish and drowsy, less reactive and sullen, and might look withdrawn, maybe because she's scared of having hallucinations. These symptoms of both hyperactive and hypoactive delirium can start pretty suddenly and can happen off and on over the course of a few hours to a few days, with some patients having what they call a mixed state delirium, where they're sometimes having hyperactive symptoms and sometimes having hypoactive symptoms. As you might guess, delirium symptoms can be really tiresome for a patient, and can make them sleepy during the day and keep them up at night, all of which causes massive disruption to the patient's life and to the lives of their friends and family. Even though this sounds pretty hard to miss, delirium can often go unnoticed or confused with other conditions like dementia, which has some similarities. To help distinguish delirium from dementia, there are some key differences to keep in mind. Unlike delirium, where the symptoms can start pretty suddenly, patients with dementia typically have a slow mental decline over months to years. Early on, dementia patients are also generally alert, oriented, and have normal behavior, and don't have hallucinations. The good news is that, unlike dementia, delirium is usually temporary, resolving when the underlying cause is addressed promptly. Delirium can sometimes resolve within hours to days, but in other cases it takes weeks or months to fully resolve. So what causes delirium? Well, the exact mechanism isn't well understood, and unlike a lot of diseases, there probably is no single cause. But we do have a lot of clues, and these come from understanding the risk factors for getting delirium in the first place. Patients who've had recent surgery are often at risk for delirium, and it might be related to the effects of certain medications, like narcotic pain medication, benzodiazepines, hypnotics, and anticholinergics, as well as the underlying diseases and chronic fatigue from not sleeping well in the hospital. Since delirium can also cause trouble sleeping, losing sleep can turn into a dangerous cycle that can really worsen the symptoms. There are a number of risk factors related to the person's general health as well. For example, elderly patients with multiple medical problems, especially ones like dementia, constipation, pneumonia, and urinary tract infections, are at high risk of having delirium. But even though we know these risk factors, there isn't a specific pathophysiologic mechanism that explains delirium that we know of. Currently, we only have theories. One theory is looking at whether the overall level of neurotransmitters like acetylcholine, dopamine, norepinephrine, and glutamate might cause delirium. Another theory is how the neuronal membrane might not be able to depolarize properly in delirium, and therefore can't transmit an action potential from one neuron to another. A third theory suggests that it might also have to do with the inflammatory cytokines that are released during an infection or trauma that might interfere with the neuron's ability to do its job. There are other theories as well, and ultimately one or maybe all of these might be involved in the neuropsychiatric changes that we call delirium. The good news is that there are things that can be done to help prevent delirium from happening in the first place. And many of these things can also help calm a patient down when they're experiencing delirium as well. The biggest key is identifying people at risk, and this is usually done with the help of multiple members of the team that interact with the patient in different ways. As a quick example from before, a nurse might notice that a patient hasn't been sleeping well. A pharmacist might notice that they're on multiple opiates for pain control, and a physician might notice that they have a history of delirium in their medical report. Taken together, this is a high-risk patient, right? And recognizing these high-risk patients often requires perspectives from various members of the medical team. Once you identify patients at risk for delirium, it's really important to help them feel as oriented and comfortable as possible. And you can do that by creating an environment similar to their home environment. Basic things like reducing extra noise and stimulation by turning off the TV so that they can feel more calm, and making sure that they have their glasses on and that their hearing aids are working. Maintaining a good daily routine really helps as well. So that means allowing them to eat healthy meals, stay well hydrated, stool regularly and avoid constipation, stay mobile and as active as possible, and maintain healthy sleep habits. This of course applies to everyone, but becomes even more important with patients who are at risk for delirium. Since we know that many patients with multiple medical problems develop delirium after having surgery, it's ideal to manage their pain using non-opiate pain medications, as well as avoiding other medications that we know can cause problems. Finally, it's always ideal to let patients feel like they're in control and avoid using restraints or putting them in unfamiliar situations. This becomes particularly tricky when it seems like a patient might be unsafe, but there are medications like haloperidol or second-generation antipsychotics that can be used to help with patients with really severe symptoms. There are also some serious long-term effects to think about. One of the most important ones is related to falling down. When patients are feeling disoriented, agitated, and confused, they can easily stumble and fall. In fact, some studies show that patients with delirium are up to 6 times more likely to fall down. These falls can lead to all sorts of painful consequences, including broken bones, head injuries, as well as bruises and bleeds. Unfortunately, this is why patients with delirium often end up having longer hospitalizations, more medical complications, and ultimately higher mortality rates. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. Frontotemporal dementia, or FTD for short, refers to a degeneration of the frontal and temporal lobes of the brain. FTD is often mistakenly called Pick disease or Pick's disease. However, this is only a specific subtype of frontotemporal dementia, characterized by the presence of Pick bodies, which are tangles of abnormal nerve cell proteins called tau proteins. Now, if we take a step back and look at the brain, it can be divided into 4 lobes: the frontal, temporal, parietal, and occipital lobes. Within each lobe is a dense network of neurons which allows neurons to communicate with one another. Like most cells, neurons have a cytoskeleton made up of filaments and microtubules that give the cell its structure. Microtubules help neurons move molecules along the length of the cell, kind of like a railway track. And just like in a railway track, the individual units of a microtubule, called tubulins, are tied together with a protein called tau. Tau comes in 6 different shapes and sizes, or isoforms. And one of the key features of these isoforms is how many times a particular sequence of 29 amino acids gets repeated. For 3 of those isoforms, it's repeated 3 times. They're called the 3R isoforms. And for the other 3, it's repeated 4 times. They're called the 4R isoforms. Although it's not completely understood why, in frontotemporal dementia, abnormal protein inclusions form in the cytoplasm or nuclei of neurons. These inclusions are often made up of tau proteins. Specifically, in the case of Pick disease, 3R isoforms of the tau protein get hyperphosphorylated, meaning that phosphate groups keep binding onto the proteins until no more will fit. These hyperphosphorylated tau proteins change shape and stop being able to tie together the tubulins in the neuron cytoskeleton. What's more, the hyperphosphorylated tau proteins start clumping together, forming tangles of tau protein. This makes Pick disease what's called a tauopathy, just like Alzheimer's disease. A key difference is that the tangles in Pick disease are called Pick bodies, and they're only made up of the 3R tau isoforms, whereas the tangles in Alzheimer's disease are called neurofibrillary tangles, and are made up of both 3R and 4R tau isoforms. In other cases, intracellular inclusions are made up of a protein called TDP43, which is involved in transcription regulation in the nucleus of normal cells. Now, just like in Alzheimer's, neurons with loads of intracellular inclusions don't function well, and the neurons get damaged or undergo apoptosis, which is programmed cell death. As more and more neurons get damaged and die away, large-scale changes start to take place in the brain. For one, the brain atrophies, or shrinks, and the gyri, which are the characteristic ridges of the brain, get narrower, whereas the sulci, which are the grooves between the gyri, get wider. With atrophy, the ventricles, or fluid-filled cavities in the brain, also expand as the rest of the brain shrinks. In frontotemporal dementia, it's mainly the frontal and temporal lobes that are affected, while the parietal and occipital lobes are spared. Here's an image of how this looks on FLAIR MRI, where there's less gray-colored brain matter in the diseased areas. Now, symptoms of frontotemporal dementia are not determined by the type of intracellular inclusion, but by the pattern of brain atrophy. So when the frontal lobe is affected, symptoms can include personality and behavior changes like being hostile toward family members. This is known as the behavioral variant of frontotemporal dementia, and is actually the most common one. When the temporal lobe is affected, symptoms can include difficulty finding the right words while speaking, a type of aphasia, called semantic variant primary progressive aphasia, or difficulty in speaking while still being able to recall the meanings of individual words. This is known as non-fluent variant primary progressive aphasia. In any case, as the atrophy progresses, dementia can develop, and a person can struggle with their memory, concentration, and ability to learn new things. Diagnosis of frontotemporal dementia is usually based on mental status changes and imaging studies that indicate changes in the frontal and temporal lobes. But the only definitive way to diagnose frontotemporal dementia is by performing a brain biopsy after a person has died. Unfortunately, there's no cure for frontotemporal dementia, or really even any way to slow it down. Alright, as a quick recap. Frontotemporal dementia refers to a heterogeneous group of disorders that involve degeneration of the frontal and temporal lobes of the brain. It's characterized by abnormal intracellular inclusions in neurons. These are most commonly made up of tau proteins, which in the case of Pick disease undergo hyperphosphorylation, stop supporting microtubules, and tangle up into smooth, round inclusion bodies called Pick bodies. Other types of intracellular inclusions contain TDP43, a protein involved in gene transcription. Just like in Alzheimer's disease, these inclusions stop neurons from signaling as well, and even lead to some of them swelling up and eventually undergoing apoptosis, or programmed cell death. Ultimately, this causes damage to the frontal and temporal lobes, which can lead to personality changes and difficulty with speaking, as well as more global effects like dementia.
Lewy body dementia is a type of dementia where individuals lose their memory and have difficulty learning new information. Lewy bodies refers to protein deposits found inside neurons, and they're named after Friedrich Lewy, the neurologist who discovered them. Lewy body dementia is a neurodegenerative disease, meaning that it worsens over time, and it's the disease that afflicted comedian and actor Robin Williams. The brain is made up of billions of neurons that communicate with each other by releasing neurotransmitters. Most neurons in the cerebral cortex are called cholinergic neurons because they produce acetylcholine. In contrast, neurons in a section of the midbrain called the substantia nigra are in charge of initiating movement and other motor functions. These neurons are called dopaminergic because they produce dopamine. The underlying cause of Lewy body dementia isn't well understood. Normally, neurons contain a protein called alpha-synuclein, and in Lewy body dementia, this protein gets misfolded within the neurons. The misfolded alpha-synuclein aggregates to form Lewy bodies that deposit inside neurons, particularly in the cortex and the substantia nigra. Under a microscope, Lewy bodies look like dark eosinophilic inclusions inside the affected neurons. As the disease progresses, more and more neurons accumulate Lewy bodies and die. The significance of Lewy bodies, however, is unknown, but they're seen in other diseases like Parkinson's disease and multiple system atrophy. In Lewy body dementia, the early symptoms are typically cognitive ones, like difficulty focusing, poor memory, visual hallucinations, disorganized speech, and depression, similar to Alzheimer's disease. Later symptoms are typically motor ones, like resting tremors, stiff and slow movements, and reduced facial expressions, similar to Parkinson's disease. But usually, these motor symptoms are a bit milder than what's seen in Parkinson's disease. Finally, some people have sleep disorders like sleepwalking or talking. A diagnosis of Lewy body dementia is based on the pattern of symptoms, but can only be confirmed with a brain autopsy that shows Lewy bodies and neurons. Treatment is aimed at alleviating symptoms. Motor symptoms respond to drugs used to treat Parkinson's disease, like levodopa, a dopamine analog, while cognitive symptoms may improve with drugs for Alzheimer's disease, like donepezil, which increase acetylcholine availability. Alright, as a quick recap, Lewy body dementia is a neurodegenerative disease caused by aggregation of the misfolded protein alpha-synuclein inside of neurons in the brain cortex and substantia nigra. This leads to the early cognitive symptoms, like in Alzheimer's disease, and late motor symptoms, like in Parkinson's disease. In normal pressure hydrocephalus, the word hydrocephalus can be broken down into hydro, which means water, and cephalus, which means head. Hydrocephalus, which is also called water on the brain, is an excessive buildup of cerebral spinal fluid within the brain. Even though the pressure on lumbar puncture is expected to be increased, in this case it's normal, which is why it's known as normal pressure hydrocephalus. Let's start with some relevant anatomy. The brain has 4 interconnected cavities in the brain called ventricles, and each one contains a structure called a choroid plexus. The choroid plexus is made up of ependymal cells which produce cerebral spinal fluid, or CSF, that helps provide buoyancy and protection, as well as metabolic fuel for the brain. Highest up are 2 C-shaped lateral ventricles that lie deep in each cerebral hemisphere. The 2 lateral ventricles drain their cerebral spinal fluid into the 3rd ventricle, which is a narrow, funnel-shaped cavity at the center of the brain. The 3rd ventricle makes a bit more cerebral spinal fluid and then sends all of the cerebral spinal fluid to the 4th ventricle via the cerebral aqueduct. The 4th ventricle is a tent-shaped cavity located between the brainstem and the cerebellum. After the 4th ventricle, the cerebral spinal fluid enters the subarachnoid space, which is the space between the 2 inner linings of the brain, the arachnoid and the pia mater. Now, the arachnoid mater protrudes into the outermost covering, called the dura mater, at various points. It looks a little bit like fingers poking through, and these protrusions are called arachnoid granulations. Cerebral spinal fluid makes its way through these arachnoid granulations and gets into the dural sinus, which is filled with venous blood and is on the other side of the arachnoid granulation. The pressure within the subarachnoid space is higher than the pressure in the dural sinus, so CSF flows through the arachnoid granulations only in one direction. Normal pressure hydrocephalus develops when cerebral spinal fluid is unable to get through those arachnoid granulations normally. This process develops gradually and most commonly affects the elderly. There are two types of this condition, the first of which is primary normal pressure hydrocephalus, where the cause is idiopathic or unknown. The second type is secondary normal pressure hydrocephalus, where the cause is damage to the arachnoid villi, which disrupts CSF reabsorption. Some known causes of arachnoid villi damage are a subarachnoid hemorrhage and meningitis, both of which cause a tremendous amount of inflammation to the protective layers of the brain. Regardless of the cause, when cerebral spinal fluid doesn't get completely reabsorbed, over time it leads to a slow buildup of CSF within the ventricles of the brain. This causes increased pressure in the ventricles, and since it develops gradually, the ventricles begin to slowly dilate. The increased ventricular volume does restore CSF pressure back to a normal level, but the expanding ventricles compress nearby brain tissue. In particular, the enlarged lateral ventricles compress the corona radiata, the part of the brain that has fibers that relay sensory and motor information between the body and the cerebral cortex. Fibers that carry motor information for the muscles of the legs and the bladder are most commonly affected, leading to gait disturbance and urinary incontinence. As the enlargement of the ventricles continues, it leads to a distortion of the paraventricular limbic system, which is a part of the cerebrum that controls emotions, memories, and behavior. So when this region is affected, it leads to dementia. So the three hallmark symptoms of normal pressure hydrocephalus are urinary incontinence, gait disturbance, and dementia, and they can be remembered as the three W's: wet, referring to incontinence; wobbly, referring to gait disturbance; and wacky, for dementia. People with normal pressure hydrocephalus have a wide-based gait, meaning that their feet are set widely apart, and they take small, slow steps. Sometimes these steps look magnetic because it's difficult for them to lift their feet fully off the ground to initiate a step. Symptoms of dementia include slow thought processes, reduced concentration, memory problems, and other behavior changes. Diagnosis of normal pressure hydrocephalus is based on an imaging study, like a CT or MRI, which can help identify the enlarged ventricles. If a lumbar puncture or spinal tap is conducted, the CSF opening pressure is usually normal, about 100 to 180 millimeters of water or 8 to 15 millimeters of mercury. The short-term treatment of normal pressure hydrocephalus is a lumbar puncture, which is when a needle is placed into the spinal canal to remove cerebral spinal fluid. Long-term treatment typically involves the placement of a shunt, like a ventriculoperitoneal shunt, which connects the ventricular system to the peritoneal cavity in order to allow fluid to drain out and get reabsorbed by the cells lining the peritoneal pleura. This helps to drain off the excess cerebral spinal fluid and reduce the need for the ventricles to dilate. Alright, as a quick recap. Normal pressure hydrocephalus is the condition of ventricular enlargement in the absence of an increased cerebral spinal fluid pressure on lumbar puncture. It's represented by the symptom triad of the three W's: wet, referring to incontinence; wobbly, referring to gait disturbance; and wacky, for dementia. Normal pressure hydrocephalus is diagnosed by imaging methods such as CT or MRI, and it's treated by insertion of shunts. With vascular dementia, vascular refers to the blood flow to the brain, and dementia refers to problems like poor memory, difficulty communicating, and difficulty learning new information. Vascular dementia is also known as multi-infarct dementia, and it's a progressive loss of brain function caused by long-term poor blood flow to the brain, typically because of a series of strokes. Okay, let's start with some basic brain anatomy. The brain has a few regions. The most obvious is the cerebrum, which is divided into two cerebral hemispheres, each of which is divided into four lobes: the frontal, parietal, temporal, and occipital lobe. The frontal lobe controls movement and our personalities. It also handles our ability to count and spell and make decisions. The parietal lobe processes sensory information, which lets us locate exactly where we are physically and guides movements in a three-dimensional space. The temporal lobe plays a role in hearing, smell, and memory, as well as visual recognition of faces and languages. Finally, there's the occipital lobe, which is primarily responsible for processing visual information. All the cells in the body need oxygen, but that's particularly relevant for neurons, which can only function in aerobic conditions, meaning with a constant supply of oxygen. Neurons also don't have long-term energy stores, so they need a constant supply of glucose to keep working. Each time the heart beats, about a quarter of the blood pumped out goes directly to your brain via the internal carotid arteries and the vertebral arteries in the neck. Once they reach the base of the brain, these arteries join to form a ring called the circle of Willis, which then branches off into smaller and smaller arteries, the smallest being the perforating arteries that eventually supply the entire brain with oxygen and glucose. Vascular dementia develops in some individuals when atherosclerosis starts to form in the arteries. That's when there's a buildup of plaque that thickens and hardens the artery wall. When this process affects the arteries supplying the brain, like the carotid arteries, it leads to a gradual decrease in blood flow to the brain, which is called chronic ischemia. Sometimes, small parts of the plaques can break away, and these bits can drift up towards the brain, and can then eventually block a smaller artery, completely stopping the blood supply to the part of the brain that's supplied by that artery. Other times, tiny perforating arteries are affected by atherosclerosis and can get completely blocked off by plaque growing within them. Regardless of the cause, once blood supply to the brain falls below the demands of the tissue, it's considered an ischemic stroke. The tissue damage from an ischemic stroke is usually permanent, because the tissue gets damaged and the dead tissue liquefies in a process called liquefactive necrosis. Brain tissue necrosis leads to a loss of mental functions governed by that area. If another stroke happens later on, more brain tissue might die off, and over time this damage gets worse and worse. The final result is dementia, a persistent loss of mental functions that is severe enough to affect a person's daily functioning. Symptoms of vascular dementia vary depending on which region of the brain is damaged. For example, if someone has strokes in the temporal lobe, it might be difficult for them to remember things or make new memories. Someone with a stroke in the left parietal lobe might lose the ability to speak, which is called aphasia. But then if they get another stroke in the frontal lobe, their personality might begin to change. One thing that's constant is that the symptoms of dementia appear suddenly and brain function decreases with each stroke. Neuropsychological tests, like the mini mental state exam, can be used to confirm that there is a loss of brain function. The vascular cause can be diagnosed using brain imaging, most commonly CT or MRI, which will show multiple cortical and subcortical infarcts and changes like atrophy of the brain cortex, confirming the ischemia. Currently, there's no cure or medication to help specifically with vascular dementia. Treatment focuses on reducing the risk of repeated strokes. This means treating conditions like high blood pressure, high cholesterol, and reducing smoking. Alright, as a quick recap. Vascular dementia is a progressive loss of brain function caused by multiple strokes or infarcts, which in turn are caused by atherosclerosis of the vessels supplying the brain. The signs and symptoms depend on where the strokes develop, and they usually appear one at a time. Treatment currently focuses on treating underlying conditions, which may prevent further strokes from happening.
Hi guys, Sam here. Thank you for watching our video on vascular dementia. Hope you learned a lot. Just want to take a minute and give credits where credits are due. The script was written by Harry and edited by Yifan, Viviana, and Rishi. I did the illustrations, Will edited the video, and Evan did the voiceover. Go team! If you're looking for more great tools to make learning medicine easier, head on over to our website, osmosis.org. There you can sign up for a free trial, get access to flashcards, study schedules, over 100 osmosis videos are available on YouTube. You can also visit our swag shop for cool coffee mugs and t-shirts, or our bookshop for, you guessed it, books. Yeah, Osmosis makes books. Beautiful, full-color illustrated textbooks, and they'll definitely help you reinforce everything you've learned from our videos. So go check it out. Or don't. No pressure. But seriously, you probably should, because all the cool kids are doing it. Alright, catch you later.
At the neurology department, a 23-year-old male named Charles is brought in by his parents because of weakness in his feet that started 2 days ago and worsened over time. During clinical examination, the deep tendon reflexes in his lower extremities are decreased, but sensation is intact. Past medical history reveals a case of gastroenteritis about 3 weeks ago. Next to Charles, there's a 26-year-old female named Maria that came in because of an episode of blurring in her left eye and pain during eye movement. She had a similar episode a few months ago that lasted about a week and resolved without any treatment. She also describes an episode where she felt an electric shock-like sensation throughout her body after having a hot shower. Alright, so both of them have a demyelinating disorder. This occurs when myelin, the protective sheath that surrounds the axons of neurons, is destroyed. Now, myelin is produced by oligodendrocytes in the central nervous system, or CNS, which includes the brain and spinal cord, while in the peripheral nervous system, or PNS, which includes all of the neurons that extend beyond the brain and the spinal cord, it's produced by Schwann cells. Myelin helps the neurons to quickly send electrical impulses. As a result, the destruction of myelin, or demyelination, makes communication between neurons difficult, ultimately leading to all sorts of sensory, motor, and cognitive problems. Okay, now demyelinating disorders can be classified into 2 groups. The first one includes disorders that affect the myelin in the CNS, such as multiple sclerosis, acute disseminated encephalomyelitis, progressive multifocal encephalopathy, and central pontine myelinolysis. The second group includes diseases that affect the myelin in the PNS, like Guillain-Barré syndrome and Charcot-Marie-Tooth. Now, other less high-yield demyelinating disorders include Crab disease, metachromic leukodystrophy, and adrenoleukodystrophy. Alright, so let's take a closer look at these different demyelinating disorders, starting with the ones that affect the CNS. Multiple sclerosis, or MS, is the most common demyelinating disorder, and a very high-yield topic for the exams. It's an autoimmune disease, which means that demyelination occurs because the immune cells, like T cells, B cells, and macrophages, attack the myelin. T cells get through the blood-brain barrier, and once inside the brain, they get activated by myelin. Multiple sclerosis is a type 4 hypersensitivity reaction, or cell-mediated hypersensitivity reaction. This means that these myelin-specific T cells release cytokines that dilate the blood vessels, allowing more immune cells to get in, as well as directly cause damage to oligodendrocytes. The cytokines attract B cells, which begin to make antibodies that mark the myelin. Next, macrophages see those antibodies and attack the marked oligodendrocytes. Without oligodendrocytes, there's no myelin to cover the neurons, leaving behind areas of scar tissue, also called plaques. Okay, now, these immune attacks typically happen in bouts, because regulatory T cells will come in and inhibit the inflammatory process until the next time this process happens. Early on in MS, the oligodendrocytes will heal and extend new myelin to cover the neurons, which is a process called remyelination. But over time, the damage becomes irreversible with the loss of axons. Now, the exact cause of MS is unknown, but it is linked to both genetic and environmental factors. Genetic factors include the female sex and genes that encode a specific type of immune molecule, called HLA-DR2. Environmental factors include infections like Epstein-Barr virus and vitamin D deficiency. Vitamin D deficiency can explain why the rate of MS is higher among people that live further from the equator where there's less sunlight. Now, a very high-yield concept is the symptoms and presentation of MS. There's a lot of these because they depend on the location of the plaques. When they build up in the brainstem, it can affect nerve fibers that control the muscles of the mouth and throat, leading to problems with eating and talking, and can lead to new things like a stutter. Now, individuals with MS very often have vision problems. It's important to remember that plaques can form around the optic nerve, causing optic neuritis, that can lead to a decrease in visual acuity in the central field of vision, and periorbital pain that is worsened by eye movement. There's also an afferent pupillary defect on the affected side that causes a paradoxical dilation of pupil in response to light, and that's referred to as Marcus-Gunn pupil. There can also be diplopia, or double vision, due to internuclear ophthalmoplegia, or INO, which results from damage to the medial longitudinal fasciculus, or MLF, in the brainstem. INO impairs adduction in the ipsilateral eye and causes nystagmus in the contralateral eye when it's abducting. So, if the right MLF was damaged, then when an individual looks left, the right eye won't adduct, and the abducting left eye will have nystagmus. And when you ask the individual to look cross-eye, they can do it because convergence is unaffected. Bilateral internuclear ophthalmoplegia is highly suggestive of MS, and that's a very specific clue. Plaques also form along the motor pathways in the spinal cord, which can lead to motor symptoms like muscle weakness, muscle spasms, tremors, and ataxia. In serious cases, this can lead to paralysis. In addition, plaques in the sensory pathways can cause symptoms like numbness and paresthesias, which is often a tingling feeling, painful itching, or burning sensation. Plaques can also involve the autonomic nervous system, leading to constipation, urinary incontinence, and sexual dysfunction. Finally, MS can also affect higher-order activities of the brain, causing poor concentration and critical thinking, as well as depression and anxiety. Now, two interesting features in MS that are difficult to pronounce are Lhermitte sign and Uthoff's phenomenon. Lhermitte sign is an electric shock-like sensation that radiates down the back with neck flexion. Uthoff's phenomenon is a transient worsening of MS-related neurological symptoms when the body temperature increases, like during exercise or a hot shower. Now, individuals with MS can have more than one of these symptoms. One common trio of symptoms that you have to remember for the exams is called Charcot's neurologic triad, including dysarthria or unclear speech, nystagmus, which is involuntary rapid eye movements, and an intention tremor. Also, another common but nonspecific symptom in MS is fatigue that tends to worsen with heat exposure, and that's high yield for the test. Okay, now MS can have different clinical patterns. The most common and the most likely to appear on your exam is relapsing remitting MS. This is characterized by clearly defined attacks, followed by full or partial recovery, and in between the attacks, there is no progression of the symptoms. An attack is an episode of focal neurological disturbance lasting longer than 24 hours, with a preceding period of stability for at least 30 days. Secondary progressive MS starts off as relapsing remitting MS, and over time, the symptoms and functional decline becomes continuous. Primary progressive MS doesn't have periods of stability at all, and symptoms worsen continuously over time. Okay, now next is acute disseminated encephalomyelitis, also known as acute disseminated post-infectious encephalomyelitis. This disease is characterized by sudden inflammation and demyelination at multiple sites of the CNS. Just like multiple sclerosis, it is an autoimmune disorder and a type 4 hypersensitivity reaction that ultimately leads to destruction of the oligodendrocytes and demyelination. The difference is that acute disseminated encephalomyelitis typically occurs as a single demyelination event that is thought to be triggered by an infection or a vaccine, whereas MS is a progressive disease with recurrent bouts of demyelination. Also, acute disseminated encephalomyelitis occurs more often in children, while MS is more common in young adults between the ages of 20 and 40, and that's high yield for the exams. Symptoms of acute disseminated encephalomyelitis have a sudden onset and progress rapidly. These depend on where the demyelination occurs and can cause visual problems, seizures, weakness, irritability, confusion, drowsiness, and even coma. Now, on to another demyelinating disease of the CNS, progressive multifocal leukoencephalopathy, or PML. For the test, remember that PML is caused by the John Cunningham virus, or simply JC virus. JC virus is transmitted from person to person through the respiratory and gastrointestinal tract, and then moves through the bloodstream and eventually enters kidney epithelial cells and starts replicating. The immune cells can keep the virus in check by killing any cell that has replicating JC virus. But the virus is not eliminated and remains latent in the kidneys. They can become active again if the immune system gets weakened. This is why a key clue to look for is the immune status of the individual, and high-risk populations include HIV-positive people, an individual with leukemia or lymphoma, or a patient taking immunosuppressive medications. These can be monoclonal antibodies, such as natalizumab, which is typically used to treat multiple sclerosis, and rituximab, which is used to treat various cancers and autoimmune diseases. All of these affect the lymphocytes, which are critical in helping to keep JC virus under control. So the JC virus can get into the blood and get through the blood-brain barrier and into the brain. Within the brain, JC virus begins to rapidly attack oligodendrocytes in multiple locations throughout the brain, causing demyelination of axons. Now, PML primarily involves the parietal and occipital areas, so look for symptoms like changes in speech and loss of vision. Other common symptoms include weakness, clumsiness due to lack of coordination, personality changes, and dementia. The disease ultimately leads to death in about half of the cases, and those who survive often have serious neurological disability. Next up is central pontine myelinolysis, which is the destruction of the myelin around the axons that are in the central part of the pons. The cause of destruction is rapid osmotic changes, and the pons is a part of the brain that's particularly sensitive. So, another name for central pontine myelinolysis is osmotic demyelination syndrome, and it's a high-yield topic for the exams. But first things first. When brain cells are in an environment with a low sodium concentration, called hyponatremia, there's a lower osmolality outside the cell compared to inside the cell, and water flows into the cells. Because the brain is restricted within the skull, there's no space to expand, and the brain becomes compressed. So, the brain cells try to have fewer osmolytes, or osmotically active substances, in order to reduce the osmotic gradient, so that less water flows into the cell. In the end, the cell will be in complete equilibrium with a hyponatremic extracellular space. Now, let's say that the hyponatremia is treated too quickly. This time, the extracellular component has too much sodium, and that creates an osmotic gradient that pulls water out of the cell. The cells don't have enough time to allow osmolytes to enter and reestablish balance. As a result, cells dehydrate, and that causes massive structural damage. Now, in general, when oligodendrocytes and neurons get damaged, reactive astrocytes come to the site and form scar tissue to fill the empty space, a process called astrocytosis, or gliosis, since astrocytes are a subtype of glial cell. When there's enough damage to the pons, it can affect the function of the cranial nerve nuclei that are housed in the pons. A great mnemonic for correcting hypo or hypernatremia too quickly is, from high to low, your brains will blow, while from low to high, your pons will die. Central pontine myelinolysis often leads to demyelination of the corticobulbar tracts of cranial nerves 9, 10, and 11. This causes head and neck weakness, dysarthria, and dysphagia, or difficulty swallowing. Since the nuclei of these nerves are not affected, it's referred to as pseudobulbar palsy. Central pontine myelinolysis can also cause diplopia, quadriplegia, and a condition called locked-in syndrome, which is where there's complete paralysis of most or all of the voluntary muscles in the body. The person is fully conscious, so it's like they're locked inside their body. Okay, now let's switch gears and talk about demyelinating disorders of the PNS, starting with Guillain-Barré syndrome. For the test, remember that Guillain-Barré syndrome is associated with bacterial infections, especially with Campylobacter jejuni, but also Mycoplasma pneumoniae, viral infections like cytomegalovirus and Epstein-Barr virus, vaccines, but also stress. It's thought that these infectious agents have ganglioside-like molecules on their surface that look similar to the ganglioside components of myelin. This is called molecular mimicry. Anyways, the myelin particles get picked up by antigen-presenting cells, like dendritic cells, which present it to the helper T cells. These helper T cells produce cytokines which activate B cells and macrophages. Once activated, the B cells make antibodies that mark the myelin, and the macrophages use those antibody markers to bind to and strip the myelin off of the peripheral neurons. The demyelination occurs in patches along the length of the axon, and so under a microscope, segmental demyelination and endoneurial inflammation of the peripheral nerves can be seen. The most common clinical variant is acute inflammatory demyelinating polyradiculopathy. On the test, they will describe a patient who had a respiratory or gastrointestinal infection 2 to 4 weeks ago. They then developed rapidly progressive symmetric ascending weakness in the distal lower extremities. Rapidly progressive in this context means the weakness usually develops within hours to days. Symptoms are at their worst around 4 weeks later. Another important clue for the diagnosis is that there's flaccid paralysis with decreased or absent deep tendon reflexes in the affected extremities. The paralysis may ascend to involve the diaphragm, causing shortness of breath and potentially respiratory failure, which is an emergency. The cranial nerves may also be affected, especially bilateral facial nerve palsy. In addition, the weakness of the pharyngeal muscles causes difficulty swallowing and increases the risk of aspiration. Autonomic dysfunction can cause fluctuations in blood pressure, cardiac arrhythmias, diaphoresis or sweating, and urinary retention. Importantly, sensory symptoms are rare. Finally, we have Charcot-Marie tooth disorder. This is actually a group of progressive hereditary motor and sensory neuropathies. Most are inherited in an autosomal dominant fashion, so there's usually a family history of the disorder. They affect the peripheral nervous system and are characterized by defective protein production in the Schwann cells, or the peripheral neuron's axon. The most common form of Charcot-Marie tooth disease is CMT1. CMT1 is caused by mutations in the PMP22 and MPZ genes, which encode proteins that are part of the myelin sheath. Over time, Schwann cells try to replace myelin, and as a result, under a microscope, there's often an onion bulb formation, which is when an axon is surrounded by new layers of myelin with underlying damaged layers of myelin. Individuals with Charcot-Marie tooth typically have distal lower extremity weakness, which is similar to Guillain-Barré syndrome. The difference is that there will also be sensory symptoms such as pain or numbness. For motor symptoms, damage to the common peroneal nerve can lead to foot drop, while weakness of the intrinsic muscles of the foot can result in pes cavus, a high arching foot that doesn't flatten with weight bearing. Weakness of the back muscles can result in scoliosis. Alright, now let's move on to diagnosis. In the exams, suspect multiple sclerosis in a young individual that has neurological symptoms disseminated in time and space, meaning that different locations in the CNS are affected at different times. Also, MS should be suspected when neurological symptoms resolve partially or fully on their own. Now, for the test, remember that the diagnosis of MS requires an MRI. MRI without the contrast gadolinium shows scattered hypointense white matter lesions. And when you add the contrast gadolinium, the acute lesions enhance, while the older ones remain hypointense. These plaques are often periventricular, that is, around the ventricles, or juxtacortical, that is, near the cerebral cortex. Also, a relatively specific sign in MS are plaques around the corpus callosum that look like fingers on a sagittal MRI, and are called Dawson's fingers. A lumbar puncture can be done to look for increased myelin basic protein and oligoclonal bands in the CSF. Oligoclonal bands are discrete sets of antibodies found on gel electrophoresis or cerebrospinal fluid IgG, and can be an important clue for the diagnosis. Another test is the evoked potential conduction velocity, which shows slowing of the electrical events generated in the brain and spinal cord when a sensory organ is stimulated. For example, a visual evoked potential, or VEP, can be helpful measuring the nervous system's response to a visual stimulus. Okay, now a brain biopsy is not needed to confirm the diagnosis. If it was performed, it would show the characteristic plaques in the gray matter with oligodendrocyte depletion, loss of myelin sheaths, infiltration by lymphocytes and lipid-laden macrophages, and astrocytosis. In acute plaques, there's relative preservation of the axons, whereas in chronic plaques, there's degeneration of the axons. Acute disseminated encephalomyelitis is typically suspected when a child develops neurological symptoms after an infection or a vaccination. The diagnosis is supported by an MRI, which shows multiple lesions in the CNS similar to MS. Also, a lumbar puncture shows oligoclonal bands in the CSF. Finally, the evoked potential conduction velocity will show decreased nerve conduction velocity. Now, progressive multifocal leukoencephalopathy is usually suspected when an individual who recently became immunosuppressed develops neurological symptoms. The diagnosis can be confirmed by finding JC virus DNA in the cerebrospinal fluid, as well as finding multiple white matter lesions on imaging techniques, like a brain MRI. In rare cases, a brain biopsy can be performed on a living person, which will show the presence of JC virus within the oligodendrocytes. Central pontine myelinolysis should be suspected in a patient that's being treated for hyponatremia too quickly. Diagnosis can be confirmed with an MRI, which will show damage to the white matter of the pons where the axons are located. The diagnosis of Guillain-Barré syndrome requires CSF analysis, which classically shows albuminocytological dissociation, which means there's an elevated CSF protein with a normal CSF white blood cell count. Electrodiagnostic testing, which includes a nerve conduction study, and electromyography, can help differentiate if the disease is demyelinating or affecting the axon. In acute inflammatory demyelinating polyradiculopathy, the conduction velocity is decreased. Finally, serum antibodies can be sent to look for evidence of autoimmune inflammation from Guillain-Barré syndrome. Finally, for Charcot-Marie tooth, electrodiagnostic testing is usually done, and the diagnosis is confirmed with genetic testing using gel electrophoresis or fluorescent in situ hybridization, FISH for short. Alright, now let's discuss treatment. Treatment of MS starts with disease-modifying medications which reduce the attack rates of MS. They include interferon beta, glatiramer acetate, or natalizumab. Next, symptomatic therapy includes muscle relaxants like baclofen, cyclobenzaprine, or tizanidine that can alleviate spasticity. Neuropathic pain can be treated with anticonvulsants like carbamazepine, gabapentin, or pregabalin, or antidepressants like diazepamine and venlafaxine. Now, if there's a relapse, treatment depends on the severity of symptoms. Mild symptoms may not require treatment, whereas paralysis or visual loss would require treatment with high-dose IV corticosteroids, like methylprednisolone. If there's an inadequate response to corticosteroids, then plasma exchange or plasmapheresis can be done. Treatment for acute disseminated encephalomyelitis includes corticosteroids, and they should be given rapidly to reduce the inflammation. Other treatments include intravenous immunoglobulin therapy to bind and neutralize the autoantibodies, or cyclophosphamide, which is a cell cycle inhibitor. Occasionally, more severe cases may be treated with plasma exchange. The majority of individuals recover fully a few months after treatment, but some have a residual disability. Now, for PML, there is no treatment for JC virus, but the disease can be slowed down by restoring the immune system so that it can control the virus. For example, HIV-infected people must start highly active antiretroviral therapy, or HAART, while for autoimmune diseases, it's helpful to stop immunosuppressive medications. As for central pontine myelinolysis, there's no way to reverse existing damage, but ongoing damage can be stopped by slowly correcting any electrolyte abnormalities. Now, for the exams, remember that Guillain-Barré syndrome can cause respiratory failure, which can be fatal, so close monitoring with serial measurements of vital capacity and respiratory support are critical. Now, the syndrome can be treated with IVIG or plasma exchange. Uniquely, unlike many autoimmune diseases, corticosteroids are not effective in Guillain-Barré syndrome. And finally, for Charcot-Marie-Tooth, management focuses on physical therapy and rehabilitation. Alright, as a quick recap, demyelinating disorders are characterized by destruction of the myelin sheath that surrounds the axons of neurons. They can either affect the central nervous system, like multiple sclerosis, acute disseminated encephalomyelitis, and central pontine myelinolysis, or the peripheral nervous system, like Guillain-Barré syndrome and Charcot-Marie-Tooth disease. A diagnosis can be made on clinical presentation, imaging techniques like MRI, and lab findings. The diagnosis can often be confirmed with more specific tests, like electrodiagnostic testing or genetic testing. Okay, back to the patients. Charles had bilateral rapid onset lower extremity weakness with no sensory defects. On physical exam, he had absence of deep tendon reflexes. All this points to Guillain-Barré syndrome, which is most likely triggered by the gastrointestinal infection he had a few weeks ago. To confirm the diagnosis, lumbar puncture to show albunocytological dissociation and electrodiagnostic testing must be done. Alright, now Maria most likely has multiple sclerosis. The episodes of blurry vision and pain with eye movement that resolve without treatment are characteristic of MS. Also, the episode after the hot shower is Uthoff's phenomenon, which is also typical of MS. To confirm the diagnosis, an MRI to show the sclerotic plaques must be ordered.
In acute disseminated encephalomyelitis, or ADEM, acute means that the disease evolves rapidly, disseminated refers to the fact that there are multiple sites involved, encephalo refers to the brain, myelo refers to the spinal cord, and itis refers to inflammation. So acute disseminated encephalomyelitis is an autoimmune disease of the central nervous system, where there's sudden inflammation and demyelination at multiple sites of the brain and spinal cord. The central nervous system consists of the brain and spinal cord. Grossly, the central nervous system can be divided into two main areas: the gray matter, which is made up of neuron cell bodies, and the white matter, which is made up of projections from the neuron cell bodies known as axons and dendrites. The dendrites receive electrical impulses from other neurons. The neuron cell body has all of the neuron's main organelles, like the nucleus. And finally, the axons transmit electrical impulses to the dendrites of the next neuron in the series. Some axons are surrounded by a fatty protective sheath called myelin that helps increase the speed at which electrical impulses are sent. This myelin is produced by oligodendrocytes, which are a group of cells that support neurons. Now, the brain is protected by harmful things in the blood by the blood-brain barrier, which only lets certain molecules and cells through. For immune cells like T and B cells, that means having the right ligand or surface molecule to get through the blood-brain barrier. This is kind of like having a VIP pass to get into an exclusive club. Once the T cell gets activated, it changes the blood-brain barrier cells to express more receptors, and this allows immune cells to more easily bind and get in. kind of like bribing the bouncer to let a lot of people in. In the case of acute disseminated encephalomyelitis, T cells are activated by myelin. Acute disseminated encephalomyelitis is a type 4 hypersensitivity reaction, or cell-mediated hypersensitivity. And this means that those myelin-specific T cells release cytokines like interleukin-1, interleukin-6, tumor necrosis factor alpha, and interferon gamma, and together dilate the blood vessels, which allows more immune cells to get in, as well as directly cause damage to the oligodendrocytes. The cytokines also attract B cells and macrophages as part of the inflammatory reaction. Those B cells start to make antibodies that mark the myelin sheath proteins, and then the macrophages use those antibody markers to engulf and destroy the oligodendrocytes, leading to demyelination at multiple locations throughout the brain and spinal cord. Now, all of this is extremely similar to another disease, called multiple sclerosis. The big difference between them is that acute disseminated encephalomyelitis usually happens as a single event of demyelination in a child, whereas multiple sclerosis is a progressive disease with recurrent bouts of demyelination that happens in young adults. The underlying trigger for acute disseminated encephalomyelitis is still unclear, but because some pathogens have proteins that are similar to oligodendrocytes proteins, one mechanism might be molecular mimicry. And this is when cells of our immune systems generate a response against pathogenic proteins, and then mistakenly attack similar proteins expressed by our own cells. A variety of viral infections are thought to be associated with acute disseminated encephalomyelitis, including influenza, measles, mumps, rubella, and various human herpes viruses. There are also bacterial infections associated with acute disseminated encephalomyelitis, like Mycoplasma pneumoniae and beta hemolytic streptococci. It's worth noting that these pathogens are relatively common in the environment, but that acute disseminated encephalomyelitis is pretty rare. That's because the disease only seems to manifest in a person with a particular genetic predisposition and the right environmental trigger. It's also thought that, in very rare situations, acute disseminated encephalomyelitis might be triggered by certain vaccines, but this topic is still highly debated. Symptoms of acute disseminated encephalomyelitis have a sudden onset, and usually start 1 to 3 weeks after being exposed to the trigger. Since acute disseminated encephalomyelitis is associated with systemic inflammation, most individuals present with fever, headaches, nausea, and vomiting. Also, since demyelination breaks down the communication between neurons, this leads to visual problems, seizures, weakness, irritability, confusion, drowsiness, and even coma. Acute disseminated encephalomyelitis is typically suspected when a child develops the typical symptoms after infection or vaccination. The diagnosis is supported by an MRI, which shows multiple central nervous system lesions. Also, a lumbar puncture can be done, since in the cerebrospinal fluid there might be high levels of antibodies, which indicates an autoimmune process. Finally, a visual evoked potential can be helpful as well, which measures the nervous system's response to visual stimuli. Treatment for acute disseminated encephalomyelitis includes corticosteroids, and they should be given rapidly to reduce the inflammation of the central nervous system. Other treatments include intravenous immunoglobulin therapy to bind and neutralize the autoantibodies, or cyclophosphamide, which is a cell cycle inhibitor. Occasionally, more severe cases may be treated with plasma exchange, or plasmapheresis, which is when plasma proteins like antibodies are removed, and then replaced with plasma from a healthy donor. The majority of individuals fully recover a few months after treatment, but some have a residual disability. Alright, as a quick recap. Acute disseminated encephalomyelitis is a rare autoimmune disease with demyelination at multiple sites of the central nervous system. It generally happens as a single event, and it usually affects children. Symptoms depend on where the demyelination happens, but can include visual problems, seizures, weakness, irritability, confusion, and even coma. Most cases have full recovery, but some retain residual disability, and a small minority do not survive. In central pontine myelinolysis, pontine refers to the pons of the brainstem, myelin refers to the fatty layer of insulation that wraps around neurons, and lysis refers to destruction. So central pontine myelinolysis is the destruction of the myelin sheath around nerve cells that are in the pons. The main cause of destruction is rapid osmotic changes, meaning that a lot of water leaves the cells, and this dries them out, causing them to die. So the other name for central pontine myelinolysis is osmotic demyelination syndrome. Now, taking a look at the brain, the pons is part of the brainstem, and it's nestled between the midbrain and the medulla oblongata. The pons itself has control centers that help manage the respiration rate and the depth of breathing, while we're awake and when we sleep. So if you try to take a deep breath right now, that's your pons in action. Neuron clusters or nuclei for cranial nerves 5 or trigeminal, 6 or abducens, 7 or facial, and 8 or vestibulocochlear are also all housed in the pons. Cranial nerve 5 allows you to feel things on your face and controls the muscles that help you chew, bite, and swallow. Cranial nerve 6 allows your eyes to move side to side. Cranial nerve 7 helps with facial expressions, like making a weird face. And cranial nerve 8 helps with hearing. All of these nerves are made up of lots of individual neurons, which capture signals from their dendrites, and then pass those signals along through their axons. In addition to the neurons, there are also supporting cells called oligodendrocytes, as well as astrocytes. Oligodendrocytes physically wrap their fatty myelin-rich cell membranes around neuronal axons that are nearby to help action potentials move more quickly through them. And astrocytes help repair damaged neurons. Neurons and oligodendrocytes are very sensitive to changes in the amount of water and electrolytes in themselves and their environment. In other words, in the intracellular and extracellular compartments. And the pons is a part of the brain that's particularly sensitive. The cell membrane is permeable to water, but some substances called osmolytes cannot cross over as easily, and are called semi-permeable. Examples of osmolytes are electrolytes like potassium, sodium, and chloride, as well as organic substances like phosphorylated glucose, which makes the molecule more polar and prevents it from slipping through the membrane easily. Intracellularly, there's a high potassium and a low sodium content, while extracellularly, there's high sodium and low potassium. Normally, extracellular osmolality matches intracellular osmolality, meaning that they're an equal balance of water and solute concentration. When there's a difference between the intracellular and extracellular osmolality, water flows toward the compartment with a higher osmolality to balance things out. And that's called osmosis, which is the process, not the company. So when neurons and oligodendrocytes are in an environment with a low sodium concentration, called hyponatremia, there's a lower osmolality outside the cell compared to inside the cell, and so water flows into the cells. Hyponatremia might happen in a condition like syndrome of inappropriate diuretic hormone, or SIADH, where the kidneys retain too much water. Because the brain is restricted within the skull, brain swelling is significant because there's no space to expand, and the brain tissue gets compressed. To avoid swelling up with too much water, neurons and oligodendrocytes have natural defense mechanisms. For example, let's say that there's a drop in extracellular osmolality. That change would first get sensed by channels on the cell membrane. In response, the cell would try to have fewer osmolytes, so that less water flows into the cell. To do that, protein kinases would be inhibited from adding a phosphate group to substances like glucose. And this allows glucose to more easily slip out of the cell. In this way, the brain's cells reduce the osmotic gradient. This process can take about 48 hours to complete, and in the end, the cell is in complete equilibrium with the hyponatremic extracellular space. Now, let's say that the hyponatremia resolves. Maybe because a person with SIADH is given an infusion of salts containing intravenous fluids. In that situation, the balance is upset again. This time, the extracellular component has too much sodium, and that creates an osmotic gradient that pulls water out of the cell. Initially, the neurons in oligodendrocytes don't have enough time to allow osmotically active substances to enter and reestablish the balance. With more osmolytes outside the cell, the water in the cell moves out. As a result, cells dehydrate, and that causes massive structural damage. When oligodendrocytes and neurons get damaged, reactive astrocytes come to the site and form scar tissue made of glycoproteins to fill the empty space, which is a process called astrogliosis. The proliferation of astrocytes at the injured site also signals the surrounding tissue to secrete proteins like laminin, fibronectin, and proteoglycans, which inhibit tissue regeneration. When there's enough damage to the pons, it can affect the function of the cranial nerve nuclei that are housed in the pons. Ultimately, central pontine myelinolysis can lead to impaired muscle movements in the head and neck, causing dysarthria, or an inability to speak normally, dysphagia or difficulty swallowing, and diplopia, or double vision. Classically, central pontine myelinolysis can cause locked-in syndrome, which is where there's complete paralysis of most or all of the voluntary muscles in the body, while a person is completely conscious. Kind of like waking up and being completely paralyzed. Central pontine myelinolysis can be diagnosed based on an MRI, which will show damage to the pons. Typically, there's no way to reverse existing damage, but ongoing damage can be stopped by slowly and carefully correcting any electrolyte abnormalities. Alright, as a quick recap. Central pontine myelinolysis, also known as osmotic demyelination syndrome, is the destruction of the myelin of nerve cells in the pons due to a rapid correction of hyponatremia. It classically causes locked-in syndrome, which is when a person is conscious but unable to move any muscles. In progressive multifocal leukoencephalopathy, progressive means that the disease worsens over time. Multifocal means the disease affects multiple locations. Leuko refers to white, and encephalopathy refers to a disease of the brain. So progressive multifocal leukoencephalopathy, or just PML, is a disease of the white matter of the brain that affects multiple locations and worsens over time. If we look at a cross-section of the brain, it can be divided into two areas. The outermost area is the gray matter, which is made up of neuron cell bodies. And the innermost area is the white matter, which is made up of the axons that come off of the neuron cell bodies. The axons transmit electrical impulses to the next neuron in the series. Those axons are also surrounded by a fatty protective sheath called myelin that helps increase the speed at which electrical impulses are sent. Myelin is produced by a special type of cells called oligodendrocytes. The cause of progressive multifocal leukoencephalopathy is the John Cunningham virus, or simply JC virus, named after the first patient in whom the virus was identified. JC virus is a non-enveloped virus, with a closed, circular, double-stranded DNA genome. It's thought that the virus is transmitted from person to person through the respiratory and gastrointestinal tract, and that it then moves through the bloodstream and eventually reaches the kidney epithelial cells. JC virus enters these kidney cells and starts replicating. But the cytotoxic CD8 positive T cells of our immune system keep the virus in check by killing any cell that has replicating JC virus. So to be clear, the virus is not eliminated, but instead it remains latent in the kidneys, meaning that it isn't dividing and causing disease. And it turns out that the vast majority of the population is infected by JC virus, which might even include you. Most people with a healthy immune system, though, are able to keep JC virus in the latent phase in the kidney epithelial cells for their entire life. But things can change if the immune system gets weakened. This can happen for various reasons, like an HIV-infected individual who loses T cells, or individuals taking immunosuppressive medications like monoclonal antibodies like natalizumab, which is typically used to treat multiple sclerosis, as well as rituximab, which is used to treat various cancers and autoimmune diseases. All of these affect the lymphocytes, which are critical in helping to keep JC virus under control. Without them, the JC virus can start to get into the blood and make its way through the blood-brain barrier, and into the brain itself. Within the brain, JC virus starts to rapidly attack oligodendrocytes in multiple locations throughout the brain, causing demyelination of axons. And that interferes with communication between neurons, so messages start getting lost. In progressive multifocal leukoencephalopathy, there can be a wide range of symptoms, depending on where the demyelination happens, including progressive motor and cognitive neurologic symptoms, like weakness, loss of vision, changes in speech, clumsiness due to lack of coordination, personality changes, and dementia. The disease ultimately leads to death, due to extensive brain damage in about half of cases. And those who do survive often retain serious neurological disabilities, since demyelination is irreversible. Progressive multifocal leukoencephalopathy is usually suspected when an individual who's recently become immunosuppressed develops new neurologic symptoms. The diagnosis can be confirmed by finding JC virus DNA in the cerebrospinal fluid, as well as finding multiple white matter lesions on imaging techniques like brain MRI. Generally, imaging techniques coupled to the clinical presentation are enough for diagnosis, and in rare cases, a brain biopsy can be performed on a living person, and that might show the presence of JC virus within oligodendrocytes. There is no treatment for JC virus, but the disease can be slowed down by restoring the immune system so that it can control the virus. For example, HIV-infected people must start highly active antiretroviral therapy, or HAART, while for autoimmune diseases, it's helpful to stop immunosuppressive medications. Alright, as a quick recap. Progressive multifocal leukoencephalopathy is a rare and often fatal demyelinating disease of the brain. It's caused by a type of polyoma virus called JC virus, which specifically attacks oligodendrocytes, leading to progressive and irreversible axon demyelination that presents with motor and cognitive neurological symptoms. JC virus can be found latent in most people, since a healthy immune system can keep it under control, but it can reactivate in the case of immunosuppression. So the only way to treat progressive multifocal leukoencephalopathy is by restoring the immune system. Multiple sclerosis is a demyelinating disease of the central nervous system, which includes the brain and the spinal cord. Myelin is the protective sheath that surrounds the axon of neurons, allowing them to quickly send electrical impulses. This myelin is produced by oligodendrocytes, which are a group of cells that support neurons. In multiple sclerosis, demyelination happens when the immune system inappropriately attacks and destroys the myelin, which makes communications between neurons break down, ultimately leading to all sorts of sensory, motor, and cognitive problems. Now, the brain, including the neurons in the brain, is protected from things in the blood by the blood-brain barrier, which only lets certain molecules and cells through from the blood. For immune cells like T and B cells, that means they have to have the right ligand or surface molecule to get through the blood-brain barrier. This is kind of like having a VIP pass to get into an exclusive club. Once a T cell makes its way in, it can get activated by something it encounters. In the case of multiple sclerosis, it's activated by myelin. Once the T cell gets activated, it changes the blood-brain barrier cells to express more receptors, and this allows immune cells to more easily bind and get in. It's kind of like bribing the bouncer to let in a lot of people. Now, multiple sclerosis is a type 4 hypersensitivity reaction, or a cell-mediated hypersensitivity. And this means that those myelin-specific T cells release cytokines like interleukin 1, interleukin 6, tumor necrosis factor alpha, and interferon gamma, which together dilate the blood vessels, which allows more immune cells to get in, as well as directly cause damage to the oligodendrocytes. These cytokines also attract B cells and macrophages as part of the inflammatory reaction. Those B cells start to make antibodies that mark the myelin sheath proteins, and then the macrophages use those antibody markers to engulf and destroy the oligodendrocytes. Without oligodendrocytes, there's no myelin to cover the neurons, and this leaves behind areas of scar tissue, also called plaques or sclera. In multiple sclerosis, these immune attacks typically happen in bouts. In other words, an autoimmune attack on the oligodendrocytes might happen, and then regulatory T cells will come in to inhibit or calm down the other immune cells, leading to a reduction in the inflammation. Early on in multiple sclerosis, the oligodendrocytes will heal and extend out new myelin to cover the neurons, which is a process called remyelination. Unfortunately, though, over time, as the oligodendrocytes die off, the remyelination stops, and the damage becomes irreversible with the loss of axons. Just like other autoimmune diseases, the exact cause of multiple sclerosis is unknown, but it's linked to both genetic and environmental factors. Genetic risk factors include being female and having genes that encode a specific type of immune molecule called HLA-DR2, which is used to identify and bind to foreign molecules. Environmental risk factors might include infections as well as vitamin D deficiency, which is an interesting one because it might help explain why the rates of multiple sclerosis are higher at the northern and southern poles compared to the equator, where there's a lot more sunlight. Together, these genetic and environmental influences might lead to the body not killing off immune cells that target myelin. So it turns out that there are actually 4 main types of multiple sclerosis, based on the pattern of symptoms over time. To break this down, we can use a graph with time on the x-axis, where time refers to the lifespan of the individual, and disability on the y-axis. The first and by far the most common pattern of multiple sclerosis is called relapsing remitting multiple sclerosis, or RRMS. This condition is what we just described, bouts of autoimmune attacks happening months or even years apart, and causing an increase in the level of disability. For example, during a bout, a person might lose some vision, but then it might be followed by improvement if there's remyelination. Unfortunately, though, more often than not, the remyelination process isn't complete, so there's often some residual disability that remains. And that means that with each attack, more and more the central nervous system gets irreversibly damaged. In the relapsing remitting multiple sclerosis type, there's typically no increase in disability between bouts, so the line stays flat during that time. Now, the second type is called secondary progressive multiple sclerosis, or SPMS, which initially is pretty similar to the relapsing remitting type, but over time the immune attack becomes constant, which causes a steady progression of disability. The third type is primary progressive multiple sclerosis, or PPMS, which is basically one constant attack on myelin, which causes a steady progression of disability over a person's lifetime. The final type is progressive relapsing multiple sclerosis, or PRMS, which is also one constant attack, but this time there are bouts superimposed, which means the disability happens even faster. Specific symptoms vary a lot from person to person, and largely depend on the location of the plaques, and multiple sclerosis typically affects individuals between the ages of 20 and 40. Symptoms related to bouts can typically worsen over weeks and can linger for months without treatment. One common trio of multiple sclerosis symptoms is called Charcot's neurologic triad, and it includes dysarthria, which is difficulty or unclear speech, nystagmus, which is involuntary rapid eye movements, and an intention tremor. Dysarthria is due to plaques in the brainstem that affects nerve fibers that control muscles of the mouth and throat. And this can interfere with conscious movements like eating and talking, and could lead to things like a new stutter, as well as unconscious movements like swallowing. Nystagmus is due to plaques around the nerves controlling eye movements. Plaques around the optic nerve causes loss of vision in one or both of the eyes because of damage to the optic nerve, which is called optic neuritis. Sometimes there's blurring or graying of the vision, or alternatively, there might be a dark point in the center of vision. Additionally, if there's damage to the nerves controlling eye movement, then eye movements can be painful and there can even be double vision, if the eyes no longer move in a coordinated way. Finally, intention tremors can be caused by plaques along the motor pathways in the spinal cord, which can affect outbound signals like skeletal muscle control. Motor symptoms can include muscle weakness, muscle spasms, tremors, and ataxia, which is a loss of balance and coordination. In serious cases, this can lead to paralysis. In addition, plaques in the sensory pathways can affect inbound signals, like sensations from the skin, which causes symptoms like numbness, pins and needles, and paresthesias, which are often a tingling feeling but might also be a painful itching or burning sensation. Occasionally, there can be very specific sensory symptoms, like Lhermitte sign, which is when an electric shock runs down the back and radiates through the limbs when a person bends their neck forward. Plaques can also involve the autonomic nervous system, which can lead to bowel and bladder symptoms like constipation and urinary incontinence, as well as sexual symptoms like sexual dysfunction. Finally, multiple sclerosis can also affect higher order activities of the brain, causing poor concentration and critical thinking, as well as depression and anxiety. Multiple sclerosis is typically suspected when there are multiple neurologic symptoms separated in space, which is attributable to damage in different locations in the nervous system, as well as time, meaning separate bouts or flare-ups, as well as remission. The diagnosis of multiple sclerosis is supported by an MRI that shows multiple central nervous system lesions, called white matter plaques, since these regions tend to have a lot of myelin. Also, in the cerebrospinal fluid, there might be high levels of antibodies, which indicates an autoimmune process. Finally, a visual evoked potential can be helpful as well, which measures the nervous system's response to visual stimuli. For treatment, there's no cure for multiple sclerosis, but there are medications which are particularly effective for the relapsing remitting type because they lessen the severity of relapses and make them happen less frequently. Medications like corticosteroids, cyclophosphamide, which is a cell cycle inhibitor, and intravenous immunoglobulin can all be used to help blunt the autoimmune process. In addition, plasmapheresis can be effective as well, which is when the plasma is filtered to remove disease-causing autoantibodies. Chronic treatment for multiple sclerosis includes immunosuppressants like recombinant beta interferon, which decreases the level of inflammatory cytokines in the brain, as well as increases the function of T regulatory cells. Other immunosuppressants actually block T cells from getting into the brain by interfering with the cell surface molecules they use to gain passage through the blood-brain barrier. Unfortunately, though, there are fewer treatment options available for progressive multiple sclerosis. Instead, treatments are often targeted at managing specific symptoms, everything ranging from depression to bladder dysfunction. Physical therapy and cognitive rehabilitation therapy can be particularly helpful with sensory, motor, and cognitive symptoms. Finally, there's also an increasing interest in the role of vitamin D as an effective treatment. Alright, as a quick recap, multiple sclerosis is a chronic and progressive autoimmune disorder, and the most common pattern is the relapsing remitting type, where individuals have flares that come and go, with each one slightly worsening their overall condition. During a flare, T cells cause inflammation and damage to oligodendrocytes in the central nervous system, which leaves behind scarred areas of demyelinated neurons called plaques, which causes a variety of symptoms depending on the location. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media. The name of the disorder, transverse myelitis, can be broken down. Transverse means extending completely across something. In this case, it refers to going across the spinal cord. And myelitis means inflammation of myelin, which is a fatty substance surrounding nerves. So in transverse myelitis, there's inflammation that damages the myelin as well as the rest of the neuron across a section of the spinal cord. Now, neurons are the main cells of the nervous system. They're composed of a cell body, which contains all of the cell's organelles, and nerve fibers, which are projections that extend out from the neuron cell body. Nerve fibers are either dendrites that receive signals from other neurons, or axons that send signals along to other neurons. Where two neurons come together is called a synapse, and that's where one end of an axon sends neurotransmitters to the dendrites or directly to the cell body of the next neuron in the series. The axons are intermittently wrapped in a fatty substance called myelin. Myelin is extremely important to neurons because it helps to allow an action potential propagate much faster. And action potentials are electrical signals that race down the axon and trigger the release of neurotransmitters or a chemical signal on the other end. Without myelin, this signal propagation is very slow and inefficient. Since some of these neurons can be very long, especially ones that go from the spinal cord to the toes, the fact that myelin helps speed up action potentials is actually super important. Now, the spinal cord is composed of both gray and white matter. Gray matter consists of cell bodies. It's in the middle of the spinal cord and is shaped kind of like a butterfly. Surrounding the gray matter is white matter, which consists of the myelinated axons of various neurons. The neurons in the spinal cord form different neural tracts that carry information to and from the brain. There are three main tracts to remember. The corticospinal tract is a descending pathway that carries motor information from the brain to different muscles in the body, and it controls voluntary muscle movement. The dorsal column is an ascending pathway that carries sensory information about pressure, vibration, fine touch, and proprioception, or the awareness of one's bodily position in space. Finally, the spinothalamic tract is another ascending pathway, and it's divided into two parts. The lateral tract carries sensory information for pain and temperature, while the anterior tract carries information for pressure and crude touch, or the sense one has been touched, but without being able to localize where they were touched. Autonomic neurons are also located in the spinal cord, and these help regulate processes like urination, digestion, and heart rate. These neurons hitch a ride with the various tracts, but their cell bodies are found in the spinal cord. For example, the sympathetic division, or the fight response, has its cell bodies in the thoracic and lumbar regions, and make up the lateral horns of the gray matter. In transverse myelitis, there's inflammation of the spinal cord across an entire spinal cord segment, or even multiple segments in some instances. Most commonly, the inflammation happens at the thoracic level, but can also happen in the cervical and lumbar regions as well. The inflammation might be caused by an infection, an autoimmune disease like multiple sclerosis, or it could just be idiopathic, meaning there's no identifiable cause. Some well-known pathogens that trigger inflammation include Mycoplasma pneumonia, herpes and dengue viruses, and schistosomiasis, which is a parasitic disease. Ultimately, the inflammation damages the myelin or the neurons themselves in the spinal cord. When this happens, neurons become unable to communicate with each other, and messages going up and down the spine fail to get delivered. Symptoms of transverse myelitis depend on which tracts are damaged, and usually affect sensory, motor, or autonomic function on both sides of the body. There's usually a well-defined sensory level, meaning that the symptoms only affect the body below a certain level of the spinal cord. Damage to the corticospinal tract causes weakness and problems with voluntary muscle movement below the level of the spinal cord segment. Damage to the spinothalamic tract causes a loss of temperature and pain sensation. And damage to the dorsal column pathways causes problems with balance and spatial orientation. Diagnosis of transverse myelitis can be done with a lumbar puncture, which is when a needle is used to collect cerebrospinal fluid from around the spinal cord. In transverse myelitis, there's usually an increase in white blood cells. In addition, MRI or magnetic resonance imaging can be used to spot areas of inflammation in the spinal cord. Treatment of transverse myelitis depends on the underlying cause. If there's an autoimmune process, it might be useful to use steroids or plasmapheresis, which is where antibodies are filtered out of the blood. Alright, as a quick recap. Transverse myelitis is inflammation across a certain level in the spinal cord. It's a rare disease which can be triggered by an infectious or autoimmune process. The symptoms are related to the affected part of the spinal cord. When the corticospinal tract is affected, a person will have problems with voluntary movement. And when the spinothalamic tract is damaged, a person will have problems sensing pain. Lastly, if the dorsal column pathway is damaged, a person will have a problem with balance and spatial orientation. We've all had them. Headaches can be debilitating, and they happen when any of the pain-sensitive structures in the head and neck are stimulated. These include the meninges, blood vessels, nerves, and muscles. Headaches can be classified into primary and secondary headaches. Primary headaches include tension, migraine, and cluster headaches, whereas secondary headaches are those that are due to another underlying disorder. When an individual has a headache, especially if it feels different from their usual headaches, it's important to think through causes of secondary headaches to avoid missing something important or life-threatening. The mnemonic SNOOP, without the D-O-double-G, summarizes some of the red flags. S is for systemic symptoms like fever or weight loss. N is for neurological symptoms like weakness, sensory deficits, or vision loss. The first O is for a new or sudden onset headache. The second O is for other associated conditions like trauma. The P stands for progression or pattern, like a headache that's worsening in severity or frequency. Any of these findings warrant further investigation like brain imaging with a CT scan or MRI, and in some cases a lumbar puncture. Some clinical features might point toward a specific diagnosis, some of which might be life-threatening. For example, if the headache develops suddenly and feels like a 10 out of 10 in terms of pain right at the onset, or if it's called the worst headache of my life, then it might be a subarachnoid hemorrhage. And it's typically caused by rupture of an intracranial aneurysm. Now, if someone has a sudden headache after a trauma, and it radiates down one side of the neck and is associated with Horner syndrome, then it could be due to a carotid or vertebral artery dissection. This is also associated with pulsatile tinnitus, which is a pulsating ringing sensation in the ears. If left untreated, the dissection could extend into the intracranial vessels, leading to a stroke. Now, it's not just arteries hogging the show. The cerebral veins might become blocked in a condition called cerebral venous sinus thrombosis. This presents with exertional headache, focal neurological deficit, and signs of increased intracranial pressure like papilledema. This happens more commonly in individuals with hypercoagulable disorders, or women who are in a hyperestrogenic state, like pregnancy or use combined oral contraceptives. Now, an acute headache that's associated with fever, photophobia, neck stiffness, or altered mental status should worry you about a central nervous system infection, like meningitis or encephalitis. Also, a brain abscess can present with headache and focal neurological deficit with or without fever, and there might be signs of increased intracranial pressure like nausea, vomiting, and papilledema. Acute angle closure glaucoma might also present with an acute headache that's more intense in the periorbital region, and is classically associated with a red eye, a fixed mid-dilated pupil, and visual impairment. If a person recently had a head trauma, epidural or subdural hematomas should also be considered. Brain tumors can also present with a chronic, dull headache that's usually worse in the morning and when lying down, improves when sitting up, and is often associated with symptoms of increased intracranial pressure, like nausea, vomiting, or papilledema. Other symptoms of brain tumors include seizures, focal neurological deficit, and psychiatric symptoms, like a change in personality. Pituitary tumors can also cause a headache along with the loss of peripheral visual fields due to compression of the optic chiasm, which is known as bitemporal hemianopia. Additionally, since prolactinomas are the most common pituitary tumors, signs of hyperprolactinemia like galactorrhea, decreased libido, amenorrhea in women, or erectile dysfunction in men might also be present. Speaking of the pituitary gland, another dangerous cause of headache is pituitary apoplexy, which is bleeding in the pituitary gland. This happens when a pituitary tumor outgrows its blood supply, and causes a sudden onset headache associated with visual field loss. Also, in pregnancy, the pituitary gradually enlarges to meet the demands of breastfeeding after delivery. If women suffer from severe postpartum hemorrhage, ischemia to the pituitary can cause pituitary infarction, a condition called Sheehan syndrome. Alright, now temporal or giant cell arteritis is a vasculitis that primarily affects the extracranial carotid circulation, and it usually happens in individuals over age 50. The headache is a superficial, pounding headache along the temple of the head. In fact, the scalp might be so tender that even brushing the hair can be difficult. Other symptoms include fever, weight loss, and jaw claudication. Because giant cell arteritis involves the carotid circulation, a worrisome complication is extension of the vasculitis to involve the first branch of the internal carotid artery, the ophthalmic artery. This could potentially cause irreversible blindness in one or both eyes. Finally, a condition called idiopathic intracranial hypertension, or pseudotumor cerebri, can also cause a headache. This disorder is characterized by an increase in intracranial pressure for an unknown reason. Individuals tend to be young, obese women, and other risk factors include oral contraceptive use, as well as tetracycline and vitamin A toxicity. In addition to headache, individuals might also complain of visual disturbances like diplopia and a sixth cranial nerve palsy. On fundoscopic examination, there's usually bilateral papilledema, and the CT and MRI of the brain are usually normal. A lumbar puncture is diagnostic and reveals an opening pressure greater than 250 milliliters of water, with a normal cerebrospinal fluid analysis. Treatment consists of weight loss along with the carbonic anhydrase inhibitor acetazolamide, which helps lower the intracranial pressure. If papilledema is extensive and vision-threatening, then a procedure called optic nerve sheath fenestration surgery is done emergently. Sinusitis can also present with headache, and a characteristic feature is tenderness of the affected sinus on palpation. Finally, caffeine withdrawal can cause a mild headache approximately 12 to 24 hours after the last cup of coffee. Alright, once the secondary headaches have been excluded, primary headache disorders should be considered. Tension headaches are the most common primary headache disorder. It's a slowly progressive, bilateral, tight, band-like headache with no other associated symptoms. Typically, it lasts from 30 minutes to up to a week, and is usually triggered by stress and dehydration. Tension headaches are commonly treated with analgesics like acetaminophen and NSAIDs. A migraine headache is another primary headache, and it's more common in women. Migraine attacks usually have triggers, like specific foods, weather, bright lights, loud noises, physical exertion, or lack of sleep. Migraine headaches usually last between 4 to 72 hours, and it's usually severe, unilateral, pulsating, or throbbing pain that's aggravated by movement. Additionally, individuals can have nausea or vomiting. Often, individuals isolate themselves in a dark room to avoid light, or photophobia, as well as sound, or phonophobia. Some migraines can cause an aura before or during the headache, which consists of visual symptoms like seeing bright lights, zigzag lines or hallucinations, or other neurological symptoms like tinnitus, aphasia, or confusion. Sometimes the aura can present as a temporary paralysis of one side of the body, in which case the attack would be called a hemiplegic migraine, and can be confused with a stroke. Migraine treatment is categorized into abortive therapies, which are used to treat an acute migraine attack, and prophylactic therapies, which are used to prevent another attack from happening. Acetaminophen and NSAIDs might be used as abortive therapy for mild migraine attacks. However, they're usually ineffective at treating moderate to severe attacks. That's why medications called triptans are usually first line for the abortive treatment of most migraine attacks. An alternative to triptans are ergotamines, like dihydroergotamine. Both classes of medications act as serotonin agonists, and can be given orally, nasally, or parenterally. Importantly, triptans are contraindicated in individuals with coronary artery disease or cerebrovascular disease, and in pregnancy. Finally, dopamine antagonists like metoclopramide and prochlorperazine have also been shown to be effective abortive therapies, especially when the migraine is associated with nausea or vomiting. This is because dopamine antagonists also act as antiemetics. More often than not, a combination of different medication classes might be needed to effectively treat an acute migraine attack. For prophylaxis of migraines, there are various classes of medications that can be used. Anti-epileptics like topiramate, gabapentin, and valproic acid, beta blockers like propranolol, and tricyclic antidepressants like amitriptyline are all options. Finally, a special consideration in women with migraine with aura is that estrogen-containing contraceptives are absolutely contraindicated, because they have shown to increase the risk of stroke in this population. Cluster headaches are the rarest form of primary headache, but are the most common amongst a group called trigeminal autonomic cephalgias, and they usually happen in men. The other types of trigeminal autonomic cephalgias are incredibly rare. Cluster headache is classically described as an excruciating, stabbing pain located unilaterally behind the eye. Now, the reason they're called cluster headaches is because they usually happen every day for about 8 to 10 weeks per year, and not the rest of the year. Interestingly, these headaches happen at almost the same time every day, and last anywhere between 15 minutes to 3 hours. Cluster headaches have been linked with cigarettes and alcohol. Oftentimes, individuals with cluster headaches pace around, because there's nothing that really provides comfort. Cluster headaches are also associated with autonomic symptoms on the affected side, like ptosis, miosis, tearing, and nasal congestion. Alright, now similar to migraines, the treatment of cluster headaches is both abortive and prophylactic. Oxygen inhalation is the first option to treat an acute cluster attack. The individual should be placed on a non-rebreather mask and given 100% oxygen at a rate of 10 to 12 liters per minute. Additionally, triptans can also be used as an alternative abortive treatment option. As for the prevention of cluster headaches, the calcium channel blocker verapamil is the medication of choice. Other prophylactic options include corticosteroids, topiramate, and lithium. Now, you could imagine that individuals with primary headache disorders might frequently use analgesic medications to treat acute attacks. But this can paradoxically cause a condition called medication overuse headache, creating a vicious cycle. Therefore, the best approach for these individuals is to reduce the dose or stop the medications, which dramatically improves their headache. This is an incredibly common issue, and it isn't possible to treat an underlying primary headache disorder effectively until the medication overuse headache has been addressed, which can be incredibly challenging. Finally, there's trigeminal neuralgia, also fancily called tic douloureux. Trigeminal neuralgia is a neuropathic pain disorder that's thought to be due to compression of the trigeminal nerve in the brainstem by the superior cerebellar artery. Individuals classically describe sudden, excruciating, sharp, lightning-like unilateral facial pain in the V2 and V3 trigeminal nerve branch distribution. These attacks can be spontaneous, or they can be triggered by irritating activities like chewing, shaving, brushing the teeth, talking on the phone, or even simply smiling. The pain can be very short-lasting, causing the individual to frequently wince or grimace in response. Therefore, it might actually look like the individual has a tic, hence the name tic douloureux. Importantly, one of the core features of trigeminal neuralgia is that the neurological examination will be completely normal, despite the localized pain episodes. Now, the symptoms of trigeminal neuralgia, in particular if it occurs bilaterally, can be due to multiple sclerosis or a brainstem tumor, so it's important to consider these diseases. Alright, now the medication of choice to treat trigeminal neuralgia is carbamazepine. Alternative options include phenytoin, gabapentin, and baclofen. If medical therapy fails, surgery might be needed to cut the nerve with heat, a procedure called thermal rhizotomy. Or since it might be caused by the superior cerebellar artery compressing the trigeminal nerve, a procedure called microvascular decompression can be performed. Alright, as a quick recap. When evaluating an individual presenting with a headache, it's crucial to exclude secondary causes of headache first, as some of them can be life-threatening. Primary headaches include tension, migraine, and cluster headaches. Tension headaches are described as a tight band wrapping around the head, and last between 30 minutes to 7 days. For tension headaches, abortive treatment includes acetaminophen or non-steroidal anti-inflammatory drugs, or NSAIDs. Migraine headaches are described as a unilateral, throbbing pain, and cluster headaches are described as a retroorbital stabbing pain. Migraine headaches are often associated with an aura, photophobia, phonophobia, nausea, or vomiting, and last between 4 to 72 hours. For migraines, abortive therapy options include acetaminophen or NSAIDs for mild migraine attacks, and serotonin agonists like triptans and ergotamine, or dopamine antagonists like metoclopramide for more severe attacks. Prophylactic options for migraines include anti-epileptics like valproate, beta blockers like propranolol, or tricyclic antidepressants like amitriptyline. Cluster headaches are associated with autonomic symptoms like ptosis, meiosis, tearing, or rhinorrhea, and are short-lasting, between 15 minutes to 3 hours. Abortive therapy is oxygen inhalation, while verapamil is the medication of choice for prophylaxis. Finally, it's important to consider medication overuse headache and trigeminal neuralgia as part of the differential diagnoses.
At the neurology department, there's a 34-year-old male named Andrew who came in due to headache. This is the first time he's had a headache like this and described the pain as the worst headache of his life. Neurological examination reveals neck stiffness. His medical history is otherwise insignificant. Next to Andrew, there's a 30-year-old female named Anna who complains of recurrent episodes of unilateral, pulsating headaches that usually occur when she's tired and last approximately 6 hours every time. Her mother also suffers from similar episodes of headache. Finally, there's a 40-year-old male named Evan who has had recurrent attacks of excruciating headaches for the past 2 months. The pain is located behind his eye, typically occurs in the morning, and lasts for about 1 hour. He also has nasal congestion and lacrimation of the affected eye. He has no family history of similar episodes. All 3 people suffer from headaches. A headache occurs when any of the pain-sensitive structures in the head and neck are stimulated. These include the meninges, blood vessels, nerves, and muscles. Headaches can be classified into 2 types. The first are called primary headaches, and they're way more common. These are chronic or recurrent headaches and include tension headaches, migraines, and cluster headaches. Now, the second type are called secondary headaches, and these are acute headaches from a specific underlying cause, like a serious head injury, infection, or a brain tumor. All right, now let's take a closer look at the different types of primary headaches. Tension headaches are the most common type, and they're more common in females. On the exams, the classic description is a headache that is slowly progressive, bilateral, tight, band-like headache with no other associated symptoms. Typically, they last from 30 minutes up to a week, and is usually triggered by stress and dehydration. It is thought that these headaches are due to an increased sensitivity to pain due to the release of vasoactive neuropeptides like substance P and calcitonin gene-related peptides. These headaches can be treated acutely by NSAIDs, and chronic pain can be treated with amitriptyline or other tricyclic antidepressants. Now, a migraine headache is another primary headache, and it's also more common in females. Family history of migraines is often present. They usually have triggers, such as specific foods, weather, bright lights, loud noises, physical exertion, or lack of sleep. For your exams, you have to remember that migraine headaches usually last between 4 to 72 hours, and it's usually a severe, unilateral, pulsating, or throbbing pain that's aggravated by movement. Additionally, individuals can have nausea or vomiting. Often, individuals isolate themselves in a dark room to avoid light and sound, and this is called photophobia and phonophobia. Some migraines can cause an aura before or during the headache, which consists of visual symptoms like seeing bright lights, zigzag lines, or other neurological symptoms like tinnitus, aphasia, or confusion. Sometimes the aura can present as a temporary paralysis of one side of the body, in which case the attack would be called a hemiplegic migraine and can be confused with a stroke. The difference is, strokes don't usually cause severe headaches. For abortive therapy, NSAIDs and other analgesics can be used. Sumatriptan is used to treat more severe migraines. For prevention, lifestyle changes can make a difference, but beta blockers like propranolol or amitriptyline can also help. Now, cluster headaches are the rarest form of primary headache and usually occur in males. In the exams, cluster headaches are classically described as an excruciating, stabbing pain located unilaterally behind the eye. They usually occur every day for about 8 to 10 weeks per year, and not the rest of the year. They also occur at almost the same time every day and last anywhere between 15 minutes to 3 hours. Cluster headaches have been linked with cigarettes and alcohol. Oftentimes, individuals with cluster headaches pace around because there's nothing that really provides comfort. Another high-yield fact you have to remember for the exams is that they're usually associated with autonomic symptoms on the affected side, such as ptosis, meiosis, lacrimation, and nasal congestion. For acute pain relief, 100% oxygen and sumatriptan, a selective serotonin receptor agonist, are used. For prophylaxis, verapamil, valproic acid, or lithium are effective. Okay, now let's go over some of the causes for secondary headaches. Diagnosing a primary headache is usually based on clinical symptoms alone. But on the exams and in practice, when an individual presents with a headache, it's important to think through the secondary causes first to avoid missing something important or life-threatening. There are some findings that point towards a secondary headache like new or sudden onset of headache that is worsening in severity or frequency, systemic symptoms such as fever or weight loss, neurological symptoms like weakness, sensory deficits, or vision loss, and other associated conditions like history of trauma. Any of these findings warrant further investigation, like brain imaging with a CT scan or MRI, and in some cases, a lumbar puncture. Also, some clinical features may point towards a specific diagnosis. A high-yield cause you're likely to see on the exams is subarachnoid hemorrhage, that it's usually caused by rupture of an intracranial aneurysm. Typically, the headache develops suddenly and rates 10 out of 10 in terms of pain, right at its onset. It's often described as the worst headache of my life. Meningeal signs like neck stiffness are often present. If a person's recently had a head trauma, epidural or subdural hematomas should be considered. Now, if someone has a sudden headache after a trauma, and it radiates down one side of the neck, and there's Horner syndrome, which is unilateral ptosis, meiosis, and anhidrosis, then it could be due to a carotid or vertebral artery dissection. This is also associated with pulsatile tinnitus, which is a pulsating, ringing sensation in the ears. If left untreated, the dissection could extend into the intracranial vessels, leading to a stroke. Now, the cerebral veins can also become blocked in a condition called cerebral venous sinus thrombosis. This presents with exertional headache, focal neurological deficit, and signs of increased intracranial pressure like papilledema. This occurs more commonly in individuals with hypercoagulable disorders, or women who are in a hyperestrogenic state, such as pregnancy or taking combined oral contraceptives. Now, an acute headache that's associated with fever, photophobia, meningeal signs like neck stiffness, and altered mental status should make you think about meningitis. Sinusitis can also present with headache and fever, and a characteristic feature is tenderness of the affected sinus on palpation. Next, a brain abscess can present with headache and focal neurological deficit with or without fever, and there may be signs of increased intracranial pressure like nausea, vomiting, and papilledema. Brain tumors can also present with focal neurological defects or seizures. The headaches they cause are characterized as a chronic, dull headache that is usually worse in the morning and when lying down. Improves when sitting up and is often associated with symptoms of increased intracranial pressure, such as nausea, vomiting, or papilledema. Pituitary tumors can cause headache along with a loss of peripheral vision fields due to compression of the optic chiasm, which is known as bitemporal hemianopsia. Additionally, since prolactinomas are the most common pituitary tumors, signs of hyperprolactinemia such as galactorrhea, decreased libido, amenorrhea in women, or erectile dysfunction in men may also be present. Speaking of the pituitary gland, another dangerous cause of headache is pituitary apoplexy, which is bleeding in the pituitary gland. This occurs when a pituitary tumor outgrows its blood supply and causes a sudden onset headache associated with visual field loss. Also in pregnancy, the pituitary gradually enlarges to meet the demands of breastfeeding after delivery. If a woman suffers from severe postpartum hemorrhage, ischemia to the pituitary can cause pituitary infarction, a condition called Sheehan syndrome. Acute angle closure glaucoma may also present with an acute headache that is more intense in the periorbital region and is classically associated with a red eye, a fixed mid-dilated pupil, and visual impairment. Okay, now temporal or giant cell arteritis is a vasculitis that primarily affects the extracranial carotid circulation. In the exams, the classic presentation is a female individual over age 50 with a superficial pounding headache along the temple on one side of the head. In fact, the scalp may be so tender that the patient complains even brushing their hair can cause pain. Other symptoms that can be important clues for the diagnosis include fever, weight loss, and jaw claudication, causing pain when chewing. Because giant cell arteritis involves the carotid circulation, a worrisome complication is extension of the vasculitis to involve the first branch of the internal carotid artery, the ophthalmic artery. This could potentially cause irreversible blindness in one of the eyes. Next, a condition called idiopathic intracranial hypertension or pseudotumor cerebri can cause daily headaches. This disorder is characterized by an increased intracranial pressure due to an unknown reason. The headache worsens with the Valsalva maneuver. This is because both cerebral blood flow and intracranial pressure changes when the maneuver increases intrathoracic pressure. Individuals tend to be young, obese women, and other risk factors include oral contraceptive use, as well as tetracycline and vitamin A toxicity. In addition to headache, individuals may also complain of visual disturbances such as diplopia, which is due to cranial nerve 6, or abducens nerve palsy. On fundoscopic examination, there's usually bilateral papilledema or swelling around the optic nerves. There could also be edema of the optic discs due to optic nerve compression. While CT and MRI of the brain are usually normal, a lumbar puncture is diagnostic and reveals an elevated opening pressure with a normal cerebrospinal fluid analysis. Treatment consists of weight loss along with the carbonic anhydrase inhibitor, acetazolamide, which helps lower the intracranial pressure. If papilledema is extensive and vision-threatening, then a procedure called optic nerve sheath fenestration surgery is done emergently. Okay, now a pain disorder that you have to distinguish from a headache is trigeminal neuralgia, also fancily called tic douloureux. Trigeminal neuralgia is a neuropathic pain disorder that is thought to be due to compression of the trigeminal nerve in the brainstem by the superior cerebellar artery. Individuals classically describe sudden, excruciating, sharp, lightning-like unilateral facial pain in the V2 and V3 trigeminal nerve branch distribution. These attacks can be spontaneous, or they can be triggered by irritating activities like chewing, shaving, brushing the teeth, talking on the phone, or even simply smiling. The pain can be very short-lasting, causing the individual to frequently wince or grimace in response. Therefore, it might actually look like the individual has a tic, hence the name tic douloureux. Importantly, one of the core features of trigeminal neuralgia is that the neurological examination will be completely normal, despite the localized pain episodes. The treatment is carbamazepine. Finally, a high-yield fact is that trigeminal neuralgia, especially if it occurs bilaterally, can be due to multiple sclerosis or a brainstem tumor, so it's important to consider these diseases. Finally, caffeine withdrawal can also cause a mild headache approximately 12 to 24 hours after the last cup of coffee. Alright, as a quick recap. Headaches occur when the pain-sensitive structures in the head and neck are affected, and they can be primary or secondary. Primary headaches include tension headaches, migraines, and cluster headaches, while secondary are due to underlying diseases. For primary headaches, the diagnosis can be made based on clinical findings. If secondary causes are suspected, further investigation like head CT, MRI, or lumbar puncture must be done. Back to our patients. Due to his description of the headache as the worst headache of his life and the presence of meningeal signs, Andrew most likely has secondary headache due to subarachnoid hemorrhage. In order to confirm the diagnosis, brain imaging with head CT or MRI must be ordered. Now, Anna and Evan have recurrent episodes of headaches, and so they most probably have primary headaches. Due to their descriptions, Anna has migraines while Evan has cluster headaches.
Headaches are a type of pain in the head, and they can also be a pain in the neck. And there are two main types. The first are called primary headaches, and they're more common. These are chronic or recurrent headaches that account for over 90% of all headaches. Some examples are migraine headaches, tension headaches, and cluster headaches. The second type are called secondary headaches, and these are more acute and come from a specific underlying cause, like a serious head injury or a brain tumor. So normally throughout the body, there are these special neurons that act as pain receptors. These neurons convert a painful stimulus into an electrical signal that conveys the feeling of pain to the brain. The brain itself doesn't have pain receptors, but nearby tissues in the head and neck, like the blood vessels, meninges, and muscles, do. These pain receptors might be stimulated by a variety of things, such as blood vessel spasm, like in vasculitis, increased pressure, like from a tumor, inflammation, like in meningitis, or increased muscle tension, like in temporomandibular disorder. That helps explain the pain in secondary headaches. Now, in primary headaches, the exact mechanisms are still unknown, but we know tension headaches are the most common. It's called a tension headache because it feels like a band is squeezing down on the head, applying constant pressure, or tension. The pain is mild to moderate, can last for a few hours, and usually there are no associated symptoms. Tension headaches are usually triggered by stress, lack of sleep, and dehydration. Imagine being late to work right after a night of drinking heavily and not sleeping much. Migraines are the second most common primary headache. They're often preceded by symptoms like irritability, depression, and fatigue that can begin hours to days before the headache itself. Sometimes there can be an aura where people experience strange smells, lights, visual disturbances, or even hallucinations before the onset of the migraine. The migraine itself usually feels like a pounding or pulsating, typically localized to one side of the head and can last from hours to days. As if this wasn't bad enough, these headaches tend to come with nausea, vomiting, irritability, pain, or discomfort with lights, sounds, and smells called photophobia, phonophobia, and osmophobia, respectively. During childhood, individuals can have nausea and vomiting without the headaches, and that's called an abdominal migraine. After a migraine's over, it can leave people feeling sore at the location of the pain and generally fatigued. To remember the main features of migraines, you can use the mnemonic POUND, where P stands for pulsatile headache, O stands for 1 day duration, U stands for unilateral, N for nausea, and D for disabling. Although the underlying mechanism causing migraines isn't well understood, there are some clues. Concentrations of the neurotransmitter serotonin increase during the aura, triggering vasoconstriction, and then decrease to lower than normal levels during the migraine attack, triggering vasodilation. This change in the blood vessel size may be a trigger for pain receptors, causing the headache. The initial vasoconstriction may also trigger cortical spreading depression, which is a phenomenon when the brain becomes hypersensitive to certain stimuli, like lights, sounds, and smells. In young women, migraines are often associated with hormonal shifts that occur during the menstrual cycle, starting up in adolescence and becoming less frequent after menopause. Migraines are often associated with specific triggers like the smell of cigarette smoke, foods like chocolate or cheese, and drinking wine. Even sleeping too much or too little can sometimes be a trigger. Finally, there are cluster headaches, which is where headache pain comes and goes, sometimes with clusters of 8 or 10 in a day. The pain is extremely strong, like a shooting or stabbing pain that's usually around one eye, and it can even awaken individuals from sleep. They usually happen at the same time each day or night, so they're sometimes called alarm clock headaches. Each cluster of attacks can last from minutes to hours and comes with autonomic symptoms like a swollen eyelid, red eye, tearing, or a runny nose. Some individuals develop a certain triad of symptoms, a constricted pupil or miosis, droopy eyelid or ptosis, and decreased sweating or anhidrosis, and together this is called Horner's syndrome. Some individuals have headache-free periods that can last months to years. Finally, cluster headaches are more common in men, and there are usually no clear triggers. Diagnosing a primary headache is usually based on the description alone. Sometimes neuroimaging and laboratory tests are used to make sure that it's not a secondary headache. For primary headaches, there are two treatment approaches. Acute treatment, like acetaminophen and nonsteroidal anti-inflammatory drugs to help manage the pain, and preventative treatment to keep headaches from happening in the first place in individuals that have severe, debilitating headaches. For tension headaches, pain medication can be used acutely, and improving sleep habits and reducing stress, as well as tricyclic antidepressants in some cases, can be helpful in preventing them. For migraines, acutely, pain medications work best if they're used at the first sign of an attack, during the early symptoms or aura. If the pain is very severe, triptans or ergotamine, which are serotonin agonists, can be useful because they mimic serotonin and cause vasoconstriction. Migraine medications are sometimes used with caffeine to be more effective. For preventative treatment, there are many options, including beta blockers and calcium channel blockers, tricyclic antidepressants, and some anti-seizure medications like valproate. For cluster headaches, acute attacks can be managed with oxygen through a face mask or by taking triptans, and can be prevented with medications like verapamil. Alright, as a quick recap, primary headaches account for 90% of all headaches, and they don't have a specific or known cause. They include tension headaches, migraines, and cluster headaches. Tension headaches are mild to moderate pain that feel like a band squeezing the head. Migraines are moderate to severe pain attacks that are pulsating, mostly unilateral, and can have associated symptoms like nausea, vomiting, and photophobia. They're also sometimes preceded by auras. Cluster headaches are severe pain attacks around one eye that come and go at the same time every day and can have associated autonomic symptoms. Secondary headaches have an underlying cause, which might be life-threatening and therefore must be treated in time.
Arterio refers to the arteries, which are the blood vessels that take blood away from the heart, and venous refers to the veins, which carry blood toward the heart. Mal means badly, so an arteriovenous malformation, or AVM, is some sort of bad or abnormal formation between the arteries and the veins. Typically, oxygen-rich blood is carried to the body's tissues via arteries. Large arteries split into smaller and smaller arteries and feed into capillary beds, where cells exchange oxygen for carbon dioxide. The capillaries then feed into larger and larger veins, which carry deoxygenated blood away from the tissues. Normally, arterial blood is under a high-pressure system, and as it goes through smaller and smaller vessels, ultimately into the capillary bed, pressure in the vessels becomes significantly lower, and blood drains into the lower-pressure systemic veins. So this capillary bed dampens the arterial flow a bit. With AVM, this whole capillary bed isn't there, and a group of arteries directly link up with a group of veins instead. The vessels in the AVM can start to tangle up and are called a nidus, which is Latin for nest. When a single artery and a single vein link up abnormally like this, it's called an arteriovenous fistula. In AVM, the arteries and the veins are both under high systolic blood pressures because there are no capillaries to dampen the pressure, which means that the AVM can expand in size over time and can put pressure on the surrounding tissue. This pressure on surrounding capillaries can pinch them shut and prevent that functional tissue from getting blood flow. Also, the high pressure causes the arteries supplying blood to dilate, while the veins thicken and undergo fibrosis. Vessel walls are also prone to forming aneurysms, which are these balloon-like protrusions. And because the vessel walls are weakened and stretched out, they're also at risk of ripping and tearing. Although AVMs can form anywhere in the body, they most often form in certain parts of the body, like the brain, the spinal cord, and the lungs. If the AVM ruptures in the brain, blood escapes into the surrounding brain tissue. Sometimes a blood loss can be small, called a microbleed, which doesn't typically cause much damage. But sometimes when blood loss is severe enough, people might experience what's called an intracerebral or subarachnoid hemorrhage. Depending on the location, this can cause several neurological complications, like headaches or seizures, as well as other neurological symptoms that can relate to the part of the brain affected. Like, for example, if it affects the hippocampus, it might affect the person's memory, or if it's the basal ganglia, it might affect their ability to move. In the spinal cord, AVMs can, by the same mechanisms, damage nerve fibers, which can cause sensory disturbances, muscle weakness, or even paralysis in the parts of the body controlled by the affected nerves. In the lungs, an AVM might result in shortness of breath or coughing up blood. It's also important to remember that having blood flow out of the heart to an artery then through the AVM to a vein, and directly back to the heart is a lot of wasted work, since that oxygen's not going to the tissue's capillaries like it should, and it's just rerouting back to the heart, which ultimately causes the heart to work harder. And over time, an AVM can contribute to heart failure because the heart's doing extra work with each beat. Diagnosis might involve several imaging techniques, one of which is angiography, which is actually the gold standard, but others are CT scans and MRI. Aside from imaging, a distinctive clinical sign of an AVM is a bruit, which is French for noise. When blood flows rapidly through the AVM, it causes a whooshing noise. Sometimes this noise can get so loud, especially if the AVM is in the brain, that the person can hear it themselves, which can cause serious psychological stress, not to mention making it hard to sleep or hear other things. The cause of AVMs isn't well understood, although it's thought to be congenital and caused by some mistaken blood vessel growth during embryonic or fetal development, some of which seems to be genetic. One well-known relationship is with Osler-Weber-Rondeau disease, which is an autosomal dominant disorder that causes problems with blood vessels throughout the body. Most AVMs are treated even if the person's not symptomatic, because of the risk of complications like bleeding. Medications can be used to treat certain symptoms from an AVM, like headaches, but also they might have certain procedures, like radiosurgery, where beams of radiation are targeted at the AVM, causing the vessels to scar and close off. Or they might have endovascular embolization, where a catheter is used to obstruct the vessels. Because the location of the AVM varies so widely, usually the procedure varies on a case-by-case basis. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. Epidural hemorrhage can be broken down. Epi means above. Dural refers to the outermost protective layer of the brain, which is called the dura mater, and hemorrhage refers to bleeding. So an epidural hemorrhage is when there's bleeding above the dura mater. Alright, let's start with some basic brain anatomy. The brain is protected by the meninges, which are three thin layers of tissue which cover the brain and spinal cord. The inner layer of the meninges is the pia mater, the middle layer is the arachnoid mater, and the outer layer is the dura mater. The pia and arachnoid maters are also called leptomeninges. Between the leptomeninges, there's the subarachnoid space, which houses cerebrospinal fluid, or CSF. CSF is a clear, watery liquid which is pumped around the spinal cord and brain, cushioning them from impact and bathing them in nutrients. The outer membrane, the dura mater, consists of two layers. The internal layer of the dura mater lies above the arachnoid mater, and the two are separated by the subdural space. The external layer of the dura mater adheres to the inner surface of the skull. These two layers of the dura mater travel together, but at certain spots the internal layer of the dura mater separates from the external one to form the meningeal folds. The meningeal folds help divide the sections of the brain, like the falx cerebri, which separates the two hemispheres of the cerebrum, and the tentorium, which covers the cerebellum and separates it from the cerebrum. Between the external layer of the dura mater and the inner surface of the skull, there are arteries that supply the meninges. The most common cause of epidural hemorrhage is a head trauma, which might happen after tripping and falling in a bathtub. The meningeal arteries are protected by the skull, but can be damaged by a serious head trauma. The most common site is at the pterion, which is the spot where the frontal, parietal, temporal, and sphenoid bones join together. This section of the skull is relatively thin and it's located right above the middle meningeal artery. When a blood vessel is damaged and there's active bleeding, it's called a hemorrhage, and the collection of blood that results is called a hematoma. In the case of an epidural hemorrhage, once a meningeal artery is torn, blood will pool between the skull and the external layer of the dura mater, separating it from the inner surface of the skull. The blood builds up between the skull and the outer layer of the dura mater, but can't cross the suture lines where the dura mater adheres more tightly. If blood accumulates slowly, there might be a lucid interval, which is when several hours pass before the onset of symptoms. A large epidural hematoma on one side of the skull can cause a midline shift, which is a displacement of the whole brain towards the opposite side of the skull. A large epidural hematoma can also cause an increase in intracranial pressure, and that can cause the brain to shift or herniate. There can be a supratentorial herniation, where the cerebrum is pushed against the skull or the tentorium, and an infratentorial herniation, where the cerebellum is pushed against the brainstem. Both of these can be lethal. Supratentorial herniations can compress the arteries that nourish the brain, which can lead to an ischemic stroke. And infratentorial herniations can compress part of the brainstem, which can affect consciousness, respiration, and heart rate. The most common symptom of an epidural hemorrhage is loss of consciousness after the head trauma, due to a concussion. In a slow epidural bleed, people might have a lucid interval, which is when they improve temporarily right after the initial trauma, but then deteriorate as the epidural hematoma grows. There can also be headaches and vomiting, as well as focal neurological symptoms like muscle weakness or sensory problems, depending on the location of the hematoma. Diagnosis of an epidural hemorrhage is typically done with an imaging study. On a CT scan, an epidural hematoma shows up as a hyperdense mass, meaning that it looks more white than the surrounding healthy brain tissue. Here's a CT scan of an intracranial epidural bleeding. On the left of the skull, there's a fracture, and underlying it is a hematoma, with a characteristic biconvex shape, meaning that it's curved on both sides. Epidural hemorrhages cause blood to build up between the outer layer of the dura mater and the skull. Since the outer layer of the dura mater adheres tightly to the skull at sutures, epidural hematomas don't cross suture lines, and they push on the brain, forming a biconvex shape. In contrast, the blood in a subdural hemorrhage is between the arachnoid and the inner layer of the dura mater. So on a CT scan, subdural hematomas follow the contour of the brain and form a crescent shape and cross suture lines. Most epidural hemorrhages are treated by craniotomy, which is when part of the skull bone is removed in order to remove the accumulating blood below. Alright, as a quick recap. An epidural hemorrhage is a bleeding above the dura mater caused by a head trauma, most commonly in the temporal region called terion, which lies above the middle meningeal artery. A slow-forming epidural hemorrhage can cause a lucid interval where a person initially seems to improve before deteriorating again. On a CT scan, epidural hematomas don't cross suture lines, and they push on the brain, which forms a biconvex shape. And this is unlike subdural hematomas, which can cross suture lines and follow the contour of the brain and form a crescent shape.
There are two main types of stroke: a hemorrhagic stroke, which occurs when an artery ruptures and bleeds within the brain, and an ischemic stroke, which occurs when an artery gets blocked. Hemorrhagic strokes can be further split into two types: an intracerebral hemorrhage, which is when bleeding occurs within the cerebrum, and a subarachnoid hemorrhage, which is when bleeding occurs between the pia mater and the arachnoid mater of the meninges, the inner and middle layers that wrap around the brain. We'll be focusing on intracerebral hemorrhages, which are more common. An intracerebral hemorrhage that involves just the brain tissue is called an intraparenchymal hemorrhage. Whereas if the blood extends into the ventricles of the brain which store cerebrospinal fluid, it's called an intraventricular hemorrhage. The brain has a few regions. The most obvious is the cerebrum, which is divided into two cerebral hemispheres, each of which has a cortex, an outer region, divided into four lobes, including the frontal lobe, the parietal lobe, the temporal lobe, and the occipital lobe. There are also a number of additional structures, including the cerebellum, which is down below, as well as the brainstem, which connects to the spinal cord. The right cerebrum controls muscles on the left side of your body and vice versa. The frontal lobe controls movement and executive function, which is our ability to make decisions. The parietal lobe processes sensory information, which lets us locate exactly where we are physically and guides movement in a three-dimensional space. The temporal lobe plays a role in hearing, smell, memory, as well as visual recognition of faces and language. Finally, there is the occipital lobe, which is primarily responsible for vision. The cerebellum helps with muscle coordination and balance. And finally, there's the brainstem, which plays a vital role in functions like heart rate, blood pressure, breathing, gastrointestinal function, and consciousness. The brain receives blood from the left and right internal carotid arteries, as well as the left and right vertebral arteries, which come together to form the basilar artery. The internal carotid arteries turn into the left and right middle cerebral arteries, which serve the latter portions of the frontal, parietal, and temporal lobes of the brain. Each of the internal carotid arteries also gives off branches called the anterior cerebral arteries, which serve the medial portion of the frontal and parietal lobes, and connect with one another with a short little connecting blood vessel called the anterior communicating artery. Meanwhile, the vertebral arteries and basilar arteries give off branches to supply the cerebellum and the brainstem. In addition, the basilar artery divides to become the right and left posterior cerebral artery, which mainly serves the occipital lobe and some of the temporal lobe as well as the thalamus. Finally, the internal carotid arteries each give off a branch called the posterior communicating artery, which attaches to the posterior arteries on each side. So together, the main arteries and the communicating arteries complete what is called the circle of Willis, a ring where blood can circulate from one side to the other in case of a blockage. There are a few ways that an intracerebral hemorrhage might happen. The most common one is through hypertension or high blood pressure. Hypertension can lead to various vessel wall abnormalities. Hypertension can lead to hyaline arteriolosclerosis, which results from hydrostatic pressure pushing proteins out of the blood vessel lumen and into the interstitial space within the blood vessel walls. Over time, as more of these proteins deposit into the walls, the blood vessels become more stiff and brittle, and therefore more vulnerable to rupture. Hypertension can also cause tiny bulges in the walls of the small arteries, called microaneurysms. These microaneurysms are called Charcot-Bouchard aneurysms, and they're more likely to be found on small arteries like lenticulostriate vessels, which arise from the anterior part of the circle of Willis and supply the basal ganglia. Intracerebral hemorrhages are sometimes associated with arteriovenous malformations, which are a tangle of blood vessels that directly connect an artery to a vein. A bit like a capillary bed, but with much, much larger blood vessels. Over time, these abnormal vessels can rupture, causing a hemorrhagic stroke. Intracerebral hemorrhages are also associated with conditions that damage the arteries in the cerebrum themselves, like vasculitis, a disease where inflammation of the blood vessel walls occurs, vascular tumors like hemangioma, which is a benign vascular tumor of the endothelial cells of the blood vessels, and cerebral amyloid angiopathy, which is a degenerative disease where abnormal protein deposits in the walls of the arterioles make them less compliant. Intracerebral hemorrhage can also be secondary, arising after an ischemic stroke. An ischemic stroke is caused by a blockage of blood flow to a part of the brain, and within hours it usually leads to brain tissue death. Arteries within the ischemic tissues are themselves made up of endothelial cells that die off, and that means that if there's reperfusion or return to blood flow, there's an increased chance that the damaged blood vessels might rupture, causing a hemorrhage. If this happens, there's bleeding into dead tissue, and it's called a hemorrhagic conversion. Regardless of the cause, once there's an intracerebral hemorrhage, blood starts spewing from the damaged blood vessels, creating a pool of blood, which increases pressure in the skull and puts direct pressure on nearby tissues and blood vessels. It also means that less blood is flowing downstream to the cells that need it, which leave the downstream tissues deprived of oxygen-rich blood. Healthy tissues can die from both the direct pressure and the lack of oxygen within a few hours. Increased pressure within the skull can also lead to brain herniation, which is when the brain moves across structures in the skull. These structures include the falx cerebri, which divides the two halves of the brain, the tentorium cerebelli, which divides the occipital lobes from the cerebellum, and the foramen magnum, which is the hole in the base of the skull where the spinal cord connects to the brain. Stroke symptoms depend on the exact part of the brain that is affected. For example, an anterior or middle cerebral artery stroke can cause numbness and sudden muscle weakness. If a stroke affects the Broca's area, which is usually in the left frontal lobe, or the Wernicke's area, which is usually in the left temporal lobe, then it can cause slurred speech or difficulties understanding speech, respectively. If there's a posterior cerebral artery stroke, then it can affect vision. An acronym to remember some common stroke symptoms is FAST: facial drooping, arm weakness, speech difficulties, and time. Time is obviously not a symptom, but just a reminder to get help as quickly as possible to minimize cell injury and maximize the chance of a full recovery. To diagnose and confirm the location and size of a hemorrhagic stroke, medical imaging with a CT or MRI can be used. Also, angiography, which uses contrast injected into the blood, can help to visualize the exact location where blood accumulates in the brain tissue. Medical treatment of an intracerebral hemorrhage includes using drugs that help control hypertension and relieve intracranial pressure. In terms of surgery, a craniotomy is often helpful at relieving intracranial pressure when there's a bleed near the surface of the skull. In a craniotomy, part of the skull bone is removed to drain any accumulated blood and relieve pressure. Alternatively, if there's a bleed that's located deep in the brain tissue, stereotactic aspiration can be done to aspirate off blood and relieve intracranial pressure. Stereotactic aspiration is done under a CT scanner to help guide a needle to the exact spot where the blood needs to be drained. Alright, as a quick recap, an intracerebral hemorrhage is a type of hemorrhagic stroke where an artery breaks within the cerebrum. The result is a pool of blood forms which increases intracranial pressure, and downstream tissue gets deprived of oxygen-rich blood. Intracerebral hemorrhages can be treated with medications aimed at controlling the high intracranial pressure, as well as surgical interventions like craniotomy or stereotactic aspiration, which can help remove the pool of blood. The goal is to identify symptoms and to reestablish blood flow to prevent long-term damage. To help remember this, a common acronym is FAST: facial drooping, arm weakness, speech difficulties, and time. There are two main types of stroke: a hemorrhagic stroke, which occurs when an artery ruptures and bleeds within the brain, and an ischemic stroke, which occurs when an artery gets blocked. Hemorrhagic strokes can be further split into two types: an intracerebral hemorrhage, which is when bleeding occurs within the cerebrum, and a subarachnoid hemorrhage, which is when bleeding occurs between the pia mater and the arachnoid mater of the meninges, the inner and middle layers that wrap around the brain. We'll focus on the subarachnoid hemorrhage, which can quickly lead to death if they're left untreated. Subarachnoid hemorrhages can lead to a pool of blood under the arachnoid mater that increases the intracranial pressure and prevents more blood from flowing into the brain. Okay, let's start with the three protective layers of the brain called meninges. The inner layer of the meninges is the pia mater, the middle layer is the arachnoid mater, and the outer layer is the dura mater. Between the arachnoid mater and the pia mater is the subarachnoid space, which houses cerebrospinal fluid, or CSF. CSF is a clear, watery liquid which is pumped around the spinal cord and brain, cushioning them from impact and bathing them in nutrients. This space is also where the arteries that supply the brain travel, and it is the location of the blood-brain barrier where CSF and the vascular system can exchange nutrients. The brain has a few regions. The most obvious is the cerebrum, which is divided into two cerebral hemispheres, each of which has a cortex, an outer region, divided into four lobes including the frontal lobe, the parietal lobe, the temporal lobe, and the occipital lobe. There are also a number of additional structures, including the cerebellum, which is down below, as well as the brainstem, which connects to the spinal cord. The right cerebrum controls muscles on the left side of your body and vice versa. The frontal lobe controls movement and executive function, which is our ability to make decisions. The parietal lobe processes sensory information, which lets us locate exactly where we are physically and guides movement in a three-dimensional space. The temporal lobe plays a role in hearing, smell, memory, as well as visual recognition of faces and language. Finally, there is the occipital lobe, which is primarily responsible for vision. The cerebellum helps with muscle coordination and balance. And finally, there's the brainstem, which plays a vital role in functions like heart rate, blood pressure, breathing, gastrointestinal function, and consciousness. The brain receives blood from the left and right internal carotid arteries, as well as the left and right vertebral arteries, which come together to form the basilar artery. The internal carotid arteries turn into the left and right middle cerebral arteries, which serve the latter portions of the frontal, parietal, and temporal lobes of the brain. Each of the internal carotid arteries also gives off branches called the anterior cerebral arteries, which serve the medial portion of the frontal and parietal lobes, and connect with one another with a short little connecting blood vessel called the anterior communicating artery. Meanwhile, the vertebral arteries and basilar arteries give off branches to supply the cerebellum and the brainstem. In addition, the basilar artery divides to become the right and left posterior cerebral artery, which mainly serves the occipital lobe and some of the temporal lobe as well as the thalamus. Finally, the internal carotid arteries each give off a branch called the posterior communicating artery, which attaches to the posterior arteries on each side. So together, the main arteries and the communicating arteries complete what is called the circle of Willis, a ring where blood can circulate from one side to the other in case of a blockage. Three things can cause a subarachnoid hemorrhage. The first and most common cause of a subarachnoid hemorrhage is a traumatic injury, like falling in the bathtub and hitting your head. Arteries in the subarachnoid space are unsupported and can easily break. The second cause is an aneurysm, which is a blood vessel that has weak walls and starts to bulge out to about 1.5 times larger than its normal diameter. The most common aneurysms in the brain are saccular cerebral aneurysms, which have a characteristic rounded shape on one side of the artery and are also called baryaneurysms. Most saccular cerebral aneurysms arise in the anterior half of the circle of Willis, whereas only a few arise in the posterior half. Some genetic disorders like Marfan syndrome can cause a defect in the connective tissues of arteries, and they can also predispose individuals to having saccular aneurysms. Aneurysms can burst open when there's an increase in intracranial pressure, like what you might feel when you're moving a large sofa into the living room. The third cause of a subarachnoid hemorrhage is an arteriovenous malformation. Normally, arteries and veins are connected by small, leaky blood vessels called capillaries, but in arteriovenous malformations, they are replaced with abnormally formed tangled blood vessels, characterized by at least one direct connection between the artery and the vein. Over time, these abnormal vessels can dilate, and since veins aren't used to dealing with high arterial pressures, they can rupture, causing a subarachnoid hemorrhage. Regardless of the cause, once there's a subarachnoid hemorrhage, blood starts spewing out from a damaged blood vessel and creates a pool of blood which increases pressure in the skull and puts direct pressure on nearby tissue cells and blood vessels. It also means that less blood is flowing downstream to the cells that need it, which leaves the downstream tissue deprived of oxygen-rich blood. Healthy tissues can die from both the direct pressure and the lack of oxygen within a few hours. Another complication is that blood vessels that are bathing in a pool of blood can start to intermittently vasoconstrict, which is called vasospasm. If the vasospasm affects arteries in the circle of Willis, it will reduce the supply of blood flow to the brain, causing further ischemic injury. Over time, blood in the subarachnoid space can irritate the meninges and cause inflammation, which leads to scarring of the surrounding tissue. The scarring tissue can obstruct the normal outflow of cerebrospinal fluid, causing that fluid to build up, and that dilates the ventricles at the center of the brain. And this is referred to as hydrocephalus. As the ventricles dilate, there's also increased intracranial pressure, which compresses the brain tissue. Stroke symptoms depend on the exact part of the brain that is affected. For example, an anterior or middle cerebral artery stroke can cause numbness and sudden muscle weakness. If a stroke affects the Broca's area, which is usually in the left frontal lobe, or the Wernicke's area, which is usually in the left temporal lobe, then it can cause slurred speech or difficulties understanding speech, respectively. If there's a posterior cerebral artery stroke, then it can affect vision. An acronym to remember some common stroke symptoms is FAST: facial drooping, arm weakness, speech difficulties, and time. Time is obviously not a symptom, but just a reminder to get help as quickly as possible to minimize cell injury and maximize the chance of a full recovery. The classic symptoms of a subarachnoid hemorrhage is the sudden onset of a severe headache called a thunderclap headache. It's often described as the worst headache a person has ever had. There's also something called nuchal rigidity, or neck stiffness, which is caused by the blood irritating the meninges. Occasionally, people can develop seizures and symptoms of increased intracranial pressure like vomiting, vision changes, and general confusion. The diagnosis of a subarachnoid hemorrhage is usually made with a CT or MRI scan, which usually shows blood pooling in the subarachnoid space around the damaged artery. Classically, a lumbar puncture will show red blood cells, or yellowness from bilirubin called xanthochromia. That's because there may be fresh blood around the spinal canal, or old blood that's being metabolized and broken down. Treatment of a subarachnoid hemorrhage typically involves emergent surgery. An artery that's bleeding can be surgically clipped to apply direct pressure to it. Alternatively, a catheter can be used to place a coil in an aneurysm, which serves as a site for clot formation, which also seals up the aneurysm. And sometimes medications like calcium channel blockers can be used to help prevent arterial vasospasm from setting in. Alright, as a quick recap, a subarachnoid hemorrhage is a pooling of blood in the subarachnoid space. It can arise due to a traumatic injury like hitting your head in the bathtub, having a pre-existing saccular aneurysm burst, or from a pre-existing arteriovenous malformation that bursts. Usually there's a sudden and severe thunderclap headache that's described as the worst headache of a person's life. Diagnosis is usually done with a CT or MRI that shows blood in the subarachnoid space and blood in a lumbar puncture. Treatment is done by surgical clipping or coiling.
Subdural hemorrhage can be broken down. Sub means below. Dural refers to the outermost protective layer of the brain, which is the dura mater. And hemorrhage refers to bleeding. So a subdural hemorrhage is when there's bleeding below the dura mater. Alright, let's start with some basic brain anatomy. The brain is protected by the meninges, which are three thin layers of tissue which cover the brain and spinal cord. The inner layer of the meninges is the pia mater, the middle layer is the arachnoid mater, and the outer layer is the dura mater. The pia and arachnoid maters are also called leptomeninges. Between the leptomeninges, there's the subarachnoid space, which houses cerebrospinal fluid, or CSF. CSF is a clear, watery liquid which is pumped around the spinal cord and brain, cushioning them from impact and bathing them in nutrients. The outer membrane, the dura mater, consists of two layers. The internal layer of the dura mater lies above the arachnoid mater, and the two are separated by the subdural space. The external layer of the dura mater adheres to the inner surface of the skull. These two layers of the dura mater travel together, but at certain spots the internal layer of the dura mater separates from the external one to form the meningeal folds. The meningeal folds help divide the sections of the brain, like the falx cerebri, which separates the two hemispheres of the cerebrum, and the tentorium, which covers the cerebellum and separates it from the cerebrum. Between the external layer of the dura mater and the inner surface of the skull, there are arteries that supply the meninges. The subdural space plays a major role in venous blood drainage in the brain. The surface of the brain is supplied by numerous arteries in the subarachnoid space that provides oxygen-rich blood to the brain. After the brain tissue has taken up the oxygen and nutrients, the blood drains into superficial cerebral veins, or bridging veins, that also sit in the subarachnoid space. These veins travel through the arachnoid mater, pass through the subdural space, and penetrate the inner layer of the dura mater to drain into the dural venous sinuses located between the two layers of the dura mater. Eventually, the blood in the venous sinuses drains into the internal jugular vein and returns to the heart. So, the main cause of a subdural hemorrhage is a rupture of the bridging veins located in the subdural space. When a blood vessel is damaged and there's active bleeding, it's called a hemorrhage, and the collection of blood that results is called a hematoma. Some people, like the elderly, often have brain atrophy, where their brain shrinks in size. And that means that the bridging veins are stretched across a wider space where they're largely unsupported, kind of like a rickety bridge across a mountain pass. In infants and in individuals that abuse alcohol, the veins are thin-walled, and therefore more likely to break. Subdural hematomas are common in head traumas, like falling in a wet bathtub and whacking your head, or in shaken baby syndrome, where a baby is violently shaken, making their head whip back and forth, which damages the bridging veins. Subdural hematomas can also happen after an acceleration-deceleration injury, like speeding on the road and then suddenly slamming on the brakes. When that happens, the seatbelt will stop the body and head from moving forward, but the momentum will carry the brain forward where it impacts the front of the skull. Right after that, the head moves backwards and hits the headrest, causing the brain to impact the back of the skull. That rapid back and forth movement once again causes damage to the bridging veins. Regardless of the mechanism, once a bridging vein is torn, the blood pools in the subdural space and creates a hematoma. Since the damaged bridging veins are under low pressure, the bleeding can be slow, which causes delayed onset of symptoms which might develop over the course of days to weeks, as the hematoma gradually expands. So an acute subdural hematoma causes symptoms within 2 days. A subacute subdural hematoma causes symptoms between 3 and 14 days. And a chronic subdural hematoma causes symptoms after 15 days. The hematoma can compress the brain and cause increased intracranial pressure. A large subdural hematoma on one side of the skull can cause a midline shift, which is a displacement of the whole brain toward the opposite side of the skull. The increased intracranial pressure can also cause the brain to herniate. There can be a supratentorial herniation, where the cerebrum is pushed against the skull or the tentorium, as well as an infratentorial herniation, where the cerebellum is pushed against the brainstem. Both of these can be lethal. Supratentorial herniations can compress the arteries that nourish the brain, which can lead to an ischemic stroke. And infratentorial herniations can compress the vital area in the brainstem that controls consciousness, respiration, and heart rate. The most common symptoms of a subdural hemorrhage are loss of consciousness right after the injury, or in the ensuing days to weeks as the hematoma increases in size. Other symptoms include headaches and vomiting. Sometimes there can be focal neurological symptoms like muscle weakness or sensory problems based on the location of the hematoma. Diagnosis of a subdural hemorrhage is typically done with an imaging study. On a CT scan, an acute subdural hematoma shows up as a hyperdense mass, meaning that it looks more white than the surrounding healthy brain tissue. A chronic subdural hematoma, on the other hand, shows up as a hypodense mass, which is less white than the surrounding brain tissue. An acute on chronic bleeding is a combination of hyperdense and hypodense, which is seen in individuals who have a rebleed in the bridging veins after a chronic hematoma is already formed. The blood in a subdural hemorrhage is located between the arachnoid mater and the inner layer of the dura mater. So on a CT scan, subdural hematomas follow the contour of the brain and form a crescent shape and cross suture lines. In contrast to that, epidural hemorrhages cause blood to build up between the outer layer of the dura mater and the skull. Since the outer layer of the dura mater adheres tightly to the skull at sutures, epidural hematomas don't cross suture lines and they push on the brain, forming a biconvex shape. Small subdural hematomas are drained by placing a small tube called a catheter through a drilled hole in the skull. Large subdural hematomas require a craniotomy, which is when part of the skull bone is removed in order to remove the accumulated blood below. Alright, as a quick recap. A subdural hemorrhage is a bleeding below the dura mater, caused by the rupture of the bridging veins found within the subdural space. Subdural hemorrhages are common in traumatic accidents, as well as in some groups like the elderly, babies, and individuals that abuse alcohol. On a CT scan, an acute subdural hemorrhage forms a hyperdense blood collection, whereas a chronic subdural hemorrhage forms a hypodense blood collection. Subdural hematomas cross suture lines and follow the contour of the brain, forming a crescent shape, unlike epidural hematomas, which don't cross suture lines and push on the brain and form a biconvex shape.
In the neurology ward, there's a mother with her child, named Justin, who's 2 years old. Justin's mother is worried because she palpated a mass in his abdomen while bathing him. Justin also has been having episodes of rapid, dancing eye movements as well as shock-like, jerky movements of his extremities. Next, there's a 42-year-old male named Oliver. For the past few months, Oliver has been acting strangely according to his sister. He forgets important information and is very aggressive with his family. He also has bursts of wild, dance-like movements of his arms. His sister is very anxious because their father died at age 50 after having similar symptoms. Okay, now next to Oliver, there's a 58-year-old male named Ashton. His wife has noticed that her husband's face has become inexpressive, and he has been having hand tremor at rest for the past few months. Also, his movements have become slower, and he has frequent falls. His medical history is otherwise insignificant. Okay, so all of them have movement disorders. The cerebrum, cerebellum, and basal ganglia all help coordinate movements, so movement disorders can be traced back to these structures. Movement disorders can be broadly grouped into two categories: hypokinetic disorders, which cause slowness of movement, and hyperkinetic disorders, which cause excessive involuntary movement. Alright, when it comes to hypokinetic disorders, a lot of their symptoms are grouped together under the term Parkinsonism. This can appear in many conditions, including Parkinson's disease itself, and other syndromes called Parkinson plus syndromes. These cause Parkinsonism plus other clinical features. Some Parkinson plus syndromes include Lewy body dementia, multiple system atrophy, and progressive supranuclear palsy. Okay, the 4 cardinal symptoms of Parkinsonism can be remembered with the mnemonic TRAP. T for tremor, which is classically described as a resting, pill-rolling tremor, because it looks like someone is rolling a pill between their thumb and index fingers. R stands for rigidity, which is often described as a cogwheel-like rigidity. This means that when attempting to passively move a limb, there are a series of stops or stalls, kind of like a cog in a wheel. There's also lead pipe rigidity, which is when a limb is rigid throughout the entire passive movement, kind of like trying to move a lead pipe. A stands for akinesia, which is the absence of movement, and is a severe form of the more common finding of bradykinesia, which is slowness of movement. This can manifest as a narrow-based, shuffling gait or a decreased facial expression, almost to the point where the individual's face looks like they're wearing a mask. P stands for postural instability, which causes a stooped posture, problems with balance, and an increased frequency of falls. Usually, these symptoms are asymmetric, with the exception of medication-induced Parkinsonism, which usually causes symmetric symptoms. Now, Parkinson's disease is a slowly progressive genetic disorder that primarily affects individuals over 50 years old. Parkinson's derives from the loss of dopamine-producing, or dopaminergic, neurons in the substantia nigra, which is a part of the basal ganglia. The substantia nigra can be split into two subregions, the pars reticulata and the pars compacta. The pars compacta sends message to the striatum via neurons rich in the neurotransmitter dopamine, forming the nigrostriatal pathway, which helps to stimulate the cerebral cortex and initiate movement. In Parkinson's, the pigmented dopaminergic neurons in the pars compacta gradually disappear, and this depigmented region can be seen in an autopsy. There's also degeneration in the nigrostriatal pathway, which decreases its projections to the cortex, thus causing bradykinesia. Under a microscope, Lewy bodies are present in the substantia nigra, and these are eosinophilic, round inclusions made of alpha-synuclein protein that are present in the dopaminergic neurons before they die. Alright, now normally within the basal ganglia, there's a balance between dopamine, which promotes movement, and acetylcholine, which inhibits movement. In Parkinson's disease, the loss of dopaminergic neurons results in less movement, as well as difficulties in speech and swallowing. In fact, a common complication in Parkinson's disease is aspiration pneumonia. Parkinson's disease also causes cognitive symptoms, like dementia in the later stages of the disease, affective symptoms like depression, sleep disturbances, and a loss of the ability to smell. Interestingly, seborrheic dermatitis, an oily skin rash that appears on the scalp, face, chest, and axilla, has also been associated with Parkinson's disease. For treatment, the motor symptoms can be managed by using monoamine oxidase type B inhibitors, amantadine, dopamine agonists, or levodopa. If these medications don't work, deep brain stimulation is also an option. Psychosis should be managed with a second-generation antipsychotic like clozapine, since first-generation drugs often worsen the motor symptoms. Alright, now on to the Parkinson plus syndromes. First up is Lewy body dementia, which is distinct from dementia secondary to Parkinson's disease in that the onset of dementia and motor symptoms are less than 1 year apart. Also, Lewy body dementia causes very vivid visual hallucinations. There's also multiple symptom atrophy, which causes Parkinsonism plus autonomic system failure, resulting in orthostatic hypotension, impotence, and urinary incontinence or retention. Another condition is progressive supranuclear palsy, which causes Parkinsonism plus a disturbance in downward eye gaze, and sometimes a disturbance in upward eye gaze as well. These individuals often have cranial nerve palsies, dysphagia, and an increased frequency of falls, especially backwards. Finally, an individual is predisposed to strokes. Multiple small vessel infarcts in the basal ganglia may cause a form of Parkinsonism called vascular Parkinsonism. But Parkinsonism can also be caused by medications that block dopamine receptors, including typical or first-generation antipsychotics, like haloperidol, which blocks dopamine receptors, and metoclopramide, a dopamine antagonist sometimes used to treat vomiting. This is why these drugs should be avoided in people with Parkinsonism. Now, in rare cases, Parkinsonian symptoms may be caused by MPTP, a toxic impurity that can be found in the recreational drug MPPP, or desmethylprodine, which is a synthetic opioid. Once inside the brain, MPTP is metabolized to the toxic form of MPP+, that can cause damage to the substantia nigra, resulting in Parkinsonism. Moving on to hyperkinetic movement disorders. First up is tremor, which is an involuntary rhythmic movement of a body part and is the most common movement disorder. Tremors can be classified into resting and action tremors. Resting tremors develop when the affected body part is resting and is gravity dependent, and they usually disappear when the person begins a voluntary movement. Action tremors are further grouped into kinetic tremors and postural tremors. Kinetic tremors are simple if they occur uniformly throughout a voluntary movement, intentional if it worsens as the affected body part approaches the target, and task-specific if it occurs during a specific task, like writing. Intention tremors are often associated with a problem with the cerebellum and can accompany other cerebellar signs like ataxia and dysmetria. Postural tremors occur when the individual is in a specific position, such as extending their arms out. One very specific type of tremor is called a flapping tremor, or astexerous, and it's induced when a person fully extends their wrists, which will cause the wrist to flap, like a bird flapping its wings. It's a classic sign of hepatic encephalopathy in liver disease, uremic encephalopathy in kidney disease, and carbon dioxide retention in lung disease. A specific and extremely common tremor disorder is essential tremor. It's thought to be inherited in an autosomal dominant way, although there can be incomplete penetrance, meaning that some affected individuals may not develop all of the features. Individuals with essential tremor usually develop a unilateral or bilateral postural and kinetic tremor in their arms, face, and head, including the vocal cords, leading to problems with speaking. The tremor is often worsened by caffeine, emotional distress, and hunger, while alcohol can relieve the tremor. The treatment is beta blockers like propranolol. Now, a dystonia consists of an involuntary, sustained contraction of a muscle group that results in abnormal twisting movements or postures. Dystonias can occur due to dysfunction of the basal ganglia and can be classified into focal dystonias, involving only a specific muscle group, or generalized dystonias, which involve multiple muscle groups. Examples of focal dystonias include blepharospasm, which is a spasm of the eyelid muscles, causing an increased frequency of blinking. Another example is the cervical dystonia, involving the sternocleidomastoid muscle and causing the neck to deviate to one side and causing torticollis. Limb dystonias are often brought on by specific tasks. For example, writing can cause a writer's cramp, or golfing can cause what's called the yips, where a golfer makes sudden involuntary jerks, messing up their putting. An effective treatment for dystonia is botulinum toxin. Now, athetosis is an involuntary, slow, snake-like movement of the limbs. On the other hand, chorea involves involuntary, random, rapid dance-like movements. When they occur together, they're described as choreoathetosis. Chorea can be seen in Huntington disease, which is a disease frequently tested on the exams. So, Huntington's disease is an autosomal dominant neurodegenerative disorder that typically affects individuals around 40 years of age. It is caused by mutation in the Huntington disease, or HD, gene on chromosome 4. This gene contains a trinucleotide repeat of CAG sequences, which encode for the amino acid glutamine. The gene encodes for a protein called huntingtin. The mutated protein aggregates within the neuronal cells of the caudate and the putamen of the basal ganglia, causing neuronal cell death. The brain regions affected by Huntington disease have decreased GABA and acetylcholine and increased dopamine levels. Over time, if enough neurons die in the caudate and putamen, which together form the dorsal striatum, this can cause actual loss of brain tissue volume in these areas, which can expand to the lateral ventricles. These areas of the brain play an important role in movement, particularly inhibiting it, and that's why Huntington disease causes movement problems like chorea. But they also have cognitive symptoms, like dementia, and psychiatric symptoms like depression, psychosis, or aggressive behavior. Death usually occurs within 10 to 20 years of diagnosis, often by aspiration pneumonia on account of discoordinated swallowing, or by suicide. Alright, now another high-yield concept about Huntington disease is a phenomenon called anticipation, which is where there's an increased number of trinucleotide repeats in subsequent generations. This leads to an earlier onset and more severe presentation of the disease. This process of adding more repeats is called repeat expansion. It happens way more in the production of sperm than eggs, and so anticipation generally occurs when the biological father is the affected parent. Okay, now chorea is also a feature of other diseases, like acute rheumatic fever, where it's called sydenham chorea, as well as systemic lupus erythematosus. It can also occur in metabolic conditions, like thyrotoxicosis or acute hyperglycemia, or even in pregnancy, in which it would be called a chorea gravidarum. Finally, a severe form of chorea is called hemibolismus. That's where there are wild, flinging movements of a limb on one side of the body. For your exams, remember that hemibolismus is usually due to a lesion in the contralateral subthalamic nucleus in the basal ganglia. These lesions are caused by strokes due to long-standing hypertension. A myoclonus is an involuntary, brief, rapid, jerky movement. A good example of a myoclonus is that of the diaphragm, which we would call a hiccup. Similar to dystonias, myoclonus can be generalized or focal. Now, a very important disease associated with myoclonus is Creutzfeldt-Jakob disease. For your exams, remember that it is a rare prion-borne illness that results in rapidly progressive dementia and myoclonus. The myoclonus is usually generalized and can be triggered when the person is startled. It's caused by accumulation of abnormal prion protein, or PRP, and it is typically fatal. Another high-yield fact you absolutely have to remember for your exams is opsoclonus myoclonus syndrome, which is when there's rapid, erratic dancing eye movements along with limb myoclonus, and is often also associated with ataxia. This is classically a paraneoplastic syndrome associated with neuroblastoma, which typically develops as an abdominal mass in young children. Myoclonus can also be a feature of juvenile myoclonic epilepsy, which is a seizure disorder that affects adolescents. Individuals with juvenile myoclonic epilepsy present with myoclonic jerks in the morning, followed by generalized tonic-clonic seizures. Finally, a mitochondrial inherited disorder called myoclonic epilepsy with ragged red fibers, or MRF, classically causes myoclonus and muscle weakness. Additionally, tics are involuntary, brief, purposeless, stereotypical movements that typically involve the head, face, eyes, mouth, and neck. Tics are broadly classified into motor and vocal tics, with each group subclassified into simple and complex. Simple motor tics involve one muscle group, such as twitching of the nose, while complex motor tics involve multiple muscle groups, such as jumping or headbanging. Simple vocal tics tend to manifest as grunting, barking, or throat clearing, while complex vocal tics involve words, phrases, or sentences. Motor tics also include echopraxia, which is mimicking the movements of others, or copropraxia, which is expressing inappropriate gestures. Similarly, interesting vocal tics include echolalia, which is repeating the words or phrases of others, palilalia, which is repeating one's own words, and coprolalia, which is verbally expressing obscenities. Now, the most important tic disorder is Tourette syndrome, a genetic disorder that affects boys more than girls and children more than adults. Interestingly, Tourette syndrome is often associated with psychiatric conditions like ADHD, OCD, and autism spectrum disorder. All right. Now, restless leg syndrome is characterized by discomfort in the legs when resting or falling asleep, an urge to move the legs, and immediate relief after moving them. Interestingly, restless leg syndrome has been associated with iron deficiency and chronic kidney disease. It can be treated with dopamine agonists like ropinirole. Finally, there's Wilson's disease, which is an autosomal recessive disorder. This is caused by a mutation in hepatocyte copper transporting ATPase, which is needed to move copper from the liver into bile for excretion. And it's also needed to synthesize ceruloplasmin, the copper storage and transport protein in the blood. So the mutation leads to excessive copper buildup in the liver and low ceruloplasmin level. Eventually, the copper overflows into the blood and deposits in the brain and eyes. A typical case in your exam will present an individual with cirrhosis and psychiatric changes like personality changes, depression, or psychosis. Some individuals can also develop a movement disorder that can be either hypokinetic, like dystonia and Parkinsonism, or hyperkinetic, like tremor. And another high-yield finding is Kayser-Fleischer ring, which is a dark ring around the iris due to copper deposits in the cornea. Treatment includes chelation with penicillamine, oral zinc, and in cases where there's liver failure, a transplant might be needed. All right. Now, generally, the diagnosis of movement disorders is based upon the clinical presentation. The diagnosis of Parkinson's disease requires the presence of bradykinesia, in addition to another one of the TRAP symptoms, and ruling out other potential causes. In terms of Parkinson plus syndromes, onset of dementia and Parkinsonism in less than 1 year, along with vivid visual hallucinations, may indicate Lewy body dementia. Autonomic dysfunction manifesting as orthostatic hypotension or impotence, along with Parkinsonism, may indicate multiple system atrophy. Downward or upward gaze palsy and an increased frequency of falls, along with Parkinsonism, indicates progressive supranuclear palsy. Moving on to hyperkinetic disorders. For tremors, the presence of a metabolic disorder, such as hepatic encephalopathy, uremic encephalopathy, or lung disease, indicates flapping tremor, while family history of tremor indicates essential tremor. Now, diagnosis of chorea can be suspected in the presence of acute rheumatic fever or lupus. Also, chorea gravidarum should be suspected in metabolic conditions like thyrotoxicosis or acute hyperglycemia, or even in pregnancy, while hemibolismus occurs due to a lesion in the contralateral subthalamic nucleus in the basal ganglia. Now, diagnosis of Huntington disease should be suspected in an individual around 40 years of age with chorea, cognitive and psychiatric symptoms. Family history of a first-degree relative is also a very important clue. The diagnosis is confirmed using polymerase chain reaction of the HD gene, which shows the CAG repeats. MRI imaging of the brain characteristically shows atrophy of the caudate and putamen, and enlargement of the lateral ventricles. And that's something you also have to remember for your exams. Okay, now presence of myoclonus can indicate Creutzfeldt-Jakob disease, juvenile myoclonic epilepsy, or MRF. In Creutzfeldt-Jakob disease, multiple vacuoles form in neutrophils and neurons of the gray matter, and these vacuoles progressively transform into cysts. These characteristic findings can be seen on MRI, and so the disease is called a spongiform encephalopathy. Now, the presence of neuroblastoma, which can be described as an abdominal mass in a child, points towards opsoclonus myoclonus syndrome. All right. Now, the difference between tics and any other movement disorder is that although tics are involuntary, the individual can anticipate when the tic is about to happen and can voluntarily suppress them to a certain degree. Additionally, tics are accompanied by an irresistible urge to let the tic occur. In fact, the longer the individual holds in the tic, the more intense the outburst will be, a bit like trying to suppress a cough. To diagnose Tourette's syndrome, 3 criteria must be met. First, the individual should develop at least 2 motor tics and 1 vocal tic. Second, the onset of symptoms must be before 18 years of age. And thirdly, the individual should have the symptoms for over 1 year. Now, the diagnosis of restless leg syndrome is primarily based on clinical presentation. However, the presence of iron deficiency anemia or chronic kidney disease can also be a clue. Finally, any individual less than 40 years of age with a movement disorder like tremor, chorea, or dystonia should be evaluated for Wilson's disease. This includes performing a slit lamp ophthalmoscopic examination to look for Kayser-Fleischer rings and measuring 24-hour urine copper and serum ceruloplasmin levels. In Wilson's disease, individuals have a high urine copper level and low serum ceruloplasmin level. All right, As a quick recap, movement disorders can be either hypokinetic or hyperkinetic. Hypokinetic disorders cause slowness of movement and include Parkinson's disease and Parkinson plus syndromes, such as Lewy body dementia, multiple system atrophy, and progressive supranuclear palsy. Hyperkinetic disorders cause excessive involuntary movement and include tremors, dystonia, athetosis, chorea, tics, and restless leg syndrome. Wilson's disease can present with either a hypokinetic or hyperkinetic movement disorder. A diagnosis can be made based on the patient's medical history and clinical presentation. Now back to our patients. Justin most probably has opsoclonus myoclonus syndrome, occurring as a paraneoplastic syndrome. The abdominal mass that his mother palpated is probably a neuroblastoma. Imaging studies and tissue biopsy of the mass must be done to confirm the diagnosis. Now, due to his age, symptoms, and family history, Oliver most likely has Huntington disease. PCR of the HD gene can confirm the diagnosis. And moving on to Ashton, he most probably has Parkinson's disease due to the bradykinesia, along with the resting tremor and postural instability.
Huntington disease, or HD, is a rare neurodegenerative disease that involves a repeated sequence of DNA that causes an abnormal protein to form, leading to abnormal movements and cognitive problems. Huntington disease is an autosomal dominant genetic disorder, which means that one affected copy of the gene is enough to cause disease. Affected people are typically present in each generation, because an affected person, male or female, has a 50% chance of passing on the affected gene to a child, which causes that child to have the disease. In most people, a gene called Huntington, or HTT, on chromosome 4 contains a triplet repeat, where nucleotides C, A, and G are repeated 10 to 35 times in a row. In people with Huntington disease, this repeat goes on for 36 or more times in a row. CAG codes for the amino acid glutamine, so people with Huntington disease will have 36 or more glutamines in a row in the Huntington protein. So in addition to being a triplet repeat disorder, HD is, more specifically, a polyglutamine disease. The specific way in which extra glutamines cause HD symptoms isn't fully worked out, but some clues are that the mutated protein aggregates within the neuronal cells of the caudate and putamen of the basal ganglia, causing neuronal cell death. Cell death might be related to excitotoxicity, which is excessive signaling of these neurons, which leads to high intracellular calcium. The expanded CAG repeats not only affect the Huntington protein, they also affect DNA replication itself. When copying the HTT gene, DNA polymerase can basically lose track of which CAG it's on, and accidentally add extra CAGs. Since as a zygote develops into a fetus and eventually into a full adult, by the time sperm and eggs are created, several dozen cell divisions, each with a round of DNA replication, have taken place. And so there have been a lot of opportunities for repeat expansion. And the more repeats that are added, the more unstable it gets. This expansion of the originally inherited gene means that a child of a parent with HD can inherit even more CAG repeats than the parent did. The higher the number of repeats in the protein, the earlier the age when a person starts having symptoms. And this phenomenon is called anticipation, which means that the Huntington disease families often show earlier symptom onset with each generation. Even repeats of 27 to 35 CAGs can expand occasionally, and these are called pre-mutation alleles, since they don't cause the disease, but they're set up for developing a mutation of 36 or more CAGs. Like we've mentioned, this process of adding more repeats is called repeat expansion, and it happens way more in the production of sperm than of eggs. So both anticipation and new disease alleles generally happens when the father's the affected parent. When a person has 40 plus repeats, they show 100% penetrance, and they will have the disease. For reasons that remain unknown, people with 36 to 39 repeats can show reduced penetrance. Some may have symptoms while others may not. Because of this penetrance, the test for HD, which counts the number of CAG repeats, is really good at determining whether Huntington's disease will develop in an at-risk individual. Now, the symptoms of Huntington's disease involve progressive central nervous system disturbances, including movement, cognitive, and mood symptoms. The average age of onset is around 40 years old, although remember that the age of onset depends on the number of CAG repeats. Over time, if enough of the neurons die in the caudate and putamen, which together form the dorsal striatum, then it can cause actual loss of brain tissue volume in that area and expansion of the lateral ventricles. These areas play an important role in movement, particularly inhibiting it. And that's why neuronal death in the basal ganglia causes movement problems like chorea, which are purposeless, dance-like jerky movements, and athetosis, which are slower, writhing, snake-like movements, mainly affecting the hands. These involuntary movements can't be consciously suppressed and stop only with sleep. Other motor problems include abnormal eye movements and poor coordination. Loss of tissue in these regions can also lead to psychological problems as well, like dementia, personality changes, and depression. The diagnosis of Huntington's disease is based on the person's history and physical assessment, followed by genetic testing to confirm the diagnosis. Additionally, brain imaging tests, like a CT scan or MRI, can be used to assess the atrophy of the basal ganglia. Even though this might be oversimplifying things a bit, the brain regions affected by Huntington's disease have decreased GABA and acetylcholine, and increased dopamine levels. This increased dopamine helps explain why neuroleptics, which are dopamine receptor antagonists, and tetrabenazine, which depletes dopamine, are used to treat chorea in people with Huntington's disease. Unfortunately, these and other pharmacologic treatments don't affect overall survival, and death usually happens within 10 to 20 years of diagnosis, often by aspiration pneumonia on account of discoordinated swallowing, or suicide. There are actually several dozen other triplet repeat disorders in addition to Huntington's disease, some of which also have CAG as the repeated nucleotides, but in a different gene. Others of which, though, have different repeats, like myotonic dystrophy, which is a CTG repeat, Friedreich ataxia, a GAA repeat, and Fragile X syndrome, a CGG repeat. Alright, so as a quick recap, Huntington's disease is an autosomal dominant disease caused by having 36 or more trinucleotide repeats of CAG in the Huntington gene, which causes neuronal cell death in the basal ganglia, causing movement symptoms like chorea and athetosis, as well as mental symptoms like depression and dementia. Huntington's disease, or HD, is a rare neurodegenerative disease that involves a repeated sequence of DNA that causes an abnormal protein to form, leading to abnormal movements and cognitive problems. Huntington's disease is an autosomal dominant genetic disorder, which means that one affected copy of the gene is enough to cause disease. Affected people are typically present in each generation, because an affected person, male or female, has a 50% chance of passing on the affected gene to a child, which causes that child to have the disease. In most people, a gene called Huntingtin, or HTT, on chromosome 4 contains a triplet repeat, where nucleotides C, A, and G are repeated 10 to 35 times in a row. In people with Huntington's disease, this repeat goes on for 36 or more times in a row. CAG codes for the amino acid glutamine, so people with Huntington's disease will have 36 or more glutamines in a row in the Huntingtin protein. So in addition to being a triplet repeat disorder, HD is, more specifically, a polyglutamine disease. The specific way in which extra glutamines cause HD symptoms isn't fully worked out, but some clues are that the mutated protein aggregates within the neuronal cells of the caudate and putamen of the basal ganglia, causing neuronal cell death. Cell death might be related to excitotoxicity, which is excessive signaling of these neurons, which leads to high intracellular calcium. The expanded CAG repeats not only affect the Huntingtin protein, they also affect DNA replication itself. When copying the HTT gene, DNA polymerase can basically lose track of which CAG it's on, and accidentally add extra CAGs. Since as a zygote develops into a fetus and eventually into a full adult, by the time sperm and eggs are created, several dozen cell divisions, each with a round of DNA replication, have taken place. And so there have been a lot of opportunities for repeat expansion. And the more repeats that are added, the more unstable it gets. This expansion of the originally inherited gene means that a child of a parent with HD can inherit even more CAG repeats than the parent did. The higher the number of repeats in the protein, the earlier the age when a person starts having symptoms. And this phenomenon is called anticipation, which means that the Huntington disease families often show earlier symptom onset with each generation. Even repeats of 27 to 35 CAGs can expand occasionally, and these are called pre-mutation alleles, since they don't cause the disease, but they're set up for developing a mutation of 36 or more CAGs. Like we've mentioned, this process of adding more repeats is called repeat expansion, and it happens way more in the production of sperm than of eggs. So both anticipation and new disease alleles generally happens when the father's the affected parent. When a person has 40 plus repeats, they show 100% penetrance, and they will have the disease. For reasons that remain unknown, people with 36 to 39 repeats can show reduced penetrance. Some may have symptoms while others may not. Because of this penetrance, the test for HD, which counts the number of CAG repeats, is really good at determining whether Huntington disease will develop in an at-risk individual. Now, the symptoms of Huntington disease involve progressive central nervous system disturbances, including movement, cognitive, and mood symptoms. The average age of onset is around 40 years old, although remember that the age of onset depends on the number of CAG repeats. Over time, if enough of the neurons die in the caudate and putamen, which together form the dorsal striatum, then it can cause actual loss of brain tissue volume in that area and expansion of the lateral ventricles. These areas play an important role in movement, particularly inhibiting it. And that's why neuronal death in the basal ganglia causes movement problems like chorea, which are purposeless, dance-like jerking movements, and athetosis, which are slower, writhing, snake-like movements, mainly affecting the hands. These involuntary movements can't be consciously suppressed and stop only with sleep. Other motor problems include abnormal eye movements and poor coordination. Loss of tissue in these regions can also lead to psychological problems as well, like dementia, personality changes, and depression. The diagnosis of Huntington disease is based on the person's history and physical assessment, followed by genetic testing to confirm the diagnosis. Additionally, brain imaging tests, like a CT scan or MRI, can be used to assess the atrophy of the basal ganglia. Even though this might be oversimplifying things a bit, the brain regions affected by Huntington disease have decreased GABA and acetylcholine, and increased dopamine levels. This increased dopamine helps explain why neuroleptics, which are dopamine receptor antagonists, and tetrabenazine, which depletes dopamine, are used to treat chorea in people with Huntington disease. Unfortunately, these and other pharmacologic treatments don't affect overall survival, and death usually happens within 10 to 20 years of diagnosis, often by aspiration pneumonia on account of discoordinated swallowing, or suicide. There are actually several dozen other triplet repeat disorders in addition to Huntington disease, some of which also have CAG as the repeated nucleotides, but in a different gene. Others of which, though, have different repeats, like myotonic dystrophy, which is a CTG repeat, Friedreich ataxia, a GAA repeat, and Fragile X syndrome, a CGG repeat. Alright, so as a quick recap, Huntington disease is an autosomal dominant disease caused by having 36 or more trinucleotide repeats of CAG in the Huntington gene, which causes neuronal cell death in the basal ganglia, causing movement symptoms like chorea and athetosis, as well as mental symptoms like depression and dementia. Parkinson's disease, which is sometimes called Parkinson disease, Parkinson's, or PD, is a movement disorder where the dopamine-producing neurons in the substantia nigra of the brain undergo degeneration. Parkinson's is one of the most common neurological disorders. It's a progressive, adult-onset disease, and it gets more common with age. Most of the time, there's no known cause, but in a few cases there might be a genetic cause, like mutations in the PINK1, Parkin, or alpha-synuclein genes. And in rare cases, Parkinsonian symptoms might be caused by MPTP, a toxic impurity that can be found in the recreational drug MPPP, or desmethylprotein, which is a synthetic opioid. In other people, one or more risk factors, rather than a single outright cause, might contribute to Parkinson's. For example, pesticide exposure or DNA variants in genes like LRRK2. No matter what the cause is, Parkinson's derives from the death of dopamine-producing or dopaminergic neurons in the substantia nigra. The name substantia nigra means black substance, since it's darker than other brain regions when you look at a slice of the brain on an autopsy. We usually refer to the substantia nigra as if it's a single location, but there are actually two of these regions in the brain, one on each side of the midbrain. The substantia nigra is a part of the basal ganglia, a collection of brain regions that control movement through their connections with the motor cortex. In Parkinson's, these darkened areas of substantia nigra gradually disappear. Under a microscope, Lewy bodies, which are eosinophilic, round inclusions made of alpha-synuclein protein, are present in the affected substantia nigra neurons before they die. The function of alpha-synuclein is unknown, as well as the significance of Lewy bodies, and they're both found in other diseases, like Lewy body dementia and multiple system atrophy. The substantia nigra actually can be split into two subregions. First, there's the pars reticulata, which receives signals from another part of the basal ganglia called the striatum, which is a term for the caudate and putamen put together, and relays messages to the thalamus via neurons rich in the neurotransmitter GABA, also known as gamma-aminobutyric acid. Second, there's the pars compacta, and this is the part of the substantia nigra affected in Parkinson's. The pars compacta sends messages to the striatum via neurons rich in the neurotransmitter dopamine, forming the nigrostriatal pathway, which helps to stimulate the cerebral cortex and initiate movement. Therefore, when substantia nigra pars compacta neurons die, the individual might be in a hypokinetic or low movement state, which is commonly seen in Parkinson's. In addition to simply initiating movements, the substantia nigra helps to calibrate and fine-tune the way that movements happen, which leads to the clinical features of Parkinson's. First, there's tremor, which is an involuntary shakiness most noticeable in the hands, characteristically called a pill-rolling tremor, because it looks like someone's rolling a pill between their thumb and index finger. This is a resting tremor, meaning it's present at rest and diminishes with intentional movement. Next, there's rigidity, which refers to stiffness that can appear as cogwheel rigidity, which is when there are a series of catches or stalls as a person's arms or legs are passively moved by someone else. Rigidity is also responsible for the stooped posture and an almost expressionless face that some individuals with Parkinson's might have. Next up is bradykinesia, which is slow movement, hypokinesia, which is lessened movement, and akinesia, which is an absence of movement, and all three result from difficulty initiating movements. Examples of this are having the legs freeze up when trying to walk and also walking with a shuffling gait, or small steps. Finally, a late feature of the disease is postural instability, which causes problems with balance and can lead to falls. Despite these multiple effects on movement, Parkinson's disease does not produce weakness. This helps differentiate it from diseases that affect the motor cortex or corticospinal pathway. In addition, the resting tremor of Parkinson's disease helps to differentiate from cerebellar diseases, which might result in an action or intention tremor, which is a tremor that's essentially the opposite of a resting tremor, where the tremor actually gets worse with movement. Also, both bradykinesia and postural instability help differentiate Parkinson's from essential tremor, of which an action tremor is also a hallmark feature. Non-motor brain functions can be affected in Parkinson's as well, leading to additional common symptoms including depression, dementia, sleep disturbances, and difficulty smelling. These are thought to come about because of dysfunction of dopaminergic signaling in other parts of the brain beyond the substantia nigra. For example, in the prefrontal cortex, leading to cognitive symptoms, and also possibly from issues with other neurotransmitters like acetylcholine. Fortunately, there are treatments that help with Parkinson's symptoms, although none stop the progressive neurodegeneration. The main strategy here is to increase the amount of dopamine signaling in the brain. Dopamine itself can't cross the blood-brain barrier, but its precursor levodopa can. And once in the brain, levodopa is converted to dopamine by dopa decarboxylase, most importantly within the remaining nigrostriatal neurons. Peripheral dopa decarboxylase also exists, which can metabolize levodopa into dopamine before it gets through the blood-brain barrier, and via additional enzymes, metabolize it into other catecholamines like epinephrine, which can cause unwanted side effects like arrhythmias. This is exactly why levodopa is administered with carbidopa, a dopa decarboxylase inhibitor that isn't able to cross the blood-brain barrier. Another strategy is to use amantadine, which is also an antiviral medication that increases endogenous dopamine production, although the mechanism here is still being worked out. A different strategy is to use dopamine agonists that can stimulate dopamine receptors and basically trick the brain into thinking there's more dopamine than there really is, like bromocriptine, which is an ergot or fungal derivative, as well as pramipexole and ropinirole, which are not ergot derivatives. Alright, the next dopamine-directed class of therapies are inhibitors of COMT, catecholamine O-methyltransferase, which is an enzyme that degrades dopamine and levodopa. COMT inhibitors like entacapone and tocopone are only given with levodopa to prevent the enzyme from breaking it down outside the central nervous system, thus allowing more of it to enter the brain. Very similarly, there are medications like selegiline, which inhibits monoamine oxidase B, also known as MAOB, which is another enzyme that metabolizes dopamine. Since usually there's a balance of signaling between dopamine and acetylcholine, a loss of dopamine reaching the striatum increases the relative amount of acetylcholine signaling there. Therefore, anticholinergics can be given to restore the balance of cholinergic and dopaminergic signaling, like benztropine, which improves the tremor of PD. A special treatment available to help treat PD is deep brain stimulation, which involves an implantable device that directly sends electrical signals to the basal ganglia, which counteracts the aberrant signaling in Parkinson's. The term Parkinsonism is sometimes used to describe symptoms of Parkinson's that are seen in other nervous system diseases, like Lewy body dementia, Wilson disease, and Pick disease, as well as side effects of a medication, like antipsychotics like haloperidol, which blocks dopamine receptors, and metoclopramide, a dopamine antagonist sometimes used to treat vomiting. Alright, as a quick recap. Parkinson's is a progressive movement disorder caused by degeneration of dopamine-producing neurons in the substantia nigra, specifically in the pars compacta, which leads to resting tremor, rigidity, problems initiating movement, and postural instability, and for which therapy primarily focuses on increasing brain dopamine.
A seizure is a paroxysmal motor, sensory, or autonomic event that occurs due to abnormal, excessive, and synchronous electrical discharges from neurons in the brain and usually lasts less than 5 minutes. If a seizure lasts more than 5 minutes, it's called status epilepticus, and the term convulsion refers specifically to motor seizures. Now, a seizure is different from epilepsy. Epilepsy is a chronic disease of the brain that predisposes an individual to having recurrent unprovoked seizures, that is, seizures without a clear triggering cause. Epilepsy is typically diagnosed when an individual has 2 or more unprovoked seizures, separated by at least 24 hours. Epilepsy is also diagnosed when an individual has 1 seizure and a high likelihood of having another. There are many different forms and causes of epilepsy. Seizures are classified into generalized and focal seizures. Generalized seizures arise from both cerebral hemispheres at the same time, while focal seizures arrive from specific areas in one cerebral hemisphere. Now, generalized seizures are classified into motor and non-motor seizures. Regardless of the subtype, generalized seizures almost always cause a sudden impairment of consciousness. Generalized motor seizures include tonic, clonic, tonic-clonic, atonic, and myoclonic seizures. Tonic seizures involve sudden stiffening of the muscles, while clonic seizures involve rhythmic twitching of the muscles. However, these clinical features are usually combined, so individuals commonly have a tonic-clonic seizure. In a generalized tonic-clonic seizure, a person may have a sudden contraction of their vocal cord muscles, causing them to involuntarily scream or cry during a seizure. Contraction of the ocular muscles can cause uprolling of the eyes. Contraction of the oropharyngeal muscles can impair swallowing, causing respiratory secretions to pool in the oropharynx. Contraction of the jaw muscles may cause the individual to bite on their tongue. Individuals with tonic-clonic seizures may also develop urinary and fecal incontinence. After the tonic-clonic seizure ends, individuals enter the period called the post-ictal phase, during which the individual's consciousness is still impaired for minutes to hours, so they seem sluggish and tired or even hard to wake up. Sometimes, if the seizure event was unwitnessed, the post-ictal phase is the only indication that a seizure ever happened, because the affected individual likely won't remember the event itself. Alright, now atonic seizures translates to no muscle tone. Therefore, they are characterized by sudden loss of postural muscle tone lasting 1 to 2 seconds, causing the individual to collapse to the ground out of the blue. The last of the generalized motor seizures are myoclonic seizures, which involve sudden, rapid, shock-like muscle contractions. This sounds a lot like clonic seizures, but the key difference is that in myoclonic seizures, the contractions are much faster, occurring at a rate of about 0.1 seconds, whereas in clonic seizures, the contractions occur at a rate of about 1 to 2 seconds. Alright, moving on to the other arm of generalized seizures, there are the generalized non-motor seizures. These are called absence seizures and are commonly found in children and adolescents. The interesting thing about absence seizures is... Alright, as a quick recap, just kidding, but what just happened is exactly what individuals with absence seizures experience. Episodes are characterized by a sudden, brief loss of consciousness for seconds to minutes without any change in the individual's posture or muscle tone. So they could be sitting down watching an osmosis video and suddenly lose consciousness without falling down, only to wake up at the end of the video. Unfortunately, episodes can occur dozens or even hundreds of times per day, and are classically described by parents and teachers as staring into space, or daydreaming, or being inattentive. In fact, many children with absence seizures are actually misdiagnosed with attention deficit hyperactivity disorder because teachers often presume that a child is just not paying attention. Focal seizures are classified into those that do not impair consciousness, previously called simple partial seizures, and those that impair consciousness, previously called complex partial seizures. Focal seizures that impair consciousness are followed by a post-ictal phase, whereas focal seizures that retain consciousness do not have a post-ictal phase. Now, focal seizures can be motor, sensory, or autonomic depending on the area of the cerebral cortex involved. For example, a focal seizure involving the primary motor cortex can cause tonic or clonic movements on the contralateral extremity, whereas the focal seizure involving the occipital cortex may cause someone to see flashing lights. Sometimes focal seizures may begin as subtle neurological symptoms called auras. During an aura, individuals may exhibit subtle muscle movements called automatisms, such as chewing, lip smacking, or rapid blinking of the eyes. Other interesting forms of aura include smelling unusual odors like kerosene, a rising sensation in the abdomen, or even feelings of fear or déjà vu. Also, an interesting phenomenon that occurs after focal motor seizures is Todd's paralysis, which describes a temporary paralysis of the affected extremity. Finally, it's important to note that focal seizures can spread to both cerebral hemispheres, causing a generalized seizure. When this happens, it's appropriately called secondary generalization of a focal seizure. Naturally, it might be difficult to know if a seizure was generalized tonic-clonic right from the beginning, or if it was a focal seizure that secondarily generalized. However, a history of an aura, unilateral shaking, turning of the head to one side, or Todd's paralysis, which is a focal weakness in part or all of the body after a seizure, is a clue it may have been a focal seizure that secondary generalized. Take that with a grain of salt, though, because the absence of these historical features does not adequately exclude a focal seizure. Alright, now seizures are just a symptom, much like chest pain or shortness of breath, and therefore the causes of seizures are many. We can categorize them based off the mnemonic vitamins. V stands for vascular, which includes ischemic or hemorrhagic strokes, or intracerebral hemorrhage. I is for infection, which includes meningitis, encephalitis, or brain abscess. T is for trauma, especially penetrating traumatic brain injury, such as that from a gunshot. T is also for toxins. This includes drugs of abuse such as cocaine and amphetamine overdose, or alcohol withdrawal, which typically develops 48 hours after the last drink. Additionally, the anti-tuberculosis medication isoniazid can potentially cause seizures secondary to pyridoxine or vitamin B deficiency. The antidepressant bupropion can also cause seizures, especially if given to individuals with eating disorders like anorexia or bulimia. A is for autoimmune, such as central nervous system vasculitis or lupus. M is for metabolic, and this category includes a bell view of electrolyte imbalances, such as hyponatremia or hypocalcemia, or other metabolic imbalances such as hypoglycemia or hyperglycemia, or hyperthyroidism, hepatic encephalopathy in liver disease, or uremic encephalopathy in kidney disease. Also, Wernicke's encephalopathy caused by thiamine deficiency should be considered, especially in alcoholics. I is for idiopathic, which means epilepsy. N is for neoplasm, and S is for the differential diagnosis like psychogenic seizures or syncope. Also, one separate diagnosis that should be specifically considered in pregnant females is eclampsia, which is when a female with preeclampsia develops seizures. Okay, so when an individual presents with a history of a paroxysmal event, it's important to first make sure that the event was truly a seizure. The differential diagnosis of a seizure includes syncope, a non-epileptic spell caused by a functional neurological disorder, a transient ischemic attack or TIA, a migraine, and vertigo. Syncope is usually preceded by a prodrome of lightheadedness or sweating, followed by a brief loss of consciousness lasting seconds. Similar to seizures, tonic or clonic movements can also be present in syncope. Psychogenic seizures can occur in anyone, but some individuals have a history of trauma or abuse. These spells often include features not seen in seizures, including full-body convulsions with retained awareness and pelvic thrusting. TIAs can last anywhere between 5 to 30 minutes, and usually present with the symptoms of a stroke, such as hemiparesis, hemisensory loss, or visual loss. Similar to seizures, individuals with migraines can also develop an aura. However, episodes usually last hours and may be associated with visual disturbance. Vertigo can last anywhere from a few minutes to a couple of days. However, symptoms are usually dependent on the position of the individual. Finally, features like tongue biting, as well as the postictal phase of confusion, can be seen in seizures, and are usually absent in other differential diagnoses. For example, individuals with syncope regain full consciousness and alertness only a few seconds after the event. Now, if there was a seizure, the next step is to determine if the individual has had prior seizures, which establishes a diagnosis of epilepsy, or if this is the first time they've had a seizure. If the individual was previously diagnosed with epilepsy and is on anti-epileptic medication, then assess for the adequacy of that therapy. This includes asking if the individual is taking their anti-epileptic medication, has changed medication doses, started a new medication which might alter the levels of their anti-epileptic medication, experiencing any side effects, and measuring the serum levels of the medication if possible. If the serum levels are low, then either increasing the dose of the anti-epileptic medication, changing the medication, or adding another medication may make sense. However, if the individual is adequately taking the medication and serum levels are normal, then this should prompt evaluation for other causes of seizures. For example, someone with epilepsy might develop meningitis. On the other hand, for a first-time seizure, it's important to start by considering potential causes. A diagnostic workup should include a CBC, electrolytes, liver function tests, serum glucose levels, a toxicology screen, and in any woman of childbearing age, a pregnancy test. An electrocardiogram or ECG can also be obtained if syncope is part of the differential. Brain imaging with CT or MRI is only done if a structural lesion is suspected or if no identifiable cause is found on laboratory evaluation. If a brain infection like meningitis is suspected, a lumbar puncture can be obtained. Generally speaking, individuals with first-time seizures are not treated with anti-epileptic medications. If the workup doesn't reveal an identifiable cause, then it's considered an unprovoked seizure, and at this point, we need to start thinking about epilepsy. The next step is performing an electroencephalography, or EEG, which is done by placing electrodes on the scalp and monitoring the brain's activity. Individuals are often stimulated to produce a mini seizure in the brain using techniques such as hyperventilation, where a person takes deep breaths, exposure to bright light, flashing lights for up to 2 minutes, and a degree of sleep deprivation. The EEG tells us whether the epilepsy is generalized or focal. Additionally, it can help with specific diagnoses. For example, a 3 Hz spike and wave pattern on EEG is characteristic of absence seizures. However, a negative EEG does not exclude the diagnosis of epilepsy. Instead, the diagnosis of epilepsy relies on the presence of 2 or more unprovoked seizures. Once epilepsy is diagnosed, the mainstay of treatment is anti-epileptic medication and largely depends on the type of seizure, the convenience of the dosing schedule, and the side effects. In general, the first-line medications for generalized seizures are levetiracetam, valproic acid, lamotrigine, and topiramate. And the first-line medications for focal seizures are carbamazepine, phenytoin, and lamotrigine. Absence seizures are uniquely treated with ethosuximide. However, if an individual with absence seizures also has generalized tonic-clonic seizures, then valproic acid is the medication of choice. If eclampsia is diagnosed, magnesium sulfate is given, followed by a prompt delivery of the baby. Finally, individuals with epilepsy are advised to avoid dangerous situations, such as heights, swimming, and driving a vehicle. Additionally, family members are taught to place the individual on their side to help them avoid aspirating and move any potential harmful objects out of the person's way while calling emergency services for assistance. Now, sometimes an individual presents to the emergency department seizing. If the seizure is lasting more than 5 minutes, or if more than one seizure occurs in rapid succession without a full recovery in between seizures, a diagnosis of status epilepticus is made. That's because more than 5 minutes of ongoing seizure activity carries a high risk of causing permanent damage to the brain and heart, so at that point it's necessary to actively stop the seizure from continuing. Emergency management comes down to the ABCs, that is, airway, breathing, and circulation. Oxygen should be administered, cardiac monitors are placed, and blood pressure is checked frequently. Next, it's crucial to establish intravenous access to take blood for labs and to give medications. Standard labs include CBCs, electrolytes, glucose levels, liver function tests, toxicology screens, anti-epileptic medication levels if the individual is on one, and a pregnancy test if the individual is a woman of childbearing age. Next, the individual is given thiamine followed by glucose. This is because these interventions can rapidly help individuals with Wernicke's encephalopathy or hypoglycemia. Next, the first-line medication given to stop a seizure is the benzodiazepine lorazepam, given intravenously. If the seizure continues, another dose of lorazepam is given. If seizures continue, the next step is to give phenytoin. If seizures continue, another dose of phenytoin is given. If seizures continue, then if an intensive care unit or ICU is available, then the next step is intubation, anesthesia with midazolam or propofol or pentobarbital, along with continuous EEG monitoring. EEG monitoring is necessary at this point because anesthesia can cause paralysis, but that does not mean that the seizure has stopped. Now, if the ICU is not available, the individual is given phenobarbital to help control the seizure. Okay, so in children, one additional common type of seizure is a febrile seizure, which is a seizure triggered by a fever. Febrile seizures usually occur in children between the ages of 6 months to 6 years and peaks around 18 months. Often a febrile seizure follows a respiratory tract infection, commonly after a roseola infection caused by human herpes virus 6 and 7, or HHV6 and HHV7. Febrile seizures are more common in children with a family history of febrile seizures or epilepsy, or those with a pre-existing neurological disorder. Febrile seizures can be either simple or complex. Simple febrile seizures must fulfill all 4 of the following. They must be generalized tonic-clonic seizures, last less than 15 minutes, occur only once in a 24-hour period, and cannot result in a neurological defect. On the other hand, a complex febrile seizure must have any one of the following. The seizure is focal, lasts more than 15 minutes, occurs more than once in a 24-hour period, or results in a neurological deficit. The reason we classify febrile seizures like this is because it will determine whether we investigate further or not. Simple febrile seizures do not need laboratory or imaging investigations, and the individual can be reassured that the risk of developing epilepsy in the future is very low, so they don't need anti-epileptic therapy. Children with simple febrile seizures are at an increased risk for a repeat simple febrile seizure. But even when there's a reoccurrence, as long as it's a simple febrile seizure, a workup doesn't need to be routinely done. On the other hand, complex febrile seizures require further investigation. First, in an individual with a complex febrile seizure, you must make sure that this is not meningitis, so a lumbar puncture may be needed. Also, brain imaging with an MRI should be considered to look for a potential structural lesion. And finally, risk of developing epilepsy after a complex seizure is up to 5%, so an EEG should be done and anti-epileptic therapy may be started. Alright, now there are some specific epilepsy syndromes that primarily occur in children and are important to recognize. Infants can have infantile spasms, which is characterized by bilateral, symmetrical limb and trunk spasms that usually occur when the infant wakes up from sleep. Unlike a generalized tonic-clonic seizure, an infant maintains a normal level of consciousness during the infantile spasms, and there's usually a long pause of more than several seconds between spasms. In between episodes, an EEG classically shows a chaotic pattern called a hypsarrhythmia. Also, a triad of infantile spasms, hypsarrhythmia, and developmental delay is called West syndrome. Interestingly, infantile spasms can be the first symptom of tuberous sclerosis. Therefore, all infants should get a skin exam using an ultraviolet lamp called a Woods lamp, which can detect hypopigmented macules that are characteristic of tuberous sclerosis. Infantile spasms are treated with an adrenocorticotropic hormone, or ACTH. Infants on ACTH should be monitored for the risk of developing hypertrophic cardiomyopathy. Now, if the infantile spasms are associated with tuberous sclerosis, then vigabatrin, a gamma-aminobutyric acid or GABA transaminase inhibitor, is the medication of choice. Other syndromes include Lennox-Gastaut syndrome, which is characterized by the triad of developmental delay, multiple seizure types, and an EEG that shows slow spike waves at a rate of 1.5 to 2.5 Hz. Juvenile myoclonic epilepsy is characterized by myoclonic seizures upon awakening, and particularly occurs in adolescence. Finally, Landau-Kleffner syndrome is characterized by disturbances in language development and epilepsy. All right, as a quickish recap, a seizure is a paroxysmal event that occurs due to an abnormal, excessive, and hyposynchronous electrical discharge from the brain. Epilepsy is a chronic disorder of the brain that predisposes the individual to recurrent seizures and is typically diagnosed when either 2 or more unprovoked seizures occur or when one seizure occurs with a high chance of another one happening. Seizures can be classified into generalized and focal seizures. Generalized seizures include tonic, clonic, tonic-clonic, myoclonic, atonic, and absence seizures. Focal seizures include those that do not alter consciousness and those that do. When evaluating an individual with suspected seizure, it's important to first rule out other differential diagnoses like syncope, transient ischemic attacks, and migraine. If it's a true seizure and the individual has a history of epilepsy, then the adequacy of their anti-epileptic medication should be assessed. If the individual is presenting with a first-time seizure, then further investigation into the secondary causes of the seizure should be initiated. This includes laboratory studies like a complete blood count, electrolyte and glucose levels, and a toxicology screen. Additionally, other investigations such as brain imaging, an EEG, or a lumbar puncture should be considered. If no obvious cause is identified, a diagnosis of epilepsy should be considered. Status epilepticus is a seizure lasting more than 5 minutes, or more than one seizure with no recovery in between. When managing status epilepticus, prioritize the airway, breathing, and circulation. Then establish intravenous access, obtain laboratory investigations, and give thiamine followed by glucose. Next, abort the seizure using medications such as the benzodiazepine lorazepam. Finally, in children, febrile seizures and epilepsy syndromes like infantile spasms should be considered. Holy jibber jabber, that took forever to do.
On the neurology ward, a 7-year-old male called Stefan is brought by his mother. His mother is worried because he's had several episodes every day where he loses consciousness for a few seconds. His teacher also complains that she often catches him daydreaming during the lesson. Next to Stefan, there's a 17-year-old male called Jacob, who seems sluggish and tired. His friends brought him because he suddenly started shaking and jerking, and he lost consciousness for about 2 minutes. His medical history is otherwise insignificant. Now, there's also an 11-year-old female called Megan, who also seems lethargic. Her father is very upset because he witnessed an episode of twitching her left foot that lasted a few minutes. Megan was unconscious and has no memory of the event. Finally, there's a 19-year-old female named Joanna that's had repetitive episodes of sudden and rapid jerking movements with loss of consciousness for the past few months. They usually happen when she wakes up in the morning and especially during periods of sleep deprivation. Alright, so all of them had a seizure episode. A seizure is a paroxysmal motor, sensory, or autonomic event that happens due to abnormal, excessive, and synchronous electrical discharges from neurons in the brain. Seizures usually last less than 5 minutes. If it lasts more than 5 minutes, it's called status epilepticus. Epilepsy is a chronic disease of the brain that predisposes an individual to having recurrent, unprovoked seizures. That is, seizures without a clear triggering cause. Epilepsy is typically diagnosed when an individual has 2 or more unprovoked seizures separated by at least 24 hours. Alright, now seizures are broadly classified into 2 types, generalized and focal seizures. Generalized seizures arise from both cerebral hemispheres at the same time, while focal seizures arise from specific areas in one cerebral hemisphere. However, focal seizures can spread to both central hemispheres, causing a generalized seizure. When this happens, it's appropriately called secondary generalization of a focal seizure. Alright, so now let's take a closer look at the different subtypes of generalized seizures. Generalized seizures are subclassified into motor and non-motor seizures. Regardless of the subtype, generalized seizures almost always cause a sudden impairment of consciousness. Generalized motor seizures include tonic, clonic, tonic-clonic, atonic, and myoclonic seizures. Tonic seizures involve sudden stiffening of the muscles, while clonic seizures involve rhythmic twitching of the muscles. However, these clinical features are usually combined, so individuals commonly have a tonic-clonic seizure. In a generalized tonic-clonic seizure, a person might have a sudden contraction of their vocal cord muscles, causing them to involuntarily scream or cry during a seizure. Contraction of the ocular muscles can cause uprolling of the eyes. Contraction of the oropharyngeal muscles can impair swallowing, causing respiratory secretions to pool in the oropharynx. Contraction of the jaw muscles may cause the individual to bite their tongue. Individuals with tonic-clonic seizures might also develop urinary and fecal incontinence. After the tonic-clonic seizure ends, individuals enter a period called the post-ictal phase, during which the individual's consciousness is still impaired for minutes to hours, so they seem sluggish and tired or hard to wake up. So on the exam, look for these subtle clues that indicate a post-ictal phase. Next are myoclonic seizures. For the test, remember that myoclonic seizures involve sudden, rapid muscle contractions. This sounds a lot like clonic seizures, but the key difference is that in myoclonic seizures, the contractions are much faster, happening at a rate of 0.1 seconds, whereas in clonic seizures, the contractions happen at a rate of about 1 to 2 seconds. Myoclonic seizures typically happen in the morning and are usually triggered by stress or sleep deprivation, and that's something you also have to know for the exams. Alright, now atonic seizures translates to no muscle tone. Therefore, they're characterized by sudden loss of postural muscle tone lasting 1 to 2 seconds, causing the individual to collapse to the ground out of the blue. Alright, moving on to the other arm of generalized seizures. There are the generalized non-motor seizures. These are called absence seizures, and they're very high yield. They're commonly found in children and adolescents. Episodes are characterized by sudden, brief loss of consciousness for seconds to minutes without any change in the individual's muscle tone. So they could be sitting in class listening to a lecture and suddenly lose consciousness without falling down. Unfortunately, episodes can happen dozens or even hundreds of times per day, and are classically described by parents and teachers as staring into space, or daydreaming, or being inattentive. In fact, many children with absence seizures are actually misdiagnosed with attention deficit hyperactivity disorder, because teachers often presume that a child is just not paying attention. Alright, now another high-yield topic is focal seizures, previously called partial seizures. Focal seizures are classified into those that do not impair consciousness, and those that impair consciousness. Focal seizures that impair consciousness are also followed by a post-ictal phase, whereas focal seizures that didn't affect consciousness do not have a post-ictal phase. Now, focal seizures can be motor, sensory, or autonomic, depending on the area of the cerebral cortex involved. For example, a focal seizure involving the primary motor cortex might cause tonic or clonic movements of the contralateral extremity, whereas a focal seizure involving the occipital cortex might cause someone to see flashing lights. Sometimes focal seizures might begin as subtle neurological symptoms called auras. During an aura, individuals might exhibit subtle muscle movements called automatisms, such as chewing, lip smacking, or rapid blinking of the eyes. Other forms of aura include smelling unusual odors like kerosene, a rising sensation in the abdomen, or even feelings of fear or déjà vu. Also, an interesting phenomenon that happens after focal motor seizures is Todd's paralysis, which describes a temporary paralysis of the affected extremity. Alright, now it might be difficult to know if a seizure was a generalized tonic-clonic right from the beginning, or if it was a focal seizure that's secondarily generalized. However, a history of an aura, unilateral shaking, turning of the head to one side, or Todd's paralysis is a clue that it might have been a focal seizure that's secondarily generalized. Take that with a grain of salt though, because the absence of these historical features does not adequately exclude a focal seizure. Alright, now a special subtype of seizures that happens in young children between the ages of 6 months and 5 years are febrile seizures. These only happen when the child develops a fever, and they can be generalized or focal. Because of this, febrile seizures are classified differently, and include simple and complex febrile seizures. Simple febrile seizures are usually generalized, last less than 15 minutes, and do not happen again within 24 hours. Complex febrile seizures are usually focal in onset, last more than 15 minutes, and often happen more than once in the span of 24 hours. For your exam, remember that infection with human herpes virus 6, or HHV6, has a particularly high association with febrile seizures. This virus also causes roseola infantum, a disease characterized by the development of a high-grade fever for about 3 to 5 days. Then the fever goes away and a maculopapular rash appears on the trunk and spreads to the extremities. So remember, fever first, rash later. Diagnostic investigations focus on looking for the cause of fever and excluding serious pathology. For example, a lumbar puncture might be performed to exclude meningitis. Alright, now seizures are just a symptom, much like chest pain or shortness of breath, and therefore there are numerous causes of seizures. We can categorize them based on the mnemonic vitamins. V stands for vascular, which includes ischemic or hemorrhagic strokes or intracerebral hemorrhage. I is for infection, which includes meningitis, encephalitis, or brain abscess. T is for trauma, especially penetrating traumatic brain injury, like from a gunshot. T is also for toxins, and this includes drugs of abuse like cocaine or amphetamine overdose, or alcohol withdrawal, which typically develops 48 hours after the last drink. Additionally, the anti-tuberculosis medication isoniazid can potentially cause seizures secondary to pyridoxine or vitamin B6 deficiency. The antidepressant bupropion can also cause seizures, especially if given in individuals with eating disorders like anorexia or bulimia. A is for autoimmune, like central nervous system vasculitis or lupus. M is for metabolic, and this category includes a Bellevue of electrolyte imbalances, like hyponatremia or hypocalcemia, or other metabolic imbalances like hypoglycemia or hyperglycemia, hyperthyroidism, hepatic encephalopathy in liver disease, or uremic encephalopathy in kidney disease. Also, Wernicke encephalopathy caused by thiamine deficiency should be considered, especially in alcoholic individuals. I is for idiopathic, which means epilepsy. N is for neoplasm, and S is for the differential diagnosis like psychogenic seizures or syncope. Also, one separate diagnosis that should be specifically considered in pregnant females is eclampsia. This is when they have preeclampsia, which is high blood pressure during pregnancy and organ damage, and then develop seizures. Alright, so when an individual presents with a history of a paroxysmal event, it's important to first make sure the event was truly a seizure. An important differential diagnosis of a seizure is syncope. Syncope is usually preceded by a prodrome of lightheadedness or sweating, followed by a brief loss of consciousness lasting seconds. Similar to seizures, tonic or clonic movements can also be presented in syncope. However, unlike seizures, syncope does not have a post-ictal phase, and individuals regain full consciousness a few seconds after the event. Next is diagnosing seizures. The first step is to determine if the individual has had prior seizures, in which case they have epilepsy. On the other hand, for a first-time seizure, it's important to start by considering all potential causes. A diagnostic workup should include a complete blood count, or CBC, electrolytes, liver function tests, serum glucose levels, a toxicology screen, and in any woman of childbearing age, a pregnancy test. An electrocardiogram, or ECG, can also be obtained if syncope is part of the differential. Brain imaging with CT or MRI is only done if a structural lesion is suspected, or if no identifiable cause is found on laboratory evaluation. If a brain infection like meningitis is suspected, a lumbar puncture can be obtained. If the workup does not reveal an identifiable cause, then it's considered an unprovoked seizure, and at this point we need to start thinking about epilepsy once again. The next step is performing an electroencephalography, or EEG, which is done by placing electrodes on the scalp and monitoring the brain's activity. The EEG tells us whether the epilepsy is generalized or focal. Additionally, it can help with specific diagnoses. For example, a 3 Hz spike in wave pattern on EEG is characteristic of absence seizures. Now, the treatment of seizures includes abortive therapy, which stops an ongoing seizure episode, and anti-epileptic therapy, which prevents a future seizure from happening. Abortive medications are mainly used when the seizure has exceeded 5 minutes. In other words, status epilepticus. The main abortive medications are the benzodiazepines, like diazepam, midazolam, and lorazepam. As for anti-epileptic medications, there are many options like valproic acid, phentoin, phenobarbital, and many others. A particularly high-yield medication is ethosuximide, which is specifically used for absence seizures. Also, in cases of eclampsia, the medication of choice is magnesium sulfate. Alright, as a quick recap. A seizure is a paroxysmal event that happens due to abnormal and excessive electrical discharges in the brain. Epilepsy is a chronic disorder that predisposes the individual to recurrent seizures, and is typically diagnosed when either 2 or more unprovoked seizures happen. Seizures can be classified into generalized and focal seizures. Generalized seizures include tonic, clonic, tonic-clonic, myoclonic, atonic, and absence seizures. Focal seizures include those that do not alter consciousness and those that do. Children are at risk of febrile seizures, which can be classified as simple or complex. When evaluating an individual with seizures, it's first important to identify the possible trigger. Diagnostic tests like CBC, electrolytes, liver function tests, and glucose levels must be done to reveal potential causes. An EEG can also be done to assess the type of seizure. Alright, so now back to the patients. Due to his age and history of episodes where he briefly loses consciousness and seems to be daydreaming, Stefan most likely has episodes of absences. Now, from his friend's description of the event, Jacob had a generalized motor seizure, and most probably it was a tonic-clonic seizure. Now, Megan had a focal seizure with loss of consciousness, or a partial complex seizure, since the seizure involved only her left foot. Finally, Joanna most likely has episodes of myoclonic seizures, which are typically rapid jerky movements that can be exacerbated by sleep deprivation. Now, a diagnostic workup can be done for all of them in order to find a potential cause for the seizures. If the seizure is unprovoked, the individual might have epilepsy.
With early infantile epileptic encephalopathy, epilepsy means seizure disorder. Encephalopathy means brain dysfunction, often due to damage, and early infantile refers to the age of onset of the disease, which is usually within the first 3 months of life. So early infantile epileptic encephalopathy, or EIEE, is a disorder characterized by recurrent and unprovoked seizures during early infancy, which can result in severe brain damage. The nervous system is made up of specialized cells called neurons, which receive and send signals from other neurons. The 2 neurons communicate at the synapse, where one neuron sends neurotransmitters to the next neuron. Excitatory neurotransmitters, like glutamate, bind to the receptors on neurons and tell them to open up ion channels and relay an electrical signal. Inhibitory neurotransmitters, like GABA, can close the ion channels and dampen down electrical signals. The most common causes of EIEE are structural brain abnormalities, like hemimegalencephaly, where one half of the brain is larger than the other, absence of the corpus callosum, which is a large fiber bundle connecting the left and the right hemispheres, and dysplasia, or abnormal development of the cerebral cortex. Other causes include metabolic disorders like non-ketotic hyperglycemia and mutations in the genes coding for normal development of the neurons. These include the ARX, or Aristillus-related homeobox gene, and STXBP1, or syntax-binding protein 1 gene. Regardless of the cause, defective neurons fire synchronously, which is to say at the same time, and excessively, resulting in a seizure. Infants with EIEE typically present with seizures within the first 3 months of life, often in the first 10 days. The seizures can occur during wakefulness and sleep. They're usually generalized tonic seizures, which means that the muscles in the trunk and extremities suddenly become stiff, the tonic phase, and then jerk, the clonic phase. Some individuals might have myoclonic seizures, which cause short muscle twitches. In general, seizures are brief, lasting less than 10 to 20 seconds, but there can be more than 100 seizures in a day. Although the exact mechanism is unknown, repeated firing of neurons causes changes in the synapse, which interferes with normal impulse conduction. Also, abnormal firing during sleep can affect brain areas involved in memory and learning. The end result is severe and permanent impairment in brain function, and a delay in the developmental milestones like sitting and babbling. Diagnosis of EIEE is made with an electroencephalography, or EEG, which is done by placing electrodes on the scalp and monitoring the brain's activity. It shows a typical burst suppression pattern, where there are bursts of high amplitude spikes alternated with periods of suppressed electrical activity. The frequent EEG abnormalities between seizures can also impair development, as the brain never has a chance to be free of disruptive epilepsy waves. Also, brain imaging, MRI is preferred, can identify potential structure abnormalities, and blood tests can be done to look for underlying metabolic or genetic disorders. Unfortunately, seizures due to EIEE are difficult to treat since they usually don't respond to anti-seizure medications. Corticosteroid therapy with prednisolone and adrenocorticotropic hormone, or ACTH, can help control seizures in some infants. Another option is ketogenic diet, which forces the body and the brain to use fat instead of carbohydrates for energy. Although the exact mechanism is unknown, this can reduce seizures in many cases. In addition, correcting the underlying cause whenever possible can help reduce seizures. Regardless of treatment, EIEE usually has a poor prognosis. Some children die within the first 2 years of life, and those who survive are left with severe physical and intellectual disabilities. In survivors, there can be a transition of EIEE into other epileptic syndromes like West syndrome and Lennox-Gastaut syndrome, which have similar underlying etiologies. Alright, as a quick recap. Early infantile epileptic encephalopathy, or EIEE, is a disorder characterized by recurrent and unprovoked seizures beginning in the first 3 months of life, resulting in severe brain damage. The seizures can be very frequent. On EEG, there's a typical burst suppression pattern that can be frequent and can impair brain function. EIEE seizures usually don't respond to anti-seizure medication, so treatment with corticosteroid therapy and ketogenic diet are recommended.
Epilepsy means seizure disorder, so people with epilepsy have recurring and unpredictable seizures. A seizure is a period where cells in the brain, or neurons, are synchronously active, or active at the same time, when they're not supposed to be. Now, when I say neurons are active, I mean that they're firing, or sending a message using electrical signals relayed from neuron to neuron. And if you look at a neuron under a microscope, each electrical signal that passes through it is really just ions flowing in and out through protein channels. The way this ion flow is controlled is through neurotransmitters, a type of signaling molecule, and receptors. Neurotransmitters bind to the receptors and basically tell the cell to either open up the ion channels and relay the electrical message, called excitatory neurotransmitters, or close the ion channels and stop the electrical message, called inhibitory neurotransmitters. During a seizure, clusters of neurons in the brain become temporarily impaired and start sending out a ton of excitatory signals over and over again, and these are sometimes said to be paroxysmal. These paroxysmal electrical discharges are thought to happen due to either too much excitation or too little inhibition, which are kind of two sides of the same coin, right? The main excitatory neurotransmitter in the brain is glutamate, and NMDA is the primary receptor that responds to glutamate by opening ion channels that let calcium in, a positive ion that tells the cell to send signals. Some patients with epilepsy seem to have fast or long-lasting activation of these receptors. On the flip side, the main inhibitory neurotransmitter in the brain is GABA, which binds to GABA receptors that tell the cell to inhibit the signal by opening channels that let in chloride ions, which are negative ions that tell the cell to inhibit signals. Some patients with epilepsy seem to have genetic mutations in which their GABA receptors are dysfunctional, and so they aren't able to inhibit signals. In addition to potentially having a primary genetic cause, though, these receptors and ion channels might be affected by all sorts of things like brain tumors, brain injury, or infection. Whether it's a decrease in inhibition or an increase in activation, when groups of neurons start firing simultaneously over and over, it's often noticed by others as obvious outward signs, like jerking, moving, and losing consciousness, but can also be subjective experiences that are only noticed by the person experiencing it, like fears or strange smells. It all depends on which neurons in the brain are affected. People with epilepsy experience recurring episodes of some form of seizures, and we can start grouping the seizures by the region of the brain that's affected. When the affected area is limited to one hemisphere, or one half of the brain, or sometimes even a smaller area like a single lobe, we call it a partial or a focal seizure. These seizures can be subcategorized by whether someone remains conscious during the seizure, which is called a simple partial seizure, or whether someone has impaired consciousness during the seizure, which is called a complex partial seizure. Simple partial seizures typically affect a small area of the brain, and can involve the person experiencing strange sensations, like hearing or tasting something, but can also involve jerking movements in specific muscle groups if the neurons controlling those muscles are affected. If the jerking activity starts in a specific muscle group and spreads to surrounding muscle groups as more neurons are affected, it's referred to as a Jacksonian march. Typically, the person is conscious, meaning that they're awake and alert, and will usually know that something's happening and will remember the seizure afterwards. Complex partial seizures, on the other hand, involve losing consciousness completely or having impaired awareness and responsiveness, so they might not remember exactly what happened during a seizure. Now, in contrast to the partial or focal seizure, a generalized seizure is where both hemispheres of the brain are affected. Sometimes the seizure will start out as a partial seizure and then quickly develop into a generalized seizure, and in those situations it'd be called a secondary generalized seizure because a partial seizure came before it and was the primary event. Just like partial seizures, there are some subcategories of generalized seizures as well. One subtype is a tonic seizure, where the muscles all of a sudden become stiff and flexed, which can cause the patient to fall, often backwards. On the flip side, though, they can be atonic as well, where their muscles suddenly relax and become floppy, which again can cause the patient to fall, but this time forward. Seizures can also be clonic, where they have violent muscle contractions, also known as convulsions. Tonic-clonic seizures are the most common generalized seizures, where patients experience a tonic phase where the muscles suddenly tense up, followed by a clonic phase where the muscles rapidly contract and relax. Myoclonic seizures are yet another type, and are short muscle twitches, sometimes just a single twitch, but sometimes many in a short amount of time. Finally, there are absence seizures, where the patients lose consciousness and then quickly regain consciousness, generally with the only outward sign being that the person looks like they spaced out, like if they were walking, they'll suddenly stand still. The key for all these is that they involve both hemispheres of the brain, and patients lose consciousness either briefly or for longer periods of time. If the seizures do last for a longer period of time, like over 5 minutes of ongoing seizures or having multiple seizures without returning to normal in between, then it's called status epilepticus. And these are usually the tonic-clonic subtype of seizures, but it can also be caused by other types that don't involve convulsions. This situation is considered a medical emergency and can be life-threatening if not treated immediately. Due to the severity of these seizures, patients are often treated acutely with benzodiazepines, which help enhance the effect of the inhibitory neurotransmitter GABA. Following a seizure, sometimes patients experience certain symptoms, like confusion, called post-ictal confusion, which means after seizure confusion. Also, patients might experience paralysis that affects the arms or the legs, usually just limited to one side of the body. And this is known as Todd's paralysis or Todd's paresis, and can last for quite a while, on average about 15 hours. And usually it subsides by itself completely after 2 days. The precise mechanism behind Todd's paralysis isn't currently well understood, but it's thought to be the result of temporary but severe suppression of activity of the area in the brain affected by the seizure. Typically, after a seizure's over, patients will have brain imaging techniques like MRI or CT scans, as well as an EEG, or electroencephalogram, which detects electrical activity in the brain. With patients who've just started having seizures, brain scans are used to find out if there are any anatomical abnormalities, like brain tumors or abnormal blood vessels that could be causing the seizures. both of which would be treated surgically. Because epilepsy can vary from patient to patient in the type, severity, and frequency of the seizures, diagnosis typically involves a variety of examinations and tests in combination with a thorough evaluation of their clinical history. Once epilepsy has been diagnosed, it's often treated with daily medication, the primary form of medication being anticonvulsants, of which there are a wide variety of options available that have different targets in the brain, so the choice is based on the specific needs of the patient, including factors like age, lifestyle, other health problems, and the category or subcategory of the epilepsy syndrome. Other treatment options include epilepsy surgery, where they'll remove what's thought to be causing the seizures, like a specific part of the brain or a tumor. Nerve stimulation might also be considered, where certain nerves like the vagus nerve are stimulated, which is thought to control seizures by influencing neurotransmitter release. Also, patients might adopt a ketogenic diet, which is a diet that forces the body to burn fat instead of carbohydrates, which produces ketone bodies, which are then used by the brain as an energy source instead of glucose. Although many hypotheses have been suggested for why this seems to reduce seizures for some patients, the exact mechanism isn't very well understood. Febrile seizures are seizures that happen with a fever, and they typically happen in young children between 6 months and 5 years of age. Now, neurons are the main cells of the nervous system, and they're composed of a cell body, which has all of the cell's organelles, and nerve fibers, which are projections that extend out from the neuron cell body. Nerve fibers are either dendrites that receive signals from other neurons, or axons that send signals called action potentials along to other neurons. Where two neurons come together is called a synapse, and that's where one end of an axon sends neurotransmitters to the dendrites or directly to the cell body of the next neuron in the series. Some neurotransmitters bind to the receptors and tell the cell to open up the ion channels and relay the electrical message, and these are called excitatory neurotransmitters. But there are others which can close the ion channels and prevent an electrical message from going through, and these are called inhibitory neurotransmitters. The main excitatory neurotransmitter in the brain is glutamate. Glutamate binds to NMDA receptors, which tell the cell to open up calcium ion channels. Since calcium has a positive charge, it makes the inside of the cell more positive, and that helps trigger an action potential. On the flip side, the main inhibitory neurotransmitter in the brain is GABA. GABA binds to GABA receptors, which tell the cell to open up chloride ion channels. Since chloride has a negative charge, it makes the inside of a cell more negative, and that inhibits an action potential. During a seizure, large groups of neurons become active synchronously, meaning all at the same time. And in a febrile seizure, the trigger for that neuronal activity is a fever. So that makes you wonder, why? Well, we actually don't know for sure, but there are some possible explanations. The first is that a fever raises the core body temperature, and it makes neurons more excitable than usual, meaning that action potentials are more likely to happen. The second is that fever causes hyperventilation, which is when you breathe faster and have a decreased level of carbon dioxide in the blood. That leads to a respiratory alkalosis, or an increase in blood pH, which also seems to make neurons more excitable. The third is that fevers are caused by cytokines like interleukin-1 beta that get released by white blood cells during the body's innate immune response. Cytokines are thought to also enhance the activity of NMDA receptors. Of course, most of the time people have fevers without having seizures, so these factors are just one part of the story. While we don't know for sure what causes febrile seizures, we do know that there are certain risk factors. Genetics seem to play a role, as children whose parents had febrile seizures are more likely to also have them. Age seems to also be a factor, because although febrile seizures happen in children between the age of 6 months to 5 years, the majority happen in children that are 12 to 18 months of age. Generally speaking, febrile seizures happen more often when the fevers develop rapidly, or are higher in magnitude. Febrile seizures seem to be more associated with some infections like human herpes virus 6, which causes roseola. Febrile seizures can also develop after vaccinations that really stimulate the immune system, like the measles, mumps, rubella, varicella vaccine. but the frequency is quite low and the benefits of vaccination outweigh its risk. Febrile seizures also always involve a high temperature, or fever, of above 38 degrees Celsius or 100.4 degrees Fahrenheit, and they can be classified as either simple or complex. A simple febrile seizure lasts for less than 15 minutes, affects the whole body, and doesn't repeat within 24 hours. A complex febrile seizure is one that lasts for over 15 minutes or affects a specific part of the body which corresponds to a specific part of the brain, or one that repeats within 24 hours. Basically, if a seizure doesn't meet the criteria for being considered simple, then it's considered complex. Having said that, most febrile seizures are simple febrile seizures that last a couple of minutes, and they're tonic-clonic, which means that there's a tonic phase when muscles throughout the body suddenly tense up and go rigid, followed by a clonic phase when muscles rapidly start contracting and relaxing, causing convulsions. After the seizure itself, there's usually a post-ictal state, which is when a child might feel confused and may not remember the episode. They can also have residual arm or leg weakness. Treatment isn't needed for most febrile seizures, because they usually stop by themselves. During a febrile seizure, it's a good idea to lay a child on their side and keep track of the time. It's a bit more concerning if a seizure lasts for a long time or if there are other serious symptoms, like vomiting, trouble breathing, or a stiff neck. Oftentimes, it's important to distinguish febrile seizures from other underlying causes of fevers and seizures, like encephalitis and meningitis, which are infections of the brain and the tissue surrounding the brain. In young infants, a lumbar puncture can be helpful in identifying the underlying cause of the seizure. In some cases, anti-seizure medication can be used, but typically they're not needed in cases of simple febrile seizures. Finally, the fever itself can be uncomfortable for a child, so antipyretic medications like ibuprofen or acetaminophen can be used to reduce the fever. Alright, as a quick recap. Febrile seizures are seizures that happen together with a fever in children. Whether it's through an increase in body temperature, the alkalosis of the blood, or the release of certain chemicals like interleukin-1 beta, fever seems to excite neuronal activity, which makes it easy for groups of neurons to start firing simultaneously, over and over again. Most febrile seizures are generalized tonic-clonic seizures that cause stiffness, jerking, and loss of consciousness. Thankfully, most febrile seizures resolve themselves without any treatment and don't cause any long-term harm.
Hi everyone, thanks for watching that video on febrile seizures. I'm Sam, and I did the illustrations for this video. The script was written by Thomas, edited by Rishi and Yifan, Tanner did the voiceover, and Evan edited the video. If you're a parent or a family member of a child who gets febrile seizures, I hope that this video gave you the knowledge you needed and hopefully brought you some peace of mind. If you're a student, I really hope you found it informative. If you're looking for more videos like this to increase your study power, I would highly recommend you head over to osmosis.org and become a Prime member. That'll give you access to some great study tools and lots more videos that are not on YouTube. That's all from me. Later, guys.
Brown-Séquard syndrome, first described by the physiologist Charles Edouard Brown-Séquard, is a condition associated with hemisection or damage to one half of the spinal cord. The hemisection damages neural tracts in the spinal cord that carries information to and from the brain. This results in the loss of sensations like pain, temperature, touch, as well as paralysis or loss of muscle function in some parts of the body. Now, if you look at the cross-section of the spinal cord, the white matter is on the outside and the gray matter is on the inside. And overall, it looks kind of like a butterfly. If we draw a horizontal line through the spinal cord, the front half is the anterior or ventral half, and the back half is the posterior or dorsal half. And the butterfly wings are sometimes referred to as horns. So we have two dorsal horns that contain cell bodies of sensory neurons and two ventral horns that contain cell bodies of motor neurons. The white matter consists of myelinated axons, which are separated into tracts that carry information to and from the brain. Think of them like highways for neural signals, where some highways carry sensory information to the brain and some carry motor information from the brain to the muscles. There are a few main tracts to remember. First, there's the spinothalamic tract, which is an ascending pathway, and it's divided into two parts. The lateral tract carries sensory information for pain, pressure, and temperature, while the anterior tract carries information for crude touch, or the sense one has been touched, without being able to localize where they were touched. Second, there are two ascending dorsal column tracts. The fasciculus gracilis, which carries sensory information from the lower trunk and legs, and the fasciculus cuneatus, which carries sensory information from the upper trunk and arms. These tracts both carry sensations like pressure, vibration, fine touch, which is where you can localize where you were touched, and proprioception, which is an awareness of your body position in space. Finally, there's the corticospinal tract, which is a descending pathway that carries motor information from the brain to different muscles in the body, and it controls voluntary muscle movement. So, sensory information has to go through 3 neurons to reach the brain, kind of like 3 people in a relay race. For example, if you accidentally touch a hot pan, the sensation of pain and temperature is carried from the nerves in the skin of your fingers through a first-order neuron, which is a pseudo-unipolar neuron. A pseudo-unipolar neuron has a cell body from which only one axon comes out, and then that axon splits into 2 branches, a lateral branch that comes from the periphery and a medial branch that runs towards the spinal cord. So the nerve in the skin of your fingers is served by the lateral branch of a first-order neuron, which carries the sensation to the dorsal root ganglion. That's where the cell body is located along with the rest of the cell bodies of the pseudo-unipolar neurons. From there, the signal continues through the medial branch and into the spinal cord to reach the dorsal horn. Here it passes off the sensory information baton by synapsing with a second-order neuron, which sends off its own axon, which ascends 1 or 2 spinal segments and crosses over to the opposite side to travel up the spinal cord, and eventually synapse with a third-order neuron located in the ventral posterior nucleus of the thalamus. This third-order neuron then sends its axon up to the sensory cortex of the brain, letting you know that there's tissue damage. Similarly, if you suddenly grab a vibrating cell phone, the sensation of vibration is carried from the nerves in the skin of your palm, via the fasciculus cuneatus, which is a collection of nerves all composed of first-order neurons. The fasciculus cuneatus is contained within the dorsal white column, located posteriorly in the white matter of the spinal cord. The first-order neuron then ascends up along the same side of the whole length of the spinal cord, to reach the lower level of the medulla oblongata, where it synapses with the cell body of a second-order neuron in the nucleus cuneatus. The second-order neuron then sends off an axon that crosses over to the opposite side of the medulla, and travels up to the ventral posterior nucleus of the thalamus to synapse with a third-order neuron. The third-order neuron then sends up an axon that carries the sensory signals to the primary somatosensory cortex of the brain, letting you know that your phone is vibrating. Once your brain receives sensory information, it sends a motor signal down the upper motor neurons through the corticospinal tract in the midbrain and crosses to the opposite side at the medulla, before continuing down the spinal cord. There, they synapse with lower motor neurons in the ventral horn, and the lower motor neuron axons then leave the spinal cord to innervate the muscles of your arm and forearm, which allows you to lift your fingers and hand from the hot pan, or pick up your cell phone. Hopefully this all happened quickly, so you haven't sustained major tissue damage and that caller hasn't hung up. In Brown-Séquard syndrome, a vertebral bone fracture or any kind of penetrating trauma like a gunshot injury or stab wound in the back can lead to the hemisection of the spinal cord, and this mostly happens in the neck or cervical region. Besides trauma, non-traumatic conditions like a spinal cord tumor might compress the spinal cord and lead to Brown-Séquard syndrome. Okay, so suppose a person was stabbed in the neck and had a complete right hemisection of the spinal cord. This means that all the principal neural tracts in the right side of the spinal cord are now damaged. Damage to the right-sided corticospinal tract means that, below the level of the lesion, the lower motor neurons, like those going to the legs, are no longer receiving signals from the upper motor neuron. So the muscles they control become paralyzed. And this is called an ipsilateral hemiplegia, or paralysis on the same side. Interestingly, these neurons become so starved for stimulation, they become hypersensitive and start firing inappropriately, causing increased muscle tone and muscle spasms. So we call this spastic paralysis. Meanwhile, at the level of the lesion, the lower motor neuron of the right ventral horn will also be damaged. This means that the muscles innervated by these lower motor neurons, like those in the arms, will not receive any neuro input at all. So they go limp and decrease in tone, which is called flaccid paralysis. Similarly, there's damage to the dorsal column on the right side, which will lead to the loss of fine touch, pressure, vibration, and proprioception in the right side of the body at the level of the injury and below it. Now, the spinal thalamic tract is a bit different, because it crosses over to the opposite side of the spinal cord 1 or 2 spinal segments above, where the first-order neurons enter. So damage to the right spinothalamic tract will cause loss of pain, temperature, and crude touch sensation from the opposite or left side, beginning 1 or 2 segments below the lesion. But at the level of the lesion, the spinothalamic tract of the same right side will be damaged too. This will lead to complete loss of all cutaneous sensation at the level of the lesion. Besides those 3 tracts, very rarely a hemisection of the spinal cord above the T1 spinal level can also damage the sympathetic chain that runs alongside the spinal cord and supplies the facial region. This leads to Horner's syndrome on the same side of the face as the lesion, which includes symptoms of miosis or constricted pupil, ptosis or droopy eyelid, and anhidrosis or failure to sweat. Now, in clinical scenarios, a complete right side or complete left side hemisection is pretty rare. That's why most of the time, individuals with Brown-Séquard syndrome will only present with an incomplete hemisection and some sensory or motor problems, depending on which tracts are damaged. For example, if an individual has been stabbed in the back and has no pain and temperature sensation on the left side, but normal motor function and normal fine touch and vibration, it means that there's only damage to the spinothalamic tract of the right side. Finally, magnetic resonance imaging, or an MRI, can be used to confirm any lesion on or within the spinal cord. The treatment for Brown-Séquard syndrome is mainly supportive and focused on rehabilitation with physical and occupational therapy. Typically, cord swelling and inflammation can be managed with corticosteroids. Alright, as a quick recap. Brown-Séquard syndrome is a condition associated with hemisection of the spinal cord, which usually damages descending corticospinal tracts, ascending dorsal column tracts, and spinothalamic tracts. The result is paralysis and loss of proprioception on the same side as the injury or lesion, and loss of pain and temperature sensation on the opposite side of the lesion.
Hi everyone, thanks so much for watching our video on Brown-Séquard syndrome. I hope you found it informative. Man, can we agree you do not want to mess up your spinal cord? But thank heavens for occupational and physical therapy, right? In fact, shout out to all the occupational and physical therapists for the amazing rehab work that they do. And an extra shout out to those OTs and PTs who use osmosis. We're thrilled to support clinicians like you in your quest for better medical knowledge. If you're not an Osmosis Prime member and you'd like more support in your educational journey, come on over to osmosis.org and sign up for a free trial. You'll get access to a bunch of videos that are not on YouTube, as well as some other great tools. Now, before I forget, let's give out some credits. This script was written by Anush, edited by Rishi and Yifan, Tanner did the voiceover, and Sam G edited the video. I'm Sam McBundy, I did the illustrations, and that's all I have for you. See you guys later.
Cauda equina syndrome is a condition caused by damage to the bundle of peripheral nerves protruding from the bottom of the spinal cord. called the cauda equina. The Latin words cauda equina means horsetail, which is what early anatomists thought the nerve bundle looked like. The spinal column is made of individual bones, called vertebrae. Each vertebra is made of a large anterior portion called the body, and the posterior part called the vertebral arch. The central cavity between the body and the arch is called the vertebral foramen. Now, the spinal column is made of 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. Other than C1 and C2, each 2 adjacent vertebrae are separated by an intervertebral disc, which allows for a slight movement of the vertebrae and acts as a shock absorber. The sacral and coccygeal vertebrae are fused together to form the sacral bone and coccyx, or tailbone, respectively. Now, if you cut the spinal column in half lengthwise, you can see that all the vertebral foramina together form the vertebral or the spinal canal, which is occupied by the spinal cord. The spinal cord is connected to the brain and travels through the spinal canal to the second lumbar vertebra, where it ends in a cone, called the conus medullaris. There are 31 pairs of nerves originating from the spinal cord called spinal nerves. There are 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Each nerve leaves the spinal canal through the corresponding intervertebral foramen, which are openings between 2 adjacent vertebrae. Since the spinal cord is shorter than the spinal canal, the nerves of the lumbar, sacral, and coccygeal regions have to travel down the spinal canal to reach their corresponding openings, forming a nerve bundle below the spinal cord called the cauda equina. These nerves carry motor innervation for the genitals, both internal and external anal sphincters, detrusor vesicae, which is a muscle in the bladder that contracts during urination, and muscles of the leg. They're in charge of the knee and ankle reflexes. Skin sensations of the leg and pelvis are also carried by these nerves. Cauda equina syndrome is caused by compression, trauma, or damage to multiple nerves of the cauda equina. Large lumbar disc herniation is the most common cause of cauda equina syndrome. And poor posture, traumas, physical activity, and strong rotational movement can cause herniations where the intervertebral disc bulges out and compresses the nerves or spinal cord. This is similar to sciatica, but the herniation is usually larger, and more nerves are compressed, including those that control the bladder and reproductive organs. Compression can also be caused by spinal stenosis, which is the narrowing of the vertebral foramen in the lumbar vertebrae. It can be congenital, meaning that the person is born with it, or acquired, usually due to degenerative disorders like ankylosing spondylitis, where the bones remodel, causing intervertebral disc ossification, and the narrowing of the spinal canal. Another cause is spondylolisthesis, where a lumbar vertebrae is displaced. This can be caused by trauma, surgery, or degenerative spinal disease. The most common type of lumbar spondylolisthesis is anterolisthesis, where a vertebra moves forward and narrows the spinal canal, causing compression of the nerves. Finally, any trauma to the spine, like the one caused by a car crash, gunshot, etc., can lead to nerve damage or compression directly, or by causing bleeding inside the spinal canal, causing compression via hematomas. Finally, any growth within the spinal canal, like tumors, cysts, or abscesses, can cause compression on the spinal cord and nerves. Symptoms of cauda equina include decreased bowel and bladder control due to a decreased tone of anal sphincters and muscle wall of the bladder, as well as decreased sexual function. It can also cause saddle anesthesia, which is a loss of sensation in the saddle area, which includes the buttocks and inner surface of the thigh and perineum. One or both legs can be impaired by muscle weakness, loss of knee and ankle reflexes, and even paraplegia, which is when the affected person loses all feeling and muscle control in the legs. Sometimes there can be sciatic pain, which is a sharp pain going down the back and leg. Diagnosis of cauda equina syndrome is usually based on the pattern of sensory and motor nerve findings and confirmed by an MRI or CT scan. The treatment of Cauda-Equina syndrome depends on the cause. If it was caused by disc herniation, trauma, tumors, or abscess, the symptoms appeared suddenly, and the surgical decompression should be performed within 48 hours. Abscesses should also be treated with antibiotics. However, if it's caused by degenerative disease, then symptoms appear more gradually, and it's treated with anti-inflammatory medications and corticosteroids. Alright, as a quick recap. Cauda-Equina syndrome is a condition caused by damage or compression to the nerves or cauda equina. The most common cause is lumbar disc herniation, and typical symptoms include decreased urinary and bowel control, decreased sexual function, and saddle anesthesia. Depending on the cause, Cauda-Equina syndrome can be treated surgically, as well as by anti-inflammatory medications or by antibiotics.
Friedreich's ataxia is a disorder where there's impaired mitochondrial function that results in damage to various organ systems. In particular, the nervous system gets damaged, which causes ataxia, where the muscles cannot be moved in a coordinated way. The disorder also affects other organs like the heart and pancreas. The disease gets its name from the German physician Nikolaus Friedrich, who first described the disease over 150 years ago. So normally on chromosome 9, there's a gene called the FXN gene that encodes a mitochondrial protein called frataxin. The normal amount of frataxin varies by tissue, with some tissues like the nervous system, pancreas, and heart containing lots of it. Frataxin helps put together cofactors called iron-sulfur clusters. It is a combination of iron and sulfur that form part of enzymes with many functions, such as electron transfer, which is a key part of mitochondrial ATP production. Friedreich's ataxia is caused by a mutation in the FXN gene where there's an abnormal repetition of a GAA sequence within that gene. This is called a triplet repeat, or trinucleotide repeat, which means that a group of 3 DNA nucleotides is repeated multiple times in a row. In this case, guanine, adenine, and adenine. Normally, the GAA sequence is repeated 7 to 34 times within the FXN gene. But in Friedreich's ataxia, there is a repeat expansion where there are 100 to 1,700 times as many copies, with most individuals having repeats ranging from 600 to 1,200 times. Now, Friedreich's ataxia is inherited as an autosomal recessive condition. It's passed on by parents who are carriers because they have one expanded FXN gene and one normal FXN gene, but they don't have any symptoms of Friedreich's ataxia. They end up passing on their expanded FXN genes to their kid. Inheriting both copies of the FXN gene with an expanded GAA repeat is the most common way to get Friedreich's ataxia. The repeat expansion causes gene silencing, which is when the FXN gene is not transcribed normally, and very little frataxin protein is made. With low levels of frataxin, the mitochondria are unable to efficiently incorporate iron into iron-sulfur clusters, and as a result, there is lower mitochondrial ATP production. So there's less energy available for the cell. Furthermore, iron accumulates inside the mitochondria, which reacts with oxygen to create unstable oxygen radicals. Over time, these free radicals damage DNA and proteins in the cells in a process called oxidative damage. Then, this energy deficiency and oxidative damage result in dysfunction and death of the cells that are highly dependent on mitochondrial function, such as neurons, cardiomyocytes, and pancreatic beta cells. The loss of neurons leads to ataxia. In the heart, there is abnormal thickening of the ventricles, a condition called hypertrophic cardiomyopathy, which is the most common cause of death in people with Friedreich's ataxia. In the pancreas, beta cells die off, leading to decreased insulin production and diabetes mellitus. In individuals with Friedreich's ataxia, the ataxia usually begins in childhood, which causes them to have difficulty in walking. They might have some muscle weakness and loss of proprioception, which is the sense of your position in space relative to other objects. Usually, it affects the legs and then moves up to the torso. A generalized feeling of fatigue is also common. Eventually, most people with Friedreich's ataxia need a wheelchair to get around. In later stages, they may develop complications of cardiomyopathy, such as heart failure, and some even end up losing their vision and hearing. The diagnosis of Friedreich's ataxia is established by genetic testing. This test is used to identify the expanded GAA repeat in both copies of the FXN gene, the most common cause of Friedreich's ataxia. Additional tests may be performed to help determine the extent of the disease, such as an MRI of the brain and spinal cord, and echocardiography to measure the heart wall thickness. There is no treatment that can slow or halt the progression of Friedreich's ataxia, but symptoms can be managed. For example, physical therapy can help maintain muscle function. Alright, as a quick recap, Friedreich's ataxia is caused by a repeat expansion in the FXN gene on chromosome 9. It is normal to have less than 34 GAA repeats, but it is pathogenic if there are over 100 repeats. Friedreich's ataxia affects the nervous system, pancreas, and heart due to defective mitochondrial function and oxidative damage. Ataxia, diabetes, and hypertrophic cardiomyopathy result.
With neurogenic bladder, neurogenic means arising from the nervous system. So neurogenic bladders typically some difficulty emptying the bladder normally, as a result of either damage to the peripheral nerves, brain, or spinal cord. Normally, urine's held in the bladder, which receives urine from two ureters coming down from the kidneys, and then that urine leaves the bladder through the urethra. As urine flows from the kidney through the ureters and into the bladder starts to expand into the abdomen. The bladder is able to expand and contract because it's wrapped in a muscular layer, called the detrusor muscle, and within that, lining the bladder itself, is a layer of transitional epithelium containing umbrella cells. These umbrella cells get their name because they physically stretch out as the bladder fills, just like an umbrella opening in slow motion. In a grown adult, the bladder can expand to hold about 750 milliliters, slightly less in women than in men, because the uterus takes up space, which crowds out the bladder a little bit. Alright, so when the urine's collecting in the bladder, there are basically two doors that are shut, which holds the urine in. The first door is the internal sphincter muscle, which is made of smooth muscle and is under involuntary control, meaning that it opens and closes automatically. Typically, that internal sphincter muscle opens up when the bladder is about half full. The second door is the external sphincter muscle, and it's made of skeletal muscles and is under voluntary control, meaning that it opens and closes when a person wants it to. This is the reason that it's possible to stop urine midstream by tightening up that muscle, which is called doing Kegel exercises. Once urine has passed through the external sphincter muscle, it exits the body. In women, the exit's immediate, and in men, the urine flows through the penis before it exits. So, when specialized nerves called stretch receptors in the bladder wall sense that the bladder's about half full, they send impulses to the spinal cord, specifically the sacral spinal cord at levels S2 and S3, known as the micturition center, and the brain, specifically two locations in the pons, the pontine storage center and the pontine micturition center. The spinal cord response is part of the micturition reflex, and it causes an increase in parasympathetic stimulation and decrease in sympathetic stimulation, which makes the detrusor muscle contract and the internal sphincter relax. It also decreases motor nerve stimulation to the external sphincter, allowing it to relax as well. At this point, urination would happen, if not for the pons. The pons is the region of the brain that we train to voluntarily control urination. If we want to delay urination, or hold it in, the pontine storage center overrides the micturition reflex. And when we want to urinate, the pontine micturition center allows for the micturition reflex to happen. Now, with neurogenic bladder, the exact pattern of symptoms depends on the nerve that's damaged. In diabetes mellitus, excess glucose levels in the blood attaches to various proteins, a process called glycation. This process can damage sensory nerve fibers in the bladder wall, in the pelvic nerve, or in dorsal nerve roots entering the spinal cord, all of which interferes with the initial stretch signal that gets sent out as the bladder fills. Another potential cause is syphilis. This infection can eventually lead to tabes dorsalis, which is inflammation and scarring of those same little dorsal root nerves. Also, with herpes, the virus takes up a home in the dorsal nerve roots for months to years, and it can also disrupt the sensory fibers that they carry within them. This all means that as the bladder fills to capacity and stretches, that sensory information is not received, and the bladder starts to overflow, drop by drop, out of the urethra. This is called overflow incontinence. Now, that sensory information goes through the micturition center at the S2, S3 region of the spinal cord. So if there's an injury to the spinal cord in that region, for example, if someone falls from a tree or a ladder and lands on their buttocks, then again that micturition reflex pathway is interrupted, and someone can have overflow incontinence. Now, if there's a spinal cord injury above the sacral region, then immediately after, all the reflexes below the injury are suppressed. This phenomenon is known as spinal shock and can last hours to weeks. The exact mechanism behind spinal shock, though, isn't completely clear. But during spinal shock, the micturition reflex gets suppressed as well, and it leads to detrusor hyporeflexia, which once again leads to overflow incontinence. Now, once that shock wears off, normal micturition reflex resumes, since the sacral region is intact, but the signals can't be sent to or received from the pons, which means that there's no inhibitory pathway from the brain. So this means that the bladder goes into overdrive mode, leading to detrusor hyperreflexia. At this point, even a tiny amount of urine initiates the micturition reflex, which leads to frequent urges to urinate, called urge incontinence. Now, in multiple sclerosis, a similar pattern unfolds, except in this case, the body's immune system attacks the myelin sheath of the nerves in the brain and spinal cord. Once again, though, this can prevent the inhibitory signals from the brain from reaching the micturition reflex pathway, which causes detrusor hyperreflexia and urge incontinence. Going a little further up, if there are acute injuries to the brain, like a stroke, then there'll be a similar pattern as spinal injuries, with an initial shock phase of detrusor hyporeflexia, as well as overflow incontinence, followed by detrusor hyperreflexia and urge incontinence. In chronic processes, like a brain tumor or Parkinson's disease, there's usually no state of shock, and instead it typically proceeds directly to detrusor hyperreflexia, as well as urge incontinence. Diagnosis can be done by measuring post-void residuals, which is the amount of urine left in the bladder after urination, as well as the pressure and flow of the urine. Treatment of overflow incontinence can be relieved by putting a catheter through the urethra that drains the urine. Urge incontinence can be relieved with anticholinergic drugs that help relax the detrusor muscle. Alright, as a quick recap. Neurogenic bladders where some form of nerve damage causes bladder dysfunction. And this dysfunction could be overflow incontinence where the bladder fills up to capacity and then dribbles out of the urethra, or urge incontinence where an individual feels frequent urges to urinate. What's going on, guys? Hope you liked that video. It was written by Debal and edited by Rishi. And then obviously illustrated by myself. Well, maybe that's not obvious, but it was. Otherwise, you can always check out our subreddit called r/osmosit. Go there, check out the videos, post some comments, upvote some stuff. You know how it goes. Also, you can subscribe to our channel on YouTube, as well as follow us on social media and donate to us on Patreon. All right, guys. Bye.
Treponema pallidum can be considered a gram-negative bacterium, even though its cell envelope differs from other gram-negative bacteria. You might know T. pallidum because it causes syphilis, a sexually transmitted disease that affects the skin and mucous membranes of the external genitalia, and also sometimes the mouth. Treponema pallidum is an obligate parasite bacteria, meaning it can't survive outside a living body. To be more specific, outside of a human being's body. They belong to a group of bacteria called spirochetes, which are long and thin and contain endoflagella, which are a band of protein filaments that coil within the spirochetes and give them a spiral shape. Kinda like a curly fry, but a little less appetizing. The endoflagella also help the spirochetes to move around by spinning or twisting, a bit like a drill that's slowly boring into a piece of wood. People that have syphilis can transmit the disease to others in one of two ways. The first way is called acquired syphilis, and that's when Treponema pallidum enters the body through bodily fluids. That can happen when there are tiny cuts or breaks in the skin or mucous membranes of the external genitalia or mouth, and when there's sexual contact, including oral, anal, and vaginal sex. It can also happen when people share contaminated needles, or when they have direct contact with a skin lesion on an infected person, because the skin lesion is covered in this fluid which is rich in spirochetes. The second way is called congenital syphilis, and that's when a pregnant person has syphilis and Treponema pallidum infects a baby either in the uterus or while the baby exits through the vagina at birth. In acquired syphilis, there are 3 stages to the infection. The first stage is called primary syphilis, or the early localized stage, and it usually starts 1 to 3 weeks after the T. pallidum lands on the skin or mucous membrane. During this stage, the spirochetes destroy the soft tissue and skin wherever they enter the body, and that results in the formation of ulcers called syphilitic chancres. A syphilitic chancre is painless, and you can remember that by dropping in a U to make it chancre, like you're cured of the pain. These chancres have a hard base, raised borders, and are usually covered by a fluid rich in spirochetes, and this can spread to other parts of the body as well as to other individuals. In individuals who acquire syphilis through sexual contact, the primary chancre develops around the external genitalia. However, for individuals that acquire syphilis by physically touching a person or in some other way, the primary chancre might appear on the hands or some other part of the body. Syphilitic chancres typically heal on their own over a few months, but during that time, some spirochetes go to nearby lymph nodes where they cause lymphadenopathy, which is lymph node enlargement, and then they get into the lymph and finally into the bloodstream. If syphilis is acquired through something like a blood transfusion, then there may not be any early localized stage at all, and no primary chancre. The second stage is secondary syphilis, or the dissemination stage, and it occurs about 6 to 12 weeks after the infection. During this stage, spirochetes enter the bloodstream, which is called spirochetemia, and this causes generalized lymphadenopathy, which is when spirochetes can be found in lymph nodes throughout the body. The spirochetes like to attach to and infect endothelial cells in small capillaries near the skin. This causes a non-itchy maculopapular rash, which are small bumps that are either flat or raised. The rash starts on the trunk and spreads out to the arms and legs, and eventually to the palms, soles, genitalia, and other mucous membranes. These rashes can sometimes be pustular, which means they're filled with the white fluid pus, or they can be papulosquamous, which is when they're really scaly and hard. In addition, there can be something called condyloma lata, which are smooth, white, painless, wart-like lesions, and they appear on moist areas like the genitals, around the anal region, and in the armpits. So, these various rashes can erupt all over the body, and the lesions are chock full of spirochetes, making secondary syphilis the most infectious stage. The rashes from secondary syphilis usually resolve within a few weeks to months. After secondary syphilis is a latent phase, called latent syphilis. This is when the disease enters a dormant or asymptomatic phase. During this phase, the spirochetes can mostly be found in the tiny capillaries of various body organs and tissues. Latent syphilis can be further divided into an early phase and a late phase. Early latent syphilis occurs within a year of infection, and during that time, the spirochetes can re-enter the blood. So, this means that during early latent syphilis, they can still be found circulating in large numbers in the blood, causing symptoms of secondary syphilis. However, the late latent phase is generally after a year, and that's because the spirochetes generally stay within the tiny capillaries of various body organs and tissues. As it turns out, only a few spirochetes are actually found in the capillaries of tissues and organs. But there's a severe immune response, so severe that it causes tremendous damage to the cells there. And that triggers the next phase, which is tertiary syphilis. In tertiary syphilis, there's a type 4 hypersensitivity reaction, which means that there's an immune response that's mainly led by the T cells, and they recruit phagocytes like macrophages and cause the release of pro-inflammatory cytokines, such as tumor necrosis factor, IL-1, and IL-6. All of this leads to local swelling or edema, redness, and warmth, as well as systemic symptoms like a fever. T. pallidum has 3 main antigens. These include group-specific antigen, which are present in all treponemes, species-specific antigen, which are specific to T. pallidum, and cardiolipin, which is a lipid antigen, which interestingly is present within the spirochetes as well as the cells in our body. Now, plasma cells like to get themselves involved in the immune reaction by producing antibodies against these antigens. In some cases, the immune cells start to huddle around and form a granulomatous lesion called a gumma, and this has lots of different types of immune cells that get surrounded by an outermost layer of fibroblasts. Often, funnily enough, there aren't any spirochetes at all in these lesions. It's just like the immune cells are getting overexcited and huddling up for no obvious reason. The tissue at the center of the gumma often ends up without oxygen, and that can lead to a coagulative necrosis. In tertiary syphilis, various organs get damaged, like the heart and blood vessels, which is called cardiovascular syphilis, the brain and the spinal cord, called neurosyphilis, and also the liver, joints, and testes, which haven't yet earned their own special names. In cardiovascular syphilis, there's endarteritis, which is inflammation of the tiny arterioles called vasa vasorum, which supply blood to large arteries like the aorta. The result is that parts of the aorta are damaged, resulting in aortitis, or inflammation of the aorta, and this can cause aortic aneurysms. In neurosyphilis, the spirochetes set up camp in the capillaries supplying the posterior or back part of the spinal cord, and this can result in something called tabes dorsalis, which literally translates as wasting or loss of the back of the spinal cord. The protective sheath which covers the nerves running along the back of the spinal cord is damaged, and this results in a loss of vibration sensation and a loss of proprioception, which is the sense of position of the joints and other body parts, like the hands and the feet. So that's what happens when syphilis damages the posterior spinal cord. But sometimes the spirochetes invade the capillaries supplying the anterior or front of the spinal cord, and that results in general paresis, which causes loss of sensation and weakness, or sometimes even paralysis, mostly in the legs. If spirochetes get into the capillaries serving the brain, then that can cause slurred speech, altered behavior, memory loss, difficulty coordinating muscle movements, and even paralysis. Syphilis can even affect the eye, causing Argyll-Robertson pupil, which is when the pupil loses its light reflex, but it does still have its accommodation reflex, which means that the pupil constricts when there's a nearby object. It just doesn't do anything when it's too light. In congenital syphilis, the spirochetes can infect the baby either via the placenta or during childbirth in the birth canal. In early disease, which is in the first 2 years, the result can range from a baby being stillborn or dying within the womb to having classic features like a maculopapular rash of the palms and soles of the feet, and snuffles, which is when the nose is blocked by increased secretions, which contain spirochetes. Babies may also have organ damage to the liver and spleen, causing hepatosplenomegaly, and damage to the eyes as well, like optic neuritis. In late disease, which is after a child is 2 years old, classic features often include a saddle nose, which is a bony destruction of the nose, saber shins, which is when the tibia gets bent, Hutchinson teeth, which is when the teeth develop little notches, and hearing loss. Diagnosis of acquired syphilis starts with identifying spirochetes in the fluid from chancres, and this can be done using dark-field microscopy. A dark-field microscope shines thin slivers of light on a slide so that the background appears dark, while the extremely thin spirochetes light up. You know how we can see dust particles better in a dark room and there's just a stream of light shining through the door? It's kind of like that. Now, the diagnosis is confirmed with serological tests, and these look for antibodies against the T. pallidum antigens. There are non-treponemal tests, like the Rapid Plasma Reagent Test, or RPR, and the Venereal Disease Research Laboratory Test, or VDRL, as well as tests that detect anticardiolipin antibodies called reagin in the blood. The key, though, is that these are not specific to syphilis. For example, cardiolipin is also released by damaged cells in our body. Then we have the treponemal tests, which include T. pallidum particle agglutination, or TPPA, and fluorescent treponemal antibody absorbed, or FTA-ABS. These treponemal tests detect antibodies that target T. pallidum. Diagnosing congenital syphilis, as you might imagine, is a bit different. In congenital syphilis, the diagnosis involves looking at the mother's and the baby's results in parallel. For example, if a baby's non-treponemal serologic titer is 4 times greater than the mother's titer, like if the baby's RPR is 1 to 64 and the mother's is 1 to 16, then that suggests that the baby has congenital syphilis. In general, for any baby whose mother was inadequately treated for syphilis, or is suspected of having congenital syphilis for a different reason, it's helpful to get CSF fluid for VDRL, as well as cell counts and protein. It's also helpful to perform long bone x-rays, as well as an eye exam and a hearing screen. The main treatment for syphilis is penicillin, but in some cases doxycycline can be used as well. When using penicillin, though, it's important to watch out for a Jarisch-Herxheimer reaction, which is when spirochetes die and break open, releasing a lot of antigens all at once, and making the immune system go into overdrive. When that happens, it results in sudden fevers, sweating, and muscle and joint pains that may last for a few hours up to a few days. Alright, as a quick recap. So, syphilis is a sexually transmitted disease, and it's caused by the spirochete called Treponema pallidum. It can cause disease in 3 stages. The first is localized primary syphilis, and this produces hard chancres. The second is disseminated secondary syphilis, which produces widespread maculopapular rash. And the third is systemic tertiary syphilis, and that affects various organs. Syphilis can be diagnosed by using serological tests and treated with antibiotics like penicillin.
When an external force damages the head, the result is head trauma. And if there's temporary or permanent brain dysfunction, we call it a traumatic brain injury, or TBI. This external force could be a blunt impact, like a baseball bat, a penetrating injury, like a gunshot wound, a blast wave, like an explosion, or an accelerating-decelerating force, like in a motor vehicle crash. The most common causes of TBIs are falls and motor vehicle crashes, and high-risk groups include the elderly and individuals using alcohol and illicit drugs. When TBIs occur in children, non-accidental trauma or child abuse should always be considered. TBIs can cause primary injuries which are a direct result of the external force. These include skull injuries like fractures, Blood vessel injuries, like an epidural or subdural hematoma or a subarachnoid or intracerebral hemorrhage, and brain parenchymal injuries, like brain contusions and diffuse axonal injury. Sometimes primary injuries can lead to secondary injuries, like cerebral herniation, seizures, and increased intracranial pressure. When an individual has a suspected head trauma, the initial evaluation starts with the primary survey, during which the ABCDEs are assessed. A is for airway, and individuals with a traumatic brain injury may not be able to protect their airway, leading to aspiration and hypoxia, which can worsen the brain injury. These individuals may require endotracheal intubation and mechanical ventilation. B is for breathing, and if there's increased intracranial pressure, it can lead to an irregular breathing pattern, which is part of the Cushing triad. C is for circulation, and hypertension and bradycardia are the two remaining features in the Cushing triad. There may also be hypotension, which can reduce brain perfusion. D is for disability, which can be assessed using a 15-point Glasgow Coma Scale, or GCS, where the minimum possible score is 3. The GCS score has 3 parts: eye movement, verbal response, and motor response. For eye movement, if the individual spontaneously opens their eyes, that's 4 points. If they open their eyes only when asked, that's 3 points. If they open their eyes only with a mild amount of pain, like rubbing the orbit of the eye, that's 2 points. And if they don't open their eyes, that's 1 point. For verbal response, if the individual can say what year it is, that's 5 points. If they get the year wrong, that's 4 points. If they respond with inappropriate words like yesterday or dog, that's 3 points. If they respond with a sound like a moan, that's 2 points. And if they don't respond at all, that's 1 point. For motor response, if the individual can obey a motor command like, show me 3 fingers, that's 6 points. If not, you can rub the orbit of the eye, and if they smack your hand out of the way, then they're localizing well, and that's 5 points. If not, you can prick the tip of their finger, and if they withdraw, that's 4 points. If not, if the upper limbs are flexed and lower limbs are extended, that's 3 points. If the upper and lower limbs are extended, that's 2 points. And finally, if there's absolutely no tone, that's 1 point. To remember the point system, think 4 eyes for 4 movement, the Jackson 5 for verbal response, and a 6-cylinder motor for the motor response. And finally, there's E for exposure, during which the individual is log rolled to expose the back, which may help identify other features like spinal fractures. Next is a secondary survey, which includes a history and head-to-toe physical examination. Key elements in the history are captured in the mnemonic AMPLE. A is for allergies, M for medications like anticoagulants and antiplatelet medications that increase the risk for intracranial bleeding. P is for pregnancy and past medical history, L for last meal, and E for the events that cause the trauma, such as the mechanism of injury and whether or not there was loss of consciousness. It's helpful to get information from eyewitnesses, because sometimes there can be post-traumatic memory loss or amnesia. Important physical examination findings to look for include an asymmetric or fixed dilated pupils, which can indicate an impending cerebral herniation. Also, contralateral hemiparesis due to compression of the ipsilateral cerebral peduncle, which occurs in uncal cerebral herniation. That can also cause ipsilateral paralysis of the third cranial nerve, causing ptosis, a dilated pupil, and a down-and-out eyeball. Sometimes the contralateral cerebral peduncle is compressed, producing an ipsilateral hemiparesis, and that's called Kernahan's Notch syndrome. Also, it's important to look for signs of a basilar skull fracture and an underlying hematoma. Signs include periorbital ecchymiosis, or raccoon eyes, a battle sign, which is a hematoma behind the ear, hemotympanum, which is bleeding in the tympanic cavity, and otorrhea, or rhinorrhea, which is often bloody discharge mixed with clear cerebrospinal fluid. If cerebrospinal fluid is mixed in with blood, then on gauze, the CSF travels further along than the blood, producing a halo sign. which is a halo or ring of fluid around a center of blood. After the primary and secondary survey, you can now classify the TBI. A mild TBI, also known as a concussion, typically has a GCS of 13 to 15 and a complete loss of consciousness for less than 30 minutes. Also, the duration of post-traumatic memory loss or amnesia, as well as a change in the level of consciousness, like feeling lethargic or confused, lasts for less than 1 day. Moderate TBI has a GCS of 9 to 12, loss of consciousness for 30 minutes to 24 hours, post-traumatic amnesia for 1 to 7 days, and a change in the level of consciousness for more than 24 hours. Finally, severe TBI has a GCS less or equal to 8. Think, if the GCS is less than 8, it's time to intubate, because individuals often can't maintain their airway. Also, severe TBI has a loss of consciousness for more than 24 hours, post-traumatic amnesia for more than 7 days, and similar to moderate TBI, a change in the level of consciousness for more than 24 hours. In terms of labs and imaging, a CBC should be obtained to make sure that the platelet count is at least 100,000 cells per microliter, which is the minimum threshold for neurosurgery. Additionally, PT, PTT, and INR should be checked to make sure that they are normal, since that can worsen the bleed. A urine toxicology, blood alcohol level, and glucose levels should be checked to identify any other potential causes of an altered mental status. Initially, a non-contrast brain CT should be done to see if there's any shift in the midline of the brain due to a mass effect. A mass effect can compress other structures of the brain and cause a cerebral herniation, which is life-threatening. The reason that the scan is done without contrast is that both blood and contrast are white, making it difficult to detect a bleed. The CT is normal in mild TBI, but may be abnormal in moderate and severe TBI. In terms of TBI treatment, there are general measures, which applies to all cases of TBI, and specific measures, which apply to specific types of brain injuries. One general measure that starts immediately is lowering the intracranial pressure. That's because the cerebral perfusion pressure, or CPP, equals the mean arterial pressure, or MAP, minus the intracranial pressure, or ICP. Since we can't measure cerebral blood flow, we use the CPP to represent it, and in the setting of TBI, the CPP needs to be above 60 millimeters of mercury to ensure that the brain gets enough blood. To do that, we can keep the systolic blood pressure above 100 millimeters of mercury using intravenous fluids and transfusions if necessary. Now, to measure ICP, an intracranial ICP monitor can be placed in the epidural or subdural space, the brain parenchyma, the lateral ventricle, or the third ventricle of the brain. Usually, an ICP monitor is placed in individuals with a GCS less than or equal to 8 and an abnormal CT scan. The ICP is normally around 10 millimeters of mercury and should be kept below 20 millimeters of mercury. One way is simply by elevating the head of the bed to 30 degrees. This level helps increase venous outflow from the brain. Before doing this, it's important to make sure that the individual doesn't have a cervical spine injury. Another method is by using sedatives like propofol, which lowers the ICP by decreasing the cerebral activity and metabolic demand, therefore lowering the cerebral blood flow, which is reflected as a low CPP. However, the blood pressure must be monitored as propofol can cause hypotension. Now, a major determinant of cerebral blood flow is the partial pressure of carbon dioxide, or PaCO2. When the PaCO2 is high, cerebral vasodilation occurs, the cerebral blood flow increases, and therefore the ICP increases. When the PaCO2 is low, cerebral vasoconstriction occurs, and the cerebral blood flow decreases, and therefore the ICP decreases. Historically, hyperventilation was used to lower the PaCO2, but that caused so much cerebral vasoconstriction that it resulted in cerebral ischemia. So now the goal is to have a normal PaCO2 level between 35 and 45 millimeters of mercury, which lowers the ICP, but maintains adequate cerebral blood flow. Now, if the ICP monitor is placed in the ventricles of the brain, then we also have surgical access to place an external ventricular drain, or EVD, which can remove cerebrospinal fluid, also lowering the ICP. Another way to lower the ICP is using osmotic diuretics, like mannitol or hypertonic saline, which work by extracting free water from the neurons. Now, although previously steroids were thought to be helpful in reducing cerebral edema, they currently have no role in TBI treatment and may in fact worsen outcomes. Finally, if the elevated ICP is refractory to medical therapy, then neurosurgical intervention is necessary. A decompressive craniectomy essentially removes a portion of the skull, allowing the squished brain to breathe and the ICP to go down. Two more extreme methods of lowering the ICP are barbiturate coma and therapeutic hypothermia. A barbiturate coma puts the brain to sleep, lowering the metabolic rate, using barbiturate medications like pentobarbital. Therapeutic hypothermia involves cooling the body, which not only lowers ICP, but also protects the brain against secondary injury. Alright, now let's move on to some specific injuries and their management. Let's start with skull fractures, which are classified into linear fractures, depressed fractures, or basilar skull fractures, all of which can be seen on a CT scan. A linear fracture is a single fracture that runs through the entire thickness of the skull. They're usually clinically insignificant and require no treatment, unless it disrupts an underlying blood vessel, like the middle meningeal artery, causing an epidural hematoma. A depressed skull fracture is when the fractured segment folds inward into the brain parenchyma. These are clinically important because they directly damage the underlying brain and often require surgery. If a basilar skull fracture is present, it suggests that there was a significant amount of force. That means there's a high risk of hematoma as well as a cervical spine injury. So in that situation, a cervical spine CT should be obtained. Also, basilar skull fractures can cause cerebrospinal fluid to leak out through the ear and nose, and there's an increased risk of meningitis. After skull fractures come specific brain injuries, which can be classified as extraaxial and intraaxial injuries. Extraaxial injuries are within the skull, but don't involve the brain parenchyma. These include epidural and subdural hematomas, as well as a subarachnoid hemorrhage. Intraaxial injuries involve the brain parenchyma and include intracerebral hemorrhage, cerebral contusion, and diffuse axonal injury. Epidural hematomas are when blood collects in the space between the dura mater and inner aspects of the skull periosteum. This happens when a linear fracture at the temporoparietal region of the skull tears open the middle meningeal artery, causing profuse bleeding. Because of the high amount of force required to produce an epidural hematoma, they're more common among young individuals at risk of such an injury, such as those playing sports or getting into fights. Individuals classically have a period of loss of consciousness, and then can have a lucid interval, during which the individual regains consciousness and feels fine. But a lucid interval isn't always seen. Finally, if not treated in time, the individual can have progressive neurological decline and deterioration to loss of consciousness and coma. If there's a rapidly growing epidural hematoma, it can cause symptoms to progress rapidly, potentially leading to a brain herniation. A brain CT is diagnostic and classically shows a convex, lens-shaped, hyperdense collection of blood. Additionally, epidural hematomas do not cross the suture lines of the skull. In addition to the bleeding, there can be surrounding cerebral edema, and if the edema is significant, it can cause a shift of the midline to the contralateral side, which signifies an impending cerebral herniation. Epidural hematomas are often an emergency, and neurosurgical intervention is often necessary to evacuate the epidural hematoma and suture up the epidural space, preventing reaccumulation of the hematoma. Optimally, a craniotomy, which is removing a portion of the skull, is done. And this magnificently cures most individuals. In some settings, a life-saving alternative is to drill a hole in the skull, which is called a burr hole trephination. Finally, non-operative management with serial neurological exams and CT scans may be considered if all of the following criteria are met. The epidural hematoma is less than 30 millimeters in size. The midline shift is less than 5 millimeters. The GCS is greater than 8, and the individual has no focal neurological deficits. If the decision is made to manage an epidural hematoma non-operatively, then close observation with serial neurological examinations and brain imaging is required, since there's a risk for hematoma expansion and clinical deterioration. It is recommended to obtain a follow-up head CT scan within 6 to 8 hours following brain injury. Alright, now a subdural hematoma occurs when blood collects between the dura and arachnoid matter. Unlike epidural hematomas, the bleeding source is usually the bridging veins that connect the cerebral venous sinuses to the superficial veins of the skull. Now, because the source is venous, the bleeding is slower than the arterial bleed in epidural hematomas, and the onset of symptoms depends on how quickly the hematoma accumulates, but tends to be more insidious. Symptoms can include headaches, nausea or vomiting, visual problems, slurred speech, dizziness, cognitive impairment, or pseudodementia, seizures, and hemiparesis that can be ipsilateral or contralateral. A subdural hematoma is considered acute if it develops symptoms within 2 days of a head trauma, subacute if it develops between 2 days and 2 weeks of head trauma, and chronic if it develops 2 weeks or more after a head trauma. Now, unlike epidural hematomas, even minor head trauma, like walking into a door, can lead to a subacute or chronic subdural hematoma, especially in individuals with brain atrophy, like the elderly and individuals who abuse alcohol. That's because when the brain shrinks, the bridging veins get stretched, making them more susceptible to tearing. Oftentimes, individuals don't even remember the traumatic event, so it's important to consider a subdural hematoma in individuals with an altered mental status. Also, if a subdural hematoma is detected in an infant or young child, it could be due to non-accidental trauma. Infants and children have large heads with relatively small brains, so vigorously shaking a young child can cause a subdural hematoma, as well as other signs of non-accidental trauma, like retinal hemorrhages on fundoscopy. In these situations, the history often doesn't fit the developmental age of the child, like a 2-month-old infant who rolled off the bed. A brain CT is usually diagnostic and classically shows a concave, crescent-shaped density that crosses the suture lines. And the density on the brain CT helps determine the age of the hematoma. Acute subdural hematomas are hyperdense, while chronic subdural hematomas are hypodense. Subacute subdural hematomas appear isodense, meaning that they blend in with the adjacent brain parenchyma, making them easy to miss. Also, a midline shift may also be seen on CT. Morbidity and mortality of subdural hematomas are high because they can develop more insidiously and are therefore harder to detect in early stages. Complications that can result from a subdural hematoma include persistent symptoms such as memory loss, headache, difficulty concentrating, seizures, weakness, numbness, and difficulty speaking, as well as brain herniation in which the pressure on the brain can be severe enough to cause coma and death. Similar to epidural hematomas, the mainstay of treatment is prompt surgical hematoma evacuation with craniotomy or burr hole trephination. Sometimes stable individuals with acute small hematomas can be managed non-operatively, monitoring as the hematoma is reabsorbed naturally. However, hematoma enlargement and neurologic deterioration requiring surgery may still occur in these individuals, so they need close observation, intracranial pressure monitoring, and serial follow-up head CT scans should be obtained during the next 36 hours after injury. Next, there's a subarachnoid hemorrhage, which is bleeding between the arachnoid and pia mater. In most cases, subarachnoid hemorrhage presents with excruciating headache, also known as thunderclap headaches, and are described as the worst headache of my life. There can also be nuchal rigidity, which is caused by the blood irritating the meninges. Occasionally, people can develop seizures and symptoms of increased intracranial pressure like vomiting, vision changes, and confusion. In general, the most common cause of a subarachnoid hemorrhage is head trauma, while the most common cause of a spontaneous or primary subarachnoid hemorrhage is a rupture of an aneurysm. Now, sometimes subarachnoid hemorrhage can be caused by both, as even a very minimal trauma could trigger a rupture of an occult aneurysm in a susceptible individual. The most common aneurysms in the brain are saccular cerebral aneurysms, which have a characteristic round shape on one side of the artery and are also called berry aneurysms. Most saccular cerebral aneurysms arise in the anterior half of the circle of Willis, whereas only a few arise in the posterior half. Some genetic disorders like Marfan syndrome cause a defect in the connective tissue of arteries, and they can also predispose individuals to having saccular aneurysms. Aneurysms can burst open when there's an increase in intracranial pressure, and a less frequent cause of spontaneous subarachnoid hemorrhage is an arteriovenous malformation. Normally, arteries and veins are connected by small, leaky blood vessels called capillaries. But in arteriovenous malformation, they are replaced with abnormally formed tangled blood vessels characterized by at least one direct connection between the artery and vein. Over time, these abnormal vessels can dilate, and since veins aren't used to dealing with high arterial pressures, they can rupture, causing a subarachnoid hemorrhage. The diagnosis of a subarachnoid hemorrhage is usually made with brain imaging, in most cases with a CT scan, or, when contraindicated or unavailable for any reason, with an MRI. In both traumatic and spontaneous subarachnoid hemorrhage, brain imaging shows blood in the ventricular cisterns, interhemispheric fissures, and within the sulci. The more blood that's seen, the worse the outcome. Now, in cases of a spontaneous subarachnoid hemorrhage, if the brain imaging is negative, then the diagnosis can be made with a lumbar puncture and cerebrospinal fluid analysis, which shows red blood cells or xanthochromia, which is a result of red blood cell breakdown. On the other hand, in case of a traumatic subarachnoid hemorrhage, a lumbar puncture is contraindicated due to the high intracranial pressure and the risk of brain herniation. Initial management of a subarachnoid hemorrhage involves general measures to stabilize the person. This includes giving intravenous fluids, ensuring a secure airway, normalizing cardiovascular function and blood pressure control, as well as bed rest, analgesia, venous thromboembolism prophylaxis, and discontinuation of antithrombotics. Now, rebleeding is very frequent, so the only effective treatment of a subarachnoid hemorrhage is prompt surgery like aneurysm repair with surgical clipping or endovascular coiling. An artery that's bleeding can be surgically clipped to apply direct pressure onto it. Alternatively, a catheter can be used to place a coil in an aneurysm, which serves as a site for clot formation, which also seals up the aneurysm. A complication that can occur about 2 days to 2 weeks after a subarachnoid hemorrhage is post-traumatic vasospasm of the subarachnoid vessels, which can cause cerebral ischemia. Therefore, individuals are given a specific calcium channel blocker called nimodipine, which relaxes the cerebral vascular smooth muscle, preventing vasospasm. A 3-week course of nimodipine should be started within 96 hours of the subarachnoid hemorrhage. Another potential complication of a subarachnoid hemorrhage is hydrocephalus, which can lead to increased intracranial pressure. This may be present with progressive deterioration in level of consciousness, and ventricular dilation can be seen on CT scan. Some cases spontaneously resolve, But if the level of consciousness is substantially decreased, drainage of the excess fluid is performed by therapeutic lumbar puncture, extraventricular drain with a temporary device inserted into one of the ventricles, or a permanent shunt for long-term CSF diversion. Some individuals with a subarachnoid hemorrhage develop electrolyte imbalances, like hyponatremia, due to water retention. This may result from either the syndrome of inappropriate secretion of antidiuretic hormone, or SIADH, or from cerebral salt wasting caused by excessive secretion of natriuretic peptides, or diminished central sympathetic activity. Hyponatremia is managed by using 3% sodium chloride solutions. Fever of infectious or non-infectious origin is a common complication of a subarachnoid hemorrhage, so body temperature should be monitored, and infection should be ruled out or treated. We treat fever with antipyretic medications and cooling blankets. Finally, some individuals with a subarachnoid hemorrhage can develop seizures, which are typically treated for about 6 months with agents such as levetiracetam, carbamazepine, and phenobarbital. Alright, on to the intraaxial injuries. Intracerebral hematomas form when the arterioles underneath the pia mater rupture due to the shearing forces of trauma, causing a small hematoma to form. These rarely happen in isolation, and instead happen alongside extraaxial injuries. Now, at first, the individual might seem fine after a head injury. However, as the hematoma expands, pressure on the brain increases, producing symptoms like increasing headache, vomiting, drowsiness, progressive loss of consciousness, dizziness, confusion, slurred speech, and seizures. Symptoms may resemble a subarachnoid hemorrhage, but on brain CT, intracerebral hematomas are well demarcated, homogeneous, regularly shaped border hematomas located deep in the brain. The mortality rate for intracerebral hematomas is high due to the risk of brain herniation, and individuals often require surgical decompression with a craniotomy to relieve intracranial pressure when there's a hematoma near the surface of the skull. Alternatively, if there's a hematoma that's located deep in the brain tissue, stereotactic aspiration can be done to aspirate off blood and relieve intracranial pressure. Stereotactic aspiration is done under a CT scanner to help guide a needle to the exact spot where blood needs to be drained. Next is a cerebral contusion, which literally translates to a brain bruise. This is similar to an intracerebral hematoma, but the key difference is that on a brain CT, contusions are often poorly demarcated, heterogeneous, with an irregularly shaped border, and are found near the surface of the brain. When a cerebral contusion occurs on the same side as the impact, it's called a coup injury. But if it happens on the opposite side of the impact, it's called a counter-coup injury. Just like skin bruises, cerebral contusions and the surrounding edema often get bigger over time, so early surgical intervention with a craniotomy is often necessary. Now, of all of the interaxial injuries, the most common ones are diffuse axonal injuries. They result from the shearing forces on the white matter axons in the brain, causing them to stretch or tear apart. This leads to a prolonged post-traumatic coma, defined as more than 6 hours, which is not adequately explained by a mass lesion like a big hematoma or contusion. If individuals recover from the coma, they often have a lasting cognitive deficit, such as memory loss or problems with language. The brain CT typically shows multiple small, hyperdense punctate lesions along the gray-white matter junction. But the diagnosis is best made with a brain MRI, which offers better resolution and can more accurately detect diffuse axonal injury. Now, even though a TBI is an intense acute event, it can lead to chronic complications. For example, post-traumatic seizures can occur up to a week after a moderate or severe TBI, so those individuals are given prophylactic anti-epileptic medications like phenytoin for 1 week. There's also an increased risk of developing post-traumatic epilepsy months to years after the event. However, prophylactic antiepileptic medications do prevent this. Also, a prolonged increased intracranial pressure can cause a type of stress gastric ulcer called a Cushing ulcer. So these individuals should get prophylactic IV proton pump inhibitors. Finally, mild TBI or concussion is treated with a combination of rest, analgesia, and observation. Now, due to the radiation in mild TBI or concussion, a brain CT is only recommended when the individual develops a worsening headache, has persistent confusion, has a focal neurological deficit, or is on anticoagulation therapy, like warfarin. Usually, individuals with a mild TBI can be discharged after 4 to 6 hours of observation or a negative brain CT. Complete recovery can take a couple of weeks, and if there are symptoms like headaches, dizziness, confusion, depression, or a decline in cognitive function that persists beyond those 2 weeks, then it's called post-concussive syndrome. Treatment of post-concussive syndrome is mainly focused on symptoms, such as analgesics for headaches or selective serotonin reuptake inhibitors for depression. Now, when it comes to athletes, any athlete who has had a concussion should be immediately removed from play. The concussion can be graded depending on symptoms. A grade 1 concussion is when there's no loss of consciousness and no amnesia, and the athlete should sit out the game. A grade 2 concussion is when there's a loss of consciousness, but no amnesia, and the athlete should sit out for at least a week. Finally, a grade 3 concussion is when there's a loss of consciousness and amnesia, and the athlete should sit out the rest of the season. It's really important for an athlete to stay out of play because although the athlete may feel fine, a second blow to the head after a concussion can be fatal, and this is called second impact syndrome. That's because a concussion can make the cerebral blood vessels weak and leaky, and a second blow can cause massive and irreversible cerebral edema. Another complication of concussion injuries is called chronic traumatic encephalopathy, or CTE. CTE usually occurs after repetitive head trauma, such as in contact sports like American football, boxing, and football or soccer. The exact amount of head trauma needed to cause CTE is unknown, but it turns out that CTE develops 8 to 10 years after the initial head trauma. In the early stages, CTE causes mood and behavior changes, but it can later affect cognitive domains like memory. Alright, as a quick recap, a mild TBI or concussion has a GCS of 13 to 15, a moderate TBI has a GCS of 9 to 12, and a severe TBI has a GCS of 8 or less. The major investigation that helps identify most primary brain injuries is a non-contrast brain CT. The brain CT is done for moderate and severe TBI, as well as in mild TBI, where the individual has a worsening headache, persistent confusion, a focal neurological deficit, or is on anticoagulation therapy like warfarin. General measures for treating TBI include lowering the ICP by elevating the head of the bed to 30 degrees, sedation, intubation, and hyperventilation in order to achieve a partial pressure of carbon dioxide or PaCO2 between 35 and 45 millimeters of mercury, osmotic diuresis with mannitol or hypertonic saline, and finally, if all else fails, a decompressive craniectomy. Specific lesions identified on CT scan, such as epidural and subdural hematomas, should be identified and evacuated. Epidural hematomas appear as convex, lens-shaped, hyperdense collections of blood that do not cross the suture lines. Subdural hematomas appear as a concave, crescent-shaped density that does cross the suture lines. Subarachnoid hemorrhage is seen as blood in the ventricular cisterns, intrahemispheric fissures, and within the sulci. Diffuse axonal injury results from the shearing forces on the white matter and presents as a coma lasting more than 6 hours with no obvious cause on CT scan. Mild TBI or concussion can also result in some complications, like second impact syndrome, and chronic traumatic encephalopathy, and is treated with rest, analgesia, and observation.
At the emergency department, 65-year-old Christian came in complaining of headaches, vision problems, and memory loss. These symptoms have gradually progressed over the past couple of weeks. On examination, there's slurred speech, and his gait is unsteady. He has a history of chronic alcohol abuse. Head CT shows a crescent-shaped hyperdense mass that crosses the suture lines. Later that day, 33-year-old Max is brought in after a fight. They reported being knocked unconscious, but regained consciousness after an unknown period of time. Head CT is ordered and shows a lens-shaped, hyperdense mass that doesn't cross the suture lines. Max was very agitated and said they felt fine. They then left the hospital against medical advice. Later that day, Max lost consciousness again and died at home. Okay, so Christian and Max had some form of traumatic brain injury. When an external force damages the head resulting in temporary or permanent brain dysfunction, we call it a traumatic brain injury, or TBI. Now, as a direct result of the external force, TBIs can cause extraaxial and intraaxial injuries. Extraaxial injuries are within the skull but don't involve the brain parenchyma. The most high-yield ones are epidural and subdural hematomas, as well as a subarachnoid hemorrhage. Intraaxial injuries, on the other hand, do involve the brain parenchyma, and the most high-yield one for your exams is diffuse axonal injury. Now, the initial brain injury can impair the normal functioning of the cerebral metabolism and result in complications, such as tissue hypoxia, cognitive impairment, and seizures. Additionally, if the brain injury is associated with intracranial bleeding or severe inflammation followed by edema, the pressure within the skull may rise and result in severe complications. For your exams, it's important to note that the most important complication of increased intracranial pressure is brain herniation. Okay, now let's take a closer look at these different types of traumatic brain injury, starting with the extraaxial injuries. Epidural hematomas occur when blood collects in the space between the dura mater, which is the outer layer of the meninges, and the inner aspect of the skull periosteum. This happens when a linear fracture occurs at the region where the frontal, parietal, temporal, and sphenoid bones join together. This region is called the pterion, and it's the thinnest part of the lateral wall of the skull. For the test, remember that a fracture at the pterion can tear open the middle meningeal artery, a branch of the maxillary artery, causing profuse bleeding. The most important concept to keep in mind is that individuals with epidural hematoma classically have a period of loss of consciousness and then a lucid interval. During this time, the individual regains consciousness and feels fine, but a lucid interval isn't always seen. Symptoms are due to the buildup of blood trapped between the dura mater and skull, which increases intracranial pressure. Now, what makes epidural hematomas so dangerous is that the dura mater is attached tightly to the sutures of the skull, so the blood can't cross these sutures and is trapped with nowhere to go. This means the intracranial pressure can increase rapidly. The individual can develop headaches, nausea, vomiting, and focal neurological symptoms like weakness, numbness, vision, and auditory problems. As the hematoma grows rapidly, it can cause a life-threatening brain herniation, resulting in the loss of consciousness, coma, and death. A brain CT is diagnostic and classically shows a convex, lens-shaped, hyperdense collection of blood that does not cross the suture lines of the skull. There can also be evidence of scalp hematoma due to the head trauma. In addition to the bleeding, there can be surrounding cerebral edema, and if the edema is significant, it can cause a shift of the midline to the contralateral side. This signifies an impending brain herniation, most commonly a transtentorial herniation. Epidural hematomas are an emergency, and neurosurgical intervention is often necessary. All right, moving on to subdural hematomas. For your exams, it's important to know that a subdural hematoma occurs when blood collects between the dura mater, the outer layer of the meninges, and the arachnoid mater, which is the middle layer of the meninges. Another high-yield fact you have to know is that, unlike epidural hematomas, the bleeding source is usually the bridging veins that connect the cerebral venous sinuses to the superficial veins of the skull. Now, the bridging veins are very vulnerable to rapid acceleration or deceleration, so they are easily damaged in car crashes. It's also high yield to remember that when there's brain atrophy and shrinkage, like in chronic alcohol users or the elderly, the bridging veins get stretched out. So even minor head trauma, like walking into a door, can lead to a subdural hematoma in these individuals. Oftentimes, individuals don't even remember the traumatic event, so it's important to always consider a subdural hematoma, especially in elderly individuals with neurological symptoms. If a subdural hematoma is detected in an infant or young child, it could be due to non-accidental trauma or child abuse. Infants and children have large heads with relatively small brains, so vigorously shaking a young child can cause a subdural hematoma, as well as other signs of non-accidental trauma like retinal hemorrhages on fundoscopy. Okay, because the source of the bleeding is venous, the hematoma usually grows slower than epidural hematomas caused by arterial bleeding. Also, since the blood isn't restricted by sutures, it can be distributed over a larger area, so pressure doesn't build up as quickly unless the hemorrhage is very large. Because of these factors, subdural hematomas tend to be more insidious. Now, as the blood accumulates, intracranial pressure increases, causing symptoms like worsening headaches, unsteady gait, nausea or vomiting, confusion, visual problems, cognitive impairment, slurred speech, seizures, dizziness, and hemiparesis that can be ipsilateral or contralateral. A subdural hematoma is considered acute if symptoms develop within 2 days of a head trauma, subacute if they develop between 2 days and 2 weeks of a head trauma, and chronic if they develop 2 weeks or more after a head trauma. Just like with epidural hematomas, if a subdural hematoma grows large enough, it can lead to brain herniation and coma or death. Now, a brain CT is usually diagnostic and classically shows a concave, crescent-shaped density that crosses the suture lines, and that's extremely high yield. And the density on the brain CT helps determine the age of the hematoma. Acute subdural hematomas are hyperdense, while chronic subdural hematomas are hypodense. Subacute subdural hematomas appear isodense, meaning they blend in with the adjacent brain parenchyma, making them easy to miss. Also, a midline shift can be seen on CT. The morbidity and mortality of subdural hematomas are high because they can develop more insidiously and are therefore harder to detect in the early stages. Similar to epidural hematomas, the mainstay of treatment is prompt surgical hematoma evacuation. Sometimes, stable individuals with acute small hematomas can be managed non-operatively as the hematoma is reabsorbed naturally. Next, there's a subarachnoid hemorrhage, which is bleeding between the arachnoid mater and pia mater, the innermost layer of the meninges. In general, the most common cause of subarachnoid hemorrhage is head trauma, while the most common cause of spontaneous subarachnoid hemorrhage is the rupture of an aneurysm. Aneurysms can burst open when there is an increase in intracranial pressure. The most common aneurysms in the brain are saccular cerebral aneurysms, also called baryaneurysms. They typically arise in the anterior half of the circle of Willis at bifurcations. Bifurcations are junctions between arteries, and the most common junction where saccular aneurysms take place is between the anterior communicating artery, or ACOA for short, and the anterior cerebral artery, or ACA. Some genetic disorders like autosomal dominant polycystic kidney disease, Marfan syndrome, and Ehlers-Danlos syndrome can predispose even young individuals to saccular aneurysms, and that's a fact that gets frequently tested on the exams. And a less frequent cause of spontaneous subarachnoid hemorrhage is an arteriovenous malformation, which is formed by abnormal tangled blood vessels that aren't used to high arterial pressures and can rupture easily. In most cases, subarachnoid hemorrhage progresses rapidly due to arterial bleeding, and individuals complain of an excruciating headache, also known as thunderclap headaches, that are described as the worst headache of my life. There can also be nuchal rigidity, seizures, and symptoms of increased intracranial pressure like vomiting, vision changes, and confusion. The diagnosis of a subarachnoid hemorrhage is usually made with brain imaging. In most cases, this is done with a CT scan. Brain imaging shows blood in the ventricular cisterns, interhemispheric fissures, and within the sulci. The more blood that's seen, the worse the outcome. Now, in cases of spontaneous subarachnoid hemorrhage, if the brain imaging is negative, then the diagnosis can be made with a lumbar puncture and cerebrospinal fluid analysis. When there is spontaneous subarachnoid hemorrhage, the test will show red blood cells or xanthochromia, which is a result of red blood cell breakdown. In the case of a traumatic subarachnoid hemorrhage, a lumbar puncture is contraindicated due to the high intracranial pressure and the risk of brain herniation. Initial management of a subarachnoid hemorrhage is supportive, but rebleeding is very frequent, so the only effective treatment is prompt surgery like aneurysm repair. A complication that can occur about 2 days to 2 weeks after a subarachnoid hemorrhage is post-traumatic vasospasm of the subarachnoid vessels, which can cause cerebral ischemia. Therefore, individuals are given a calcium channel blocker called nimodipine, which relaxes the cerebral vascular smooth muscle, preventing vasospasm. Another potential complication is hydrocephalus, which can lead to increased intracranial pressure. This can present with progressive deterioration in the level of consciousness, and ventricular dilation can be seen on CT scan. Some individuals with a subarachnoid hemorrhage develop electrolyte imbalances like hyponatremia due to water retention. This can result from one of three things: the syndrome of inappropriate secretion of antidiuretic hormone, or SIADH, cerebral salt wasting caused by excessive secretion of natriuretic peptides, or diminished central sympathetic activity. Other common complications of a subarachnoid hemorrhage are fever of infectious or non-infectious origin and seizures. All right, on to the intraaxial injuries. The most common ones are diffuse axonal injuries. They result from the shearing forces on the white matter axons in the brain, causing the axons to stretch or tear apart. For example, this can happen due to rapid acceleration or deceleration during a motor vehicle crash. Diffuse axonal injury leads to a prolonged post-traumatic coma, defined as more than 6 hours, which is not adequately explained by a masked lesion like a big hematoma or contusion. If individuals recover from the coma, they often have lasting cognitive deficits such as memory loss or problems with language. Diagnosis is best made with a brain MRI, which typically shows multiple small, hyperdense punctate lesions along the gray-white matter junction. Okay, now let's switch gears and talk about brain herniation, which can be a consequence of the previous types of traumatic brain injury we've just discussed. Brain herniation occurs when a part of the brain is pushed into another space of the skull, or even out of it. It typically happens in response to increased intracranial pressure resulting from an epidural or subdural hematoma, intracerebral hemorrhage, or a brain mass like a tumor or abscess. Brain herniation can either be supratentorial or infratentorial. Supratentorial herniation refers to a displacement of the cerebrum above the tentorium, which is a meningeal fold located in the back of our skull that separates the cerebrum from the cerebellum. Infratentorial herniation refers to the herniation of the cerebellum located below the tentorium. Supratentorial herniation includes transtentorial herniation and cingulate or subfalcine herniation. Transtentorial herniation can be further classified into uncal herniation and central herniation. All right, let's take a closer look at these types of herniation, starting with transtentorial herniation. A very high-yield type you have to remember is uncal herniation, where the medial or innermost part of the temporal lobe, called uncus, slips down towards the tentorium and puts pressure on the brainstem. This can lead to a few very high-yield complications. The uncus can compress the oculomotor nerve, or cranial nerve 3, resulting in an oculomotor nerve palsy. The result is the eye looks down and out. Since this nerve carries the parasympathetic innervation to the eyes, another clue to look for is a dilated pupil that doesn't respond to light. In addition, the posterior cerebral artery can be compressed, resulting in ischemic stroke of the occipital part of the brain, which is responsible for vision. This leads to homonymous hemianopia, which is a loss of vision in either the left or right halves of the visual fields of both eyes. The vision is lost in the halves that are contralateral to the posterior cerebral artery that is affected. Although there is a partial loss of vision, macular function is spared, meaning that central vision is still sharp and detailed. This is because the part of the occipital lobe in charge of the macula gets blood from both the posterior cerebral artery as well as the middle cerebral artery. Now, the uncus can push the brainstem against the free edge of the tentorium, forming what's called a Kernahan's notch. The commonly affected part of the brainstem is the cerebral peduncle, and it's rich in motor fibers that travel from the cortex to the muscles in the ipsilateral side of your body. Since both sides of the brainstem can be compressed, it can lead to bilateral, contralateral, or ipsilateral hemiparesis. Sometimes uncal herniation also stretches and breaks branches of the paramedian basilar artery that supplies the brainstem, which is responsible for breathing and cardiac function. As a result, uncal herniation can lead to coma and death. Small, linear, or flame-shaped hemorrhages, called Dere hemorrhages, can be seen on autopsy. The second type of transtentorial herniation is central herniation, and it's when there's caudal or downward displacement of the brainstem. Central herniation can also cause dilated and fixed pupils and paralysis of upward eye movement, which leads to the sunset eyes sign. That's where the eyes are in a downward position and part of the lower pupil is covered by the lower eyelid. Now, central herniation usually stretches and ruptures branches of the paramedian basilar artery. As a result, it is usually fatal, and Dere hemorrhages can be seen on autopsy. All right, now another supratentorial herniation is cingulate or subfalcine herniation. In this herniation, the innermost part of the frontal lobe, called the cingulate gyrus, gets squeezed below the free edge of the falx cerebri. This is a meningeal fold that goes down into the longitudinal fissure that separates the hemispheres of the brain to the opposite side of the skull. The displaced part of the brain can compress the anterior cerebral artery, and that can cause an ischemic stroke. Finally, a cingulate herniation is often a forerunner of other types of supratentorial herniation. Now, the other category of herniations are infratentorial herniations. An important infratentorial herniation is tonsillar herniation, which is when parts of the cerebellum, called cerebellar tonsils, slip down through an opening in the skull called the foramen magnum. The most common signs are headache and neck stiffness. It can also give rise to flaccid paralysis, where there's reduced muscle tone. Tonsillar herniation is particularly dangerous because the displaced cerebellum can push onto the brainstem, which normally helps regulate breathing and cardiac function, ultimately leading to coma and death. Okay, now regardless of the type of the brain herniation, increased intracranial pressure can cause a decreased level of consciousness, focal neurological signs, and papilledema. Papilledema is the swelling of the optic disc, which is the point where the optic nerve fibers leave the retina. Also, these individuals can have increased blood pressure, irregular breathing, and bradycardia. These signs are referred to as Cushing's triad, and they represent a physiological response of the central nervous system to increased intracranial pressure. Lumbar puncture is a relative contraindication in individuals with suspected increased intracranial pressure due to possible herniations. In order to confirm the presence of a mass effect that can be causing increased intracranial pressure, imaging such as CT or MRI can be used. If CT and MRI fail to prove any mass lesions within the skull, lumbar puncture can be performed. The needle that is inserted into the spinal canal is attached to a manometer, which is a device that can measure and confirm the increased CSF pressure. Treatment of increased intracranial pressure and brain herniation is aimed at reducing the pressure within the skull. This can be done surgically or by using osmotic therapy, such as mannitol, which helps remove excess water from the body. Treatment of the underlying cause, such as surgical removal of the hematoma, should also be done. All right, as a quick recap, TBIs occur when a head trauma leads to temporary or permanent brain dysfunction. TBIs can cause extraaxial brain injuries, such as epidural or subdural hematomas and subarachnoid hemorrhage, and intraaxial brain injuries, such as diffuse axonal injury. Sometimes these brain injuries can lead to increased intracranial pressure, which can have various consequences, like brain herniations, which are life-threatening. Diagnosis can be made based on clinical presentation, imaging tests of the brain like CT or MRI, or other techniques such as lumbar puncture. TBIs usually require surgery. Okay, now back to our cases. Christian's head CT showed a crescent-shaped, hyperdense mass that crosses the suture lines, which is typical of a subdural hematoma. Due to his age and history of chronic alcohol abuse, he most probably has brain atrophy that led to stretching and rupture of the bridging veins after a minor trauma. Headaches, vision problems and memory loss, slurred speech, and unsteady gait are all common in a chronic subdural hematoma. Now, Max's head CT showed a lens-shaped hyperdense mass that doesn't cross the suture lines, which is characteristic of an epidural hematoma. Also, the fact that they first lost consciousness but then became alert is most probably what we call a lucid interval. Afterwards, the rapid progression to death is also typical for epidural hematomas.
Concussion, also called a mild traumatic brain injury, usually starts with a hit to the head. But what makes it a concussion is that the hit results in diffuse brain injury, meaning a large part of the brain is affected rather than a small specific area. Also, concussions don't cause obvious brain trauma that can be seen on imaging, like bleeding. Most concussions are the result of injuries from things like motor vehicle accidents, falling down the stairs, recreational activities, like getting hit in boxing or getting tackled in a football game, or even violence in the home. Now, the brain is made up of neurons, which are the functional cells of the nervous system. Neurons are made up of three parts: the dendrites, which are little branches off the neuron that receive signals from other neurons, the soma, or cell body, which has all of the neuron's main organelles, like the nucleus, and the axon, which is intermittently wrapped in fatty myelin. When an electrical impulse called an action potential flows through a neuron, it causes the release of stored neurotransmitters into the gap between two neurons, called the synapse. This first neuron is called the presynaptic neuron, and the next neuron is called the postsynaptic neuron, and it has receptors for the neurotransmitters on its dendrites which trigger the opening of ion channels. When the neurotransmitter glutamate binds to a postsynaptic neuron, it causes ion channels to open, and positively charged ions like sodium, potassium, and calcium enter the cell. This is called an excitatory postsynaptic potential, or EPSP, because more positive charge inside the cell causes a depolarization to happen. If the overall charge of the cell increases enough, it triggers an action potential, which is an electrical signal that races down the axon at speeds of up to 100 meters per second, triggering the release of more neurotransmitter at the next synapse. In contrast to glutamate, neurotransmitters like GABA, or gamma-aminobutyric acid, bind to postsynaptic neurons and open ion channels that lets in negatively charged chloride ions, creating an inhibitory postsynaptic potential, or IPSP, which make the cell more negative by hyperpolarizing it. So ultimately, it's a bit of tug of war between stimulation from EPSPs and inhibition from IPSPs that decides if a neuron fires an action potential. Now keep that idea in mind as we shift gears a tiny bit. A key concept with concussions is to understand the mechanisms of injury. With concussions, there are two main types of injuries: coup contra coup injuries and torque injuries. Let's use boxing as an example. The initial blow causes a contusion, or bruise, at the point of impact. This is called a coup injury. Further, this causes both his skull and brain to move backwards. As this happens, the momentum of the brain causes it to strike the inside of the back of the skull, resulting in a contusion on the brain on the opposite side of the initial blow. This is called the contra coup injury. A torque injury, on the other hand, is a bit different. And using our boxing example, let's say the boxer is now struck with a right hook, causing his head and neck to twist. The brain suspended in the skull twists against the thinner stalk of the brainstem, stretching the structures within. The area most affected is called the reticular formation, which is a network of nerves throughout the brainstem that controls the levels of consciousness, which is how awake we are. So when the boxer gets punched, the reticular formation gets stretched and damaged, potentially causing the person to pass out. So compared to coup contra coup injuries, torque injuries usually result in more severe concussions, as well as the loss of consciousness. With either type of injury, though, damage happens on a microscopic scale at the level of the neuron, rather than causing visible damage to a specific part of the brain. Both coup contra coup and torque injuries damage the long axon of neurons, and that allows potassium ions to leak out of the neuron while sodium and calcium ions leak into the neuron, and this causes it to depolarize and fire an action potential. Now, when millions of neurons get depolarized from this sort of damage, excessive glutamate gets released, generating a ton of EPSPs, causing even more action potentials to be generated. So in short, the injuries cause a huge increase in the brain's metabolic activity, and that increases the brain's demand for blood. Now, at that very crucial time when the brain needs more blood, for some unknown reason, blood flow transiently decreases right after a concussion. So there's actually a decreased supply of blood. An increase in demand and a decrease in supply is a bad combination, and it leads to neurons being starved of energy, and it can stay that way for a few hours up to a day or two. Because a concussed brain is in a state of glucose starvation, subsequent head trauma can cause secondary impact syndrome. Secondary impact syndrome is a rare disorder that results in rapid cerebral edema, or brain swelling. But the cause here isn't well understood. Another consequence of repeated concussions is chronic traumatic encephalopathy, which is when certain proteins become dysfunctional and accumulate in neurons over many years. These proteins include tau proteins, which also cause Alzheimer's disease. Buildup of dysfunctional proteins can cause neurons to die, and if that happens on a large scale, the brain can atrophy or shrink, while the ventricles or fluid-filled cavities in the brain get larger. The main symptoms of an acute concussion are confusion, memory loss, and sometimes loss of consciousness, and usually these symptoms improve within 1 or 2 days. Symptoms that might appear a bit later include headaches, dizziness, and nausea or vomiting. The diagnosis of a concussion is mainly based on the description of the injury and the symptoms. Usually a head CT scan is normal, and there are no focal neurologic deficits. The treatment for a concussion is rest and making sure that they've completely recovered from the concussion before returning to an activity. Alright, as a quick recap. A concussion is usually the result of either a coup contra coup or a torque injury. And typically torque injuries are more severe and more often result in a loss of consciousness. After an injury, there are more EPSPs in the concussed brain, which creates a greater demand for blood, with a subsequent decrease in blood supply, and that results in the neurons getting starved for energy and getting damaged. The main symptoms are confusion, memory loss, and loss of consciousness, followed by a headache, dizziness, and nausea or vomiting.